and welcome to this day two of this amazing meeting that we've been doing for over 7 years now. Our relationship with the American Diabetes Association, the foremost diabetes organization in the world, and the intellectual wealth that it has brought in has helped shape this conference and many conferences who have learned from our experience and built up powerhouses of learning and networking in the past few years. This has been a wonderful opportunity for all of us to get together. One of the things that we do on the second day morning of any ADA primary event is an exclusive endocrine session because slowly the barriers between diabetes, metabolism, and endocrinology are being blurred to an extent that it does become an en masse specialty. It also gives us an opportunity to showcase some of the leading and the emerging stars in endocrinology in this country. So as part of that, without wasting time, I hand you over to our very young chairpersons this morning, Anantharaman and Srinath, to take this forward. Their CVs are online and for all of you to see. Rajesh has become a cloud blur and he will burst soon. And I will leave it to all of you to continue this discussion. And again, I welcome my very, very good friend, Unikrishnan, who has always gone beyond the call of duty to be where his heart is. Welcome, Uni. Anantharaman, Srinath, all yours. Anantharaman, you're muted.
Yeah, thank you, Dr. Krishna, for having me in the program. It's a great delight every year to be on this program. So, proceedings will be Dr. Unikrishnan AG. Dr. Unikrishnan AG is an endocrinologist and he's also the CEO of Chelaram Diabetes Institute, Pune. It's a leading diabetes institute in India, and it's an IDF certified center for education and excellence in diabetes care. And recently, he received a Diabetes Excellence Award at Digital Diabetes Summit at Hyderabad 2019. And arguably, he's one of the best articulates in India. So it will be a delight to listen his pre-recorded talk. And after that, Dr. Uni will be available for a Q&A session. So can we take this forward?
Friends, it's a pleasure to be here. Thank you for the invite. And let me begin my talk on self-limiting thyrotoxicosis. It is well known that hyperthyroidism is common in India. Studies have shown that the prevalence of overt hyperthyroidism is about 0.67%. And this will be my agenda for today. I will introduce the case, look at some differential diagnosis, and end with some practical tips for management. So here's a 41-year-old lady, 8 weeks post-COVID. She then develops fever, a thyroid swelling in the neck with pain for 5 weeks. If you look at her thyroid functions, it's very clear that the free T3 is high, the free T4 is normal, and the TSH is low. The nuclear scan, as you can see, shows no uptake in the neck, and this is a classic case of subacute viral thyroiditis causing a T3 kind of toxicosis. So I've looked at my beginning with a case study. Let's look at the differential diagnosis and causes of temporary or self-limiting hyperthyroidism or thyrotoxicosis. So if you just take this example of COVID, the 3 reported effects of the coronavirus are COVID-19 are thyrotoxicosis, This could be either subacute, painful thyroiditis, or it just could be a painless, atypical form of thyroiditis without any pain. COVID is also associated with hypothyroidism, that could be central or primary. And as we know, COVID can also be associated with non-thyroidal illness syndrome, where the thyroid function tests may be abnormal because of a coexisting severe illness. So one of the effects of the COVID virus, coronavirus, is direct damage to the thyroid gland. But there are other explanations also. The thyroid cells have been selectively, the receptors in the thyroid cells selectively have seen to sort of attach to the coronavirus, because the ACE2 TMPRSS2, you will know that the ACE2 receptor on cells attaches to the coronavirus, and so the COVID-19 virus may attach to the ACE2 TMPRSS2 pathway, which is selectively expressed in the thyroid cells. So that could be another. It's also important to know that the structural proximity of the virus-laden superior airways to the thyroid gland. Remember, the coronavirus or COVID-19 affects the respiratory system, the upper respiratory system, and this is physically and structurally very close to the thyroid gland, and that could play a role as well. We know that lots of vitamins are nowadays taken by patients in the hope that it will improve immunity, and some of these may contain biotin, and that can also interfere with thyroid function test, and we'll come to that. And the third is non-thyroidal illness conditions such as inflammation, sepsis, and steroids can also disrupt thyroid function tests. So these are the four largely important causes of self-limiting thyrotoxicosis. One is, as you can see, subacute thyroiditis. Second is Hashimoto's. Even less common is, trauma to the gland. It could be surgical trauma, certain drugs, palpation, hemorrhage into a thyroid gland. All these direct structural damage to the thyroid gland can lead to a temporary release of thyroid hormones. Remember, thyroid hormones have a half-life of 6 to 7 days, and it takes 6 to 7 half-lives of the drug to be washed away. So the thyrotoxicosis, because of direct thyroid damage, is usually self-limiting unless the damage is ongoing in some other ways. Like, for example, if there is a coexisting Graves' disease or something like that. Rarely this kind of thyroiditis can also persist for long, but usually it's self-resolving. Very rare to see spontaneous resolution of Graves' disease, which can occur, and also important to remember biotin interfering with tests. Now, is it really thyrotoxicosis? That's the first thing we must be asking in clinical practice, and the biochemical thyrotoxicosis that you see on biotin is temporary. I call it biochemical because it does nothing clinically. Biotin interferes with the thyroid function testing protocol in the lab, and therefore it can cause laboratory thyroid functions to be derailed. So here's a 45-year-old gentleman who took a health checkup package. He's on biotin supplements for his baldness. And what was seen in this gentleman was that the free T3 is high, the free T4 is high, the TSH is extremely low, 0.0001. Can TSH receptor antibody help in these cases? No, because biotin can also interfere with TRAb measurements, as we will see. What is the management of these patients? It is careful follow-up, and important, friends, to note that drug-induced thyroid disease is underrated. So this is a very interesting publication published in 2019 May, where they studied the thyroid function test of a 41-year-old adult endocrinologist who volunteered to be administered biotin 30 milligrams per day for a week. Now, the biotin minimum interfering dose, the minimum dose of biotin that interferes with the thyroid function test is 5 mg. But this gentleman, this endocrinologist, took 30 mg, and you can see that on biotin, his TSH was low at 0.8. It was 1.45 the TSH, it came down to 0.8, and off biotin it is 1.33. Similarly, the free T4 was 1.36 initially. After taking biotin, it shot up to 1.94, and it came down to 1.24 24 hours after stopping biotin. So the T3 also went up with biotin and came down after stopping biotin. But what is important is that the anti-TPO and the TSH receptor antibodies also shot up after taking biotin and went back to normal levels after biotin was stopped. The biotin streptavidin is a reaction which is used in the laboratory in the measurement of thyroid hormones. So it's very important that biotin can actually interfere with thyroid function tests, and we as doctors should know it. And as you can see, it's important to stop biotin at least for 2 days and test thyroid functions. But if you are doing TSH receptor antibody, you need to wait for a week after stopping biotin. So important to note that we must not label a patient as thyrotoxicosis on biotin, because the T3 may be high, T4 may be high, TSH may be low, and even the TSH receptor antibody may be positive. So important to remember that. So there are two other things to remember when we look at self-limiting or self-resolving thyrotoxicosis. The first is Hashimotoxicosis. There are several definitions of Hashimotoxicosis, bit of a controversy. So this is an article, a commentary I wrote many years back on Hashimotoxicosis. Generally, it refers to Graves' disease with Hashimoto's thyroiditis. So patients present with thyrotoxicosis, but they remit very early. How do you diagnose it and differentiate it from classical Graves? Because the gland is very firm. The TPO antibodies are very high. Now, if you do a nuclear scan in Hashimotoxicosis, yes, there may be an increased uptake, but the uptake increase is only a slight increase on technetium scan. And there is no sparkling intense vascularity on Doppler. It will just be a little bit of a high vascularity. So these subtle features should differentiate Hashimotoxicosis from classical Graves' disease. Why is it important to differentiate? Because once you differentiate, you will know the cause better. Hashimotoxicosis is often, once you treat with antithyroid drugs, you can taper and stop it fairly quickly. On the other hand, it's also remember to understand that the TSH receptor antibody is two-phased. We know that the TSH receptor antibody binds to the TSH receptor, but it can stimulate or block. If it stimulates, it causes thyrotoxicosis, and if the TSH receptor antibody blocks the thyroid gland, it can cause hypothyroidism. And it's also important to note that this stimulating antibody can change into blocking antibody and vice versa. So sometimes thyrotoxicosis due to Graves' disease with TSH receptor antibodies can not just resolve, can also be replaced with hypothyroidism. It's also important that in neonates where there is thyrotoxicosis, when the mother's TSH receptor antibody goes to the baby can get a temporary toxicosis, and when these IgG antibodies disappear, the thyrotoxicosis in the baby will get better. It's also important to note that our current assays do not differentiate between TSH receptor stimulating antibodies or blocking antibodies. It will only measure the TSH receptor antibody, and it's left to our clinical sense to actually take care of the real diagnosis. So I've looked at the introduction, I've looked at some differential diagnosis and causes. Now let's look at some of the management practical tips. As I said, one of the important things in thyrotoxicosis is to find out whether it's really a thyrotoxicosis. Is it a sick thyroid syndrome or non-thyroidal illness? Is it that the TSH is suppressed because of some condition like, say, pregnancy? Is it biotin? If none of this is there, is it subacute thyroiditis? Does this patient have pain and tenderness in the thyroid gland following a viral infection? Sometimes atypically it may not even be there. The pain may not even be there. Is it Hashimotoxicosis? Is the gland firm and is the uptake just slightly high? Does it have atypical features? And wherever you are in doubt, it's important to follow up the patient without really treating, and you can just follow. So some tips here. One is please look for biotin, rule out a lab error and retest, go by your clinical acumen. Remember that some trauma to the thyroid gland, like for example a hemorrhage into a nodule, can cause temporary thyrotoxicosis that can get better. In today's pandemic era, COVID has to be considered. Sometimes when there is very painful, tender, subacute viral thyroiditis, steroids may help. Remember the two-phased TSH receptor antibody, that it may be blocking to stimulating and thyrotoxicosis may remit. In many cases, masterly inactivity and careful follow-up is enough, and time will tell whether the thyrotoxicosis will remit. So some of the cases of thyroiditis may last for a longer period of time, so you can carefully treat and see. But always, whenever you start antithyroid drugs, for patients with Graves' disease, please look for an early remission because some of these cases, as discussed, can remit very early. It's a pleasure discussing this topic with you, and thank you so much for listening to me. And it's a pleasure being here virtually. Thank you very much.
Thank you very much, Dr. Unnikrishnan.
Anantharaman, Unni is agreed to stay on till the end. And,
thank you, Dr. Unnikrishnan.
Unni is agreed to stay on till the end.
Thank you, Dr. Unnikrishnan. It was a wonderful talk. I think very nicely you touched based on the thyroiditis, the drug-induced hyperthyroidism, the biotin. Although biotin causes hypothyroidism, there's always interference, but drug-induced is very important that we always need to consider when also the true.
I think something to say. Yeah, I think
Dr. Anantharaman, Dr. Unnikrishnan has agreed to stay till the end. Let us continue with Dr. Rajput, and then Unni and Usha can take the questions together.
That'll be great. I mean, it's great to have them together in the panel. Yeah, sure. So then I'll ask Dr. Rajesh Rajput to start his presentation. It's a delight for me to introduce Dr. Rajesh Rajput. So he's MBBS, MD Medicine from GMC Bhopal, DM Endocrinology from my own alma mater. He's actually my senior. I mean, I worked with him for a year and a half during my training. So he is, he's a senior professor and head of the Department of Endocrinology at PGIMS Rohtak. So, and Dr. Rajesh will speak about interpretation of thyroid function test and its pitfalls.
Thank you,
over to you,
Dr.
Dr. Rajesh.
Yeah, I am audible. Hello.
Yes, sir. Yes.
Okay, fine. Good morning, everyone. Thank you, Dr. Anantharaman, for nice words. I am going to speak on interpretation of thyroid function test, and the topic become more relevant in today's era when we have easy availability of thyroid function test, and it has been done for so many reasons which are beyond explanations. And when test does not make any sense, then such type of patients with these test reports are sent to physicians and endocrinologists. So what I am going to do over next 12-13 minutes, briefly understand, giving you the knowledge how to do interpretation of thyroid function test. For that, we have to understand the physiology of hypothalamo-pituitary thyroid axis and the factors which governs the circulation of thyroid hormone in the plasma as well as tissues. There are many laboratory conditions which interfere it, and in last lecture you have listened that there are drugs, there are heterophile antibodies which do assay interferences. We will not go into the details, and to make you understand it more easily, again I will take you through some of the cases where interpretation of thyroid function test will be made easy. Now this is how thyroid hormone is synthesized and secreted in our body. From hypothalamus, there is release of TRH, which act on pituitary, from where TSH is secreted, which act on thyroid gland, from where T4 is secreted, and this T4 goes and act in a negative feedback manner and control secretion of TSH and TRH. So why I am telling you, there is a negative logarithmic relationship between T4 and TSH. So whenever there is a rise in TSH, T4 rise in TSH, it means T4 is low, and whenever there is fall in TSH, which means T4 is high. So they are interlinked with each other. And whenever this relationship is lost, we have to look into the other conditions. Also, after secretion, T3 and T4 are bound to plasma protein, and majority of T3 and T4 are bound to thyroid binding globulin, apart from transthyretin and albumin. Now, why it is again important to know? Because there are conditions which are associated with alteration in thyroid binding globulin. So any drug, any clinical condition which is going to change the concentration of thyroid binding globulin is again going to alter the concentration of circulating total T3 and T4. The commonest example is pregnancy, where TBG levels are increased. So the normal range for T3, T4 are more than 1.5 times the non-pregnant range. So these are some of the normal physiological aspects which we must remember. If we look at the algorithm for diagnosis of thyroid function, this is an oversimplistic view that if TSH is normal, you have not to do anything. If TSH is high, measure T4. If it is low, it is hypothyroidism. If it is normal, it is subclinical hypothyroidism. Similarly, if TSH is low and your T4 is high, it is hyperthyroidism. With low TSH and normal T4, it is subclinical hyperthyroidism. But then the life is not that easy. So the things are not so simple when it comes to thyroid function test. And there are potential pitfalls. So when to consider these pitfalls, when your thyroid function test is discordant with your clinical pictures. And when thyroid function test itself is a discordant, means T4 is elevated, T3 is normal, TSH is going in some other direction. And there are a number of names which are given to such thyroid function test, that is anomalous TFT, discordant TFT, and so on. So we are going to discuss these things after this slide through some case reports. So if we see the potential permutation and combination of T3, T4, and TSH, the normal is normal free T3, normal free T4, and TSH. Now let's see one of the most common scenarios, that is TSH is suppressed and free T4 and free T3 are high, which means patient is having hyperthyroidism. But then such thyroid function profile will also be seen in thyrotoxic phase of thyroiditis, which you have learned in last lecture. It is also seen in iodine excess, secondary to some drugs like amiodarone, ingestion of lots of tablet of levothyroxine, and even in hyperemesis gravidarum. If we see the next scenario, that is TSH is high and T3, T4 are low, the most commonest cause is hypothyroidism. But again, it is also seen in post-radioiodine therapy, that is post-ablative hypothyroidism. It is also seen in hypothyroid phase of thyroiditis, and also seen with the drugs which are mentioned here. If we see the next scenario, then you may see a patient where TSH is suppressed, but T3, T4 are normal range, which means patient is either having subclinical hyperthyroidism or patient is already receiving treatment for hyperthyroidism. And remember, TSH always take long time to normalize. Secondary to number of drugs which are commonly used in COVID pandemic in critical care settings like steroid and dopamine, which are because of central action are going to change the concentration of TSH, SA interference, and non-thyroid illness. Then the next scenario is TSH is elevated, but free T3, free T4 are normal. The diagnosis is either subclinical hypothyroidism or poor compliance to therapy, which is again very common. Patient before visiting to the doctor started taking levothyroxine tablet, which will result in the normalization of free T4 measurement. But again, TSH normalization takes regular ingestion of levothyroxine tablet. Then the next most common cause, especially in northern part of the country, is malabsorption of levothyroxine, drugs, then SA interference, non-thyroidal illness, and TSH resistance, the disease entity which is not recognized before 2000, and after 2000, and especially after 2010, nowadays more and more such cases are recognized. The next important pattern is when your TSH is either normal or decreased, at the same time, free T3, free T4 are also decreased. Now, it can be because of central hypothyroidism or non-thyroidal illness, or it can be because of SA interference. And lastly, if we have TSH which is increased, slightly increased, or normal with increase in free T4 and TSH. Again, it can be because of SA interference, or it can be because of familial dysalbuminic hyperthyroxemia, or it can be secondary to non-thyroidal illness, TSH secreting pituitary adenoma, and resistance to thyroid hormone. I know some of you must be thinking there are lots of causes, and that is why in a slide I have tried to show different permutation and combination of T3, T4, and TSH which can happen. And and mind you, this is actually happening when we are ordering tests without considering the clinical situation why we are ordering. So now let's discuss some of the cases through which we will try to learn the interpretation of thyroid function test. Case 1, 47-year-old women, increasingly tired and fatigued. There is 6-month history of general deterioration, marked weakness, fatigue, and sleepiness, stable weight, no constipation. Radioactive iodine therapy for hyperthyroidism has been done way back in 2016. Presently, she is receiving thyroxine 275 microgram per day. Remember, this is supraphysiological dose. Normally, in a common garden case, we need 1.6 to 1.8 microgram per kg per day. She has also been prescribed gabapentin and citalopram because of number of somatic complaints. Her BMI is 33. Rest of the clinical examination is normal. Reflexes are slow. There is ankle edema. And when thyroid function test was ordered, it showed free T4 of 0.3, which is reduced, free T3 of 1.9, which is again reduced, and TSH of 100, more than 100, despite the fact she is receiving 275 micrograms of levothyroxine per day, and thyroid peroxidase antibody are negative. So the 4 options, which is the most likely explanation according to you, you can write down your correct answers in your chat box, which is the most likely explanation for this lady's failure to respond to the supraphysiological dose of thyroxine therapy. The options are elevated T3 and T4, enhanced metabolism of thyroxine, increased deiodination to inactive form, that is reverse T3, malabsorption, or non-concordance with therapy. So if we see, the patient has been investigated and IgA-TTG, which is done to rule out celiac disease, which is quite common in north part of the country, wheat allergy, it is negative, which means we have ruled out malabsorption. So how to proceed in such cases? Now, if we see such type of thyroid function test, where the levels are pretty disturbed despite receiving very high dosage of levothyroxine, there are 4 scenarios. Consider assay interference. The next very important cause is consider levothyroxine malabsorption. I have told you celiac disease is one common cause which has been ruled out. Apart from that, what we forget that even simple tea and coffee intake with levothyroxine is going to interfere by its absorption by as much as 30%. We have seen people prescribing levothyroxine, asking the patient to take it fasting, but patient after taking tablet immediately consume tea and coffee. So we have to tell very carefully that do not consume tea or coffee even for 40 minutes, at least for 40 minutes after consuming your levothyroxine tablet. Then there are a number of commonly prescribed drugs which include ferrous sulfate, sucralfate, antacids. They are again going to interfere with absorption. The next important scenario is either increased metabolism, increased excretion, or change in binding capacity. Now again, as you see clearly, there are a number of drugs which are going to alter. And lastly, despite that we have repeatedly asked, sometimes the true history is not coming up, and then lies the issue of compliance. So how to do it? One way to do it is to do supervised levothyroxine absorption test. Patient should not have an underlying coronary artery disease. Under direct supervision, administer 1 week cumulative thyroxine dose, which is 1.6 microgram, multiply it by 7, give it in a tablet form, and then draw samples as has been mentioned in the slide, 0, 30 up to 360 minutes. And this has to be continued for next 6 weeks, samples to be repeated. And then what are the interpretation? If after 6 weeks, TSH normalizes, it is nothing but non-compliance. We have to explore patient perspective, and we have to counsel the patient carefully. If there is inadequate free thyroxine rise post administration of once a week levothyroxine, then it might be because of malabsorption. And if there is a consistent rise in free T4, but there is no change in TSH, then we have to consider conditions like thyroid hormone resistance. So that's how we should proceed in such cases. Let's see the case number 2. 77-year-old female, known case of hypertension, receiving amlodipine 10 milligrams a day. She had a fall and fractured her left femur. Post-operatively, she developed atrial fibrillation and was given heparin. Patient was otherwise euthyroid, no goiter, but in view of atrial fibrillation, cardiologist ordered thyroid function test. Rest of the physical examination was normal, and thyroid function test showed a TSH of 3.2, which is within normal range, free T4, which is very high, 35 against the upper limit of normal of 20, and TPO antibodies are negative. So the options for you are, is it because of drug effect, or is it because of non-thyroidal illness, or it is because of radiocontrast agent induced thyrotoxicosis, subclinical hyperthyroidism, or TSH secreting pituitary adenoma. So again, you can write down your answers in chat box. Now, if you see this case carefully, she has been on heparin therapy. And if we see, whenever patients are given heparin, it has an influence of free fatty acid and it displaces levothyroxine from thyroid binding globulin. The result is there is a rise in free T4 level. So this is one condition where measurement of free T4 gives spurious information in contrast to measurement of total T4. So what we have done, we have ordered a total T4 measurement in this patient, which was found to be within normal limit. So again, friends, this is a busy looking slide, but if you see carefully, the list of drugs is long. It can interfere direct TSH synthesis or release, to conversion of T4 to T3, to change in alteration of thyroid binding globulin. So we have to keep this list. I know it is difficult to remember long list of drugs, but it is always prudent to keep such type of table print of such type of tables under our table, where we can immediately consult if we are considering drug interference and patient is taking number of other drugs. Coming to case 3, 72-year-old male, known case of chronic obstructive pulmonary disease and congestive heart failure, admitted to ICU with urosepsis secondary to BPH. Patient was in shock, was on inotropic support with dopamine, intubated. TSH laboratory feature shows a TSH of 0.35, which is lower range of normal, free T4, which is low, 9.5, and total T3, which is again markedly decreased, 0.3. So what are the options? The options is, this is nothing but non-thyroidal illness. If you see, there are a number of names given to this entity, which is low T3 syndrome, and in such cases, there is no place for thyroxine replacement. Now, the important point here is, this type of thyroid function test mimics central hypothyroidism, but this is an adaptation of the body against increased catabolic state, and it is commonly seen in patients who are severely sick, patients who are on steroids, who are receiving inotropic supports, who are having a cytokine surge like COVID illness. If we see the natural history or trend of thyroid function test in such type of patient, with the increasing severity, initially there is fall in T3 levels. As the severity of illness progresses from mild to moderate, T4 also starts falling. And as you see clearly, TSH remains normal. In severe stages, both T3 and T4 are reduced, and it carries a poor prognostic significance. And if patient survives, start recovering, T3, T4 starts normalizing, and there is a transient rise in TSH, followed by normalization. So we have to remember the severity of illness, the temporal profile of change in various components of thyroid function test. Remember, this is an important catch, that in critically sick patient, if you have ordered thyroid function test, TSH value of less than 0.1 is only seen in less than 7% of the cases. And a pre-illness TFT, if it is available, is invaluable. Most of the time, there is no abnormality of hypothalamo-pituitary thyroid axis. We have to do a careful follow-up of such patients, and that is why the dictum is avoid testing unless strongly suspected in ill and hospitalized patients. The next case is a case 4, again patient of 75 years, acute myocardial infarction, has a non-sustained ventricular tachycardia. Patient has been given treatment accordingly, and this patient is given amiodarone 200 milligrams a day along with other cardiac supportive medications. After 1 month, patient was readmitted with non-sustained VT, and at that time, again cardiologist ordered thyroid function test, which have shown a T4 which is 13.5, which is higher than the normal, T3 which is in the low normal range, and TSH which is slightly elevated with borderline elevation of TPO antibody. And a call is sent to endocrinologist for giving opinion about this thyroid function test. Now remember, in this patient, the important component, this patient is receiving amiodarone. And amiodarone is a type 3 antiarrhythmic drug, and it contains 39% iodine by weight, which means it will result in 40-fold increase in plasma and urinary iodine level. Also important to remember that it is stored in adipose tissue, so the high iodine level will persist for more than 6 months. And if we see the effect of amiodarone on thyroid function, acutely because of high iodine content, there is transient suppression of thyroid. That is Wolff-Chaikoff effect. A normal thyroid gland will come out of it, but if the thyroid gland is diseased, it will stay under this suppression. In a hypothyroid patient, there is susceptible inhibition of this high iodine persists. And in a given case where there is underlying autoimmunity, multinodular goiter, because of high iodine, Jod-Bashido effect will be seen. So if we see the pattern of thyroid function test, there will be increased T4, decreased T3, increased reverse T3, and a transient increase in TSH. Remember, TSH normalizes or remains slightly suppressed for within 1 to 3 months following amiodarone therapy. There are 2 types of thyrotoxicosis. We will not discuss in detail, but it is, remember, in type 1, the treatment of choice is antithyroid agents. For type 2, which is a destructive type of thyroiditis with use of amiodarone, the treatment of choice is steroid therapy for a short time. Last case before I stop, again 69-year-old lady followed by a serial of thyroid function tests where TSH is 5.4, which is slightly elevated, FT4 is markedly elevated, FT3 is a markedly elevated with positive TPO antibody, and ECG is showing AF. So what is your diagnosis? The differential diagnosis of this case is, this can be TSH secreting pituitary tumor or resistance to thyroid hormone. How to differentiate between 2? Now this table shows the differentiation in patients who have TSH secreting pituitary tumor. The simplest test to measure in routine clinical practice is measure sex hormone binding globulin. These are elevated in TSH secreting pituitary tumor, and they are normal in resistance to thyroid hormone. And then you can order an MRI scan, which will be abnormal in TSH secreting tumor, and it will be normal in resistance to thyroid hormone. If you have suspected resistance to thyroid hormone, also measure thyroid function test in first degree relative, where similar degree of abnormality will be noted. So friends, if we carefully follow T3, T4 and TSH, keeping in mind different permutation and combination which we have discussed, it is possible to reach at a logical conclusion in most of the cases. Thank you very much.
Thank you, Dr. Rajesh. That was a wonderful tour of hyperthyroidism and hypothyroidism. You really took us over the importance of checking the compliance, the thyroid illnesses, the heparin and the amiodarone interference, and clearly the differentiation between TSH, OMA, and the thyroid hormone resistance. So whatever we, it was a very good tour. But my question to you, sir, is one question, if I may.
Yes, yes.
When we have a high TSH, in situation where you have excluded the compliance and you have also ruled out the malabsorption issues in our clinical practice, the assay interference, sir, this becomes
Absolutely.
really difficult for us.
It is.
So what is the practical advice you advise for us to send it?
You are absolutely correct. The assay interference is one of the common conditions, but nowadays with change in assays, there is an inbuilt mechanism within the assay where they check for anti-mouse antibodies, which is one of the common interfering antibodies. And if we are not comfortable in doing so, my best suggestion to my general practitioner colleagues is that kindly change and do it from a good accredited NABH laboratory, which is taking care of these interfering assays. Now, with increasing availability, quality care actually is becoming a big issue. And in most of the time, this will sort out the issue. I have purposefully not touched upon the details of assays because that make the things more complex, and that is beyond the time which is allotted to me. But this is according to me what we can do in a routine general practice.
Thank you, sir. So I think in the interest of time, I think it was a wonderful session. We'll move on to the next session.
Thank you very much.
I think may I invite upon, thank you, sir. Yeah, our next speaker, I think is a very tough mind, Dr. Usha Ayagiri, whom I know her. She's a senior endocrinologist from Chennai. She practices various platforms, Apollo Sugars, Apollo Specialty, Apollo Proton Cancer Center as well. So I take the pleasure of inviting Dr. Usha to the symposium. She will be talking about TSH and fertility. Over to you, Dr. Usha. Thank you.
Thank you very much for the very kind introduction, Srinath. And it gives me an absolute pleasure to be speaking once again in Dr. Krishna Seshadri's My Mentors program. So let's start. TSH and fertility for the next 20 minutes. I have no conflicts of interest. Quick recap of the basic physiology.
Usha, your screen is not shared, Usha.
Sorry, beg your pardon. We're supposed to do.
That's what happens when you're on the beach.
Yes, indeed, but I can't stop enjoying it. Sorry. So, TSH and fertility over the next 20 minutes. No conflicts of interest. Recap of basic physiology. So we know that TSH shares a common alpha subunit with FSH, LH, and HCG. And this is why there is such a lot of interaction and overlap in their actions at the tissue level. There is also, LH is quite a powerful stimulator of the TSH receptor in vitro, but in vivo, the relative concentrations of LH and TSH mean that TSH is still the main stimulator of the TSH receptor, and HCG, of course, in pregnancy. Now, I'm going to be talking about TSH and fertility. What I'm not going to be doing is talking about treatment of thyroid disease in pregnancy. That's a completely different topic. So we know that TSH affects ovulation, and about 5% of women with infertility or subfertility have abnormal thyroid hormone levels. This is because the TSH receptor and the thyroid hormone receptors alpha-1 and beta-1 are seen on the ovarian surface epithelium, in oocytes, at primordial, primary, and secondary follicles. Thyroid hormones also participate in this complex interregulation of ovarian function. In animal models, FSH has a direct effect. Thyroid hormones synergize with FSH, and they interact at the level of morphological differentiation of granulosa cell functions, LH-HCG receptor formation, and induction of our 3-beta hydroxysteroid dehydrogenase and aromatase, which we know are involved in the steroid hormone genesis pathways. Now, thyroid hormones may also influence fertility indirectly. So they have an effect on GnRH secretion and prolactin secretion, and they alter SHBG levels, thus altering the free versus total hormone levels. We know that when you have an overt thyroid dysfunction, this thyrotoxicosis or hypothyroidism affects all levels of your hormones, including your SHBG, the carrier proteins, your adrenal and gonadal male and female hormones, and your pituitary gonadotrophins. But even without overt thyroidal dysfunction, there is a load of interaction between thyroid function and ovulatory function. So an increase in TSH, even a marginal increase, can lead to a pseudo feedback inhibition of FSH and LH. You know that hypothalamo-pituitary changes in hypothyroidism can impair LH response to GnRH stimulation, and a high TRH can cause hyperprolactinemia. But independently of that, there is a decrease, as we said, in the SHBG, a decrease in androgen clearance, an increase in ovarian volume, and an increase in stromal deposits. Now, on a slight aside, this looks very familiar, doesn't it? And that's because you see that there is a high prevalence of PCOS in adolescent girls who are euthyroid but have chronic lymphocytic thyroiditis. This was shown in 175 girls, where women have a higher degree of PCOS when you are euthyroid and have chronic lymphocytic thyroiditis. We are very familiar with the menstrual abnormalities in thyroid disorders, but even without overt thyroid disorders, some women can have some degree of menstrual disorders. In the older studies, the reported menstrual disorders were much higher, but in the newer studies, they range between 8 to 22%. This is a very good review published about a year and a bit ago about the impact of thyroid disease on fertility and assisted conception. So the first bit looks at subclinical or overt hyperthyroidism and female infertility. Now, for the purposes of this talk, I'm not talking about male fertility, but we know that thyroid dysfunction can impact sperm production and sperm count and quality. But for this purpose, so menstrual disturbances, as we said, are common in hyperthyroid women. And compared to euthyroid women, in thyrotoxicosis, there are increased levels of SHBG and estradiol in the serum. There is increased androgen production and increased conversion of estrone to estradiol, and LH secretion and its pulsatility are altered in Graves' disease. Now, in subclinical or overt hypothyroidism, the rates of metabolic clearance of both androstenedione and estrone are decreased, but their peripheral aromatization is increased. Plasma binding activity of SHBG is decreased. Plasma concentrations of total testosterone and estradiol are decreased, but their free or unbound fraction is increased. There is also a blunted LH response. This stimulates TRH secretion, increasing prolactin levels. And we know that when you have high prolactin, you lose pulsatility of GnRH and LH secretion, again feeding back into ovulatory dysfunction. So this whole axis of SHBG, estradiol, GnRH keeps feeding on itself. Thyroid autoimmunity also impacts female fertility, and I'll talk about it in a bit. So this has led to guidelines from both ITS and FOGSI in 2019, which recommends evaluation of thyroid TSH concentration in all women seeking care for sub or infertility. Now, if you look at sub or infertility, there is a range of TSH levels. This review from 2018 has been presented previously in a primer, but not in this forum. Effectively, what they looked at was to compare TSH and prolactin levels in women with unexplained infertility compared to women who were seeking reproductive help for male factored infertility. So the women themselves had normal fertility, but there was male factor. So that was the control group. And it was a cross-sectional study of 187 women. And they looked at TSH levels within the normal range, with the upper limit being 5. So what you and I would consider completely normal. And what they found was that the women with unexplained infertility had significantly higher median TSH levels compared to those women who were seeking help for male factor fertility issues. And the difference was that the median was 1.95 in this group with unexplained infertility versus 1.66 in this group seeking help for male factor infertility. And also a significantly higher percentage of women in the unexplained infertility group had a median TSH over 2.5. So nearly 27% of women had a TSH more than 2.5. So even that level between 2.5 and 5, they postulate, may have an impact on unexplained infertility, but they do acknowledge that more studies are necessary in this area to clarify this. Then we come to subclinical. So TSH levels over 4.5, but under 10, subclinical hypothyroidism and infertility. So the first one was TSH under 5. Now this is slightly over that. This is a very good review from about just under a decade ago, where they looked at levothyroxine treatment and pregnancy outcome in women with subclinical hypothyroidism undergoing assisted reproduction techniques. After doing the usual culling, they ended up with 3 studies, and these studies, Negro et al. Looked at a TSH under 4.2, Rehman et al. TSH more than 4, and Kim et al. TSH more than 4.5. And the crisp summary of this is that these meta-analyses provide enough evidence that thyroxine supplementation should be recommended to improve clinical pregnancy outcomes in women with subclinical hypothyroidism and or thyroid autoimmunity undergoing assisted reproduction. A few more studies on the same line, 64 infertile patients with subclinical hypothyroidism with a TSH over 4.5 with a normal FT4, and they were randomized to either 50 micrograms of thyroxine or no thyroxine therapy. And the group treated with thyroxine had significantly higher number of grade 1 or grade 2. So the good transplantable embryos, a higher implantation rate, and a higher live birth rate, and significantly lower miscarriages. Again, 13 eligible studies looking at a meta-analysis of outcomes of thyroxine supplementation in women with subclinical hypothyroidism and thyroid autoimmunity. So for women undergoing assisted reproduction, you can reduce the miscarriage rate with thyroxine supplementation. So this led to a change in the guidelines in 2019, saying that thyroxine therapy may be considered in subclinical hypothyroidism in women who are attempting natural conception given its potential benefits, but is certainly recommended and achieve a goal of less than 2.5 in women undergoing IVF or ICSI. So for women with normal contraception, natural contraception, you can consider it. It is recommended for women with any assisted reproduction to get to a TSH under 2.5. Here comes the autoimmune bit of it. So autoimmune thyroid disease affects about 5 to 20% of women of childbearing age. It can increase your miscarriage rate. It can decrease the oocyte fertilization and successful pregnancy rates. Autoantibodies are also found in the follicular fluid, ovarian follicular fluid of women with positive TPO antibodies. It's also associated with endometriosis, polycystic ovarian syndrome, and we saw some of the data earlier, and premature ovarian failure. So all of these affect fertility through impaired cellular and humoral immune responses. And one of the postulates is that this increased antibodies increase interleukin-2 production, and through NK cell activation, it can add to reproductive failure and miscarriages. So in this meta-analysis of 4 studies, including 334 patients and 1679 controls, antibody positivity had an odds ratio of nearly 1.5 for subfertility. So if you have antibodies, 1.5 times the risk of being subfertile. So this is a very recent publication. It's still EPUB ahead of print, not yet printed. Therefore, I've given you the DOI. Thyroid disease is quite prevalent in about 11% of women of reproductive age have thyroid autoimmunity, and they postulate a mechanism. They say that at the early stages of thyroid autoimmunity, the follicular cell function isn't affected, but these antibodies create a microenvironment at the level of the granules of cell, which affects oocyte survival. Advanced stages, not only is the thyroid follicular cell productivity affected, but the ovarian function and oocyte health. So the follicular health and the oocyte health is also affected. So they propose 2 models for early and late autoimmunity. What they've basically shown is that in recent studies, as I've shown you, TSH higher levels or anti-TPO antibodies are associated with sub or infertility in some, but not all women. And there is a confirmed benefit to treating women who have antibodies and a TSH over 4 to improve the rates of miscarriage. So levothyroxine, this again has led to a change in the guidelines where they say that levothyroxine may be considered for euthyroid women with thyroid autoantibodies which are positive and who are undergoing assisted reproduction. Now, this is a flowchart proposed by the same authors where they look at TSH and thyroid antibodies. More than 4, consider or start thyroid replacement, thyroxine replacement. 0.3 to 4, antibody negative, no further action. Antibody positive, look at thyroid function. And if it starts going over 4, please consider starting thyroxine replacement. Less than 3, TSH, T34 and T4 and T3 normal, just check TSH. If they're increased, treat with, so this is the pathway that Dr. Rajesh was showing us earlier for suppressed TSH. I'm going to stop here. Thank you. I'm open for questions.
Thank you, Dr. Usha. That was a wonderful tour. Exactly what you showed us the importance about the thyroid, monitoring the thyroid function test with the fertility of pregnant ladies, ensuring them they have a smooth outcome. So in my practice, one question I would like to ask you, Dr. Usha, is what do you do when you have TSH who are probably gray area between 3 and 4 and women who are trying to conceive and your gynecologist have already started them on thyroxine, and these patients come out as an antibody negative. So do you go with the gynecologist or you do justify and say, okay, we can just wait and watch? What do you do? I know it's practical to always to work with them closely, but what is the practical advice you give us?
So that's a very difficult and tricky situation because clearly the guidelines recommend differently, but this is a patient in whom it's already been started. I always feel that undoing something that's been started is much more difficult. And if it's been started because a woman has already been seeking help for fertility, any future adverse outcomes may come back to land on your desk. So it's a very tricky situation. My approach has generally been to first talk to the gynecologist, understand their approach and see why. And if they feel very strongly about it, as long as you're monitoring the TSH and it stays in what is considered a safe range, I think against the recommendation of the guidelines and in the interests of the patient feeling confident and in the interest of being able to work together with my gynae colleagues, I would probably, as I say, against the guideline recommendations, I would probably go with this. But I would also have a conversation with my gynecology colleagues as to how we could maybe do things differently the next time round for the next patient and maybe apply the guidelines a bit more closely. So, tricky situation, as you said.
Yeah, thank you. Thank you, Dr. Usha. I think it was a wonderful talk from all the 3 speakers. I think knowledge has been really expanded. We may have a couple of minutes for Q&A session for interaction.
We have 15 minutes for questions. Okay.
So, okay.
I have
yes,
a question.
fine. Yes,
Dr.
Dr.
Prasanna?
Krishnan, can you hear me?
Yes, sir.
See, when you say hashitoxicosis, let us take classical grapes. Many of them have anti-TPO positive. Their uptake is also high. Is it a diagnosis you make at the beginning? Is it a retrospective diagnosis that you make?
I completely agree with you, sir. Often when we make the diagnosis of hashitoxicosis, it's a retrospective diagnosis. Because when we see the patient that there's thyrotoxicosis, T3 is high, T4 is high, TSH is low, and then the uptake is high. But then we find patient has already had TPO done from some lab which is positive. Then we give some anti-thyroid drugs. Suddenly there is a remission. Then you may think, oh, this might have been hashitoxicosis. So I completely agree that this diagnosis is, first of all, probably we should not even be making it prospectively, but it probably should be more of a retrospective diagnosis. And the main message is that we have to follow up the thyroid functions very carefully. Of course, people with some people with a large goiter, high initial free T4, free T3, very low TSH, high TRAb. These people may have, people with, for example, with a smaller goiter, likely to remit earlier, and high TRAb likely to remit late. But if the high TRAb comes down quickly, likely to remit earlier. But this use very important point, sir. It's usually a retrospective diagnosis.
Because even 8 to 12% of normal healthy population also have anti-TPO. I feel it has no prognostic value at all. Even people who are anti-TPO positive, 4 years they are on antithyroid. Again, taking what Dr. Rajesh puts it also. Whatever test in the world, whether you do TRAb, whether you do anti-TPO, whether even technetium uptake, also I have seen many times it is wrong. Maybe it has not even gone there also. After 1 week, 15 days, I don't believe do it. And what is shown as low becomes high. So many of these fallacies, I still feel whatever, and even the best of the labs, I'm not telling an ordinary lab, even the best of the lab also, anti-TPO may be positive. That does not give, even in subclinical hypo, that the conversion of subclinical to clinical hypothyroidism, not even 30%. So much so, it becomes more an academic interest, whether it is hashiotoxicosis, subclinical hypo. Ultimately, best thing is you are the clinician, come back after 2 months, he will know what. Many times, as you said, Graves' thyrotoxis, start antithyroid with 10 mg. Within 2 months, he comes with hypothyroid. Oh, maybe I was dealing with hashitoxicosis. So I feel all the tests in the world fine, but ultimately I feel it is the clinical judgment. Follow up regularly will avoid many tests, including TRAb. It's not going to help me at the beginning just because TRAb is there. Maybe in pregnancy, yes, because I can't do technetium scan, iodine scan with that. So I still feel with all thyroid, ultimately follow up, clinical judgment will be more useful than any test in the world. You do battery of test is not going to. That's all what I want.
I think one of the things that we forget is the greatest armamentarium in the quiver of the endocrinologist is actually patients. That many diseases reveal themselves. If we are patient enough and talk to our patients and say, you know what, I'd just like to monitor this. I don't want to act. I don't want to get a further test now. It will complicate issues. Let me monitor it. Uni, can you also comment on, the pitfalls of TRAb? I think, what is happening is slowly TRAb is replacing radioiodine uptakes and technetiums as a surrogate for, deciding if somebody has Graves or not. What is your view on this?
So, TRAb, I think, I frankly don't do too many TSH receptor antibody tests in my practice, because if I want to diagnose Graves' disease, I prefer to do a nuclear scan. The only situation I order TSH receptor antibodies are that if the patient is pregnant or something like that, or mother with previous Graves' disease. Otherwise, I don't order too much. Number one, it's a costly test. Number two, as I showed you, even things like biotin can interfere with it. Number three, some people say you can do a TSH receptor antibody. Some studies show that you do a TRAb level, and that TRAb level high means you should not stop the antithyroid drugs. And if the TRAb level is normal, then you can stop the antithyroid drugs after 18 months. But I have not found that in my practice. Whenever I did it, I have not found it to be predictor. One of the more important thing is TRAb antibody does not differentiate between a stimulating TRAb and a blocking TRAb. So, in fact, if the antibody is a stimulating TRAb or a blocking TRAb, the differences can be enormous, because a stimulating TRAb causes hyperthyroidism, a blocking TRAb causes hypothyroidism. And therefore, it's a test with a lot of limitations to be used very, very cautiously. Unless, of course, you cannot do without the test, I don't order the test. This is my view.
So I have one more question. Do we have pregnancy normals for TSH receptor antibodies? See, there is a 22-week data that is done much earlier, and that was used to predict neonatal Graves. But do we have normals that differentiate between Graves and non-Graves in pregnancy by TSH receptor antibody? I am not aware of it. I don't know if any of the panelists have data on this.
So I'm also not aware of any such data in pregnancy. Of course, I've seen the data where in Graves' disease versus other forms of thyrotoxicosis, the TRAb is, even the scatter plots are different. But in pregnancy, I'm not aware of any such data. But I'll be glad if Dr. Usha or Dr. Any of the other panelists would like to comment on that?
But whether data is there or not, see, now basically two things. One is, I don't know, is there any data technician scan is dangerous in pregnancy? Is there any data that is available? Many times the nuclear medicine says, after all, millicurie we can agree. Iodine is agreed. When you are doing technetium, I don't think there is any danger when you are doing 50 or 65 microcurie for a scan. So that can be done. But most often it is the patient who is reluctant to undergo the nuclear scan. And many of the nuclear medicines still think that technetium scan is dangerous. Why should technetium scan? We don't have data, it is good or bad also, both ways if you talk. In such a situation, if the TRAB is positive and you have features that it means more of grave thyrotoxicosis rather than it is subacute thyroiditis, you take it. Suppose patient does not want to do, he cannot afford all this. Such situation, all right, when you're in the third month, we don't treat at all. Why do you bother subacute thyroiditis or graves? It does not make difference. After 3 months or more, still T3, T4 is high. That is the stage when you have to decide between TRAB and rather than going clinical alone, that I take help. And I feel those data are not, whatever I have seen, these are the situations where I use TRAB and it is helpful if it is positive. Even at the end of 2 months, the T3, T4, it cannot be thyroiditis going on 2 months, then I will use it.
Anantharaman or Usha, you want to comment on this?
I have one comment, sir. So even in this scenario where we come to the second trimester, third trimester, we are again in gray zone. Actually, we really do not know whether giving antithyroid drug will improve any fetal or maternal outcomes, basically. So, I mean, basically, I ask the patient with, I've had many patients like this. So where I've not been, where I did the TSH receptor antibody, and since there are a lot of pitfalls with TSH receptor antibody, it comes negative. Still, the patient is thyrotoxic well into the 3rd month, 4th month. So there's always a dilemma whether to treat her or not. So I go by whether the patient is having symptoms or not. If the patient is not having symptoms, gaining weight normally, so sometimes the TSH can remain suppressed, well up to 20 weeks. And probably not beyond 20 weeks, well up to 20 weeks, you can have suppression. So, and beyond that, if the TSH is suppressed also, there is no evidence to treat based on the thyroid hormone reports alone, the T3, T4 and TSH reports alone. So if there is a benefit to the patient in terms of symptom improvement, I would prescribe an antithyroid drug. Otherwise, I probably don't prescribe. The patient is frankly has hyperthyroidism, then we should treat, I believe. But otherwise, we can hold off of treatment because we really don't have any evidence to say that if you treat a mild sort of hyperthyroidism in pregnancy, it actually improves either the fetal outcome or the maternal outcome.
Basically, it depends on symptoms, as you said. Most of them are, in pregnancy, they tolerate thyrotoxicosis well because as it is a hypermetabolic state as such. Very few come. And even when you treat, as you said, will keep the upper limit of the normal rather than trying to make them euthyroid also. That's what I think most of the guidelines also say.
Sure.
I think that especially in pregnancy, this is a tricky situation, isn't it? Because the TRAB that we talk about is a genetic term. There are subcategories, and in any individual, you can have heterogeneous mix of these subcategories. Especially in pregnancy, you can go from stimulating to blocking in the latter half of pregnancy. And if I remember correctly, HCG also has a slight interference both at the tissue level and at the assay level with TRAB antibodies. So whilst we monitor TRAB in pregnancy because of the potential impact on the fetal goiter, I think that is my only, if I have positive TRAB antibodies, whatever the kind, I look at the fetal heart rate and goiter much more closely. But that is really its only clinical value for me in pregnancy, not for the maternal health.
Sure, can I take you on from here because we have about 6 minutes. You can start this. So I was very interested in looking at this algorithm that you had put in. So and I was very, from the publication that you quoted, very interestingly. The data is very incongruent. Even, you can go back and forth simply because that, for example, the negative studies many of us feel that, the right amount of thyroxine was not used. There was a fixed amount of thyroxine, not necessarily a
50,
upscaled
yes.
thyroxine, isn't it? So the one question that I have is that at least in patients who have had multiple absence of clinical pregnancies with IVF, right? And an anti-TPO positivity, knowing that a TSH less than 2.5 is probably conducive, would you consider that you actually branch this off and say that, look, if you have an anti-TPO positive and your TSH is say between 2.5 and 4, that this is a patient where you would give even though the data is very minimal, would you give the benefit of doubt to the patient and say, let's start a titrating dose of thyroxine? I ask you, and then the others can all chip in.
Yes. And this is why when Srinath asked me if the gynecologists have started it, would you stop it? I said the gynecologist would have started it because the woman went to them for sub or infertility, perhaps a history of recurrent miscarriages. So in this kind of scenario, as long as I'm monitoring the TSH closely and don't allow it to become too suppressed, I would give the woman the benefit of that doubt, because what's the harm is my argument.
Similarly, what is the harm with the suppressed TSH for some time?
I mean, we see it in early pregnancy anyways. How suppressed is the only thing I get worried about. If the free and total hormones are within the recommended range for that trimester, and the TSH is even 0.1, I'm not going to panic about it.
So a few months of thyroxine in the anti-TPO situation, in your view, is not a bad idea.
I can't see the harm in it as long as we are monitoring closely. And as long as we've had the discussion with the patient and the gynecologist and it's an informed consent.
I agree with you, because if we say that subclinical hyperthyroid is not dangerous, and we have data that high TSH is dangerous, I buy what Dr. Bushayagari said. Nobody is going to die, neither father or mother, when you are giving 25 microgram. So all the data has shown, yes, TSH 2 point. In fact, I attended a meeting where Brazilian and US, European and Asian are there. The Brazilian guy said, I don't care for antibody. Don't care for TSH. Even if it is below 2.5 antibody positive, I'm giving it. This is another extreme where they say. But if it is more than 2.5, giving 25, as you said, since we don't have data and hydrostatic, even if TSH 0.2, you are not going to treat in another woman. So I think it is good what you said, we should treat rather than not.
Anantharaman, Unni, Srinath?
I completely agree. Yes, Dr. Srinath, go ahead.
Sir, exactly. Why to go anti to the gynecologist here? So working with them and monitoring it towards the safety outcome is the right way to take forward. Now, on that high note, I'll just go back to another patient where someone who's diagnosed Graves and who responded very well to the antibiotic, and the antibiotics are not greatly increased. Okay, this patient wants to become pregnant. So preconception, would you start them on, you continue them on the antithyroids, or do you change them into PTU as clinic? So how do you take this forward, sir?
So if you have heard the question correctly, if somebody is planning pregnancy and has hyperthyroidism and is on carbimazole, is that right?
Yeah, correct. And
So
as a preconception clinic, you want to move on to PTU, who was very well controlled, sir. The TSTs are very well controlled. Patient doesn't have any signs of toxicity, and this is a low risk. Now, I agree with Dr. Anantharaman's point, whether you continue them, what is the benefit and what is the outcome. So what do you do in this situation? PTU is dangerous, it's hepatotoxic. We have seen a lot of liver issues, although not many have handled any true liver failures. So what do you do?
I think we have Dr. Susan Mandel talking about this. Is it later today or tomorrow? There's a whole session on this.
It's only hypothyroidism in pregnancy.
Yeah,
so
because
not
of
hyper.
pregnancy outcome, yeah.
and it's in a different context.
Yeah, okay.
So let's not mix that. So the important issue is, would you switch? I don't. I wait till in fact, this discussion occurs with infertility specialists all the time. Some of them ask you, will carbimazole or methimazole interfere with implantation? And the answer is there's no data. There's absolutely no data to suggest that there is a change in the implantation with carbimazole or methimazole. And remember that the infertility is a long-drawn process. The treatment is a long-drawn process, well beyond the window of safety of PTU. In my view, I switch patients the moment they are confirmed. Lower the dose. I don't care if they're a little bit toxic, and get them off at 12 weeks. This is what I do. I keep the NNC. In fact, the truth is that given it's only a medico-legal issue of shifting the PTU. It is like, a Ganesh Puja that is done. I do it for a few weeks and get it out as quickly as possible. That's what I do.
Krishna, can we move on to the next one? We have finished 11:45.
Yes, we can.
Thank you.
We can continue this because it's fun.
So I thank all the three speakers, Dr. Unni Krishnan, Rajesh Rajput, and Usha, and also Chairperson Srinath and Anant Raman. We move on to the next one, and Dr. Krishna Sheshadri will be taking the clinical case seminar. And we have two experts, Dr. Anant Raman and Usha Egari. In between, I will join.
Right, and Unni, feel free to be part and or exit whenever you feel you have to. Okay,
please join me, Krishna.
So this is something that we have learned more and more over a period of time, and has a lot of controversy. As you can see, anything with thyrotoxicosis has controversy. Please note, I have conflicts of interest. The others can disclose it as they speak. We won't spend time on interpretation of thyroid function tests. We all know this. We have heard this ad nauseum. If we are talking about this particular space where the T4 is elevated and the TSH is suppressed, that's primary thyrotoxicosis. And here is a condition where the free T4 is elevated, the TSH is suppressed. And sometimes the TSH is suppressed, but the T3 is elevated, which is T3 toxicosis. Sometimes the T3 is normal, that is earlier subclinical thyrotoxicosis. So let's start with this background. We have a 26-year-old woman who presents with palpitations, a 6-kilogram weight loss and prominent stare. She has increased frequency of bowel movement. Symptoms are present for 3 months. Menses is regular and scanty. Recently married, does not plan to start a family now. Here is her physical exam. Pulse is 100. Regular blood pressure is 130/80. Weight is 56 kilograms. She has lid retraction, mild proptosis, no diplopia, fine tremors. Has onycholysis, diffuse soft to firm thyroid enlarged and palpable, some lymph nodes in the cervical chain. The free T3 is 6.5 picograms per mils. Free T4 is 4.6 nanograms per deciliter. The TSH is less than 0.01. Okay, so we won't spend too much time on it, but let me quickly get the panelists. Each of you can feel free to pitch in, or if you want me to ask specifically, I will do that from the clinical presentation. What is the most likely diagnosis? Are the clinical features sufficient to confirm the diagnosis? And what is your diagnostic test of choice? Anantharaman, you want to start?
I'll go first. And
Yes.
this is a clear-cut case of Graves, I feel. I mean, the clincher is probably the duration. I mean, the duration has been there for more than 3 months. And then there is a fairly clear-cut increase in thyroid hormone and then a low thyrotropin. So more than this, you really don't need any evidence to, there's no doubt regarding the diagnosis of Graves actually. So when there is thyromegaly, increase in thyroid hormone, TSH low with duration, so that clinches the diagnosis clinically. You really do not need any other diagnostic test. So I would directly treat this patient with antithyroid drugs.
So in a resource limited setting, just to confirm, Anantharaman, that you're saying that when you have duration and you have other features like proptosis, your pretest probability is so high that if you don't have the resources to order another test, you will not order it, and you may actually offer therapy to this patient. Is that correct?
Yes, absolutely.
Usha, you want to comment anything more on this?
Yes, so in addition to the features that Dr. Anantharaman pointed out, as you said, the eye signs, one, point me more towards Graves' thyrotoxicosis than to either an autonomous or multinodular etiology. The second thing for me is that slightly higher T3 compared to the T4. That also points to me towards Graves' thyrotoxicosis. So the clinical presentation is not just hyperthyroidism, but thyrotoxicosis with the clinical features of it. The most likely diagnosis is going to be Graves' thyrotoxicosis. Would I stop there or would I want to confirm? Depends on, I think for me, the prominence of the eye signs and how keen the patient is to have a firm diagnosis. I have, I suppose, the luxury of practicing in a setting where resource is not the dictating factor for my practice. So in this patient, I would probably order a radioiodine uptake scan or a technetium, depending on what the next step might be and depending on what's more readily available. Because sometimes we do have restrictions in terms of availability of one or the other agent. So depending on
so it depends on where you train, because I'm a big proponent of I-131, and I can see I can promise you, Prasanna will do this. But I did ask Indrani this morning, who's doing a beautiful nuclear medicine talk in our other meeting, and so if for convenience it's technetium. For the purists like me and those who want more things like uptake, which is use iodine. So the question is, again, we will quickly run through it. But in an urban situation where you have access, would all of you get an imaging first? Puneet?
Yes, probably I would get I agree with Dr. Anantharaman that the diagnosis is Graves' disease. Likely there are lymph nodes, there is a little bit of proptosis. The diagnosis is Graves' disease. But as Dr. Usha also said, when we practice, what happens is many patients want to know more. They want to know why this happened. They want to know what's going to happen to me. And then, you can do the nuclear scan, uptake scan, and that will tell you, you can even prime the patient before the nuclear uptake scan that if the uptake is high, that means your gland is going to make a lot of hormones and you need medicines for 1.5 years surgery, etc. Where on the other hand, if the uptake is less, it'll be self-remitting, and this is the best way to know that. And because of the urban kind of fussy patients that we see nowadays, it is better to do the nuclear uptake scan. But I agree with Dr. Anantharaman that, if I had been in, say, CMC Vellore many years back during my training, I would have just started on carbimazole in those days.
Not just CMC Vellore. When I trained in Oxford, if you had eye signs, you didn't order anything else. You got on with the treatment.
So because if you
clinical diagnosis and get on with the treatment.
But remember that this is also good science in the sense that when you have eye signs, your pretest probability of disease is around 91%, and you add one more sign and it becomes 96%. The predictive value of a positive test does not improve much after that. So it is actually good science. It's not just it's just so that is the issue. But again, this is not the purpose of our talk. So what our discussion? So just to sort of say that it sort of distinguishes between high uptake and low uptake thyrotoxicosis. Low uptake thyrotoxicosis, self-limiting. Dr. Unnikrishnan spent a beautiful 20 minutes on that this morning. And those of you who are interested, please, these sessions are available for you to view. But we will move on to this increased or where there is hyperfunction. Three diseases: Graves, Getz disease, which is the name of the solitary thyroid nodule. Emil Getz described it in 1911. And of course, Plummer. A lot of people think that this is Plummer's disease. No, this is Plummer's disease. So let's move on. So we have spent enough time on TSH receptor antibody. I won't spend too much time on this. We will take it as a consensus that most people don't require a TSH receptor antibody to make a diagnosis. But will you use this to plan therapy? I've put in the comparisons of RAIU versus TRAB. Maybe who wants to start? Prasanna or Usha or Anantharaman, whoever wants to start, and only anyone can take this up.
Can I start there?
Yes, please.
So I think we've all agreed that clinically we know this is Graves' thyrotoxicosis. If we do a radioiodine uptake scan, it's likely to confirm it with near 100% certainty. So for me, the only thing is, is there an argument to be made for testing TRAB in this particular patient? And I would suggest that there is one and only one argument from my side, in that she's a young woman who may plan a pregnancy in future. She's 26. And the presence of TRAB antibodies now, and maybe a suppression in pregnancy or a presence and their relative level in pregnancy may, I'm not saying it will, but may guide my monitoring and may guide my treatment in pregnancy. So that, if at all anything, that would be the only argument I can make for doing a TRAB at this stage.
So Anantharaman, can I just supplement that question and ask you, aren't you interested in knowing the baseline levels of TRAB, especially if you're contemplating medical therapy to see remissions? Are you interested in this? And then we will get Prasanna and Unni on the same question.
I don't think there's enough evidence to say that, we need serial monitoring of TRABs basically. So you measured the TRAB today, and then you measure it again after 6 months or 8 months. A downward trend would probably help in saying that this patient may remit. But when you put it to the proper filter of evidence, I don't think it's really beneficial. So because I've had many patients where the TRAB has been negative, and then we have withdrawn the antithyroid drug, and then the patient relapses within 1 or 2 months. So both false positives and false negatives abound. So the likelihood ratio, of serial monitoring of TRAB, I don't think there are enough studies to use it clinically as yet. So I would probably wait for some more evidence to build before, routinely using it in practice. So if at all we are saying that TRAB antibody should be used to assess whether this patient will go into remission or not. So what is that level of TRAB antibody and how much it should drop by? We really don't know actually.
Unni?
I completely agree. Yeah, I completely agree, because I have also, seen this data where TRAB, just before stopping, some papers have suggested that at the end of 18 months, before you stop the antithyroid drugs, you do the TSH receptor antibody. If it is low or normal or undetectable, you can go ahead and stop the antithyroid drugs. So I've stopped the antithyroid drugs, and after 2-3 months, it has come back. So I have not found this to be very relevant in clinical practice. And also it's a costly test to keep on doing TRAB. It's not like doing, say, random blood glucose or something like that. It should keep on doing TRAB. So I don't really believe in that TSH receptor antibody should be done at any time. Yes, two things are that if you are in a very academic setup, scientific setup, if you think that there is a very high initial TSH receptor antibody, and at the end of 6 months, there is a dramatic fall, those people are likely to remit early, and the sensitivity and specificity of this is around 60 to 80%. But I don't think all this is relevant in practice. Like Dr. Prasanna Kumar sir said, go by your clinical acumen, follow up the patient, and then decide. I think one of the areas where TSH receptor antibody is useful is only in the pregnancy situation where you can't do nuclear scan. And also I remember reading some reports that even in neonates, the 3rd generation TRAB is not reliable. So even some normal healthy neonates get TRAB positivity in neonates. So these are some points to remember.
Prasanna, baseline TRAB?
2 things I want to say. No, let me come back also. In the last 15 years, nobody in Bangalore does iodine scan unless you specifically ask for it. Uptake is really not necessary, because even for radiodiode, nobody calculates what is your uptake and all those things. Even in technician scan, and I remember 30 years back, 2 hours, 4 hours, 24 hours, 48 hours, nobody has time money patient, except in government hospital. Of course, in some situation where particularly you say, no, I want iodine scan, they will do it. So that is one thing. I always will do, even though eye symptoms are there, I have burnt my fingers, I will always do, I will never, even a villager comes, I can get free, doesn't matter. I will always get the technician scan before I start even antithyroid. Even if somebody has started, I will ask him to do with antithyroid, it's not going to see. Regarding this TRAB, I will never use unnecessarily because expensive. At the beginning, all the data I shown, it is useless. Only at the end, 2.5 years, you want to withdraw that the TRAB is, the titer is less, the chances of relapse is less. That's all, even not 0. Even that I have finished that set. And even you don't need it, because if somebody is needing 15 milligrams, why do you want to do TRAB? With 15 milligrams, he is thyrotoxic. He is not. Forget about your TRAB. He is not going. Unless somebody is on 5 to 10 milligrams, euthyroid, then only I withdraw. Otherwise, don't. So I don't use though all my patients can afford neither at the beginning nor at the end, unless it is absolutely necessary in specific cases, as Dr. Unni and Dr. Usha said.
Okay, so let's go to the treatment options in this patient. There was a time you would discuss 3 treatment options, and then it became 2 options. And over a period of time, we have a lot of data building up to offer medical therapy as a first option in many of the patients. So in your own practices, and again, now we will start with Unni and go back. How has this changed? Have you changed the way you discuss options with patients? Why is it? And your own philosophy about treatment of thyroid disease with medicines or otherwise, has it changed over the years? Unni?
So one thing I want to say here is that, yes, earlier I used to say there are 3 treatments. There is surgery, there is radioactive iodine, there is medical treatment. Now, most patients, over the years, I found that the best person to make the decision is the patient. We can only say the pluses and minuses of each. Now, one area is that because we are endocrinologists, we are not surgeons, we are not nuclear medicine doctors, we may have a inherent tendency to offer medical treatment because we are, after all, medical people. So keeping that in mind, I always discuss all the 3, but usually, I don't know if it's because of my counseling, patients choose medical therapy. The second thing what I found is, I don't know if I'm right or wrong, I'm not very rigid about this 1.5 years of anti-thyroid drugs anymore. Earlier, I used to be very rigid. Okay, 1.5 years after that, stop and go for radioactive iodine or surgery. Now I don't do that anymore because I found value in a lot of people taking anti-thyroid drugs for a long period of time and they are okay with it. So it's their choice. If somebody is going to take, say, sitagliptin for 30 years or say vildagliptin for 30 years, why not they can take this drug which really doesn't cause any problem except for the very rare occurrence of agranulocytosis. So now there is a lot of accumulating evidence that people on long-term anti-thyroid drugs are doing well, and we should be open to that possibility. I'm not saying give long-term anti-thyroid drugs. In my practice, after 2 years, definitely I offer them radioactive iodine therapy, and if they don't go for it, I continue medical therapy. But the other situation, very rare situation, is people who are going to travel on some ship or merchant navy. They may not be able to monitor the thyroid functions. Those kind of professions, I prefer to do radioactive iodine therapy and then cure the problem. And also for people who don't want to take medicines long term, this is a good option. Another situation is pregnancy. If they are very young, I tell them you go for radioactive iodine therapy, and after 6 months or a year, plan pregnancy. But to put it in a nutshell, I've become more open to the possibility of longer-term anti-thyroid drug therapy medically.
We will discuss this indefinite thyroid therapy towards the end of our discussion. Usha, has your opinion changed?
So I would still offer her medical therapy as a first line for a few reasons. I think most of them have been enumerated by Dr. Unni. She's young. She may or may not want to take thyroxine replacement therapy long term because patients don't perceive the difference between taking ATD or thyroxine therapy. To them, a pill is a pill is a pill, monitoring is monitoring lifelong. And from that point of view. And most of these patients come into remission. There is a good 60% chance, depending on her uptake at the beginning, that she might come into remission, and there will be less complications for a future pregnancy in a woman who is remitted and on no therapy than on either option at either end, either radioiodine therapy and thyroxine replacement or surgery and thyroxine replacement or ongoing ATD therapy. On the other hand, should in 18 months or so, should she not come under control? I think I would agree with Dr. Unni. Again, considering the...
So let's park this 18 months for a while, because let's just confine right now.
So I would stay anti-thyroid drug therapy for the beginning, consider everything else in the future.
Okay. Anantharaman, have things changed since the time you started practice?
Definitely, sir, because like Dr. Unni is saying, so I don't stop after 1.5, 2 years of therapy. And I continue to offer the anti-thyroid drug because, we know even in the 1.5 years or 2 years, when you actually try to reduce the antithyroid drug and the TSH value drops or the patient becomes thyrotoxic, then there's very less likelihood that you stop the tablet and then, the patient again will go into remission. So, and if the TSH is on the lower side, so the TSH is about 2.5, 3 while on treatment, say 5 milligram or 10 milligram, to reach your down titrated. And if the TSH value is above a certain value, say 3 or 4, then the chances of remission are much higher. So I'm very comfortable with continuing antithyroid drug. And also another point is that I feel the radioiodine works very well when you give it right up front rather than wait for 1.5 years and give. So our earlier protocol of giving antithyroid drug for 1.5 years, then giving radioiodine probably does not work very well. So if you give upfront, so I think in the US the practice is to refer the patient to the nuclear medicine specialist. So as soon as they arrive, though at that point I think the success rate is much higher. But if you give antithyroid drug for about 1.5 years, I think there's some evidence to say that the radio sensitivity will be lesser and the patient may not have as much success with radioiodine. Again, they'll come back to you. Again, you'll have to start the antithyroid.
So Prasanna has probably the largest experience of radioiodine in the subcontinent, if not a big part of the world. So Prasanna, you've been doing radioiodine for a long period of time, but are you doing more thionomides now than radioiodine? Has your practice changed?
No, my practice has not changed. Whenever patient comes, Graves' disease, I give one page. Previously I had my own. Now I give American Thyroid Association. Know your disease, what is Graves' disease, how it occurs, what are the treatments. I tell them, take your time, ask your husband or children or father or mother, come on. Now, this is what I did even 35 years back also. Some patients say, doctor, let me try tablet and then see others. And also they ask them, what is the advantage, disadvantage? What is the advantage of surgery, disadvantage? I tell all this, now you choose. It's a cafeteria approach. Everything, we want coffee, tea, badam milk or beer or whiskey. It is you who are drinking, which is good, all are bad. Nothing is good. So you choose what it is. One extreme American, 80% is to be radioiodine. The Air Force pilot in Japan used to take antithyroid lifelong, no question of radioiodine. So there is data to say they have taken 3 decades. And I had patients who have taken 16-year antithyroid drug in Bangalore. After that, I said, you want to continue? She has become 34 kg. No, 1 dose of radioiodine. But still, a lot of people prefer, I want to continue antithyroid. And I never reduced at 18 months. It was 24 to 30 months. Even now I say 24, 30 months. I tell them, now I have taken, still you are on that. Would you like to continue radioiodine surgery? Nobody prefers surgery. Some people still say, no, I don't want that. And there are people who have taken 2 doses, refused the 3rd dose of radioiodine, 10 years they are on antithyroid also. Ultimately, I feel it is patient choice. This choice is informed choice. It is his body. I don't want dictators, but sometimes patients ask, sir, if you are a doctor, what will you do? If I am the patient, I will not take antithyroid, I will take radioiodine first. Okay, sir, give me that. It is patient choice.
Okay. So the patient was offered treatment options. She preferred medical therapy. We won't spend a lot of time on this, but especially about PTU. Let us spend, let's talk about duration. The second is this whole methimazole versus carbimazole thing. Let us spend some time on this. Anantharaman, you wanted to start with this?
Answer to question number 1 is I start with carbimazole. I mean, I don't see the difference between carbimazole and methimazole. I'm used to giving carbimazole, so I continue with it. I feel that the number of milligrams is more and it's easier for me to adjust the doses. I can give as low as 2.5 milligram of carbimazole. So, PTU I do not usually initiate except for the first trimester of pregnancy. I mean, only when there is pregnancy, I switch to PTU and then put them back again on carbimazole.
Usha, once a day or twice a day or 3 times a day? Do you start with 2 or 3 times a day and then reduce? I just do a single day. So
I know that there is some small evidence to suggest that at least initially, if you do twice daily, But to be honest, I think that the compliance and convenience for the patient is much higher if you just give it to them once a day. You have a choice of doses 5, 10, 20, mix and match and get them to the correct dose and let them take 2, 3, whatever the number of tablets is in one go. Easier to remember, easier to get them to do it.
Only
Carbimazole once
6, 12, 24, 18. What is your pick? What is your pick? Eeny, meeny, miny, mo.
So
well,
once daily carbimazole.
I completely agree with Dr. Anantharaman and Dr. Usha that no, we have been using carbimazole for so many years, and whether we like it or not, we doctors have a default brain that works. Whenever we think of a disease, we think of a medicine, and it's usually carbimazole. If I were to look at it very objectively, without the carbimazole being in the brain for a longer period of time, I don't think there is any difference between carbimazole and methimazole in clinical practice. But because we have more years of experience in carbimazole, which has worked well, I always prescribe carbimazole in the majority of my persons. And of course, the duration, I tell the persons, if I treat you for 1.5 years, the chance of remission is 50%. If I treat you for 2 years, it goes up to 75%, and then we will discuss later. But I use carbimazole in my practice, and I use it once a day most of the time.
Okay, so this patient was started on 30, reduced to 20, then to 10. And 2 months later, the patient feels better. Menses is normal. She has gained 2 kgs. Tremors no tremors are seen. So we're almost 6 months into the therapy. Now the free T3 is 2.1, the free T4 is 0.8, and the TSH is 4.2. What would you do? Usha, you want to start?
I guess we have 2 choices here. My choice would be to actually further titrate the carbimazole dose rather than to go for a block and replace. And the choice here for me is one, training. As Dr. Uni just said, this is how we are bred and brought up. Second thing for me is when you block and replace, you always require a slightly higher dose of the blocking agent. And whatever you tell me, yes, the relative risk of side effects is low, but even with the relative risk of low side effects, I would rather take the lower rather than the higher in the relative. So if I can get them to 5 mg of carbimazole, for me, that's always a better risk bet than even on 10 mg with a block and replace. So I block and replace extremely rarely in the very difficult patient in whom you can't get to it any other way. But my usual choice is to titrate down the carbimazole and then see how they maintain.
Anantharaman?
I mean, unless I have if the patient will not follow up, if this happens within 2 months, the TSH going up, what I do is I shorten the duration of follow-up and down titrate the carbimazole. I don't do the block and replace very often. I don't know why, but probably block and replace works more effectively in the long run. I mean, if you look at it as a strategy, it looks probably, it's more attractive. I use it for situations where the patient is elderly, cannot come for follow-up. Somebody needs to bring her for follow-up. So in that scenario, I will be blocking and replacing. But otherwise, if the patient is young, is able to come for follow-up, I would probably reduce the duration of follow-up and reduce the down titrate the carbimazole.
Uni?
I would certainly agree to that. I would down titrate the carbimazole dose. That's what I would do in this case. Block and replace, very, very rarely used in my practice. Conceptually also, while it works in some people, giving one drug to reduce thyroid function and giving one drug to increase thyroid function seems a bit like giving some glucose and insulin together at the same time. Well, that's also done in some cases, for example, in hospital control. So it probably has a role, but it's a very selective and rare role. So I would probably reduce the current dose.
Prasanna, are you there?
Yes.
Yeah.
Anyway, Uni gave an example of insulin and glucose. For Krishna, I will not give that example. When you are doing yagna, you are putting ghee and also water to the same. You want to extinguish the fire or you want to grow it more? I don't know what it is. I have never used block therapy. And the basis for that was mostly surgeons in UK were doing. It was not popular in USA also, India also, all over the world. Yes, I agree with all of them. I will reduce the dose. Many times I have given 2.5 milligrams because minimum period I treat them is 18 months, unless somebody gets cured in 1 year, very rare. Go up to even 30 months and then check the thyroid receptor antibody. If the antibody is negative, then I will have more courage to stop the antibody.
Okay, so it depends on where you train. And initially, we were all sort of taken up by Hashizume's article that talked about, greater reductions and antibody reductions at that time by Hashizume. But all of us, the one poor outnumbered person is me, who actually use a lot of block and replace. More for convenience, because what you do is, whether you bring it down to 5 or 10, if you add thyroxine and keep the TSH somewhere in the normal or a lower limit of normal, number of visits are less, the patient is more comfortable. And I in my personal view, and I have done this for years, I find that compliance is improved. But for each course, there is not really data to support whether one is better or the other. So in this patient, we did add thyroxine and had the TSH around 0.1. I think we've done enough of pregnancy bit, so I will remove the sidetrack in interest of time. At the end of 18 months, the patient is on carbimazole 10 milligrams and LT4 88 micrograms. The free T3 is 2.1, free T4 is 1.4, TSH is 0.06. What will you do now? Let me give you some clinical thing. Her thyromegaly is sort of reduced. She's asymptomatic. Things are fine. What would you do at 18 months?
Shall I start?
Yes, please, please.
I would simply stop her carbimazole and just see how she goes, because that suppressed TSH suggests to me that the gland has calmed down. I would simply stop her carbimazole, possibly even down titrate her thyroxine given her suppressed TSH. No. Maybe even stop it, recheck in 4 to 6 weeks. So I'd probably just stop the whole lot, recheck in about 4 to 6 weeks. To be honest, I'm not a great, I don't routinely check antibodies when I stop therapy for 2 reasons. One, as Dr. Unni and Dr. Prasanna Kumar have said previously, it's very granular. The antibodies only provide you reassurance. I don't think they're that predictive in terms of what the remission is going to do eventually. And the second thing is, I think most of us have seen enough of grapes to get a feel, if you will, by how quickly they settle, what dose you require clinically, what their eyes and their thyromegaly and their heart rate and the rest are doing. By a combination of clinical features, the rapidity of settling and their dose requirement, I think we get a feel for when we can stop, be that 1 year, 1.5 or 2 years. And I'm just somebody who says, well, there is a 60, 75, whatever chance you'll go into remission, depending on when we stop.
So
we
Usha,
take our chances.
So now it's my turn to needle you a little. Did I hear iScience? Don't they run an independent course? So, I mean, would you use iScience as a reason to the thing? Because don't they completely run an independent course?
I wouldn't take iScience as a reason to stop or continue therapy. But at the initial discussion, when I have right at the beginning, now not 18 months, but somebody who has a large goiter, somebody who has florid iScience, I might advocate a word of caution in these people. But at the point of 18 months or 24 months, I don't think any of this makes a difference to me when making a decision to stop. If they're getting a TSH that's climbing on a tiny dose, 5 alternate days of carbimazole, I think the time has come to have that discussion about stopping.
Okay. Now, let's say this patient actually got a second opinion and has a TRAB done at 18 months and it is over 3. What would you do?
I would send her back to the doctor who did the TRAB and say, deal with it.
Okay. You have a large practice. Only what would you do?
Well, if the TSH receptor antibody is more than 3, I would probably, say that, okay, let's continue treatment for some more time, because the chance of remission isn't much there. And also the TSH is also on the low side. If I remember, you had shown the TSH is on the low side.
No, but that was thyroxine induced. So remember, okay, the patients also.
So I would probably continue for some more time. But as Dr. Usha said, I wouldn't order the test. But if it's already done, I'd probably say, okay, now you have done this test. Let's wait. Let's continue treatment. Let's plan for another 6 months and see. So I may push that 18 months to 2 years.
So if you have a
All
devil, you
jokes
still have to
aside,
deal with
sorry,
it, right?
all
The devil was a
jokes
test.
aside,
Yes, Usha.
with this trap, I'd stop her thyroxine and see what her TSH does. If it remains suppressed, then we need to talk either longer or definitive management. If with releasing the thyroxine, the TSH comes up and behaves differently, that's a different discussion for me. So in this patient, I would stop the thyroxine with this trap and then see where we go.
Okay, this patient had a trap of 0.8, but I'm throwing up a 3 for you. Okay, Anantharaman, what would you do? 18 months stop, a measured trap, or let us say you have a trap that is elevated, what would you do?
Trap is elevated, it clearly indicates that the patient may not go into remission when you stop the drug, especially if he has remained consistently hyperthyroid throughout. There are certain situations where the trap can be high and it can be a blocking antibody. The patient might have had episodes of hypothyroidism, fluctuating thyroid function. So in that case, it's very difficult to predict where he is going to go. But in this scenario where the patient has remained hyperthyroid throughout for the last 1 year or so, and the TSH RAB is high, very high likelihood that they will not go into remission. And I'll probably continue the antithyroid drug.
Okay, so I'm going to move forward and let us say we've stopped the drug, the patient is in remission. What I generally do in my practice, and it could be quite wrong, is, I leave them on propranolol for a month. This is the only time I use propranolol. I take off the drugs, put the propranolol on for a month, and then they come back, repeat the testing. If they find, and they take off everything to say, maybe you're home free for a while, and follow them up. How often? Question quickly. In this kind of a patient who you've taken off the drugs, things look fine, how often will you follow the patient? And if there's a recurrence, what will you offer? Unni, we will start from you and then go backwards.
So if there is a recurrence, if there is a recurrence, then I would probably offer, of course, we'll have to initially reinstitute medical therapy to control the thyroid functions, but then I'd offer either surgery or radioactive iodine treatment. My choice would be, in today's world, radioactive iodine treatment, because it comes without the baggage of problems with surgery like, voice change and hypopara, and even the need for anesthesia and scar and all that. So that would be my choice in this situation.
You don't reinstitute medical therapy in someone who's recurred. Is that correct?
Sorry?
You don't reinstitute medical therapy in someone who's recurred.
I will certainly reinstitute medical therapy, but then I'll offer this, but it depends on the patient. Some patients say, no, doctor, you please continue the medical therapy. I don't want to go for any radio, iodine or surgery. That's their choice and I continue. But definitely at that point, I'd like to restart medical therapy and offer them this choice once more of a permanent cure. Whether they take it or not, that's up to them, because as I said, there's not that much evidence to favor anything over anything else, but I definitely do offer them at that stage.
Okay, I'm going to ask for one-line answers from the others. Usha? Recurrence.
Offer radioiodine, cover with medication in the meantime.
Anantharaman?
I'll again discuss the possibility of radioiodine with the patient, but now, like I said, I would slant it towards medical therapy only most of the time, and I'm not aggressively advocating for patients to undergo radioiodine as well, because it's an expensive one-time treatment again, and recurrences or failure of radioiodine is also pretty common.
So that brings again, this is an area that is evolving, and most of us are struggling because we have brought up with radioiodine as a definitive answer, but indefinite medical therapy has been done in Japan for years and years and years, and I think we can no longer ignore the thing that that even in a recurrence, medical therapy may be a possibility. I will leave it at that. I will. Is there any more? We are towards the end of discussion. I let KMP come up with his last comments, but before that, this is just amazing, the kind of this is hardcore endocrine discussion where the nuances are brought up by people who have both the expertise and the wisdom. They have seen, they have evaluated the evidence, but they also know how that evidence has to be applied in practice. And as Usha has tweeted it, I will say it again, that its knowledge is interesting and it's wonderful, but wisdom is the premium that our patients pay for. So with that, Dr. Prasanna Kumar, last words from you, and then we will thank everyone and move on to the next session.
Grace disease, all three options are fine. Ultimately, choice is patient. It is informed choice, and it's the duty of the doctor to say benefits, disadvantage of all the three, whether at the beginning of Grace disease or even when there is a relapse. Ultimately, accept the patient choice. He wants to continue antithyroid or radiating, go for surgery. That is how it should be practiced, rather than being dominating or dictatorial, say, this is the best treatment, this is the only treatment. That's all what I have to say at the end of it.
Thank you again for this wonderful discussion to all our illustrious faculty, Dr. Prasanna Kumar, Anantharaman, Usha, and me. Of course, it's been a special day for all of us here. Thank you so much. We will move on. And now we have three beautiful discussions. One is from, and all of these on how do I, somebody with hypercalcemia, asymptomatic hyponatremia, and a person with a hip fracture. And again, from Masters of the Art, we have Dr. Badada, the foremost expert on parathyroid in the country today, Dr. Arpan Dev, and my mentor, friend, and guardian, Manoj Chadha. I want to introduce Dr. Mahesh, a consultant endocrinologist at Aster CMI in Columbia, Asia, and my long-term colleague and friend, Dr. Rajeshwari Janakiraman, who is also a consultant endocrinologist in Columbia, Asia. Dr. Rajeshwari and Dr. Mahesh, the session is yours. We will close at 13:45. Thank you so much. Dr. Rajeshwari?
Hello, sir. Good afternoon.
Hi, Sanjay.
Yeah, good afternoon. How are you?
I'm very good. I'm trying to get hold of the things are there, but the chairmen are there, but I can't see them.
Manoj, sir. Good afternoon.
Yeah. We have all the speakers. I think Dr. Rajeshwari has dropped off. So Sanjay, let me just start off without wasting much ado. Dr. Sanjay Badada is one of the foremost experts on hyperparathyroidism in the country. He's a professor of the Department of Endocrinology at PGI Chandigarh. His very interesting ability is to be able to do a webinar from a moving train. I've never seen anyone do that. So that is an added qualification. Dr. Badada, all yours.
Thank you, Dr. Krishna, for keenly observing what is going on. So I appreciate your keenness to that. In addition to the participating the seminar person, what it is doing is you are observing. But anyway, I want to tell you on that I was traveling to my hometown, and so I don't want to say no to also that, so that I thought let it do it on moving wheels, no problem. So allow me to share my screen.
Badada ji, are you in a place where a mask is required?
Yes, sir. I'm in hospital.
Okay,
right
perfect.
now.
Let's move on.
So, very good afternoon, and thank you, Dr. Krishna, Dr. Manoj, Dr. Arpan Dev, and the organizing committee for this opportunity. And the task assigned to me is that approach to a 60-year-old man with incidentally detected hypercalcemia. So these 2-3 things are there in this particular title, that one is 60-year-old men, but it may be women also, there is no problem. And same time, incidentally detected. This is a very interesting thing, because unfortunately, if you look at the symptoms of hypercalcemia are very, very non-specific. Like you talk about the constipation. The constipation is there in 60 years of age of maybe 30% of the people. Some anxiety, depression is another very common symptom. So that can be there with increasing age because some or other reason. So sometimes it is diagnosed incidentally, but we take a detailed history, then actually not incidentally the patient is having that kind of symptoms. So hypercalcemia is defined when any serum calcium level above the reference range. And the reference range are keep changing every 5 years. And it should be always adjusted with the serum albumin. And that is very another important thing for the young colleague is that, or the young students who are attending this seminar, that it should be confirmed by the repeating the test at least 2 times. On the single calcium value may not be sufficient to reach to the diagnosis. And sometimes we may require the ionized calcium as well. So looking at the etiology of calcium, according to the clinical setting is that you are dealing a patient in outpatient department, then they probably primary hyperpara is the most common cause. If patient is hospitalized and hypercalcemia, then probably malignancy is most common. But PHPT is biased because almost all patients do require surgery, so they will be admitted. In an emergency setting, again, the malignancy is very common, and of course, the PHPT is always with us, so that will be there. But there are certain rare etiologies are there of the hypercalcemia. These are really rare or not, but these are also there. Of course, less common than what I have described in my previous slide. That is granulomatous disorders. Lot of patients of vitamin D intoxication we are seeing nowadays. The reason is that, especially in the COVID time, the vitamin D was free flowing, whether it is oral or IV or intramuscular or something like that. So there is a lot of patients are getting vitamin D and coming with the intoxication. Others are rare causes, not that common. So hypercalcemia 60-year-old men, so the topic given to me is that if you keep in the order of the frequency of the hypercalcemia, then probably malignancy will top the list. Maybe vitamin D intoxication or PHPT. Though the PHPT in India, the mean age is around 40 years, but if in the Western population, the age is 65 years, in that case, the PHPT will be little higher on the order. And then, of course, granulomatous disease and some disorders are there. So mainly these 2-3 things are there: malignancy, PHPT, and vitamin D intoxication. Now, coming to the symptoms of hypercalcemia, it is important because when to suspect the hypercalcemia can be a cause for the symptom. And the absolute calcium level is important, as well as rate of rise of serum calcium is an important parameter that patient will develop symptoms. The rise of calcium is very rapid. And of course, age of the patient is also important because that can cause polyuria, they can cause dehydration, and the symptoms are more pronounced in the older patient as compared to the younger patients. Here in this slide, you can see that various symptoms related to hypercalcemia and with the grade of hypercalcemia. So the mild symptoms, the mild hypercalcemia is below 12, and moderate is 12 to 14, and the severe is more than 14. And as I mentioned in my opening remark that constipation, anxiety, depression are common symptoms of the hypercalcemia of the various stages, that is mild, moderate, or severe. So these can be symptoms of hypercalcemia, or these can be a non-specific symptoms. And of course, when you see a patient of renal stone disease, obviously primary hyperpara will come in your mind. And if the fracture is there, of course, again, primary hyperpara, rarely some malignancies come in mind. So that's why the message what I want to say here is that constipation is an important symptom. And if it is, say, prolonged, then definitely we should ask for this investigation that is related to the hypercalcemia. So hypercalcemia, if it is a PTS dependent or the independent, mainly there are 3 causes only. One is the primary hyperpara, followed by FHH, that is familial hypocalciuric hypercalcemia. So it is very hardly reported from our country, but nowadays we are looking some patients, those are there. And the lithium is another cause for the PTH dependent hypercalcemia. And remaining all are actually PTH independent hypercalcemia. As I mentioned, the malignancy tops the list, and the malignancies are multiple, and they can have the different kind of presentations. So how to approach a patient of hypercalcemia? First and most important thing is probably first to confirm the hypercalcemia. Also look carefully on that, what is the other part of the calcium profile, like what is the phosphate level, what is alkaline phosphatase level. So that will also determine what is the cause of hypercalcemia. But like William says, that urinary calcium creatinine ratio is very important, and that be able to differentiate between the what you call PTH dependent hypercalcemia versus FHH, though the FHH is not a very common problem. But what this algorithm says is that if the urinary calcium creatinine ratio is less than 0.01, then look for the PTH. If PTH is normal, consider FHH. If the PTH is high, then the possibility is PHPT is there. The urinary calcium creatinine ratio is less than 0.01. It is not less than 0.01, then there is either PHPT or lithium therapy are the two common causes. Obviously, we all know that how to approach a patient of primary hyperpara. And lithium, it is simple. Stop the lithium and see if the response is good. If not, then you can subsequently plan the workup for the localization. And if required, some patient may do require surgery. If that after stopping the lithium for more than 3 to 6 months, the calcium hypercalcemia persists, they may do require the surgery. Now coming to the PTH independent hypercalcemia. So it depends on the serum phosphate level. And if his serum phosphate is low, then it is most likely PTH-RP mediated, and that is because of the humoral hypercalcemia of malignancy. If serum phosphate is normal or high, then these are the three few causes are there. That is local osteolytic metastasis, granulomatous disease, and vitamin D intoxication. Now I'll take interesting cases in next few minutes. That is the 60-year-old male patient presented with dyspnea on exertion. On evaluation found to the low hemoglobin. That can explain the cause for the dyspnea. But same time, when looked at the serum creatinine, that was high, and also calcium was 12.8 milligram per deciliter. Alkaline phosphatase was 82 international unit, that was normal, well within normal limit. Phosphate was normal, and the PTH was low, that was 5.8 picogram per ml against the normal value of 5 to 65 picogram per ml. And vitamin D was, you can say, vitamin D deficiency, and the AG reversal was there, and the ESR was elevated. So I'm sure here you can say PTH independent hypercalcemia. So that cause is clear, and most likely maybe some malignancy, though the phosphate level is 4.1. If it is low, then it is PTH-RP mediated. So here another very important finding in this particular slide, to reach to the diagnosis of hypercalcemia, that is, I think, alkaline phosphatase. When we investigated this patient, this was the picture, and that you can say classical lytic lesions are there in the X-rays skull lateral view. Then subsequently, obviously investigated and found to have the IM spike was present. Bone marrow aspiration shows the 34% of plasma cells, and the diagnosis was multiple myeloma, and was managed on the line of multiple myeloma. So in this particular patient, even looking at the calcium profile, that is serum calcium phosphate, albumin, alkaline phosphatase, and PTH was sufficient to make the diagnosis. And that was the clue, was the low alkaline phosphatase in this particular patient. So message I would like to say is that look carefully on all the component of the calcium profile. Why in the myeloma or multiple myeloma, the serum alkaline phosphatase is normal? We know that myeloma cells secretes various cytokines, and that will act on the osteoclast, and that is responsible for the mature osteoclast, that is responsible for the bone resorption hypercalcemia. But you look at here, in addition to the myeloma cells secrete another cytokines, those are actually inhibiting the osteoblast activity, and that is the cause for the low alkaline phosphatase or normal alkaline phosphatase in spite of sky high level of calcium. So calcium profile was sufficient to make the diagnosis in this particular patient. that low alkaline phosphatase with low PTH with high calcium, most likely diagnosis was the multiple myeloma. Now coming to the malignancy-related hypercalcemia, this can be because of multiple mechanisms. One is PTHRP related. If PTHRP related, as I mentioned, maybe low phosphate will be there. And the PTH, sometimes some malignancy can secrete PTH, though it is very difficult. This is a large peptide and not easy to synthesize by the malignant cells. Elevated level of vitamin D, that is in the granulomatous disorder, some malignancies like lymphoma that can present with the high calcium because of elevated 125 dihydroxyvitamin D. And certain malignancies, those are known to cause osteolysis, can cause hypercalcemia. Those are the breast and lung as well as the myeloma cells. Now coming to another second case, the 60-year-old male patient, constipation from last 3 months, no response to the laxatives. And as usual, he contacted the gastroenterologist and he underwent detailed evaluation. So calcium was 13, phosphate is 5, PTH was 4.5, and vitamin D was 186 nanogram per ml. So on further probing, there was a history that he received multiple injections for the bone pain. And interestingly, the patient continued that injection. He was given one injection by an orthopedic surgeon for the bone pain, but he continued himself. That injection had some benefit. So that led to such a high level of serum vitamin D, and that patient presented with the hypercalcemia and constipation, not responding to the laxatives. So that is important. Sometimes the oral vitamin D generally does not cause vitamin D intoxication. But recently we have seen patients, if oral vitamin D is given very frequently in high doses, it can also cause the vitamin D intoxication. Coming to the another patient, 60-year-old male patient, underwent total thyroidectomy for the follicular thyroid carcinoma, and he had a iatrogenic hypopara. And in emergency presented with recurrent vomiting and drowsiness, and so thought the diagnosis patient might be having the myxedema coma, because the patient is basically presented in emergency with the drowsiness. So send the routine biochemistry. And many times our emergency people do miss the serum calcium level. That is not an important metabolite, because a lot of emphasis is given on the sodium and potassium rather than the serum calcium. But here you see the patient had a total calcium of 13.6 milligram. Creatinine was 2.3, and the interestingly pH was sent, and that was 7.6. So, and bicarbonate is high, PTH was low. So obviously, you know what is the diagnosis. And on history, that found that patient had high dose of the calcium intake, 14 gram of calcium he was taking, calcium carbonate, and that lead to a condition of the metabolic alkalosis, and that is the milk alkali syndrome. So not very common, but the detailed history is sufficient to make the diagnosis in this patient. Coming to the other patient, 60-year age is because you asked me to stop the 60 years, it may be 65 years also. So 60-year-old male patient with diabetes and hypertension had a history of reduced urine output and presented with altered sensorium last 5 days, E2, V2, M5, and the calcium was high. And since calcium was high, so sensorium improved with the saline diuresis partly. And we found that compression fracture on evaluation D11 2 years back. So he was on the oral risidronate for last 2 months, but there was no history of vitamin D intake or the calcium intake. But here the history of over-the-counter analgesics for the backache. Looking at the calcium profile here, you see the corrected calcium was high, phosphate was low, PTH was also low. So calcium high, phosphate low, PTH low. So the diagnosis goes in favor of the PTH independent hypercalcemia, and most likely PTH-RP related. Vitamin D was 22 and 125 is normal, so that exclude the granulomatous disorders. CTX was elevated, P1NP was normal, and SPAP, UPAP was negative, and creatinine was initially high. That is because of the hypercalcemia. Subsequently was decreased, but still it was high. BMD was suggestive osteopenia or maybe osteoporosis. So workup done for the PHPT, negative. Workup done for the multiple myeloma, in view of hypercalcemia, anemia, and renal failure, but that was negative. Even underwent bone marrow also, that shows 3% plasma cells. Milk alkali, unlikely. ABG shows no alkalosis. So it was possibly the humoral hypercalcium malignancy. PTHRP could not be done because patient was not affording. All markers for the malignancy was negative. Lymph node biopsy was done. That was inconclusive. FDG PET was done, and that shows a some lymph node in 1.8 to 1.6 centimeter size around the diaphragm. So there was no obvious cause. So from this particular patient, I just want to say that in spite of the best effort and the best team is working under the best facilities, still you may not be able to find a cause for the hypercalcemia. And that was reported in the largest series, maybe 5 to 10% of patients, we may not be able to localize the cause. So obviously this patient was managed with the calcitonin nasal spray and Jolidronate infusion. Patient was discharged with the serum calcium 10.4, readmitted after 3 weeks. But meanwhile, COVID came into the picture and patient became COVID positive. And so had to discharge and plan for the follow-up. But unfortunately, we lost the follow-up of this patient, so I don't know what was the cause of hypercalcemia. Coming to another interesting patient, just in maybe 1 or 2 minutes, 60-year-old male patient presented with new onset dyspepsia. Obviously, reached to the gastroenterologist. I think we have to talk to our gastroenterologist that please get the serum calcium level. That is very, very important. So they planned upper GI endoscopy for this dyspepsia and some constipation was there. As a pre-endoscopic workup, ECG was done. That shows the ventricular premature complexes, VPCs. Cardiology opinion sought and workup for VPC revealed hypercalcemia. So see how interesting it is. Patient is having symptoms of constipation, patient is having dyspepsia, planning upper GI endoscopy, ECG done, then that is showing VPC, and then hypercalcemia was there. So calcium was 13 milligram per deciliter, PTH was high, 174 picogram per ml, creatinine was high, 2.2, though the creatinine was normal 1 month back. So that is evidence that hypercalcemia can cause renal dysfunction. Alkaline phosphatase was 74. So a little surprise for us that high calcium, high PTH. That is a PTH dependent hypercalcemia, and PTH is not showing any effect on the osteoblast. So that is very, very interesting. The LP was normal. Patient underwent system AB scan and ultrasound neck, and patient is actually mother of a radiologist, and this radiologist of metabolic bone disease specialist. So we did in the night itself the ultrasound neck and showed the right inferior parathyroid lesion was there. We're happy that patient is having the hyperpara treatable disease. So undertaken, but there is one thing I mentioned earlier, that alkaline phosphatase is a little tricky. Why alkaline phosphatase is 74 in spite of high calcium, high PTH? But fortunately that RIPA was localized, subjected for the surgery, and frozen section suggestive of the parathyroid carcinoma. Further surprise, in spite of parathyroid carcinoma, such high level of PTH, high level of calcium, alkaline phosphatase is normal. As usual, patient was okay. So obviously, as I mentioned, high calcium, high PTH, PTH dependent hypercalcemia, RIPA was found, but odd point was normal ALP. So we went on the SPF and the short M band. So bone marrow aspiration was done, and that is showed the 20% of plasma cells. So within 1 month, the patient was diagnosed with primary hyperpara. Patient was also diagnosed with the multiple myeloma. So the message here again I want to tell you is that sometimes there's two diseases of hypercalcemia can coexist, and that can alter the biochemical parameter. What exactly happened here was the normal alkaline phosphatase clue that this patient might be having. In addition to hyperpara, something else was there, and that was the multiple myeloma. I think I don't want to discuss a lot about the treatment part. We all know that there is a very standard treatment, but this patient has serum calcium 1 times 22. So subjected for the hemodialysis, and the plan for this, but this patient was operated upon. Serum calcium is now normal, and the plan is that to get the final biopsy report, that is parathyroid carcinoma or is minimally invasive parathyroid carcinoma, that will histopathology will tell. So I end my presentation by saying here that hypercalcium in elderly male often points towards an underlying sinister etiology. It may be male or female, that's fine. I think some female may object, you are talking male and male every time, so no, it can be any patient. Benign causes like PHPT and vitamin D deficiency are, however, not uncommon. Proper estimation of IPTS is extremely crucial. Look carefully for the calcium profile. That means calcium phosphate, PTH, alkaline phosphatase. That will clinch the 90% of diagnosis of the hypercalcemia. And sometime, in spite of best effort, you may not be able to localize any cause. So thank you, sir, and thank you very much.
Thank you, Dr. Patada, for a very nice and wide range of spectrum of patients, right from the physician, from the OPD or the ICU or the emergency team, gastro, cardio, anyone can get this hypercalcemia. So it should not be for physician. This is for every field of medicine. I don't see any questions in the chat box. To start with, I will ask you this urinary calcium creatinine. I think at this point, as the first step in ascertaining
questions were to come at the end, excuse me.
Huh?
I think questions were supposed to come at the end.
Okay. I thought because they are not to continuity, the hyponatremia, so I thought I will take the question. Okay. That's fine. Okay.
Okay, fine.
We can go ahead with the next, talk. For this, I will invite Dr. Arpan Dev Bhattacharya. He is a consultant in the Department of Diabetes and Endocrinology at Manipal Hospitals, Professor of Endocrinology, JJMC, Davangere, and he is a co-chair of Shiva Jyoti Indiranagar, Bangalore Diabetes and Endocrine Center. Welcome, Dr. Arpan Dev. For I think always he has a very interesting cases. We'll have a nice academic feast.
Okay, thank you very much. Yeah, my screen is visible and I'm audible, correct?
Yes. Yes.
Thanks very much. So next around 16 to 18 minutes, approach to a 70-year-old man with asymptomatic hyponatremia. I'm sure is all this Krishna's idea of this type of framing. I'm very, very happy with this. But interestingly, if you don't know, I'll tell you that. But for my slide preparation, I'm very grateful to these people. One is my good friend Bhagish Iyer and one more fellow, Dr. Ashita Das. Interestingly, the ADA primer, they just love me, always put me into sandwich. One side, the professor of endocrinology, PGI, another side, Mumbaikar Dawn endocrinology. I am in between with the sodium. Okay, let's do this a bit, start with a bit of a basics of it. So hyponatremia means sodium concentration is low, and traditionally we'll tell less than 135 because 135 to 145 is normal. It's a very common disorder. Up to 30% of hospitalized patients in the different cities has hyponatremia, whatever the reason is that. Most of it you still don't understand, particularly I don't understand. And there are hundreds and one of the causes are there, and I'll refrain myself to show you any of the textbook chart of the causes of hyponatremia. But certainly these three things you need to know. Spurious hyponatremia, which is basically a lab error or sampling error. Pseudo-hyponatremia, sodium is normal, but for something else it is coming. Like blood sugars are very high, patient receive mannitol, patient has paraproteinemia or very high triglyceride level and so on. We need to get rid of this, although they are uncommon condition, then we tell is real, it is true hyponatremia. So based on the duration, we divide acute and chronic. Probably days and weeks is the best way to tell acute and chronic rather than 48 hours. Mild, moderate and severe, 130 to 135, 125, 129, less than 125, based on symptoms, divided symptomatic and asymptomatic. But one thing is very clear, true hyponatremia or hyponatremia, unless proved otherwise, acute, symptomatic, chronic, asymptomatic. Now, this is my plan. The problem given to me, is approach to a 70-year-old man with asymptomatic hyponatremia. I'd like to hear the 5 headings. Why bother sodium in this gentleman? Who else is there? How do I assess this gentleman? What do I offer? And what my take-home message for you? So why bother sodium in this gentleman? Now, we all know acute hyponatremia has a severe substantial morbidity and definitely mortality. It can be because of the comorbidity, the reason why the patient is hyponatremic, but it is very important to understand that hyponatremia is not at all a benign disorder. More so, if we correct very quickly, we can create actually more problems. That is very important. If we neglect, but my patient is asymptomatic, okay? If we neglect, what happens? That's what is important. I am giving a sodium of 132. Okay, leave it. 132 is not that low. What happened? This is what happens. We'll have functional impairment, cognitive impairment, mortality increases, risk of fall, fracture increases, and osteoporosis increases. And these are the literature review. And the different time it's shown that if you have a mild chronic hyponatremia, in this particular series, it was 128 is the mean. Your mini mental state examination score has become less in comparison to people who have a normal sodium level. Attention span, postural assessment, gait, all becomes a problem. And this is very, very important. And again, it has been proven that people admitted in the trauma ward, emergency ward, had a milder form of hyponatremia, so-called the classic question here, asymptomatic hyponatremia, particularly elderly people, can cause a lot of problem, and we need to give due importance to this. So who else is there? Hyponatremia, I was very bold to put this, equals to hypoosmolality. This is what we need to accept it. In its literary terms, the significant hypoosmolality indicates there is more water related to the solute. Here we are talking about the sodium in the extracellular fluid component. You remember that water moves freely, both ECF and ICF. And excess total body water related to the solute, and this solute is basically, we are talking about the sodium. And this osmolarity is maintained by AVP and the thirst response. And our normal plasma osmolarity between 285 and 295. How do I assess this gentleman? So this gentleman has asymptomatic hyponatremia. He came with a medical OPD because asymptomatic, not in the word. His sodium was 131. We didn't repeat it. It is 130. It was a routine health exam, a routine health screen. So this is a true hyponatremia and asymptomatic. Now, even if we tell asymptomatic, like subclinical hypothyroidism, even if we tell asymptomatic, actually there can be some symptoms. Exactly what Sanjay told about hypercalcemia and the constipation type of thing. You don't know the constipation happens in the general population, but it can be a symptom of milder hypercalcemia as well. Here also, hyponatremia, when you are telling asymptomatic, people may, if you ask, you may see this about more fatigue, nausea, feeling dizzy, problem in walking, forgetfulness, confusion, muscle cramp, this all can be there. We need to remember in the back of my eyes. So clinical examination, I need to see the history of fluid loss or poor intake, vomiting, diarrhea, diuretics. Physical exam, mainly extracellular fluid volume depletion. This is the most important and the most difficult physical examination. I repeat, this is the most difficult physical examination to find somebody's extracellular volume status. Two statistically proven parameters, which sometimes we don't do, supports that dehydration, extracellular fluid dehydration. One is axillary dryness. I bet how many of us do. One is postural drop, which most of us will do. Otherwise, skin turgor and all those things, our dry tongue is not very actually reproducible. Also, at this same point, I want to see with fluid overload. With the patient with nephrotic syndrome or congestive cardiac failure and so on. And if we get in history of the comorbidity like chronic liver disease, chronic renal failure, Addison, hypothyroidism, all this we need to calculate. So this is my gentleman. I am examining this gentleman. I find him, he is in good health. At present, he is on no medication. His activity of daily living is good. His quality of life, by his definition, is good. He is not obese. He denies history of weight loss or fluid loss. Clinically, euvolumic. That's what I have put it. Sinus rhythm, normal blood pressure, and no postural drop. Systemic examination is normal. There is no goiter, no pigmentation. I think another wholesome sound is coming. So when I assess the biochemistry, I want to check the other electrolytes, sugar, liver function, renal function, uric acid, osmolarity, and also urine spot sodium osmolarity. So here I do this gentleman again. I check the blood test, which showed a normal complete blood count, blood sugar, renal, liver function. Uric acid is normal, 3.4. Chest X-ray and urine routine examination is normal. And here I bring these two concepts of urine sodium and urine osmolarity. Urine sodium I find very helpful. If it is less than 20, it suggests hypovolemia. If more than 40, it suggests SIADH. And if it is in triple figure, it strongly suggests cerebral salt resting syndrome. This gentleman is asymptomatic. This is an unlikely diagnosis, but for the completion of my talk, I'm bringing this diagnosis. And the serial monitoring of urine osmolarity, urine sodium concentration in response to saline can help in differential cases. Urine osmolarity, hyponatremia, there's low sodium suppressed ADH secretion. That means if your sodium is low, ADH will be low, so that free water clearance will be more, so that you will get the homeostasis concern. But despite hyponatremia, if ADH is very high, that is the pathology. And then we'll find that we are excreting a dilute urine. Urine osmolarity will be less than 100. I'll come to this in my discussion. But as I was telling you, the volume status is a wonderful way to assess the patient. This is only my cut and paste chart. Hypovolemia, urine sodium more than 20, it means we are using a osmotic or loop diuretic or something like that. If it is less than 90, means we are deficit, either losses, sweating, diarrhea, fistula, burn. If it is hypervolemic, sodium gain, hyperaldosteronism, rare condition comes, all those things. But if it is euvolemic, which is again reasonably common, urine sodium variable, it can be renal loss, it can be extrarenal loss. So question comes with two diagnoses, common to diagnose, SIADH and cerebral salt wasting. Two very important conditions to differentiate, because unless we are very critical, clinical feature may be almost same. But the treatment is completely different. Here you will restrict the fluid, here you will give more fluid. And that's what the assessment of the volume status comes. Here it will be euvolemic in SIADH, whereas in cerebral salt wasting, there will be volume deficiency. And this is because of the brain natriuretic peptide. Urine sodium in SIADH will be more than 40. Here, as I told you, it will be in triple figure, most of the time more than 90 to 100. So dehydration is present in cerebral salt wasting, absent SIADH. Urine sodium markedly increased in CSW. SIADH is increased, that is more than 40. Urine output, CSW increased, SIADH can be decreased. Uric acid, another thing, is not very helpful. CSW, it should be normal, SIADH should be decreased. I find particularly my clinical practice is not of great help, although textbook it has given quite a bit of importance. Let me come back to my gentleman. We have investigated, we found he is euthyroid, normal TSH, normal free T4. Morning cortisol 465 nanomole, normal response. We have a critical typical data, less than 200 likely deficient, more than 400 likely sufficient, 200 to 400 borderline. Urine sodium 54, urine osmolarity 255, plasma osmolarity 279, and here the diagnosis comes. So what is the cause then? This is true hyponatremia, we documented. He is asymptomatic, his cortisol thyroid normal, drug induced ruled out, is not on any medication, and salt loss from the kidney again has been ruled out. So this is the diagnosis. The gentleman has an SIDH, asymptomatic SIDH, giving a chronic hyponatremia. Clinical euvolemia, decreased serum osmolarity, increased urine osmolarity, increased urine sodium, normal thyroid adrenal function, and no recent use of diuretics. All of them fulfill the diagnostic criteria of SIDH. I have one more job for this gentleman. I need to find why he has SIDH. We have done a CT scan brain and the chest, both abnormals. At this point, we know this gentleman has asymptomatic hyponatremia because of SIDH, but we don't know why SIDH, and over the course of the time, we'll know what happened. What do I offer him? The first thing, fluid restriction, different definition is there. Better not to go very stringent. I will be thinking around 1.5 liter, pretty good. Encourage added dietary intake, salt, protein, and aquaretics. That's what available to us is called tolvaptan. Okay, so you should make sure before giving tolvaptan that the patient is not dehydrated, because otherwise patient will go again will be more dehydrated. That's the volume status important. Frequent monitoring of serum sodium is important. It works in the level of the kidney. Vasopressin acts on beta receptor, and this is the blocker. So it will cause the leakage of free water. So free water clearance will increase. And that's the reason, other than SIDH, even some cases of heart failure, hyponatremia, the nephrotic syndrome, it usually given for a short while. We have available 7.5, 15, 30, and 60 milligram. I think in our country, 60 is not available, but very importantly, we should use for a short while, maybe around few weeks, 4 weeks, 6 weeks. We need to monitor serum sodium, creatinine, and we don't over-treat it. That's important. Common error, isotonic saline, unsuitable for correcting hyponatremia. Sole unit indication is that if you are deficient, depleted extracellular fluid volume, unless it's symptomatic, hypertonic saline has no role. We should try again to avoid. Also, I started that we should avoid a rapid correction. No question of doing this, gentleman, a rapid correction. You always go very, very slow, because then we can create a bit of a more problem. An appropriate allowance should be given on ongoing fluid loss. That's very, very important. So that's my take-home message. Hyponatremia, particularly asymptomatic hyponatremia, is commonly encountered problem in the hospital, particularly when the routine screenings has come from everywhere, hospital and clinic as well. A prompt identification and treatment is important, and definitely we should try to find the cause of hyponatremia. And we should be based on more of a clinical judgment rather than, obviously we need a lab balloon, clinical rather than lab and algorithm. A careful monitoring is very important, and I think we are very clear about that slow but steady wins the race. Thank you very much. Be safe, stay healthy, please. All of us, we need to follow the COVID appropriate behavior still with us, and which is unfortunate. Thank you.
Thank you, sir, for a wonderful lucid talk on hyponatremia. I think it is very important that we try to find the cause and then decide on the appropriate medications. Before going on to any discussion or questions, we'll move to the next topic first, which is approach to a 62-year-old woman with recent hip fracture. For this, I would be honored to introduce next speaker, Dr. Manoj Chadha, who is the consultant endocrinologist at PD Hinduja Hospital, and also has his own center, Hope and Care Center in Navi Mumbai. I hand over the session to sir. We'll be happy to listen to you, sir.
Thank you, Mahesh, and thanks to the primer team and Arpan Dev and Sanjay for accompanying me in this session. It's always a pleasure to hear the two of them. And I've learned on record, I've learned something from both of you. So let me share my slides for today. And I think from two male patients, now let's talk about a 62-year-old female with a recent hip fracture. And unlike the first two cases, which were asymptomatic, there is nothing like an asymptomatic hip fracture. This patient is going to land up in the hospital. And it's a very unfortunate situation. Always look forward to trying to avoid these situations. 62-year-old lady, G3P2, postmenopausal since 12 years. She suffered a hip fracture after a trivial fall in the bathroom. She's been a hypertensive for some time and has been on amlodipine, fairly well controlled. BMI is 31, but overall she's been healthy, no history of diabetes. The beginning I want to mention here is that once the patient has had a fragility fracture, if you see an X-ray like this or the hip fracture, you have a diagnosis of osteoporosis. You don't need any more investigations to confirm your diagnosis of osteoporosis. The investigations are for other reasons. And I think once you have this picture, your orthopedic surgeon should be ready to operate on her as early as possible. During one of our recent discussions, we were talking about risk assessment of patients who have not fractured. But once the fracture is already there, it's probably too late to do the risk assessment. But it's important to get a little medical history, any long-standing complications, childhood problems, young adulthood problems, obstetric history. Nutritional history is also very important because very often our population doesn't reach a decent peak bone mass, and so they're at an increased risk of osteoporosis and fractures. Any prolonged medications, we talk about steroids, but I'm not going to go into the list, but we should know some of the common drugs that can lead to bone loss. Certain endocrine problems, thyroid, hypogonadism. At 62, we don't talk of hypogonadism, but if the patient is younger, we must look at the gonadal status. And most important, probably along these things, last but not the least, is the family history. Because of history of fragility fracture in the patient is equal to osteoporosis. A history of fragility fracture, especially in the mother, also is a very high risk factor for osteoporosis in the index case. So while we wait for an orthopedic surgeon, the trend now is to operate as early as possible. And while we are waiting, the first thing we need to do is relieve the pain. So whether we are using analgesic agents, local block is supposed to be very useful. Remember that osteoporosis is a silent disease till the patient fractures. Once the patient fractures, then it's a painful disease. And we get an anesthetist for fitness. Again, we ask for anesthesia fitness, but there's nothing like an unfit case for hip surgery after a fragility fracture. You're only talking of fit for surgery, high risk or very high risk. You can never not operate because of some unfit condition. So the standard preoperative care, cardiological evaluation, X-ray chest, a hemogram, they're looking at renal function, including creatinine and electrolytes. I just want to stress what Arpan Dev said again, that hyponatremia remains one of the important contributory fractures to hip fractures. Diabetes, at least the HbA1c, and you know what the glycemic status is. In addition, if you can do it with the same sample, I think Sanjay has also stressed on the calcium, phosphorus, and alkaline phosphatase. A rare case of hypercalcemia may actually present with a hip fracture. And possible at the same time or a little later date, a parathormone is a useful investigation. At 60, 65, 70, maybe you're not thinking of secondary osteoporosis, but just to complete the list, especially in a younger patient with a fragility fracture or a male at 60, you would think of secondary osteoporosis, Cushing syndrome, thyrotoxicosis, multiple myeloma. I think the history would be there and then appropriate investigations would be necessary. I made a remark that fragility fracture is equal to osteoporosis. So at that time, a BMD DEXA is not necessary. Please don't try to get this investigation done for a patient who's already in pain. But at a later date, to get a baseline is worth doing a BMD. The surgeon has operated, everything has gone well. The patient is in the recovery ward, day 2, day 3. We ensure that the vitamin D is sufficient. Time and again, it has been shown from different centers in our country that most of us are vitamin D insufficient or deficient. So they need to be replaced with whatever regime that you follow. The native vitamin D is good enough in a large majority of cases. Very rarely, if you do have a preference, a short-term 2 to 3 week course of activated D3 may be useful in this patient. Ensure that the calcium is sufficient in the diet, or else up to 1 gram of calcium has to be given in the form of tablets. And if PTH has not been checked earlier, then please ensure that this patient is not hypercalcemic, hyperparathyroid, or secondary hyperparathyroid, because that might influence your decision in terms of choosing therapy. Because before this patient leaves the hospital, we need to take a decision on the treatment for osteoporosis. This patient is a captive patient, and the patient and the relatives have to be given the options without going into too much of details, but it could be a bisphosphonate. Preferences for the parenteral intravenous zoledronic acid over the oral anandronate. But in terms of treatment, you could give either to the patient. I think I have something interesting in the next slide between the choice, but as of efficacy part, you could have oral alendronate working at about 40-50% reduction in hip fracture, and zoledronic acid about 70% reduction in subsequent hip fractures. Denosumab is a very good, useful, powerful anti-resorptive agent and has become popular in the last 3 years. Remember that there is no memory with denosumab. So once we say once in 6 months, the patient is given a 10 to 14 day leeway. Otherwise, they need to take their injection on time. Between the anti-resorptives and the bone forming agent, when it comes to hip fracture, probably teriparatide comes second to the anti-resorptives. We know that teriparatide is better when it comes to the cancellous bone, whereas it is not as effective as the anti-resorptives when it comes to the cortical bone. However, there are situations, especially if the patient has already had a history of Colles fracture and a lumbar compression, that you would like to start with teriparatide and then go on to the anti-resorptives. The important point is adherence to therapy. You may give the best treatment, generic versus the original and all those things, but the important thing is patient doesn't take your treatment, it doesn't work. And with oral therapy, it has been shown that the adherence is less than 50% at the end of 1 year. 13% of patients actually never start their prescription after leaving the osteoporosis clinic. And that is why after hip fracture, you must think in terms of starting the therapy while in the hospital. And that's where zoledronic acid scores, because you have 12 to 15 to 18 months to get the patient again to you for starting the second dose. Unlike hypertension, diabetes, thyroid, where you never talk of duration of treatment, with osteoporosis, it's always for a finite period. It's another long period of discussion, but the important thing is teriparatide, 18 to 24 months. Depending on the bisphosphonate, it's 4, 5, 6 years. Alendronate could go up to 10 years. Denosumab, efficacy and safety has been proven for 10 years. And we'll skip this part of the holiday part. So in the past, we used to worry about giving anti-resorptives to a fracture patient because anti-resorptives influence the osteoclast function and you need osteoclast for healing. But I think that fear has now gone away. You can be assured that it doesn't interfere with bone healing. So you can start your anti-resorptives on day 3 or day 4. And this interesting study looked at delayed fracture and whether zoledronic acid was a culprit. And you can see in most cases, whether it was delay more than when zoledronic acid was given within the first 2 weeks, 2 to 4 weeks, or on follow-up after 4 weeks, it was about the fracture healing delay in small cases was about the same with both the zoledronic acid or placebo. So I think this fear is now more or less over. And it has also been seen that denosumab does not interfere with fracture healing. There's enough data on that part. What has to be, I think, clarified to the patient and the relatives is that we are talking of a finite period with one drug. So there is anabolic therapy, which is followed by anti-resorptive therapy. You have oral bisphosphonates followed by IV bisphosphonate. You have IV bisphosphonate, which could be changed over to denosumab for some reason. And the denosumab followed by IV bisphosphonate. So either permutation combination, There may be certain advantages which I really can't discuss that today, but again, stressing on the fact that duration is important. And as far as possible, I mean, there may be a situation in practice where the patient is on antiresorptive therapy and then needs teriparatide. Please go ahead, although data has shown convincingly that this is not as good as teriparatide followed by antiresorptive. And very quickly, the advantage of using now a teriparatide with denosumab, you have got data from what is called as data extension. And this was a small but a good study for 2 years, and then was extended by another 2 years to see if you keep your eye on the blue line, that's the teriparatide line, you find that you get that is the denosumab line, you get the maximum increase in BMD at the lumbar spine, femoral neck, at the radius, and at the total hip. But when you look at the extension, the switch study where teriparatide was changed to denosumab, that was the blue line, they did best. What was worrying was denosumab to teriparatide, which if you see here, 6 to 12 months go in reversing the effect and may not be the best form of therapy. But yes, there are situations where from denosumab, you may be forced to go into teriparatide, another fracture or an atypical fracture, which is another separate talk. But probably what is summarized from the data extension and the data switch study is that teriparatide to denosumab or combination of teriparatide denosumab to denosumab, so that's the blue and the green line, which seem to do the best for these patients. One slide to talk about the side effects. We are very worried about atypical fracture, but in your side effects of bisphosphonates and denosumab in perspective to other things like fatal motor vehicle accidents, murder, osteonecrosis of the jaw is less than 1 per 100,000 patient years, and atypical fractures is about 2 per 100,000 in less than 2 years, and it goes up to about 100 when you talk of very long therapy, 8 to 10 years of bisphosphonate. So the advantages of anti-resorptive therapy far outweigh the disadvantage of atypical fracture and osteonecrosis of the jaw. My last slide is to tell you that one fracture begets another fracture. If you have missed out for some reason, I would use the word, it's a crime not to treat that patient. Keep in mind that this patient needs follow-up. I think most orthopedic surgeons are very busy, endocrinologists are getting busy. So a fracture license service is a simple way of following up these patients. Most license service don't interfere in the management. They just want to ensure that the patient is taking, and the maximum recurrence of fractures is in the first 2 years. So most fracture license services follow up patients for 2 years. So to conclude, the important thing is osteoporosis is preventable to a large extent. Unfortunately, patients come to us late, and the worst situation is when they've already fractured. We need to increase the awareness of this disease amongst the medical fraternity and then in the public. Important point, repetition, is that fragility fracture is equal to osteoporosis. You don't need additional tests. Treat appropriately, proper choice of therapy for appropriate duration. There's no idea prescribing teriparatide for 3 months and then leaving it at that. Adverse effects, you can talk to the patient, but don't present it as if it's the end of the world. And repetition of the first point, we cannot at this stage prevent primary fragility fractures, but at least work towards preventing the secondary fragility fractures. Thanks for this patient hearing, and I hope I've completed it in my 15 minutes that were allotted to me.
Thank you, sir, for the lucid talk. I think this is summarized every aspect of management, and the sequential use of medicines is something that is very, very important, because sometimes we have seen that the orderly way in which it has been used is depends on the patient's wish. And I think give for 1 month and then change to another for 6 months, then give another for 1 year, which is going in no direction. I think we have to stick to what we have learned, that give it till it has the maximum impact for the patient, and then only consider shifting it. Because most patients, we always think that they're taking daily injection, they will just stop taking for after 1 or 2 months. So we should also think for the patient and stop on our own. I think we have to give it till the patient sees the benefit and then only change. I had one question, sir, that regarding the BMD, you said that there is no need to do in the initial part. So should we do an X-ray of the spine to see whether we should think of teriparatide in the beginning, or is it okay to just reevaluate the patient later?
So a fracture hip patient is really in pain. So I mean, if you can get it done easily, fine, but it doesn't change the decision. You could wait for a week. Patient has been fixed, ready for discharge. You need to take a decision. Probably even a BMD could be done at that time. But as I mentioned, unless there is a, what we call a severe osteoporosis in terms of more than one fracture or a BMD score of minus 3.5 or less, teriparatide is not the drug of choice.
Yes.
So we can open up this session to everyone because Sanjay and Arpan can also chip in because we have sufficient time for interaction. So the other experts can also chip in if they.
I want to clarify one doubt. Can I?
Yes. Yes, sir.
I think it will be very difficult to get an opportunity like this to talk to this panelist. So let me just get my information from Sanjay. Sanjay, that somehow or other in the training period, my Chatterjee of Cambridge has put into my brain that ionized calcium is almost useless and it doesn't give any extra advantage on calcium albumin. So my all workup happens with this is calcium, albumin, PTH-D. And whenever I need a 24-hour urine calcium, because I work in corporate hospital, but I'm fed up with the surgeons and other colleague too. One parathyroidectomy done every day morning, there is an ionized calcium down. Now, obviously, I work in corporate hospitals, so patient pay money up to most of them unnecessary. Hospital is very happy when the bill goes up. It's very nice to see that your presentation, you completely sidelined the ionized calcium, although one slide you mentioned it at the bottom, but discussion you completely sidelined. How helpful is this ionized calcium?
Thank you, sir, for asking this question. Actually, in our clinical practice, we don't go for ionized calcium. We ask ionized calcium in 2-3 conditions. One is that in the patient of post-op hyperpara, the total calcium will take longer time as compared to the ionized calcium. So that is the one and most important indication in our clinical practice to ask the ionized calcium.
So for how many days?
Yeah, not every day. That is just in immediate after the surgery. They send the arterial blood gases, and in that there is a column of ionized calcium is there. Okay. Otherwise, we are not asking for the ionized calcium. The second condition.
Can I just add a question?
Yes, sir. Yes, sir.
So that's what exactly I was coming to is that in most institutions, the ionized calcium is measured from an arterial blood gas that's probably not even calibrated. Is that reliable? Because I don't know, getting an ABG ionized calcium.
Yeah, so I think you further talked about that. So it's interesting, but yeah, you multiply ionized calcium by 8, factor of 8, that will give the total calcium. So in our clinical practice, not look very carefully about that, but often it is almost like corroborating that kind of thing. So you can use in the emergency situation, there is no doubt about that. And the second thing what Dr. Arpan wanted to know about the ionized calcium, other condition is that we are getting when the patient is having serum calcium of 6 total calcium, but patient is not having symptoms of hypocalcemia. So in certain situations, we do ask for the ionized calcium to see that
I'll get an albumin done, I'll get an albumin corrected total calcium. If somebody has no symptom, definitely albumin is low.
Yes, sir. So actually, many times albumin, we simply correct albumin is not with the full formula, not with the albumin and globulin. We just say albumin, we take it as standard. If it is lower than that, we'll add it. If it is more than that, we deduct it. But if you really want to do that, there is a complete formula. That may be better way to say the protein or albumin adjusted serum calcium. So you are correct, sir. It is not required every day, at least in post-op hyperpara or a kind of situation. Total calcium is good enough. Only emergency situation, you can ask for that. And we do ask in these 2 conditions, not in each and every patient.
The permission of the chair is one more supplementary on this ionized calcium. One of the places where I use ionized calcium is when I see normocalcemic hyperpara where the vitamin D is corrected. Do you think it is required, or we just even there, its utility is limited?
Yes, I agree with you that, and you can add in addition to that magnesium also with the ionized calcium. So that is good idea to have. If the say normocalcemia is there in total calcium, and we are strongly suspecting yes there is hypocalcemia, you can get it done. Yes.
Yeah, just want to continue with this normocalcemic hypocalcemia. You didn't mention in the talk, but what would be the urinary calcium in that calcium creatinine ratio in that if it is normocalcemic hyperpara?
So in normocalcemia, actually, that is one of our problematic area in our institute. You worked in PGI, I know that. So Dr. Rajeshwari, that is the problem because we are in the process to standardize this urinary calcium excretion actually. And whenever we sent our publication of Indian PHPT registry, and the calcium, we looked at the calcium level, that is a very haywire. So it is really difficult. And I must say that unless the biochemistry people are keenly interested to solve this problem, otherwise it is not a easy problem, because collection is the issue. Sometimes patient is some tablet is taking, not sample stored properly, something like that. So that is a problem. But in my clinical practice, I did not find really very, very useful urinary calcium excretion, except as I mentioned, when we are suspecting FHH, then it is really an important parameter, but it is not really requiring, and we manage hundreds of patients of hyperpara. It was not required really.
But should it be very suppressed, urinary calcium, like less than you had mentioned 0.01
calcium creatinine ratio?
So should it be suppressed, or is it in the lower range of normal also you can consider, FHH?
So normocalcemic hyperpara, it should be more than that only, because in FHH it is less than 0.01. So it should be more than that. Yeah. Then only you can say it is normocalcemic or hypercalcemic hyperpara.
No, in FHH, is it completely suppressed? Is it a lower?
Yeah, it is definitely low, because the mechanism that hypocalciuric hypercalcium, obviously calcium is not there in the urine, and that's the reason for the high serum calcium. Yeah.
Okay.
So I think I have a question for Manoj sir. Very, very interesting. That fracture, hip fracture and the spine fracture together, that is really a problem, and sometimes it poses a difficulty to choose the medication. So I must say, I'm just having your opinion. Can you use denosumab? Because the denosumab will solve the few problems. Like one is that it is subcutaneous. It is a 6 months injection, and that will take care of the BMD at both the side, hip as well as the spine, as compared to the teriparatide, which is mainly meant for the spine BMD. I know that because that will reduce the hip fracture also, because change in the geometry or the remodeling of the hip bone. So maybe denosumab can be one of the good option.
I think the use of denosumab in our practice is definitely increasing every day. And, the combination therapy, teriparatide with denosumab, is slowly catching on when you're looking at a lumbar compression and a hip, So you would think of using both together. Earlier on, we used to talk about cost of therapy and obviously daily injections of teriparatide. Fortunately, cost has come down, and the acceptance of daily injections for a finite period is also getting more acceptable. So I very often now have started suggesting that go in for the combination therapy.
Thank you, sir. Thank you, sir, for your daily injection problem will be overcome by one of our study, that weekly teriparatide.
Yes.
And Sun Pharma is going to soon launch the once a week teriparatide therapy.
Yes, I've seen your publication on that. 60 micrograms, I think.
Yeah. So Dr. Krishna, sorry, I interrupted you.
No. This is great news. Manoj, can I supplement that question? In fact, I've been wanting to ask you. So when someone has an established osteoporotic fracture, right? Let's assume that, usually the BMD is sort of more than minus 3.5. So we're really looking at, and if you send them home, in the olden days, we were talking about sending these patients home after, an injection of zoledronic acid or at that time, pamidronate. But are we really not helping them actually by not starting on a bone building agent? Because it's not just the BMD, but it's also the geometry, the architecture, the quality of the bone that is involved. And we know that whether it's denosumab or whether it is zoledronic acid, that the quality of bone building is not as good when an anti-resorptive agent is coating the osteocytes.
So Sanjay, Krishna, if you had asked me this question about 5 years ago, I would have confidently told you that teriparatide does not have any decent data in terms of fracture healing and fracture prevention at the hip. But that has changed. Last 5-7 years, there's been a lot of data coming in with teriparatide also. So we could have this argument of anti-resorptives versus bone-forming agent as the first line of treatment. And so to go against what I have said and go for what you have said, is that it has been very clearly shown with romosozumab now, that if you go for the anabolic agent first, and which is there in the data switch also, that the anabolic agent first, followed by the anti-resorptive, even if it's denosumab, the outcomes are better. So probably as the time goes on, we may change over from our current stand of using an anti-resorptive first for hip fracture to a combination therapy. And then eventually, if you get a strong agent like romosozumab, you would use that as a first line therapy. Although again, the data for hip is not as impressive as the lumbar spine. So this is something which is going to be open. We are going to talk of quantity versus quality. And the important point is to see that whatever you prescribe, the patient takes it.
A question for either Dr. Chadha or Dr. Parada can take up. Some of my patients who have been on teriparatide on follow-up, I just get their calciums. They are in the upper range of normal or slightly above that. So in that case, what do you do with the supplements, calcium supplements? And it's usually I do it after 12 hours after the last injection. Yeah.
So I think that is known one of the side effect or the adverse effect of the PTH therapy. But are you telling me that after starting the first injection you are getting, or it is in the follow-up?
Follow-up, on the follow-up.
Generally on follow-up, it is not there. High calcium is not a usual phenomena. Either your patient is taking the serum calcium, tablet calcium before getting the serum calcium. That may be one of the reason. If it is not getting, they taking the test giving the test in the fasting.
Fasting. Usually we get fasting.
Yeah, but otherwise this is not a common phenomena. On the contrary, the PTH is suppressed. If you are getting the PTH, the patient, the PTH therapy, that is suppressed. But I have not observed the patient calcium is high. Yes, that is known that after 1 week, that is a part of the teriparatide that we get the serum calcium. If it is high, we ask to stop the calcium and repeat it. If it is normal, then we restart. But if it is high, after stopping the calcium, in that case, we give a break of say 7 days or fortnight of the PTH therapy to stop. So that is known, but on long-term follow-up, maybe 2 months, 3 months, I am not aware of this. Any sir can tell or?
Yeah, no, sir. I would actually agree with Sanjay that you don't get proper hypercalcemia. You are 10.2, 10.5. All you need to do reduce the calcium supplement. And if you're really worried, I mean, occasionally I've actually done a 24-hour urinary collection to see for the urinary calcium. And it's very rare that you missed out a PTH dependent hypercalcemia in the beginning. I mean, we see our ortho colleagues who are excited about giving teriparatide and we end up with that. But if it's a physician involved, I would give them that much credit that they would check for the primary hyperparathyroidism.
In fact, in 2 such patients, I had seen that urinary calcium was very much suppressed. So I don't know whether there is something, related or there some mild type of FSH or not very sure.
So in that case, I think your baseline workup will be very, very helpful. That we have done the baseline workup and there was no, say, hypercalcium was not there, even borderline. Then any other thing like RSD, renal stone disease was there or not, that might give you some information on that. Or I think other good idea is that rather than supplementing the serum calcium tablets, ask the patient to maybe taking more dietary calcium. That may be another useful suggestion.
That's exactly I have done for two of
Yeah,
them.
that's correct. Yeah.
So
I have a
can you bring
question.
Arpan in? Yeah.
I have a question for Arpan sir.
Okay.
Thank you, sir. Hyponatremia is one of the difficult area I know, but you made very easy, and I'm really happy that actually in our clinical practice it is sometimes really very difficult to differentiate the SiADH and cerebral salt wasting. But three parameters you have said is that one is dehydration, urinary sodium more than 100. That will cleanse the diagnosis of cerebral salt wasting. So, sir, it is maybe a good textbook information, but is it really applicable in your clinical practice? Just I wanted to know that. That is my.
But three figure, whatever I mentioned, urine sodium actually is completely my comment. It's not written here. But we have collected around 15 people with a cerebral salt wasting syndrome after neurosurgical event or head injury. And all of them actually found in this urine sodium is three figure, 100 plus. That's not one. That doesn't mean that if you have an 85, it cannot be CSW. Yeah. But main issue what I wanted to focus, the treatment of SiADH and CSW are completely opposite. So we need to remember this to diagnosis when we are giving therapy. Otherwise, we'll be completely in the wrong foot.
Yes, sir. So really, it is very useful because two conditions are really difficult in our clinical practice to differentiate. Actually.
So, yeah, just one comment. Sorry, we have seen in our neurosurgical patients, like sir said, the urine intake output also is less than like 300. The difference, if it is more than 500, I have seen the chances of SiADH is more. If the difference between the input output is very less, or sometimes the output is more, means that goes highly in favor of cerebral salt wasting. But if the urine intake output is marginally 200, 300 ml difference, then we have seen that adding fludrocortisone really improves their sodium significantly, and tolvaptan doesn't make much difference when the volume is already high.
Okay, correct. But most of the cases we get referral already, they have given a hypertonic saline, all these. So it's very difficult in the de novo to assess ones.
Arpan, quick follow-up questions on this. Most endocrinologists don't use tolvaptan much, but there is but if you look at the general population of physicians and neurosurgeons, it is written without at the drop of a hat, right? Can you elaborate on this? Who should be given tolvaptan? I know you've touched this, but I think it's worth remitting.
Difficult question in our healthcare system. Very difficult question to answer. But we do see the people giving tolvaptan without monitoring, and sometimes it is scary. And so they really looks like the lion's heart, and I am the poor fellow getting scared of the side effect. I do this the same experiences there.
Dr. Krishna, you have to organize less webinars if you want to prescribe the tolvaptan, because we endocrinologists read a lot. We analyze every study, what is the outcome of the tolvaptan. It is not improving the overall mortality. And we stop, no, it is not required because it is not improving the mortality. But let me say one thing is very clear. Even if it is improving the morbidity for a short time, I think there is no harm. Until unless there is a clear-cut contraindication that patient is having liver dysfunction, you don't prescribe. If you have facility for monitoring, I think we should prescribe, though I am not prescribing. What I am trying to say is that because we read a lot and then we start following that study, that study showed that there is no benefit in the mortality and we don't prescribe. But I think little bit we should start writing being endocrinologist rather than, and will be better person to prescribe rather than neurosurgeon is prescribing the tolvaptan without monitoring anything.
Yeah.
Okay.
Most of the time, mild hyponatremia, they do settle well with fluid restriction, and not a severe one, but a mild fluid restriction. But only thing is, monitoring is something which we have to,
and it's actually quite a difficult issue also, fluid restriction. For hospitalized patient is okay. For 1 week, 2 weeks at home is for long term, it definitely becomes a very difficult.
So as you know, my former teacher Sharat Chandra used to say, my patient gets better with your help, without your help, and in spite of your help. So, and with that, let me thank all the chairpersons, Dr. Rajeshwari, Dr. Mahesh, and our really illustrious panel of experts, Dr. Badada, Dr. Bhattacharya, and Dr. Chadda, who have been the BBC of today's meeting and just brought so much star value to this. Each of them are eminent speakers and teachers in their own right, and my sincere and grateful thanks to all of them. Thanks to the chairpersons, and I hope the audience have found this beautifully useful for their practice, and we will and this is going to be available at our YouTube and sites for generations of learners to continue to learn. Thank you, everyone. I'm sorry we impinged on lunch, but we are finishing right on time. Thank you so much.
Thank you.
Thank you, everyone.
Thank you, Dr. Krishna. Thank you. Happy Janmashtami on Monday.
Yeah. Hi, Bhavna.
Thank you. Yeah.
Thank you all.
Thank you.
I already see Dr. Manohar has joined us well in time, but we do have a couple of minutes for everyone to get some lunch. So I request Neelam and the technical team to actually play some icebreakers, and we'll start the next session right on time. Thank you, Neelam. So I hope those of you who've been with us right through the day that you've had some time to take a break, get some lunch. And now we're back again for the second half of the day. And we're going to start off with some of the pharma symposias before heading on with the plenaries. So the first symposia post-lunch is sponsored by AstraZeneca, and we have 3 talks lined up for all of you over the next 55 minutes. So we're going to have 3 eminent speakers, Dr. Manohar, Dr. Ravdesh Kumar Singh, and Dr. Dinesh Kullar, joining us over the next 1 hour. So let's start off understanding and learning about newer evidences with a focus on dapagliflozin. And I now invite Dr. Manohar, who's the physician diabetologist from Manipal Hospital, Bangalore, to give us his talk, which is a case on comprehensive on how to approach a patient with metabolic syndrome in a comprehensive manner. So thank you, Dr. Manohar, for joining us, and over to you.
It's always been a pleasure to be here. I was logged in the morning and a very nice session on the thyroids, followed by your session. I just set the point right and before I minimize. So we can go ahead. As Dr. Bhavna told, I'll be first talking on a comprehensive solution to a metabolic syndrome case, and followed by the big gun AK we will be waiting to listen to, and others, and then we can have a panel discussion later. Well, I'm talking about a young lady. Young keeps changing as we age is what I always feel. Shweta is an executive of global company. Hyperglycemic, as you can see, A1C at diagnosis was 8.2, BMI was 24, and BP was at diagnosis 136/90, and total cholesterol was 250, and EGFR was 75, LDL was pretty high at 154. So hyperglycemic, overweight, hypertensive, and dyslipidemic. But she didn't have any cardiovascular event or heart failure. But it's an important entity to take note of. Current ECG shows a heart rate of 110 beats per minute, and she's prescribed diet, exercise, and metformin. And to control her blood pressure, she was on a modest dose of ramipril. So she shared the reports, and Shweta, a metabolic syndrome patient, is the question. Obvious answer is yes. What we need to address is hyperglycemia, weight, hypertension, dyslipidemia, and I mentioned that she didn't have any cardio-renal issues as of now, so we need to look at the preventive aspect of it. And also, importantly, tachycardia. You know, there are a lot of insights into the tachycardia itself can predict mortality higher. So what molecules should we use in the management of us? First, look at the glycemia. A host of molecules as listed on the top of your screen: sulfonylureas, TZDs, DPP4, SGLT2 inhibitors, GLP-1 receptor and agonists, and insulin. And we all know that how the guidelines have changed based on what is important. Is it cost effectiveness is the most important consideration, hypoglycemia is a consideration, reduction of ASCVD is a consideration, and so on. So we'll not waste time alluding to it. And if you look at these molecules, and we have subdivided it based on their efficacy, risk of hypoglycemia, their effects on the weight, and the cost, which is self-explanatory there. And that need to be considered. And we have, coming to the next slide, an early role of intensification. We always talk about it. If you look at this graph, as we used to do in the past, or it was taught in the past, is to add one medication, build up the dose, and add another one, and then add another one. So this, we all know, that is a failure to treat hypothesis. So pathophysiologically, now we have learned that anyway, there are multiple mechanisms, if not just 8, maybe sweet, 16, or dirty dozen, or whatever you want to call it. So now, and we also clearly know that if the target A1C is more than 1 or 1.5, unless you are using insulin, no single drug would achieve it. And we have learned this, and we know that early intensification treatment and the legacy effect and so on. So that is the role of early intensification, which this slide highlights. So earlier lowering of A1C, avoiding clinical inertia associated with stepwise approach, people start getting fed up by keep on looking at almost the same value of A1C, but keep increasing the same dose of same medication. Initiation of therapeutic intervention with complementary mechanism of action is very important, like SGLT2, DPP4, not only reduces genitourinary tract infection, reduce the risk of euglycemic decay, and also glycemic efficacy is better when we use it. And the fixed drug combination, we all know, improves compliance, and just an improvement in compliance over and above addition of some molecules will improve the risk of complications. Just a snapshot view of SGLT2 inhibitors. We know it's a glucose lowering effect, insulin independent mechanism of action. Both couple reduces the risk of microvascular morbidity and low risk of hypoglycemia. The osmotic diuresis will also help in weight loss and a modest decrease in blood pressure. And we lose calories, 60 to 70 grams of glucose into 4, about 280 calories. And that helps in weight loss, even though it puts you at a risk of having genitourinary tract infection. And if you look at dapagliflozin as a molecule in the context to just look at how the HbA1cs on the other side effect profile compare of SGLT2 inhibitors, it's very clearly seen that as the baseline A1C is higher from 7.92 to 9.4, as they add on to metformin therapy, the HbA1c drop, the efficacy improves from 0.8 to anywhere between 0.8 to 1.4. And I'm sure my next speaker has done a lot of work on it, especially on background metformin therapy, how SGLT2 inhibitors do well. It would add on to my points definitely. And whether you look at it as SGLT2 inhibitors in general and DAPA in particular, whether it is monotherapy or as add-on to metformin, sulfonylurea, other DPP4 inhibitors or other drugs, it has definitely shown a consistent efficacy somewhere around 0.82 to 0.96 A1C reduction over a period of time. And as we talk, higher the A1C, higher the benefit with respect to the reduction of A1C, higher the weight, higher the reduction of weight too. So from normal weight to obese individuals, if you start looking at the data analysis, people with normal weight may reduce till 1 kilogram, but people with higher weight may reduce much higher, up to 3.5 or so. What is of interest amongst the pleiotropic effect is a modest anti-hypertensive effect. So in the comparison on the bottom half of your screen onto the right, if you look at it, DAPA 10 milligram with placebo, but it is an add-on to existing ACE inhibitor or ARB. So there is definitely a 3 to 4 millimeter of mercury reduction of the blood pressure. And in spite of an added ACE inhibitor ARB, even though it sounds a modest reduction, but this still becomes very important because it comes free with the other benefits of the SGLT2 inhibitors. So when you add DAPA-SAXA on the background of metformin, we almost cover all the ominous octet mechanism except on the effect on the lipids and the neurotransmitter dysfunction. So that's what this slide says. And there are data to show that definitely DAPA-SAXA or two beta molecules with respect to the safety profile do very well as compared to glimepiride, which is clearly shown DAPA-SAXA in maroon versus glimepiride in green. With time, as you look at 52 weeks, definitely adjusted mean change in A1C is better with this combination. I mean, you can argue that there are two molecules and how can you compare it to one? But anyway, so how do we manage Shweta's hypertension? This much about the glycemia. She's already on ramipril, as I mentioned. But most important thing to note was she had tachycardia of 110 beats per minute, possibly such a sympathetic overactivity, and definitely please rule out the other causes of possible thyrotoxicosis or any rhythm disturbances of the heart, which are transient, tachycardias, pulmonary embolism, so on and so forth, the generalized anxiety disorder, before we just zero it onto suggested of sympathetic overactivity, which can't be really measured. So it's always a diagnosis of exclusion in practice at least. So what is the next line of treatment? We all know beta blockers, especially cardioselective beta blockers, are good, and we always restrict them in diabetics, but there are certain indications like increased sympathetic activity, presence of IHD or LV dysfunction. Sometimes there's a definite scope for beta blockers here. So if you look at the data about Indian hypertensives, more than 60% of us have increased sympathetic activity, and especially in young Indians. This sympathetic activity could be made worse by the presence of diabetes, smoking, and obesity. and not to mention stress. Metoprolol reduces the sympathetic activity. An average reduction of 14 beats per minute is what is documented in the trials. And we all know about the good old metoprolol. Excretion is through the hepatic route, and therefore even in CKD it can be used. Potassium should be monitored because there could be some minor changes because of that. Otherwise, it's a very good, safe drug. And when you look at the data, it also shows all-cause mortality or sudden cardiac death. If you're comparing it with the diuretics, over a period of 5 years, there is a definite risk reduction of both all-cause mortality and sudden cardiac deaths, which are an important entity in a person diabetic who has possibly sympathetic overactivity. So that we need to draw attention to that. And coming to the most important parameter, metabolic dyslipidemia, we all know in comparison with Europeans, we get ASCVD a decade earlier. 10% of the heart attacks occur in a younger age group of less than 40, and 52% of the CVD deaths occur under the age of 70. So this is the thing, and then we all know the dyslipidemia management has moved just from looking at the LDL or parameters to ASCVD management. So that is a transformation of late what we have seen. And so that also means that we need to have risk calculators, and we need to treat according to the risk and also the high risk categorization. 5 to 7.5% is the borderline risk, and more than 7.5% on your risk engine says the risk is higher. And then we look at this entity where I'm pointing LDL cholesterol risk reduction by 30 to 50%. And also if there is higher risk of more than 20, you need to target the LDL reduction of more than 50% from the baseline. So we don't usually look at just the absolute levels. So what was the baseline and what percentage you need to reduce is another change what we have seen. And we all know that this Uranus trial has clearly showed that LDL reduction is very well done by rosuvastatin as compared to atorvastatin. So rosuvastatin treatment reduced risk of CVD by 44%. So you can put out all the parameters what we generally assess, like MI, stroke, revascularization, CV death, fatal or non-fatal stroke, CV events in CKD, and all-cause mortality. Around 44 to 49% reduction of this is done by the rosuvastatin. So coming back to our patient, of course, lifestyle changes are the most significant important thing. I'm a big proponent of it, and I keep urging that is the most important thing to be told. 10% of weight loss is as good as adding a single tablet for diabetes, hypertension, and dyslipidemia. This is what I keep telling patients. So metformin, dapasaxa combination, statin, preferably rosuvastatin. She was already on ramipril. We put her on metoprolol because of the sympathetic overactivity. So I think that completes my slide set, and over to the moderator. And we come back again for the question and answer session later.
Thank you, Dr. Manohar, for sharing that case with us. I would now like to call upon Dr. A.K. Singh. I request Dr. A.K. Singh, and all of you know Dr. A.K. Singh from Calcutta, and I request him to give us the next talk on dapagliflozin and how we're probably rewriting guidelines for heart failure and reduced ejection fraction today because of evidences that we have since the last couple of years. So over to you, Dr. A.K. Singh.
To Bhavna, these topics are pretty close to my heart. So, skip the timeline which have been given. अगर मैं भावना में भाग जाऊं तो भावना मुझे रोक दे. All right, so thank you, organizers, Dr. Arvind and entire team of ATA Primer. Always good to have in these meetings. See, my job is little difficult. They have been given to rewrite the guideline in 15. And I think any guideline is not a subject of 15 minutes. You need to really dissect the guidelines and the data to make a guideline. However, I would be very hurriedly trying to push my case. First, this talk is sponsored by AstraZeneca, who are the makers of innovator dapagliflozin across the world. However, the entire presentation has been made by me, and slides has been edited, deleted, and added as per my own personal thoughts. Now let's look into what is the current guideline regarding standard of care in people who have got a heart failure with reduced ejection fraction. So my topic was, do we need to rewrite a guideline with dapagliflozin in people with heart failure with reduced ejection fraction? So today I'm talking as a cardiologist, being an endocrinologist. Let's look into the evidence. The one of the trial which was made a headline in people with heart failure with reduced ejection fraction is this trial called Paradigm Heart Failure Trial, conducted with Ernie. As you all know, this trial was conducted head-on with a neprilysin inhibitor with enalapril AC inhibitor, the prime contender for the treatment of heart failure with reduced ejection fraction. I think if you see the cardiovascular outcome trials in people with heart failure with reduced ejection fraction, the highest data before the Ernie or SGLT2 was with the AC inhibitor. Remember, we have got trial called Consensus with enalapril. We have got trial called SOLVE with lisinopril. We have got another trial conducted with enalapril. So we have got 3 trials in people with heart failure with reduced ejection fraction, where ACE inhibitor shown a significant reduction in the cardiovascular and the all-cause death. Now, in the Paradigm Heart Failure trial, the beat out smartly a ACE inhibitor, which has the best data prior to the Paradigm Heart Failure trial, and there was 20% reduction in the composite of cardiovascular death and heart failure. And this trial, published in 2014, changed the entire landscape of treating the people with heart failure with reduced ejection fraction. Remember that although this trial reduced, the composite of CV death and heart failure, there was a highly remaining residual risk still, despite you use even a newer class of anti-failure drug. And in 2016, the people proposed that there should be a different kind of guideline in people with heart failure with reduced ejection fraction. If you see the ESC 2016 guideline, you can see the ACE inhibitor and beta blocker was the first line of drug in people with heart failure with reduced ejection fraction. And if they can manage with ACE inhibitor and beta blocker well, then you go ahead. If they still have symptoms or their ejection fraction is less than 35%, add a mineralocorticoid receptor, spironolactone, and so on and so forth. So this was the ESC 2016 guideline. Remember, at that point of time, just the Ernie trial came into the picture and said that use diuretics when you have got a feature of congestion, etc., etc. Now, after the trials with dapagliflozin, which was the DAPA heart failure trial, which was conducted in people with heart failure with reduced ejection fraction, again the entire landscape of treating heart failure with reduced ejection fraction seems to be changing. And thanks goes to the SGLT2 inhibitor, which has started showing the prevention of heart failure in people of diabetes, regardless of the background established cardiovascular disease. You remember in the DECLARE-TB trial, where more than 10,000 patients were primary prevention cohort, there was a significant reduction in heart failure hospitalization, irrespective of or regardless of the background established cardiovascular disease. And this was the first evidence to suggest that a SGLT2 inhibitor like dapagliflozin can prevent heart failure in people with diabetes, even without any established cardiovascular disease. Interestingly, in the DECLARE-TB trial, if you see the people with a baseline heart failure with reduced ejection fraction, so this was a secondary post hoc analysis of DECLARE-TB trial who had a history of heart failure, stratified to have a heart failure with reduced ejection fraction diagnosed by echocardiography at the baseline. Remember, in the 17,000 odd patient of declared TIMI, 10% had baseline heart failure. This means the 1,700 people in the declared TIMI trial already had heart failure at the baseline, of which majority of them were characterized with heart failure with reduced ejection fraction. And in fact, in the declared TIMI, this analysis, there was a clear signal that the dapagliflozin shown a significant reduction in the composite of cardiovascular risk in people with heart failure with reduced ejection fraction. So this was the first suggestion which came from the declared TIMI as a prevention and also in declared TIMI as a treatment in people in a sub-cohort with heart failure with reduced ejection fraction. But that was not enough evidence to suggest that the dapagliflozin works in people with heart failure with reduced ejection fraction. And therefore, you are supposed to conduct a big trial, a dedicated heart failure trial, the DEPA heart trial, which in people with heart failure with reduced ejection fraction, with or without diabetes. I'm not going to detail. You all know what happened after the results of DEPA heart failure trial. It was compared with placebo. These background characteristics. Interestingly, if you see this trial, see the mean age of the patient. I always wonder that we all are circumspect while prescribing a SGLT2 inhibitor. So, and when it comes to using SGLT2 in elderly people, we are always scared. What is the mean age of people in PRESERVE trial published yesterday? It was 72. Look here in the DEPA heart failure trial, the mean age is 66 years. These are elderly people who benefited most with the SGLT2 inhibitor. There is no point to be scared while using a SGLT2 inhibitor in elderly population, simply. Now, as you all know, this trial has got people having already receiving the standard of care of heart failure, like diuretics or ACE inhibitor or ERNI or a beta blocker or MRI. So that is one of the most standard trial where even the placebo arm were receiving the best of the treatment for the heart failure. And what happened? This is the result. You all are aware. And there was a significant reduction in the primary outcome of composite of CV death and worsening heart failure by 20%. And if you see even the sub-analysis of DEPA heart failure trial, whatever you look into data, there was a significant reduction in cardiovascular death. There was a significant reduction in all-cause death. In fact, this was not replicated in the IMPERA-reduced trial with empagliflozin. That's the unique finding which came in the DEPA heart failure trial. And when it comes to safety, it was surprising to believe that in a mean age of 66 years, the drug has got basically the no side effect. And that was pretty amazing. What was interesting that, regardless of diabetes, you have got an advantage of significant reduction in cardiovascular risk of composite of CV death and heart failure. And this was pretty similar. If you look here, 0.75, 0.3, tempting to believe that in non-diabetic, patients with heart failure, it tends to have a little larger quantum of benefit, although the p-value of interaction suggesting no difference. And therefore, the heart failure benefit in people with heart failure with reduced ejection fraction was there regardless of their diabetes status. And also this benefit was there regardless of the background ERNI use. And at the top of ERNI use, thereby suggesting this molecule has got some potential in people with heart failure with reduced ejection fraction. Now, if you see what interesting finding, that this is the first evidence being generated by any SGLT2 inhibitor to show a prevention of progression of diabetes from pre-diabetes. And this study found 32% people in the DEPA heart failure trial did not progress to a frank diabetes from normoglycemia or pre-diabetes. And in fact, this is the first evidence generated with a SGLT2 inhibitor for the prevention of diabetes from the pre-diabetes. And that too in people with heart failure with reduced ejection fraction. Now, if you see not only the episodes of first heart failure, but the number of times of heart failure, recurrent heart failure, first bout of heart failure, second, third, everywhere there was a significant. And this is the data and the forest plot suggesting that the recurrence in the heart failure was significantly reduced with DEPA compared to placebo. Now, in the DEPA heart failure trial, this is perhaps the unique finding which published yesterday. This got lost in the noise of IMPEROR-PRESERVE trial, and we could demonstrate that dapagliflozin shown a significant reduction in cardiac arrhythmia, sudden cardiac death in the DEPA heart failure trial. And this is one of the astonishing data of 21% reduction in arrhythmia, sudden cardiac death with dapagliflozin in people with heart failure with reduced ejection fraction. Now, I don't think there is a point to compare empagliflozin and dapagliflozin in cases with heart failure. Both the drug has shown a tremendous potential and pretty similar advantage, in these patient cohort. However, there were certain difference in the CV death and all-cause death reduction in DEPA versus IMPA in these two trials. And perhaps I believe that it is nothing to do with the molecule as such, but then perhaps related to a difference in the baseline characteristic of this trial, where in the IMPEROR-reduced patients were more both cardiac and renal sick compared to the dapagliflozin that could have made the difference in the CV death and all-cause death outcome, which wasn't seen in the empagliflozin IMPEROR-reduced trial. But then remember, we had evidence in the past with empagliflozin in the IMPAREG outcome trial of a significant CV. Now, this is one paper which is rightly under review, and this would be one of the interesting findings which as you have never seen in past and never learned. Now, what we did is we tried to understand whether benefit of a SGLT2 inhibitor happens across the degree of glycemia. So what we did, that we looked into the DEPA heart failure and IMPEROR-reduced and tried to understand whether the cardiovascular benefit is related to any difference in glucose lowering. And we put into three groups of normoglycemia, pre-diabetes, and diabetes. This is a one step further to the DEPA-HF and IMPEROR-reduced and try to understand whether the benefit is happening only with people with diabetes or with pre-diabetes. And we could find out that the benefit in the composite of cardiovascular death or heart failure happened irrespective of baseline HbA1c, whether you have got normoglycemia or you have got a pre-diabetes or you have got a diabetes. The benefit is happening across the board in people with heart failure with reduced ejection fraction with a SGLT2 inhibitor. That's the message from this meta-analysis which we conducted to suggest that if you have got a patient with heart failure with a reduced ejection fraction, don't look into the glucose, go for the SGLT2 from day one, and then therefore the guideline come into. What is the positioning of dapagliflozin in the recent guideline? You can see these are the position statement, 2020 Heart Failure Association and ESC position highlight. They recommended here the Canadian guideline suggesting SGLT2 inhibitor in people even without diabetes. This is a proposed, guidelines maker suggested that initially you go for ACE inhibitor and beta blocker, then you add a MRA, and then you go for a ARNI. You use diuretics and SGLT2 from the day one, and that's what after the DEPA and heart failure. Remember, these are the proposed. Another groups of people proposed that go for a step one of ACE ARB, then beta blocker, then MRA, then ARNI, and then a SGLT2. And they said that use it within 4 weeks of sequencing. Another group said that these are the proposed pathway that go for beta blocker, SGLT2 in a step one, and then ARNI, then MRA, but do use all the drugs within 4 weeks. So people keep on, changing their goalposts as the trial result came into the picture. And now you can understand how we all are looking into this heart failure space. And yesterday, the ESC 2021 guideline came up with a proposal that if you have got a patient with heart failure with reduced ejection fraction, go with all the 5 drugs from day one. Start with AC inhibitor, or add a beta blocker, add a MRA, add a SGLT2, DEPA or empagliflozin, and add a loop diuretic if there is a fibrinogen. So you can see the 5-group class of drug is starting or being started from day one if you have got a patient with heart failure with reduced ejection fraction. Try to use the maximum class of the drug which has shown a significant reduction in CV death and the composite of CV death and heart death. Now, finally, then how to approach the CLT2 inhibitor or dapagliflozin in this case in patients with heart failure with reduced ejection fraction. Now, when you're using all the 4 drugs like ACE inhibitor or ARNI with beta blocker or MRA with SGLT2, first look into the patient. Select the patient that it has to have a patients with heart failure with reduced ejection fraction. Look the dose of the drug which is recommended in patients with heart failure. Don't use dapagliflozin 5 milligram. All the trials of heart failure use dapagliflozin 10 milligram. And there is no dose requirement if your patients had got an eGFR of more than 30. Look into some of the pre-considerations of hemodynamics and their clinical status. Look into the volume. Look into the renal function. Counsel your patient regarding the side effect of the CLT2 inhibitor, possibility of postural hypertension, possibility of genital infection. Talk about the hygiene, with the CLT2 inhibitor, and then use these drugs. So these are some basic reasons while using all these drugs which has shown a significant reduction in the composite of CV death or heart failure in patients with heart failure with reduced ejection fraction. Thank you very much for your patience listening, and I will take question and answer after Dr. Kulal presents.
Thank you so much, Dr. A.K. Singh. I now request Dr. Dinesh Pulal to give us his presentation on dapagliflozin and data available in CKD. So over to Dr.
Well, thank you very much, and thank you organizers for this wonderful opportunity. So it's always a feast to listen to people like Dr. A.K. Singh. So I will be discussing and giving a viewpoint of a nephrologist. And do we really believe that SGLT2 inhibitors in general and dapagliflozin in particular have proved to be a game changer, especially when it comes to the management of chronic kidney disease? So before I begin, let us try to recapitulate as to what we do not have in the management of CKD. Well, we may have had drugs like RAS blockers, but then if you look beyond RAS blockers, there is not much which we have for our patients of chronic kidney disease. Look at the prevalence of almost like 70 crore of patients across the globe who have some degree of chronic kidney disease. And mind you, we haven't had much improvement in the mortality. As you can see here, most of the diseases have shown an improvement in the overall mortality rates, barring the kidney disease, the chronic kidney disease. And like any other nephrologist, I would also tend to believe that this is because of the disease and not because of the poor performance by the nephrologists across the globe again. Well, this is what I was talking about. Hardly anything beyond RAS blockers. And obviously, we have looked at the availability of SGLT2 inhibitors with a lot of hope and enthusiasm, because none of the drugs on the right-hand side could really prove efficacious. And we are back to square one when most of these have what they have proved in the recent times. So obviously, we have been trying to look at SGLT2 inhibitors, not just in the management of diabetes, but in the management of chronic kidney disease. And we are all aware of the various mechanisms of action by which SGLT2 inhibitors have been shown to work and offer renal protection. And let me confess that we are still learning a lot, and every day we are coming across something really unique about the way they are helping our patients. But coming to the nephrology side, all the data initially was as a post hoc analysis of the various cardiovascular outcome trials, starting from the Canvas program, DECLARE-TIMI, and the AMPA-REG. It's basically with the post hoc analysis of AMPA-REG that we realized that they may be good for the heart, but they are probably even better for the kidneys. And that's when we decided to go down as far as the GFR of our patients is concerned, trying to see whether SGLT inhibitors will be working in these scenarios as well. So we tried to move on because what we realized was that most of the cardiovascular outcome trials had not included patients with more advanced chronic kidney disease, and Credence was the first one which enrolled patients with GFR as low as 30 ml per minute and with a significant albuminuria. Here with DAPA-CKD, and why we believe it's been a game changer is because we have gone one step ahead and two steps ahead rather. So one, we went to GFR as low as 25, again with a significant albuminuria and people who were already on maximally tolerated dose of RAS blockers. But the other game changer was that this enrolled people even who were not diabetics, and that was the real interesting bit here. Dapagliflozin, 10 milligrams over and above the standard of care. And as you can see, as we move from the left-hand side of the cardiovascular outcome trials to the renal dedicated trials with SGLT2 inhibitors, Credence included patients who had a significant GFR impairment, but mind you, they were all diabetics. And as I said, DAPA-CKD went one step ahead. It had even more number of patients who had more significant GFR impairment, who had albuminuria, and there were also a sizable population who were non-diabetics. As you can see here, 67% were diabetics. And out of these, roughly about 10% diabetics did not have diabetic kidney disease. That means they were having a non-diabetic kidney disease. So totally 42% in DAPA-CKD trial were patients who were either non-diabetic or diabetics with non-diabetic kidney disease. They were already on the maximally tolerated dose of RAS blockers and had albuminuria of roughly about 1 gram, and a mean GFR in the trial was 43 ml per minute. Coming to the trial, to the results, I'm sure most of you are already aware of the overwhelming results, as a result of which the trial was prematurely stopped. As you can see, this primary composite outcome sustained reduction of more than 50% in the eGFR, attainment of end-stage kidney disease, renal or cardiovascular death. The relative risk reduction was to the tune of 39%. If you look at whether the patient had diabetes or not, you can see both the classes were equally benefited. In fact, at one point of time, you would believe that people who were non-diabetics probably stood to gain even more as compared to diabetics. A reduction in the GFR of more than 45 was probably having more profound effects as far as the overall results were concerned. Well, whether you look at the primary composite endpoint or the secondary outcomes, at every step, DAPA-CKD showed that dapagliflozin scored heavily over the placebo arm. Of course, we are all well aware of the fact that there will be some decline in the GFR the moment you put these patients on an SGLT2 inhibitors. But importantly, if you have the patients and the confidence on SGLT2 inhibitors, as you can see at the end of 3 years, the decline in the patients who were put on dapagliflozin in the GFR was minus 1.67 as compared to 3.59 in those who were put on placebo. Well, we have heard a lot of concerns regarding the safety of SGLT2 inhibitors. Ever since they were launched, we were talking about genital infections, the urinary tract infections, the amputations, fractures, 4-year gangrenes. DAPA-CKD, which included more than 4,000 patients and more than 2,100 on in the dapagliflozin arm, showed that the safety was of not significant concern. As you can see here, hardly any patient with diabetic ketoacidosis, volume depletion, or any of the major concerns. So even in patients with compromised GFR and albuminuria, dapagliflozin was found to be safe enough. Now, the interesting thing, let's look at what DAPA-CKD showed us in the subgroup analysis. Number one, according to the diabetic status, as you can see here, the primary outcome was good with diabetics, but probably it was even better in non-diabetics. The renal-specific outcomes were there favoring dapagliflozin, not just in diabetics, but also the non-diabetics, and including the heart failure, at least in the type 2 diabetic population, it was found to be efficacious. The cardiovascular death or hospitalization due to heart failure in the non-diabetics crossed unity, but then you can see the number of events were just 15, and that may have been one of the main reasons. All-cause mortality, both diabetics as well as non-diabetics stood to gain if they put on dapagliflozin. Now, according to the etiology, and that's something which we as nephrologists were really interested in, not just what it does to diabetes, but does it do anything more to patients who are non-diabetics and yet initiated on dapagliflozin. As you can see here, we knew with Credence trial that SGLT2 inhibitors will do a good, whole lot of good to patients with diabetic nephropathy. As you can see here, hazard ratio of 0.63, 37% relative risk reduction with patients who had diabetic nephropathy. But more importantly, because as I said at the outset, we haven't had anything to offer to our patients with many of the glomerulonephritis, including a very common entity, that's IgA nephropathy and FSGS in our patients. Look at what kind of benefits were shown in the DAPA-CKD trial in patients who had primary glomerulonephritis and were started on dapagliflozin. We have struggled to treat IgA nephropathy, which is a very common entity, including in our country. Well, we have had some trials like Stop IgA and testing, which looked at what steroids can do. They showed benefits of steroids, but they cautioned us with the side effects, with what steroids can bring in these patients with IgA nephropathy. Mind you, the numbers were just 162 and 262 in the dedicated IgA trials. Here in the DAPA-CKD, you can see the number of people who had IgA nephropathy was more than numerically, even in those who had the primary objective of looking at what it does to IgA nephropathy. And look at the mind-boggling figures here. The hazard ratio of 0.29, that is 71% relative risk reduction of the primary outcome in patients with IgA nephropathy who were started on dapagliflozin. And the same about the relative effect as when you look at the stages of CKD, whether they had early stage of CKD, which the predominant population in the DAPA-CKD was, compared to the more advanced, that is CKD stage 4. As I said, DAPA-CKD enrolled patients even with CKD stage 4, that is less than 30 ml of GFR. As you can see here, of course, it showed a great effect in the overall outcome, regardless whether it was CKD stage 2, 3, or 4. But when it came to the stage 4, as far as the attainment of end stage was concerned, they were almost very close to end stage disease. And of course, it crossed unity. But then again, the number of events was not too much. And especially in the kidney death or cardiovascular death, there were only 14 events out of 293. May have been one of the reasons. But overall, it showed that even according to the stage, DAPA-CKD showed that patients benefited across all stages. So have the latest guidelines? Well, yes, KDIGO already has recommended the use of SGLT2 inhibitors and asked us to stop only if GFR is less than 30. And I think times to come with as and when the DAPA-CKD results are incorporated, or the eagerly awaited AMPA kidney results, which has included patients with GFR as low as 20, which are going to be available next year, are available, we'll probably will be lowering the bar for SGLT2 inhibitor again. DCGI also has allowed us the use of dapagliflozin even in patients with GFR as low as 30. Even it has allowed us nephrologists to use it in CKD non-diabetic indications, and this has been allowed even to the non-nephrologist specialists very recently. To conclude this DAPA CKD trial first, it has shown that in patients with CKD, both with as well as without diabetes, DAPA showed, as compared to placebo, reduction in the risk of kidney failure, reduction in the risk of death from cardiovascular diseases or hospitalization for heart failure. And these effects were consistent regardless of the etiology of CKD and the stage of the CKD and whether the patient had a prior cardiovascular event. So to conclude my talk for today, SGLT2 inhibitors have been shown to have positive effects on the renal biomarkers in the various cardiovascular outcome trials, with the availability of the results of the Credence trial, which demonstrated that it improves both the renal as well as the cardiovascular outcomes in diabetics with GFR as low as 30 ml per minute and who already were receiving the maximally tolerated dose of RAS blockers and had a significant albuminuria. DAPA CKD has gone 2 steps ahead. One, it has lowered the bar of GFR to include patients with GFR as low as 25, and it has even included non-diabetics and has extended the benefits to these two populations as well. So these trials have not highlighted any unexpected safety issues with SGLT2 inhibitors and have been found to be relatively quite easy to use, even in the chronic kidney disease population. Thank you very much, and I'll be happy to answer any.
All right, so thank you, Dr. Dinesh, Dr. Manohar, and Dr. A.K. Singh for giving us your insights on how we have evidence to use dapagliflozin and address multiple problems at the same time in individuals with diabetes. So Dr. Manohar, considering all the data and evidence we have today, someone with diabetes who comes to you, who's newly diagnosed, who doesn't need 2 drugs, let's say they need just 1 oral drug, would you still say metformin first, or would you consider the evidence and say, I can prevent all of this, so I can prevent complications, so would I use an SGLT2 inhibitor like DAPA straight away?
I think we are evolving with respect to our management, and even the ACC ACE guidelines also start saying that if there is a high-risk group involved, why not use SGLT2 inhibitors as a first line of drug? Someone is obese, multiple risk factors, strong family history, smoking instead of metformin, why don't we go ahead with the SGLT2 inhibitors? I think we'll do that in the future, time to come.
And Dr. Singh, you were showing us the data from the studies which have shown that conversion from normal glucose tolerance or pre-diabetes to diabetes is much slower in individuals who got dapagliflozin and DAPA-HF. Now, based on that evidence, would you actually consider using dapagliflozin for prevention of diabetes in someone with pre-diabetes? Not talking about heart failure, but just as a molecule for pre-diabetes.
Well, answer is no, because we don't have license, in fact, to use any anti-diabetic drug at the moment to prevent diabetes, despite we have got such humongous data from metformin. We still don't recommend metformin in patients with pre-diabetes unless someone has got both impaired fasting glucose as well as the impaired glucose tolerance. So if someone has got IFG and IGT combined, then you are allowed to use metformin at the moment. You have been given license to use metformin. For the SGLT2, this is a welcome evidence which has emerged from DAPA heart failure trial. However, I would like to reiterate that it was not replicated in the Impera reduced, neither in the Impera preserved trial. So surprising to believe that it is uniquely seen with dapagliflozin, which was not seen in the Impera reduced or even in the Impera preserved. So we do have another trial after the DEPA-HF where the prevention of diabetes was not significantly achieved. In the IMPERIAL reduced trial, there were 12% reduction, in diabetes progression. In contrast to the DEPA-HF, there was 2%, which was highly statistically significant. But in IMPERIAL reduced, although there was reduction by 12%, but it did not achieve a statistical significance. Similarly, in IMPERIAL preserved, published yesterday, there was a hint of prevention of diabetes, but again, it did not achieve a statistical significance. So these are the welcoming data, but not yet to the extent that you can recommend a SGLT2 for the prevention of diabetes.
Thank you. I think that was a very clear answer. To follow up on that, now with DAPA, we have evidence for HFrEF, but the studies with the HFpEF are ongoing, and we have the Emperor Preserve data out. So if we see a patient with heart failure, would you extrapolate and say that you probably get the same results with the DAPA even with the preserved ejection fraction, or would you consider using a different SGLT2 which has the evidence for HFpEF?
So we always go by the evidence, and you may theoretically suppose that DEPA may have a similar result in their respective preserved ejection fraction trial, which is delivered, but then you need to deliver the result first, right? So we expect that there should be a similar kind of benefit, or maybe that the deliver may outbeats even the IMPERIAL preserved if they show a significant reduction in cardiovascular death or all-cause death, which the IMPERIAL preserved could not. So it's not a matter of putting drug B at the place of drug A. Maybe it can happen that might deliver a similar result in the composite of CV death and HF, and maybe it can also deliver that if there is an additional cardiovascular death and all-cause death reduction, which even IMPERIAL preserve could not show. So we don't know exactly at the moment, and it is also possible that deliver may not deliver anything, and the trial becomes neutral without any benefit. So everything is a matter of conjecture unless the trial results come into the place. I do not see in that way that I put as a class effect. Every molecule has to undergo into the race. We expect that Sachin Tendulkar's son would be playing like a Sachin Tendulkar, but it had not happened with Rohan Gavaskar as the Sunil Gavaskar was playing. So you can theoretically assume, but on paper, you need to show the evidence.
So thank you for that answer. So Dr. Kular, as a nephrologist, from your point of view, could you give us your thoughts on the safety of dapagliflozin and CKD? You've already shown us the data with the trials, but several physicians, they're still worried to use dapagliflozin as the GFR comes down. So please give us your thoughts on this once again.
So, well, you see, that's a very important and interesting question. We are, of course, going to expect some physiological decline in GFR, but I think what I would want to emphasize on, only those who actually show this reduction are probably going to benefit the maximum. The same was true for RAS blockers as well. So rather than being overly worried about what has happened to the GFR initially, I think we should have the confidence in the molecule so as to be able to continue it for a longer period of time. Of course, we have the responsibility of educating our patients to get their GFR rechecked at an interval to make sure that there's not a very constant fall in the GFR, in which you have to think otherwise. But you will have to probably counsel your patients, and I would want to do that to my fellow physicians as well, that such a decline should not hold you back from introducing dapagliflozin or any SGLT2 inhibitor for that matter. Problem arises when you are already on the verge of, your patient is on the verge of requiring dialysis, typically already in the stage 4. If we go by DAPA CKD result, even have the inclination to, once the regulatory authorities allow us, to initiate these patients on SGLT2 inhibitors, even at a GFR of something like 26, 27. The moment you do that, the GFR is going to fall to about 20. But the good thing is what we have learned from the various trials, it is probably going to stay at that level at probably for a longer period of time. And you may not actually be allowing your patient to reach end-stage kidney disease for a longer period of time as compared to the situation where you had not put them on SGLT2 inhibitors. Regarding the other safety, I don't think we, and including Credence trial, raised any safety concerns even in patients with more advanced chronic kidney disease who were put on SGLT2 inhibitors. So we were skeptical about the efficacy. We have two big trials, including Credence and DAPA-CKD, have shown that these are efficacious even in patients with more advanced CKD. And about the safety factors, I think we can have some consolation that none of these have shown any significant safety concerns, even in patients with more advanced CKD.
Thank you. Dr. Manohar or Dr. A.K. Singh, I'd like to hear both of your views on this. Now, all the data that we have for heart failure, for reduction of CKD events, and so on, is all with 10 milligrams of dapagliflozin. So why is 5 milligrams even available today and marketed when the evidence for reduction of complications and reducing events is all with 10 mg? So either of you can take it. Dr. A.K. Singh first, as I see your video is on. So Dr. Manohar is probably around. You're on mute.
Yeah.
Yes.
Okay. So yeah, that's a good question. I don't know. I don't feel where the 5 milligram dapagliflozin is at the moment available and what's the use of this. But then they brought it in the beginning when we didn't have the result from their cardiovascular or heart failure or renal outcome trial. And initially, the SGLT2 inhibitor was primarily used for the treatment of diabetes. Now, over the time being, from anti-diabetes drug, it went to the cardiologist, then it came back to the nephrologist, everyone claiming that this is their drug. Now, cardiologists and nephrologists say, hello, why you need you are an endocrinologist and diabetes people just need a drug to reduce diabetes. These are the drugs which prevent kidney and heart disease. So these are cardiorenal drug rather than anti-diabetes drug. In fact, Bruce Neal wrote an editorial in JAMA and saying that this is the cardiovascular drug which has got also an ability to reduce blood glucose. Now, so the ball is rolling into everyone's court diamond again. What happened yesterday in the Emperor Preserve trial? That there was no benefit in the renal endpoint despite having benefit in the cardiovascular endpoint. Now earlier, prior to the Emperor Preserve, there was a classical thought and learning that the benefit in the cardiovascular endpoint is happening through the kidney because this drug is working directly on the SGLT2 in kidney. So this drug primarily is a kidney drug, not a heart drug. And entire benefit in heart failure is primarily derived from the benefit in the kidney. Now, by results from Emperor Preserve, where we didn't have any renal advantage and yet there was a reduction in the composite of heart failure and CV death, this proves that the drug works directly on the heart and not really it is mediating through the kidney. The kidney outcome might be different from the renal outcome. So every time and again we are learning things, how SGLT2 is moving forward. So the scope of 5 milligram is limited. The data is entirely with the 10 milligram of dapagliflozin. I still believe that perhaps 5 milligram will be gradually withdrawn from the DAPA makers.
Thank you. And I also thank you for sharing that recent data of dapagliflozin reducing sudden cardiac death and arrhythmias, because we've always focused on heart failure and renal endpoints, and sudden cardiac death is a problem that patients with IHD and heart failure have. So not necessarily those with advanced heart failure, even those with stage 1, stage 2 NYHA heart failure also can have this. So I think that is important data that you shared as well with us. So any last thoughts before we end this session, Dr. Kular?
No, I think I would totally agree with Dr. A.K. Singh. We nephrologists were very eagerly awaiting the results of Emperor Preserved, because you see a big chunk of renal patients have heart failure with preserved ejection fraction, and we were wanting to know what would be the outcome. So a little disappointing, but I'm sure probably the post-hoc analysis will have some, the way we had with the Arni as well. So let's see, let's hope if something important comes out of it. But I think most of the things, as far as where the SGLT2 inhibitors stand as of today in with regards to the cardiac dysfunction and the renal dysfunction, have been covered. And just in case there are any other questions, I'll be happy to take. I don't think the time is going to allow us any more questions though.
I think we have run out of time now. So thank you very much, Dr. Pullar, Dr. A.K. Singh, Dr. Manohar. All three of you gave excellent talks on how dapagliflozin can be placed in clinical practice for treatment of diabetes, heart failure, and to reduce CKD progression as well. So thank you all very much. And we now move on to the next session. I see that Dr. Manoj Chawla has already joined us. This is a Pharma Symposia, which is being sponsored by Eli Lilly. And I now request Dr. Manoj Chawla from Mumbai, from the Lina Diabetes Center, to take over the session.
Hi, Bhavna. Thank you, ADA Primer, for inviting me to be a part of this session and moderate this session with some of the stalwarts in the field of diabetes. So we have in our panel today, Dr. Banshi Sabu. I believe Banshi is joined in. Dr. Banshi is the president of RSSDI, chief diabetologist and chairman, Diabetes Care and Hormone Clinic. As we all know him, he doesn't need to be awarded, but he's been one of the most impactful health leaders. Joining Banshi in the panel today is Dr. Supratik Bhattacharya. Supratik is from Kolkata. He's the consultant at the Department of Endocrinology at AMRI, Salt Lake, and Apollo Sugar at Kolkata, and director of the SKN Diabetes and Endocrine Center. Supratik, welcome to the panel. And then we also have Dr. Jyoti Dev, who will be joining us soon if he's, Jyoti is here already.
I'm here.
Great. Yes, Jyoti. I've seen your message and great. Jyoti is the chairman of Jyoti Dev's Diabetes Research Center, Trivandrum, Kochi at Ingal, which is an IDF recognized center of excellence, and as Jyoti is better known as the technology man of India. So I think we can have the presentations go down so we can have all the panelists in the panel discussion. Dr.
Manoj's connectivity is poor.
Yes, sir.
Dr. Banshi. Banshi?
Yes, you may keep your video off and will it be good?
Yeah. I thought there is something wrong with my internet connection.
I think he is coming back. We'll just give him a minute to come.
Me and Manoj both are in same hotel.
Oh, really?
He's staying only in different rooms. I don't know why his connectivity is poor, using the same Wi-Fi.
No, Benshibhai, your Wi-Fi was also not that good. There was an indication. There was an indication between.
Oh no.
Hello in color.
So out of 4, we 2 are not good enough today. So only Bhavna, Jyoti and Supratik, you can start. I can share the screen. I'm sure the Supratik also must be having the slides. You can share the slide and in between we can have the discussion. Will it be okay, Supratik?
Yes, I think that's fine. We can start off by the
Cool.
Dr. Manoj.
Supratik, you can start out sharing this.
Please let me know whenever it's visible, sir. I'm just sharing the slides. Now, I think this, sir, could you please, I'm trying, whoever gets there first. Yes, I've got it, sir. So hopefully it's visible, it's from the last, but
Yes, now it's visible.
Perfect.
Yes, now Manoj is
just back. Yes.
So Manoj, slide is already
Right, sorry.
Dr. Supratik,
Okay, great.
and you can
Somebody
start.
put on the slide. Thank you so much. Am I heard?
Yes,
You're absolutely heard.
Hello.
Yes, Dr. Manoj.
Hello. It's stuck again, man.
I think it is more or less like a discussion with questions and answers as in a panel. So I think we can start the discussion. Supratik, you can start.
Yes, absolutely. So we just wanted to give the disclaimer that, we had all been contacted by Eli Lilly for this particular session. And the first session is going to be on the use of insulins. And we know it's a very pertinent topic because we are now on the 100 years of insulin use, and we want to understand how we have evolved and where we stand at the moment. So this is, I'm sure Dr. Manoj is going to talk about the entire story about how the insulin evolved and where we are at the moment. But before that, I think we'll get to a few questions and learn from Dr. Keshavdev and Dr. Bansi Sabu regarding this use of insulin during this COVID-19 pandemic when we have been using a lot of steroids. So those who have been hospitalized, yes, and also those who have been using home-based therapy where they require oxygenation and, when they're requiring steroids, how did you go about initiating insulin, if at all, and what did you do? So Dr. Jyoti Dev first, please.
Yeah. Manoj, can I? Am I audible, Manoj?
Yeah, please, I'm not sure. I'm having some connectivity issues. Am I heard?
Yeah, now we are okay. Now we are absolutely okay.
You can take it up. Dr. Manoj.
Great. No, thanks, Supratik. Thanks for taking that. So I think we will start with the first set of questions. And Jyoti, please go ahead with the question that Supratik is posting.
Yeah. Supratik, the question was on the use of steroids in the hospital or at home and the control of diabetes during this COVID-19. So I would say that the numbers with diabetes has gone up tremendously. It has gone up in India and maybe all over the world. And when the patient is having an infection and when admitted in the hospital or when the patient is on corticosteroids, the preferable therapy is always with insulin. Always with insulin. And when we are providing insulin to the patient, we need to make sure that they are reaching a target. There is an upper target and there is a lower target. Because during an infection, when the patient is critically ill, because even when there is a mild or a moderate COVID, it is absolutely significant that you should be treating diabetes properly. And even new onset hyperglycemia, NOH, is now proven to have a higher risk in transforming a mild or moderate to a severe form of COVID, and it increases the number of days in the hospital and also increases the mortality. So the use of insulin has to be justified, and preferably we should be going for the rapid acting analog insulin such as Humalog. So Lispro can be given multiple times daily. It need not be just 3 times daily because it has got a very short duration of action of 4 to 5 hours. And we can perform either a frequent SMPG, self-monitoring of blood glucose, or we can have the hospital use a continuous glucose monitoring device because CGM is also now approved for use. Of course, it is not approved for use in the hospitals, but even in the US, there is an emergency use authorization for continuous glucose monitoring in COVID-19 patients. Of course, we need to adjust it along with the glucose meter reading. But the key take-home point is when the patient is on corticosteroids, when the patient is having an infection, more frequent use of a rapid-acting analog insulin should be promoted. Why we are overemphasizing this. Very often the human insulins are being used, regular insulins are being used, and either the patient will have persistent hyperglycemia or they will go for a hyperglycemia. So since the pandemic is continuing, we need to be more updated in the use of insulins during this pandemic. Benshi-bhai?
Supratik, can I request you to take the slide, one or two slides back? Yes. So I think no. So the next one.
Yeah. One after
no, the
this.
one with the type 1, type 2 challenges. Yes, the one after this.
Okay.
After this.
Yes. Okay. So and Supratik took us through the fact about the discovery of insulin, the progress, and where we've reached. And still, after 100 years of discovery of insulin, we're still very often caught up with the situation of multiple challenges, both for type 1, which are different challenges, and type 2. And our next set of questions to all the panelists are based on the same aspect. So let me start by asking Dr. Bansi. Bansi, what are the challenges that you find associated with management of type 1? Dr. Bansi does a lot of type 1 work, so an appropriate question for what kind of challenges do you come across that? Bansi?
Thank you, Manoj, first of all, asking for this. Thanks the ADA Primer team for giving me an opportunity. I'm really honored with all of you that I've been here as an expert panel for this. There are multiple challenges for type 1 in our country. The challenges are from the availability and access to the insulin for a type 1 child to the what they are getting the insulin. Many of our patients of type 1 who are getting treatment from primary care physicians, pediatricians and physicians, and still they are writing them on a premix insulin. The biggest problem with premix insulin when somebody is writing to this type 1 child, neither child is getting hypoglycemia, nor they develop the diabetic ketoacidosis. So the patient, the caregivers, as well as the doctors, they all feel that the sugar is okay or the patient is fine. But the average HbA1c of these patients is around 8.5 to 9.5. And some of these centers who are taken care by this primary care physician, even their A1c are more than 10 or 10.5. Now what happens? The first 15 years or 10 years of a type 1 child, they may not develop a lot of complication, but they develop complication once it is after 10 or 15 or 20 years. And this is the time when these children, neither they are now no more child, they are young adolescents. They might be going to the physician or a diabetologist or endocrinologist, and you and me might be seeing them as in tertiary care center. And we see them with a lot of complication. So there are multiple challenges in type 1. We understand that what type of insulin, but for all primary care physicians, at least what they can do, first the insulin supply that should be secured. And then second thing, they should be on basal bolus insulin therapy. These two minimum things should be given at least. And the third is the self-monitoring of blood glucose with a regular A1C monitoring for these children is very important. SMBG is also very, very poorly monitored these children, and that's the reason their A1C is never under control. So with multiple challenges, I'm just talking about the two is the basal bolus therapy and second about the monitoring. With that, definitely they should have the availability of insulin and they should have access for insulin also.
So thanks, Bansi. I think it's not fair to ask a broader question like that, that what are the challenges in type 1? I'm sure there are many at every stage that you have challenges for the type 1 individual with diabetes. So let me ask Supratik, and again, let me start thanking Supratik for doing this. And I'm still not sure if I have a problem with the network. And if I do, I'm sure you'll take it from there. So, as we can see here, one of the things that Lilly did and provided us was with the QuickPen Junior, the only probably device to have that 0.5 unit ability to be able to use the 0.5 unit dose. So how much do you think this 0.5 unit precision dosing can actually help in the management, especially from type 1 point of view?
Thank you so much, Dr. Manoj, for this question. I think it's very pertinent. As Dr. Bansi was very correctly saying that we are not even optimally getting to the targets where we should be, what should be achieved for these individuals with type 1 diabetes. And we know that these are young individuals who have very active life. They'll be playing, and like you need to be very precise. So you can't afford any hypoglycemia in these particular individuals. So it needs to be customized. And before this, we really the conventional pens that were meant for the older individuals, like they had only a setting which could be increased in the increments of 1. So that is now that, and also the size of the needle was slightly thicker. So with this particular pen, I think it's very customized for the younger individuals, because the pain is less, the prick is very easy. The up titration is very precise, so you are avoiding any hypoglycemia at all. So I think it's a boon for any of these young type 1 diabetic individuals.
Thanks, Supratik. So Dr. Jyoti, your thoughts on the same before I ask you the direct question, that this 0.5 unit dosing, have you been using it and do you find that helpful, especially in younger children?
To me, Manoj?
Yes, Jyoti.
Yeah, I have been using, Dr. Manoj. I have been using, because 0.5 units is found to be extremely useful, especially in children below the age of 12 years. And we have found that the parents will keep on asking, because all of those children cannot, of course, they cannot afford an insulin pump, because insulin pump is very expensive. And there are many children who will develop a hyperglycemia or a hyperglycemia if the dose is less or more. So in those cases, they require 1.5 or 2.5, or sometimes just 0.5 units. In the beginning of diabetes, maybe for the first 1 or 2 years of diagnosis of type 1 diabetes, I have many children requiring only 0.5 units of insulin before every main meal or before a snack. So this QuickPen Junior with 0.5 dosing, I think it need to be much more popularized, because in our state in Kerala, the government is providing Humalog to more than 50% of the population. Of course, Benchipa is also supported with RSSDA. So Humalog is being provided by the government, but not to everybody, but I think maybe 50% are getting it. But this QuickPen Junior, they are not getting it free. And many of them are getting it from us. And this is currently only a disposable unit. It is not a durable device. And Benchipa is also helping a lot all over India with the RSSD initiative of providing the analog insulins and other diabetes supplies to children with type 1 diabetes. So I need to remember this in this occasion.
Thank you, Jyoti. Thank you. One more, Manoj, I want to add here. There are some children where the requirement of insulin is very, very low. And sometimes with a small amount of the snack, they need only 0.5 unit to be given. So there also this 0.5, Humalog Junior is very, very useful. Their total daily requirement is hardly 10 units. Out of them, 4 or 5 units is with the longer acting insulin, and short acting insulin, they may be given 1.5 before breakfast, 1.5, then again 0.5, then again 1 unit or 1.5 again at dinner time. And sometimes for them, correction dose or with a small amount of the carbs which they are eating, their requirement may be only 0.5 units. So I mean, this 0.5 unit availability in our country itself is very good, because before that we used to have a junior pen, but it used to be imported. It was not available in our country.
True. So I think
I want to highlight, Dr. Manoj, and this topic is very, very close to Dr. Bansi's heart and this type 1 diabetes, and he has been doing so much on this. But on the other end of the spectrum, like frail individuals, elderly individuals, where the chance of hypoglycemia is very much, and also with cases, like with renally compromised patient or somebody with a liver disease, where you need to very precisely up titrate or down titrate the dose. I think this will come very handy.
Yes,
absolutely, Supratik. So yes, I think in the aspect on the special situations which we were come to this. So thanks for already answering some of those questions, and absolutely right with this 0.5 does have. So I haven't landed up using much of 0.5 as in only 0.5, but the fact that you have the half dose ability, a lot of patients in the younger segment where you're able to use a 1.5 or a 2.5, I think the usage of that is far more important sometimes than just the fact that it's 0.5, because in 0.5, extremely young children, maybe some of them, very often the question is when you're actually injecting 0.5, how much dose is the individual really getting? But the fact that you can use 2.5, 3.5, 4.5, and fine-tune it, especially in patients with kidney disease and as Supratik said, and young children, I think is a boon. So let me ask the next question to Jyoti, and all of you are welcome to contribute here. So, we struggle and there are challenges with management of type 1. Any innovative thoughts or means, Dr. Jyoti Dev, that you would say, which can be used in our country to improve the glycemic status of individuals with type 1 diabetes, especially children and adolescents?
It is a billion-dollar question. So the question itself implies that the control is still poor, and that has been highlighted by Venshibai, Supratik, and Manoj already. So I will say that it should start from the diagnosis of diabetes. Because when Venshibai was discussing about the basal bolus therapy, even today morning, I happened to see via telemedicine a newly diagnosed patient, 8-year-old, started on premix insulin twice daily, and that was by a specialist. So my suggestion is we need to have an education for everybody, for general practitioners, for diabetologists, for physicians, and also endocrinologists. Also endocrine, because diabetes as a topic is underrepresented in all the curricula. So it should start from our syllabus. And number two, at the time of diagnosis of diabetes, the doctor, the nurse, we should spend sufficient time with the family, and there should be an ongoing process. And they should have a personalized attention. And the third thing is to improve the care. If you look at most of the deaths in type 1 diabetes, most of these deaths have happened in those families where they have kept it as a secret. So they should be part of the type 1 diabetes community. They should share the thoughts with each other, and they should share the secret with all the family members and also with the school. And then with your question, precise question on the use of technologies, the cost-effective technologies, like the pen that we discussed, the junior pen, the Humira junior pen, the quick pen with 0.5 dosing, the use of some mobile health applications, which are cheaper or which are available at no extra cost, along with glucose meters. And if possible, at least intermittent use of a continuous glucose monitoring device. So the patient should be taught on the use of technologies, preferably cheaper and with no extra expenses from the beginning onwards. And a supportive system, like RSSD is doing, for example, at least once in 6 months, a hemoglobin A1C to be done. And then every time the patient is visiting or having a consultation, an ongoing process where at least one topic will be discussed on education. It can be injection techniques, or it can be glucose monitoring technology, or it can be a counseling for their anger. So something structure should keep on as an educational in different modules, and during each visit, it should be executed. So these are some of the thoughts, but of course, we can talk about this topic for hours together, but something need to be urgently done.
Great. Thank you, Jyoti. So that let me move on to the aspect of insulin and type 2. So we spoke about type 1. Type 2 is another challenge itself. So let me start by asking Dr. Bansi about, when you talk about type 2 and insulinization, and we were speaking about this some time back, basal versus premix. What do you really think is the right approach, especially in the Indian Asian population, keeping everything in background? And I'll let you speak what that background and the typical characteristic in the Indian diet is. So what do you think should be the right way?
So Manoj, again, to decide between a premix insulin versus basal insulin. Now all international guidelines, including RSSDI also, supporting the initiation of insulin should be given basal insulin. There are multiple advantages to start with, but here I just wanted to tell you some of the things where we can start, or we should start with the patient to straightway with a premix insulin also. Now, why we should do in particularly in Asian Indians or Asian countries, a premix insulin to be initiated, one of the reasons is our carb content in our diet is very high. That's number one. Our postprandial hyperglycemia is a major challenge in compared to the fasting. Now, this we cannot decide only on A1C. Suppose you have two different type of patients whose A1C is 8.5 and both are to be started with insulin. You may find in India, particularly a patient with 8.5 A1C with a fasting plasma glucose of 120 only, with a postprandial glucose level of 230. Now, there is no point of starting these patients only on basal insulin. And I'm sure even if you start with this patient in basal insulin, you may not increase the dose more than 8 or 10 units because ultimately this patient will go in hypoglycemia. The postprandial will never get controlled by just by adding 8 units of insulin. This patient requires a bolus supplement also. Now, these type of patients, when you see the glycemic, variability completely, you know the complete graph that how the patient fasting and post-meal glucose are there. These are the patients who can be given straightway with the premix insulin also. Now, premix insulin also comes in a co-formulation, which is available in our country. Or you can start with a basal plus, or you can have a premix, which is available with us 25-75 or 50-50 to start with these patients also. So it depends on what type of patient which you are seeing, what is his A1C, what is fasting post-meal glucose level. I will not go only with one post-meal. It could be post-lunch, post-breakfast, and post-dinner also. And that will decide my dosing. That will decide what type of insulin I can initiate with these patients. Yes, definitely initiating the patient on a basal and then going with basal plus or basal bolus, it becomes much easier and your intensification is also much comfortable in compared to that flexibility which you get in that, which may not be there with the premix insulin. But yes, still it is useful in many of our patients whose post-meal glucose level is initially very high, and they can be started with premix insulin also with pre-breakfast, pre-lunch or pre-dinner depending on the sugar. But I strongly not to advise to start with premix insulin for a type 1 child. They should be always given a flexibility of putting them on a basal bolus insulin only.
Sure. Thank you, Mansi, for clarifying that. Before you said the thing, then I thought it was a very diplomatic answer all the way, but then you clarified in the end the specific places and of course the important aspect of the fact that in type 1, especially children, not to use premix, either the basal bolus or even a split mix is okay because it gives them the flexibility of fine-tuning the dose. Let me take the next question to Supratik. Supratik, human insulins and analogs, is this just made too much out of really nothing, or the actual pharmacokinetic property of an analog insulin has that kind of advantage, and where do you really see the usage of analogs over human insulins?
So I will be least diplomatic in this, and I say that since the time the analog insulin has been available, I have stopped using human insulin for certain reasons. So let me clarify: insulin is insulin when it comes to reducing the glycemia to the targets. Whether it's human or analog insulin, both do their job equally well. What I'm concerned as a doctor is the welfare of the patient in terms of not having hypoglycemia, especially nocturnal hypoglycemia, which becomes a concern. We know that analog insulins mix body's physiology of insulin secretion, and so that is why, as a physician, I'm relieved because I don't expect too many phone calls at the middle of the night saying that I'm having an episode of hypoglycemia. And nocturnal hypoglycemia is a big challenge for any physician or patient to handle. So since that, saying that, as I've said, I have stopped using human insulins unless somebody actually comes back and says that, I cannot afford analog insulins, or for a fact that if they had been on human insulins for a very long time and they want to continue, it's only then that I continue with the human insulins. But for initiating, it's only analog insulins.
Great. So, Supratik, a question as follow to that, and this is a practical thing. And type 1 patients, and we train them to be more involved in their care, and they are the ones living with themselves. So they are actually the masters of what they should be doing. We can only be guided once in a while that we meet. So I've seen a couple of patients and their families involved with them have devised the way that they take a analog insulin. Those who are on basal bolus at breakfast, they'll take the short-acting analog. At dinner, they'll take the short-acting analog. Then they'll take the long-acting glargine or whatever at bedtime. But for lunch, they tend to take the human short-acting because of the duration of action. So those who really want to avoid an extra shot in the evening, because typically the gap in the Indian context between lunch and dinner is huge. Now, of course, there is individualization and improvisation, but that's an interesting aspect that I've seen a couple of patients devise, and especially those who are part of the Juvenile Diabetes Foundation here in Mumbai, somewhere that being advocated, and it's actually worked for them. So any thoughts from either of you on this kind of different strategies that people use?
So I think, we keep on improvising based on the results that we get. One big challenge is the timing of the insulin. With the human insulins, you need to give it at least, say, 20 minutes in advance. You have to calculate that time. And with analog insulins, you can just give it prior to the meal, which is a boon. And even you can, if say you have missed it, you can finish your meal and then give it after the meal as well. So you have that window period of opportunity where you can actually use this insulin, which is not there with human insulins. But I can understand the rationale why you can use a human short-acting insulin, which will cover the next meal, which is going to be closer to the lunch. However, if you ask me, I do not use that in my clinical practice. So I can understand where they're coming from, but that's not my practice.
I do agree, Dr. Supratik. Dr. Manoj, I have also seen many patients using this, and I have seen the prescriptions also, and I haven't changed, because if you use an electron microscope to go through the ISPAD guidelines, in small prints, this is there in the guidelines. There are some recommendations on the use of a human regular along with analog insulins, and that's because of the longer duration of action for those children who are going to the school. But of course, this is not based on any scientific evidence, but it works in some patients, in some children.
Practical, yeah.
Practical.
Okay, great. Thank you.
With the use of continuous glucose monitoring, you can decide and you can individualize the patient therapy also. Like the some patients who may do well with the putting them on a regular insulin, just their post breakfast and post lunch, or the school going children, as you are rightly saying, who are taking within 2 hours, the 2 different snacks in the school they are taking, and you are trying to cover them with a regular acting insulin instead of that short acting insulin analog. And if you put them on a continuous glucose monitoring and you are comfortable by putting that, after that you are seeing there is no peak which is there, you can use it. I mean, that is what. So I think after uses of continuous glucose monitoring, we can become more individualized and we can precisely treat the patients rather than just thinking that, the scientifically this is better or this is better. This is my
absolutely well said. So I think, so, besides the fact that we are in a panel discussion, we are here in a Lilly session, we are discovering their newer insulins. But the fact does remain that there would be many situations. So we clearly know the advantages and the peaks of the analog insulins, but at some places we may still end up using something which is currently considered unconventional, but something which suits the patient. So I'm aware of the time. The organizers have been generous in giving us an hour for this discussion, and we have to discuss the incretins as well. But let me ask the next question on insulin, an important one to Dr. Jyoti Dev. Dr. Jyoti Dev, type 2. Always a challenge to initiate insulin. What is it that you do different, besides the fact that Kerala has 100% literacy, which works in your favor in convincing patients? But what is it that you do different to convincing patients to start insulin type 2? And where do you see the role specifically for these two, the low mix and high mix insulins, the Humalog mix 25 and mix 50, in which situations?
Okay, excellent question. So we are first in literacy, and now we are also first in COVID. So how to convince a patient? So I do the same what all of you are doing, all my colleagues are doing, because it is slightly difficult for us to initiate insulin type 2 diabetes, and there should be a conversation. So usually I go by the science. First of all, I will decide upon how much the patient is educated, number 1. Number 2 is basic knowledge on diabetes, whether he has got a basic knowledge or not. Number 3 is attitude. So 3 or 4 basic assessments, and then we start the conversation. That is again customized. If the patient is not at all knowledgeable about diabetes, then I have to spend a little more time, and my diabetes educator will also spend some time. And if everything is okay, then we will start discussing about how diabetes occurs and the beta cell population and 1 billion to start with. And the diagnosis of diabetes itself could be delayed. And now it is almost 7 years of diabetes, and there could be a further decline in the beta cell. So I will simply draw a picture and will show that almost 50 to 70% of beta cells have already declined in mass and in function. So it is not functioning well. And this has happened at the time of diagnosis of diabetes itself. And if you are delaying and delaying and delaying insulin initiation and only on oral therapies, then this will further decline. And anyway, we have to start insulin. And if I am starting insulin late, then you probably could have already developed a heart attack or a neuropathy or a retinopathy. And I will also stress on sexual dysfunction because that is a very sensitive area. And the acceptability of insulin will be very high if you discuss on a loss of sex or sexual dysfunction rather than discussing on amputation. So that works. So, so if you go by all these scientific aspects, then the acceptability of insulin is very high. And I do agree, Dr. Manoj, on premix. If I am discussing on a Humalog mix 25-75 or a 50-50, and that also need to be customized. Since in India, usually the insulin initiation is also delayed, and the patient is already on a maximal dosage of sulfurias, when, as Dr. Benchipai said, basal insulin alone will be insufficient. And in more than 75 to 80% of our patients requiring insulin type 2 diabetes, they need a premix to start with. So I usually start either with once daily or twice daily, and then keep on titrating once in 3 days or 4 days. So the initiation is quite easy if we can spend at least 3 to 5 minutes more. But the conversation should be customized based on their knowledge in diabetes, their attitude, and their basic education. Manoj, thank you. I think Supratik can.
So do you prefer in some patients using the low mix 24?
Manoj, your voice was breaking.
Am I heard? Hello.
Now you are heard. Can you say it again?
Am I heard now?
Yes, dear. Please say it again.
I said, do you come across patients where you're using the list?
Manoj, we are not listening you.
Hello.
Yes.
I'm not able to hear you. You can switch off the video probably.
Hello.
I think you switch off your video, Manoj, and then on.
Can I be heard, Dr. Jyoti?
Yeah, in between the voice is breaking. The question actually we couldn't hear properly.
Okay. Yeah. Okay. Okay.
Yeah, the question is on the use of different strengths of insulin, I believe. Supratik, I think the question was on 25.
Yeah, that's correct. So I think he would want to ask you which circumstances would you want to use a mix 25 versus a mix 50?
Yeah, of course, in the Indian subpopulation, in the majority of the patients, we use 25/75. So for patients and for doctors, we explain it because 25 will be the regular insulin, which will be acting for the postprandial reduction in the glucose, and the 75 will be the long-acting component. So 75 will be there for a longer period of time, maybe for another 12 hours in the premix. And for 50/50, it is 50% suddenly. So if it is a high in carbohydrate, if the person is having a high carbohydrate diet, and if the postprandial excursions are more, they may require more of regular. I mean, a rapid-acting insulin will be required more in dosage. So then I will go for a 50/50, and then I can use a metformin or a gliptin along with this. And Lilly insulins, we have different options. So we have 25/75, we have 50/50, and for the human premix, that is human insulin, we have even 30/70. And the good thing about Lilly is all the strengths are available, the disposable devices are available, and that is in the QuickPen, all these insulins are available in QuickPen as well. And that is one of the most advanced delivery systems for insulin. Very user-friendly and convenient to use.
Supratik, you can take the next slide.
Yeah, please.
I think we'll move on. So I think we have been already talking about special circumstances, like we already talked about, use of steroids during this COVID pandemic and how to use the insulin and how to initiate and modify. Again, choosing the right insulin in the CKD, CLD patients. So I'll ask Dr. Bansi Sabu to throw some light on what particular regime would you prefer? Would be a
We have
basic
already
bolus?
talked about the low dose or the 0.5 unit, which is available to us, and sometimes it is useful in the patient with CKD and CLD also, where the requirement may be low and still we have to up-titrate the dose with 0.5 unit. With a patient with CKD and CLD, again, the recommendation will be the basal bolus. The requirement will be the short-acting insulin analog will be higher in compared to the longer-acting insulin. So the premixed insulin will not work, rather it will cause more hypoglycemia. And again, it is not strongly, I will say, it is not recommended. We should go with the basal and bolus only, try to fix the fasting, and also simultaneously post-breakfast, post-lunch and post-dinner to titrate the dose of short-acting insulin analog before breakfast, before lunch and before dinner. Again, I will agree with Jyoti that we should not restrict only with 3 doses. Sometimes they require 4 or 5 shots, like in the steroid-induced hyperglycemia. Now,
sorry.
all this is a tight glycemic monitoring also for getting a tight glycemic control. So many of our patients are not monitoring very regularly, self-monitoring, and with the use of continuous glucose monitoring, now I think we are reaching to more of precisely treating the patient, individualizing the treating the patients and achieving a tighter glycemic control. In GDM patient, also in very special situation, where also we require a bolus or the short-acting insulin analog to control their post-meal glucose, because they also a condition which is requiring more of a post-meal glucose control, require more control in compared to the fasting, because their PPG is a major challenge for these patients. Sorry, Manoj.
Thank you. No, thank you. I think it's my network. Can we move ahead? I think we spent a lot of time on insulin, so we'll move ahead. Supratik, can you show the next slide?
Yeah, so we'll move on to the next one.
Yes. Yeah.
Shall I move on?
Yeah, so we'll just spend half a minute that, we are going to be talking about incretins. Of course, everybody here realizes the fact that in patients, especially with type 2 diabetes, you have reduced incretin effect and the multifactorial benefits that GLP-1 receptor analog therapies have in trying to change that pathophysiological defect as seen here in this presentation also. Next. No, so yes. So I think also there's been great evidence for when we talk about the usage and benefits of the once weekly dulaglutide Trulicity. Great evidence shown in terms of its HbA1c reduction capacity, the efficacy, and this is in multiple trials, head-to-head clinical trials. Also, when you look at the weight benefits besides A1C, in head-on trials, even with liraglutide, it has shown comparable weight reduction. In fact, in this study shown here, the difference best compared to weight reduction in Trulicity 1.5 vis-a-vis liraglutide 1.8 was just 700 grams. Again, to remember that hardly some of the patients in India end up using 1.8, it's 0.6 to 1.2, which is the average usage. So the weight reduction benefit clearly seems to be as much, if not better, than the other GLP-1s, and so is the efficacy data. So we hold on to this slide and we start our questions on the incretin aspects. And let me again start by asking Dr. Bansi the first question here, that factors that really influence the A1C lowering in patients with type 2 diabetes, which is, you have patients baseline A1C, what other therapies they are on, whether it's SGLTs, SU, basal insulin, etc. If you could comment on the durability of glycemic control in patients with type 2 diabetes in real life. So what really are the factors which make you choose a particular therapy, and how much importance should we be giving to the durability of each of these drug options? Bansi.
Of all, what are the factors? If you see our RSSDI guideline, we made it, from ABCD EFGH approach. The age of the patient is important, deciding the how tight control you need for a patient. The B is for BMI. So the BMI is also the deciding factor which therapy you should start with the patient. If the higher the BMI, you would like to add the molecule which will not further increase the weight, rather it should help you to decrease the weight. The C is the CKD status of the patient. What is the EGFR? That will also decide your therapy and also adjust the dose which is there. The duration, D is for the duration of diabetes. If someone who is at diabetes of duration of more than 10 years, 15 years, and already on the 2-sulfonylurea, there is no point of now further increasing the dose of the multiple molecules or not adding these patients on insulin. The E is for the established cardiovascular disease. If somebody is having ECVD, established cardiovascular disease, then definitely use the molecule which are to be given to these patients like GLP-1 and SGLT2 have a proven benefit for CVD. Then EFG, E for F is the financial condition of the patient, which is very, very important, because unless the patient is affording, you can't use these newer molecules. And the GLP-1, as you know, that's very costly, but at the same time, they are very beneficial. But the financial condition of the patient is also very important. And G is the glycemic variability. Overall GV or the glycemic status, or how much A1C is there. What you talked about the baseline A1C. If somebody is with the 9 A1C, you will start with a dual or triple drug therapy instead of waiting for adding one and then you will wait for the second one. And the H is the hypoglycemia risk for the patient. So all these factors are very, very important to decide the therapy, A to like H. And the one important thing which you asked about the durability of the medication. Now, what I had seen, it is the glycemic control. If somebody is having a uncontrolled diabetes, he will lose, the efficacy of the molecules earlier, because the glucotoxicity itself will have the beta cell failure earlier, rather than if somebody is keeping a very early and tight glycemic control from day one. Probably the same molecule can be effective for another 2 years, 4 years, or 5 years. But what we had seen, the GLP-based therapy or the SGLT2 found to have more durable in compared to the molecules like sulfonylurea or the other molecules. But definitely the glitazone is also very durable, but it depends on what molecules where you are using. But I always believe that early and tight glycemic control is more important to make the whatever therapy which you are using, it will become more durable.
I think it's difficult to pose questions to Bansi because he's so eager to explain and teach, and is a walking, talking encyclopedia currently that he may cover the whole circle of RSSDI and give us that information. Thanks, Bansi, and emphasizing on the durability aspect. So Pratik, the next question to you on really the dosage of GLP-1. So what really are the doses that you see around of different GLPs being used in real life? And whether the benefits, whether it is A1C or weight reduction, are they dose dependent when it comes to GLP-1 RA therapy?
Yeah, so I think it's a very pertinent question. I think we have only access to, at the moment, liraglutide. Lixisenatide was supposed to be a once daily molecule. However, it didn't do too well because of the n number of reasons that we can talk about. But honestly speaking, now we have liraglutide, which is a once daily injection, versus once weekly injection, which is dulaglutide. And the conventional doses, as you had been mentioning, we hardly get to see anybody tolerating a dose of liraglutide more than 1.2. It becomes difficult to push somebody beyond that. However, the tolerability with 1.5 dulaglutide is very good. And we have not only comparable drop in the HbA1c and body weight with dulaglutide once weekly, but the acceptability of the molecule is very high, and so is the adherence to the therapy. So I believe that was your question.
Yes, Supratik, thanks. And I'll take the next one to Jyoti, and we'll request all for crisp answers as we need to cover some more before our time's up. Jyoti, your thoughts on the GLP class per se, and do you believe they should come before insulin?
I'm a very, very strong believer of GLP. Because the GLP-1s have an action specifically on atherosclerosis, whereas the SGLT inhibitors have a hemodynamic action. And hence, this is more durable. As Dr. Benchibai was telling, this is a more durable therapy. And GLP-1, apart from glucose lowering and apart from body weight reduction, there are GLP-1 receptors in the brain. So via POMC cut neurons, it enhances the satiety, and it has got some action in Parkinson's disease and Alzheimer's disease. And of course, these are ongoing clinical trials. So there are a pleiotropic benefits which are apart from in type 2 diabetes. So I think GLP-1 should be given, if possible, before insulin or along with the basal insulin. So, and if you consider dulaglutide, this is one GLP which has been proven to have a benefit very early in the disease, both for primary and secondary prevention. So I prefer that this need to be provided early in the course of diabetes in affordable and eligible subjects.
Thanks, Jyoti. You seem to have read the mind of the presentation, because that's our next slide. And Supratik, if you can take us to the next one. So Jyoti brought up this aspect on the cardiovascular outcome trial data. And we know that this is what we saw in REWIND, where Trulicity was used on top of care compared to placebo, that there was relative risk of 3 pace reduction, 3-point MACE was reduced by 12%. And the difference between the cardiovascular outcome trials for most of the GLP-1s, as we understand, has been the population included in the study. In the REWIND trial, majority of the patients had only risk factors and not established cardiovascular disease. And that was the reason that the study lasted for that long duration of 5.4 years. But in spite of having a primary prevention population, you could still see the reduction in 3-point MACE by 12%. Now, all of us who've been following the CVOTs, whether it's for SGLT2 or GLP-1s, know that this would be difficult in a primary population. So it's a great achievement for the drug in itself. So which gets me to the next set of questions to our experts. And let me start this time by asking Dr. Jyoti Dev, that do we see more patients with cardiovascular disease or more patients with risk factors in our routine clinical practice? And is there any need to stratify our type 2 patients when seen in OPD based on their cardiovascular risk?
So I'll be very brief. So if possible, we can use a risk calculator like QRIS-3. And if you approximately go by the numbers, it will be something like 70-30. So 70% of the patients will have a high risk and 30% will be the number with already established cardiovascular disease. So if you go by a risk calculator, then your primary objective in treating diabetes should be in preventing either a primary cardiovascular event or a subsequent cardiovascular event. And that can be a CV event or that can be a chronic kidney disease. Because if you look at the numbers of diabetes in India and the millions of those patients developing complications, it is so unfortunate that they are still, even after all these therapies and technologies being available in our country, millions are still developing the complications. And once we have the established clinical practice guidelines from national and international organizations, and they have already endorsed the use of the proven GLP-1 receptor agonists. So that includes dulaglutide to be used in diabetes in high-risk population. It need not be those who have already developed the disease, but in high-risk population. So it makes sense that we should be assessing the risk and providing the appropriate therapy, which includes medications such as Trulicity for our patients with type 2 diabetes.
Can I request you to stop sharing? I think we don't have too many slides to show, so we can take it in the gallery form and where. Yes, great. Thank you so much. So then let me ask the next question. And if you're getting any questions from the delegates joining in, would ask the organizers to throw that as well. Yes, Sanjay, thanks. So, Pratik, the next quick question to you. This I already mentioned that. Sorry for the introduction. This long duration, 5.4 years, is it relevant from the cardiovascular outcome study point of view?
Yeah. So this cardiovascular outcome trials are very different from the ones that are done for the glycemia, and like these are event-driven trials, and that's why the duration was less, because we recruited less number of patients with established cardiovascular disease, but more with a background of cardiovascular risk. So this very closely simulates our clinical practice. And that is why, based on the numbers that came from REWIND, they've got a label update. So this is the only molecule which has got approved, approval for use for primary prevention of cardiovascular disease, and which is excellent because we are moving away from secondary prevention to primary prevention. So I think we have only evidence with once weekly dulaglutide, which we do not have with liraglutide or even semaglutide, which has failed to show any benefits when it comes to primary prevention.
Thanks, Supratik. Now, one of the dilemmas very often that we are caught up in is treating patients with diabetes and chronic kidney disease, especially in the moderate kidney disease segment. SGLT2 inhibitors, great evidence in renal endpoints, can't be used below a GFR of 30. You can continue, but you can't initiate for sure. So Bansi, the question to you, dulaglutide, Trulicity, how comfortable are you in using it with patients with CRF? Until what GFR is it approved to be used for our audience to understand that?
Use it, but the issue is that, patients with CKD, particularly they may have nausea, they may have uremic symptoms, and many of the times they're already not eating well. So mostly I don't use it when eGFR goes less than 30, even if it is indicated. But yes, in stage 3 to 4 CKD, it can be used, particularly dulaglutide had shown the data where it had been used in the patient where eGFR even less than 30 also. But in clinical situation, in our day-to-day clinical practice, we would like to use in the patient with CKD where the sugar problem, post-meal glucose control is a major issue, and you don't have the issue of nausea or the person is not having the uremic symptoms.
Great, thanks. So just for the information for everybody joining in, Trulicity is approved to be used till a GFR of 15. Can be considered in patients, as Bansi said, who do not have issues with GI side effects and nausea. Jyoti, the question to you, chat box, comments on biosimilar GLP-1 analogs.
Okay, it's a very difficult question. Anyway,
I was also scratching. Do we have biosimilar GLP-1? So
yeah, there is a biosimilar coming up. I know, because one of the earlier GLP-1s, it is more than 12 years old now. So biosimilar, like any other biosimilar for insulin or for the generic drugs, ultimately, if the manufacturer is convincing and there is a credible history, probably it will also get established, because cost has been the major limiting factor for the use of GLP-1. It is not the GI side effect, it is the cost. Because people might start it, but they may not continue it. So with the availability of biosimilars, I believe that not only the biosimilars will get established, the original molecules will also get established at large. So they will also become more popular. So that is my opinion. Yeah, thank you.
Fair. I think biosimilars do have their place, and we'll have to really see in this segment. Supratik, an important question to you as we come towards the end of this discussion. We always keep talking about cost of GLP-1 receptor analog therapy and India in a self-pay market. But besides cost, what are the other reasons that you come across as a reason for people not continuing GLP-1 therapy or stopping it? You are a great GLP-1 user, so I want you to share your experience. Is GI side effects an issue, or there are some other aspects you want to tell us about?
Yeah, so I think the one thing that attracts people is, the once weekly option. So whenever you talk, give the option of once weekly versus once daily, anybody is going to choose a once weekly option. If you have data saying, it's from your clinical practice, saying that one has a lesser side effect, GI side effect, and better tolerability as compared to the other, that is also helpful. Second thing is, one of the reasons where you can convince the person that the initial cost of therapy does not translate into how your total expense is going to be in future, because your quality of life, the kind of complications that you might develop if you're not using the molecule at a later date, the cost of hospitalizations, all of these will incur additional costs. So I think these are the kind of things that needs to be taken into consideration besides the initial cost of the therapy.
Okay, we have a question. Thanks. So we have a question in the chat box, which I think is Sanjay's question, and he's trying to put it as somebody else's question, which is when are we moving away from injectables for diabetes?
I have.
Anyway, Manoj, I will have a quick answer to this. Anyway,
when are we moving away from
insulins are to be there for long. Of course, the oral peptides are going to get launched very soon. but tirzepatide is going to be there, and that is again injectable, a dual agonist of GIP and GLP-1. So a lot of newer drugs in the pipeline. So injections are going to add.
Sanjay, you got to live with injections, so please remember that.
We've been living with 100 years, I think another 100 years. Somebody said ban everything apart from an injectable. So,
sure. So as we are coming close to this end, I want some words of wisdom from all the three panelists about how really do you counsel the patient for GLP therapy in terms of initiating it, in terms of avoidance or minimizing GI side effects and continuing this therapy. Quick short answers from all three. Supratik, you could start, and then Jyoti and Dr. Bansi then.
Yeah, so I think the best way to go about is to educate the person when you're initiating them on a GLP-1 receptor analog therapy. I do not usually initiate them on a lower strength unless they undergo a GI side effect. So I give them 1.5. If they have any problem, then I reduce the dose. Second thing is, of course, talking to them and making them understand that GI side effects is part of the therapy, and it usually gets better after the first 3 doses, and you can expect the frequency of side effects and the intensity of side effects coming down eventually for most of the individuals. And even if there are certain GI side effects, they get mitigated by simple interventions. Also, timing of the injection is very important. So you need to time the injection properly so that you can reduce the GI side effects.
Even for the once weekly, is there a specific time that you advise, Supratik?
Yeah, so usually I advise it during the evening or at a time where the patient is not having a very heavy meal, which is, so a relatively empty stomach is where we plan the injection, but there is no particular timing of the meal. You can place it anytime before or after, it doesn't matter.
Thank you. Jyoti and then Bansi quick.
Yeah, earlier the better, but GLP-1s will work at any stage of diabetes. But if it is early, it is the best, and a long-acting one, such as dulaglutide, will address both fasting, postprandial, and also A1C. A little bit of counseling is always necessary with respect to GI side effects, and we need to again customize based on the patient-specific characteristics. I think it's already 4 o'clock, so I'll stop here. Thank you.
Bansi, your final thoughts?
I fully agree with both Supratik and Jyoti. I will not take more time. Only thing is, I start many of my patients with 0.75. If they tolerate it well with 1 or 2 injections, then I escalate it to 1.5 and then I continue. Rather than going with 1.5 straight, and if they develop a lot of side effects and they develop nausea and vomiting, then they may opt to stop it. So that's the reason my start is 0.75, but we have to educate them. Thank you once again, Manoj. Sorry if you
Thank you. Thank you all the panelists, and apologies again for the lost connection. I couldn't say the disclaimer. All of us are contracted for this conversation. Trulicity continues to be one of those GLP-1 receptor analogs, which is once weekly, approved more for primary prevention of cardiac disease, GI side effects, and the therapy which continues to can afford. So we all need to consider this therapy. Yes, India is a price sensitive market, and even though we believe in the therapy, we are not able to offer it to many of our patients. But do have the conversation with your patients, and you'll be surprised how many of them may actually start considering this therapy. So with these words, let me thank all the 3 experts and panelists for being here and having this wonderful conversation on insulin and on incretins, and thanking Dr. Sanjay Reddy and the ADA Primer Group again for having all of us here. Over to you, Sanjay. Thank you.
Thank you, Manoj.
To Dr. Manoj
for a wonderful moderation. Thank you,
Absolutely.
Dr. Manoj, Dr. Supratik, Dr. Jyoti Dev, and Dr. Bansi. It was a pleasure listening to all of you. Then the usual PowerPoint presentation. I like the dialogues very well. They answer many questions better. Thank you very much.
Thank you so much.
We move on to the next session. It is a symposium sponsored by Torrent Pharmaceuticals, and to take forward this symposium, I welcome Dr. Shashank Joshi. Dr. Shashank Joshi needs no introduction. He is one of the senior most endocrinologists in this country. He runs Joshi's Clinic and Leelavati and Bhati Hospital, a Padma Shri awardee, a former president of Endocrine Society, RSSDI, and various other organizations in the country, and his work on COVID during the COVID times. And we've been saying listening to him Over to you, sir, to conduct the next session, introducing the faculty and taking on all the 3 talks. Over to you, sir.
So thank you, Sanjay. Thank you, Primer. We are having this new symposium on meta flexibility and metabolic dysfunction. And we have 2 of the most prominent speakers from India. They're extremely bright. The first talk is going to be by Dr. Saptarshi. Dr. Saptarshi is going to talk on young onset diabetes and meta flexibility. Dr. Saptarshi Bhattacharya is an endocrinologist at the Max Hospital, Patpatganj and Kailash Hospital. He's one of the brightest endocrinologists in this part of the world. He's very academically oriented. He's a clinician, educationist, and researcher. And then he will be followed by Dr. A.G. Unnikrishnan, who is also one of the most foremost speakers. He is an endocrinologist. He's the CEO of the Jalaram Diabetes Institute, a very leading institute, and he's recently been conferred a Diabetes Excellence Award at the Diabetes Digital Summit. Both of them are excellent speakers. Dr. Unni will talk about the ominous octet and the metabolic modulation. And then probably we'll have a nice panel discussion. So over to you, Saptarshi and Unnikrishnan. Both of you all are a delight to hear. And we are looking forward to listening and learning from both of you. Saptarshi.
Thank you, sir. Thank you very much, sir. So it's an honor and pleasure to be with ADA Primer, and thank you, Dr. Joshi, for the introduction, and thanks to Dr. Reddy for the invitation. So let me share my screen. So my slides are visible.
Yes, sir.
So this is a challenging topic because this is a new concept of metabolic inflexibility or meta inflexibility, and we will also see that what this topic is all about, and also how it is actually linked to youth onset diabetes. So we all know that flexibility is the ability to change and adapt to various circumstances. And that is an integral part of not only metabolism, but of life. So we have changed ourselves to COVID-19. So there are so many things which have changed, and change is critical to survival. So if we now look into the definition which was proposed by Kelly as early as in 2000, metabolic inflexibility describes the ability of an organism to respond or adapt according to the changes in metabolic or energy demand, as well as the prevailing conditions or activity. Actually, the first concept was proposed way back in around 1986, and it was shown in helminths who are adapt to living in very different conditions. So they live in the soil, they're also present in our gut, and they are again adapting to multiple types of metabolic needs as well as oxygen availability. So and they have a unique strategy of energy conservation in amongst themselves. I'm not going to go into the details of it, but this was the concept which was proposed by Kohler et al. As early as in 1986. And over the course of evolution, over so many billions of years or millions of years, human organisms, they have evolved. So we started from a hunter-gatherer society where hunting and fishing was the human survived through all that. Then we gradually developed into an agriculture-based society, and now we are more of a technology-based society. So there has been a considerable change and adaptation which the human race has gone through over the last so many years. So our priority has changed from fighting pathogens and avoiding starvation to favoring the extraction and intestinal absorption of nutrients. So so what was metabolic flexibility all about? So to make it very simple, so when we are in a fade state, glucose is our primary source of energy. So glucose oxidation is the primary mechanism by which energy is derived. But as we go into a fasting condition, so the glucose oxidation gets suppressed and fatty acid oxidation is the predominant mode of energy generation. So this is a concept which we all know, but what was proposed is that there is a change, this transition, this flexibility which occurs from fade to fasting state. Not only in fade to fasting state, we'll see during the next 10-15 minutes that in all aspects of life. So if you're doing some very active exercise, or somebody is running to catch a bus, or somebody is fighting, or somebody is running. So in all these situations, there is a change in metabolism, and in metabolic inflexibility, this balance, this transition, that gets hampered. So there are clear cut, if we go back to our good old biochemistry days, so we all know that there are intricate pathophysiological mechanisms, biochemical mechanisms, when there is a transition from glucose to fatty acid oxidation. So there is a reciprocal inhibition mechanism. Just to make it simple, so if somebody is in a fade state, there is high levels of insulin. Insulin suppresses lipid oxidation, and it promotes glucose uptake and oxidation. And the methods to assess it is a very simple way, which is respiratory quotient. So if the primary mechanism of energy generation is glucose, the respiratory quotient increases to 1. But if the primary mechanism is fat oxidation, then the respiratory quotient tends to go down. So most of the clinical studies or animal studies or experimental studies, they have utilized the respiratory quotient as a mechanism to, as the method to study metabolic flexibility or inflexibility. So where coming back to simple clinical situation, so when we are sleeping, or so then fatty acid oxidation is more, glucose oxidation is suppressed, glycogen storage is suppressed, lipolysis is increased. When we are eating, just the opposite changes takes place. So again, if we are running or going into an exercise like activity, then fatty acid oxidation is also increased, glucose oxidation is also increased, glycogen storage goes down, lipolysis is increased, and fat storage is decreased. So there are various, it's not about only the mitochondria or the cells. Metabolic flexibility, the concept actually has broadened. So it can start from intake of food. So if the food intake is different, if somebody is having a high carbohydrate diet, in that case, that can alter the metabolic pattern. So if we now then we move into the circulation. If somebody is given a glucose infusion in an experimental setting, or an insulin infusion, or say fatty acid infusion, so in all those situations also, what we see is that there is a transition, and it can be at the level of the cells, it can be at the level of organelles like mitochondria. So initially what was proposed was that mitochondrial indecision actually governed metabolic inflexibility. So in the setting of a fade state after a meal, as we have been discussing, glucose is the primary source of energy. If we are in a fasting state, fat is the primary source of energy. That transition is not possible in the setting of metabolic inflexibility. We will see how it occurs. And it's not only about fasting or exercise or taking rest. So there are different types of stressors. So we were already discussing that exercise can be one stressor which can modulate metabolic flexibility. calorie restrictions, sleep deprivation, cold exposure, and there are other regulators also. It's not only about insulin or mitochondria modulating it. There are other regulators like catecholamines or brown adipose tissue or sympathetic nervous system activity. And there are effectors other than mitochondria also. And maybe this is a subject of research where we will try to understand that how actually it can be related to glucose metabolism and development of diabetes. So it's very important to have that intricate balance between the various factors which actually govern or modulate metabolic flexibility. So if you are having a healthy diet or having proper physical activity, have the right genes, you are metabolically flexible. On the other hand, if with aging, metabolic flexibility goes down, if you are having an unhealthy diet, inactive lifestyle, and genes are something which are not exactly in our hand. So even there are epigenetic mechanisms as well, like a fetal environment. So these are things which might not be totally in our hand. So there are some modifiable factors which modulate metabolic flexibility or inflexibility. There are some like genes which are not modifiable. So if we look into aging as an example, so again, we see that there is mitochondrial degeneration, alteration in mitochondrial mass and integrity over the over lifespan. And we know that with age, our glucose tolerance also keeps on decreasing. So that is one example. And there are specific changes which occur in the mitochondria. These are again complex slides. I will not going to go into details of it, but just to make you understand. So this is a area which is being researched a lot, and aging related, even carcinogenesis or neural degeneration, neuroplasticity, say they all have been actually linked to metabolic inflexibility. And what we see is in the mitochondria has been proposed as a central modulator of metabolic flexibility. So if somebody is having a chronic nutrient overload, so somebody is having lots of junk food, lots of fat, lots of simple carbohydrates, so the constant influx of the nutrients, they modulate the mitochondrial function. There tend to be an accumulation of reactive oxygen species. There is a alteration in mitochondrial membranes. So even there are then feedback signals go back to the membranes. So in the setting of chronic availability of say glucose in the mitochondria, so because of the mitochondrial alteration, there is actually feedback mechanism going back to the cell membrane, where the cell membrane is being told that we have lots of glucose, we have lots of metabolite. So the cell membrane will stop taking in glucose, and there will be insulin resistance, and there will be reduced glucose uptake. And there is studies which have shown that there is actually a threshold or a set point where from a healthy condition you transit into a subclinical condition, and then you develop a full-blown disease condition. So all the different organs like adipose tissue, muscles, liver, and heart, so there are studies which have shown that these organs, the adipose tissue is the one which is most susceptible. And if this metabolic inflexibility does not get corrected, even there are cardiovascular changes which can set in. So to come back to more basic way of summarizing this whole concept, so if there is metabolic inflexibility, there is reduced skeletal muscle glucose disposition, impaired suppression of adipose tissue lipolysis, reduced suppression of hepatic glucose output, and skeletal muscle mitochondrial dysfunction, which can impair glucose transport, lower fatty acid turnover, reduce the oxidative capacity, cause ectopic lipid accumulation. We know that visceral adiposity is a very predominant driver of so many metabolic abnormalities. So that again can be explained by the concept of metabolic inflexibility, and ultimately we have multi-organ metabolic dysfunction. And it's like a vicious cycle. So all this metabolic dysfunction can actually again lead to more metabolic inflexibility, and this cycle just keeps on going, and there is a progression from a healthy state to a disease state. So the metabolic inflexibility takes into account a framework within which changes in fuel oxidation can be examined along with changes in fuel availability that results from modification in dietary intake, energy demand, or peripheral metabolic process. So the concept behind metabolic inflexibility is that it's a dynamic model. So it's not that in our biochemistry classes we are given very clear points, okay, this is the metabolic pathway. But what we see is that there is a dynamicity to it. So we already discussed that there are some factors like genes or epigenetic modifications which might not be in our hand totally, but obviously there are other factors which are there. And insulin sensitivity has been clearly shown to have a link to metabolic flexibility, and lifestyle changes as well as exogenous substances as well as genes can modulate it. So we already discussed that lipid accumulation is a predominant driver of insulin resistance. So there is decreased lipid storage capacity initially in subcutaneous adipose tissue, then we see it in visceral adipose tissue, then we see more of lipids in liver. So NAFLD has emerged as a very threatening complication of diabetes and dysmetabolism and metabolic syndrome. So again can be accounted for by metabolic inflexibility. Increase in lipotoxicity is another driver. So all this together can cause metabolic inflexibility and dysmetabolism and tendency towards diabetes. And we have studies specifically in youth onset diabetes also, where normal weight person with normal glucose tolerance were compared to pre-diabetes and type 2 diabetes patients, where it was seen that the respiratory exchange ratio, so the fat oxidation, fasting free fatty acid level, adipose tissue, insulin sensitivity. So they are all actually more in even young patients who have type 2 diabetes or pre-diabetes as compared to normal weight or normal glucose tolerance diabetic individuals. So these are important aspects of which we have seen that can be a driver of type 2 diabetes even in young, and how can we actually modulate it. So the most important step will be exercise and lifestyle changes. So again, there are intricate pathophysiological mechanisms by which we know that exercise can actually modulate the metabolic flexibility. So it's a very simple concept that it's like whatever carbohydrate or fat intake you have, so you need to burn it out by exercise. And if you are not able to burn it out by exercise, you have a positive calorie balance. That balance is then going to get stored as fat, and accumulation of fat in multiple organs, including say obviously in liver, adipose tissue, and ultimately intracellularly in the organelles like mitochondria, they can actually alter the balance of your metabolism. Again, effect of calorie restriction. So we know that there are complicated pathways like including AMPK, which we often discuss related to metformin, that calorie excess or obesity will promote metabolic inflexibility. Calorie restriction or fasting will keep the person metabolically flexible, and each of them are having intricate mechanisms which can explain the development of insulin resistance and metabolic inflexibility and deranged metabolism. So this is another thing which is very, very common and very well discussed nowadays, intermittent fasting. And there are animal studies where it has been shown that intermittent fasting, we were discussing that calorie restriction is one of the aspects by which metabolic flexibility can be improved. And what we see is that even there are animal studies which suggest that if you subject the short-term high-fat diet fed mice to intermittent fasting, the metabolic flexibility parameters, they actually tend to improve. Again, there are calorie restriction mimetics, which and some of them are like pioglitazone and metformin and even SGLT2 inhibitors. They all have such properties. They again, by multiple complex mechanisms, can also not actually, they do not restrict calories, but mimic that the calories are getting restricted, and they can also improve metabolic flexibility. So there is to finally, this is like the penultimate slide. So there are unmet needs in the understanding of metabolic inflexibility. We know that dyslipidemia and hypertension are very it's like another pandemic we have been having for a very long time. It's only that it was not getting recognized like COVID-19 because the effects are very slow. But obviously the consequences over the next next 4 or 5 decades, it's going to be alarming, and we need to be cautious and careful and find out the unmet areas and the unmet needs are there, which needs to be addressed to counter them. So metabolic flexibility, the main advantage of this model, it's a dynamic model and efficient switches in metabolic fuel depending on physiological demand. So they explain a lot of the this metabolism related effects like development of diabetes, obesity, hypertension, dyslipidemia. Even there are studies which show that even in the failing heart, there is a alteration in metabolic flexibility. So caloric excess and resulting metabolic inflexibility develops into insulin resistance at hepatic, adipose tissue, and skeletal muscles. Calorie restriction and exercise are important components of addressing metabolic inflexibility and improving insulin resistance. And there is an unmet need for drugs which can address the issues of dysglycemia by addressing metabolic inflexibility. So it's a dynamic model. It's an integrated assessment of the interaction between environmental factors and regulation of the metabolism, and the modifiable aspects should be researched and targeted for optimal medical outcome. Thank you. Thank you. I will now request Dr. Joshi to take on the proceedings. Dr. Shashank, if you have any questions, or we can have the discussion.
I think we can start off with, I think we can start off with Dr. Unnikrishnan's talk, that is Omnisocic and mitochondrial modulators. Over to you, Vinay. If you're giving it, or you get it.
Friends,
yes,
thank you for inviting me for this meeting, and it's a pleasure to be here talking on the ominous octet and meta inflexibility. This will be my agenda for today. I will look at the global burden of type 2 diabetes. I will look at the reasons for progression of diabetes like insulin resistance, beta cell dysfunction, beta cell resistance. I'd look at the possibility of cutting risk with meta flexibility and how an early interventional model of meta inflexibility might play out in cases of obesity and type 2 diabetes and dysmetabolism. Finally, I'd end by the potential of meeting certain unmet needs in treatment of type 2 diabetes and cardiovascular disease via a mitochondrial modulator. This is a slide which shows the burden of type 2 diabetes in India, and it's very clear whether it is pre-diabetes or diabetes with complications, the numbers run into millions. In fact, 72% of type 2 diabetes people have either hypertension or dyslipidemia or both. Now, these are the 4 important studies of glucose control in type 2 diabetes: the UKPDS, the ACCORD, the ADVANCE, and the VADT. what you will see is that the UKPDS was done on newly diagnosed type 2 diabetes people, whereas the ACCORD advanced and VADT is to people at least 8 to 11.5 years of diabetes. In all the 4 studies, there was an intensive arm and a control arm, and in all these studies, intensive arm showed a reduction in microvascular complications. But the benefit of intensive control on macrovascular complications and mortality and cardiovascular disease was not seen, and there was some sort of controversy as to whether glucose control can help in cardiovascular protection. And of course, the other challenge in type 2 diabetes management is that whether you look at the novel subgroups of diabetes and cluster-driven analyses, or whether you look at progression and treatment response, despite sulfonylurea or metformin, what you will find is that there is an inexorable rise in HbA1c over time because the beta cells fail or the insulin resistance picks up. At this point, I'd like to go in for a case discussion. This is a gentleman with diabetes, obesity, hypertension, and dyslipidemia. Not a very rare case indeed. This is a very common kind of case, Wignet. And this gentleman is taking metformin 500 mg twice a day, SGLT2 inhibitor, sulfonylureas, statin, and ACE inhibitor. Now, given that he is on these medicines, is he 100% protected from heart disease? Time for a fresh perspective, because we are not very sure whether we should treat the individual components. We are also not very sure whether there is a unifying mechanisms of the disease. We also need to know that if there is a unifying mechanism of the disease, what could be the ways in which this unifying mechanism could be tackled? So that brings us to the concept of the ominous octet. The ominous octet, or the 8, shows that type 2 diabetes is a multifactorial disease and treating hyperglycemia may not be sufficient. These are the 8 components of the ominous octet. You have the gut, the L cells, which produce incretins. You have the brain, which controls appetite. You have the liver, which produces glucose by glycogen breakdown or glycogenolysis, as well as new glucose production or gluconeogenesis. You also have the kidneys, which help in glucose metabolism. Indeed, they have a role to play in gluconeogenesis. You also have the skeletal muscle, and skeletal muscle insulin resistance. Some people believe it is some connection to mitochondria, which are the energy storehouses of the cell, can worsen diabetes control. Alpha cell and beta cell dysfunction. The alpha cell produces glucagon, which increases blood glucose levels. Beta cells produce insulin, which decreases blood glucose levels. So if there is an imbalance with too much glucagon or too little insulin, hyperglycemia can occur. And finally, there is the adipose tissue. The adipose tissue is the largest tissue in the body, not just in terms of its size, but also in terms of the large number of hormones that it produces. So all these show that type 2 diabetes is a multifactorial disease. The central component of metabolic syndrome type 2 diabetes is central obesity. And could it be that mitochondrial dysfunction is a trigger for the ominous octet? Because all these organelles do have some effect on mitochondria. So let's look at this metabolism leading to mitochondrial dysfunction, leading to adipose tissue lipolysis, leading to incretin deficiency and resistance, and of course that itself leads to hyperglycemia, endothelial dysfunction, and atherosclerotic cardiovascular disease. And metabolic inflexibility could be at the heart of the matter. On your left, you can see a mitochondria. You can see the outer membrane and in red color, the inner membrane in yellow color. Between the outer and the inner membrane, you have the intermembranous space. There are infoldings of the intermembranous space called cristae, and within the inner membrane is a matrix which contains both DNA and ribosomes as well as granules. Ultimately, it all helps in ATP synthesis. And on your right, you can see the mitochondria. And you can see the mitochondria is a kitchen that fires the metabolic reactions in the body with production of bundles of ATP at the electron transport chain. This happens because of certain steps. Depending on the availability during fasting or fed states, glucose or free fatty acids can enter the cytosol. Glucose is successively modified by hexokinase to generate pyruvate. Similarly, free fatty acids are acetylated before they are facilitated by carnitine palmitoyl transferase to enter the mitochondria. Now, both the pyruvate and the free fatty acids together enter the TCA cycle because of one molecule, and that is acetyl coenzyme A. So pyruvate and acetylated free fatty acids both release acetyl coenzyme A that enters the TCA cycle to generate reduced NADH equivalents, NAD equivalents or NADH. The rate limiting step is pyruvate dehydrogenase. I'm not going into the biochemistry, but we must know that NADH enters the electron transport chain and eventually releases ATP and energy. But the point I'm trying to make is, on one side glucose enters the mitochondria, on the other side fatty acids enter the mitochondria, and the mitochondria has to have an inherent capacity to switch freely between the oxidative fuels depending on the nutritional context, and that might be lost in obese or type 2 diabetes persons, and that probably could be the reason for disease progression. So glucose toxicity and lipotoxicity may be at the heart of mitochondrial inflexibility. The mitochondria can alternate between pyruvate and acetyl coenzyme A, and the glucose enters the pathway, but it can only be glycolized. It cannot be utilized further. So glucose metabolism is affected and glucose signaling is affected, and that means the beta cells, which also have inherent glucose signaling, they are not responsive. On the other hand, because glucose entry is sort of blocked, the fat or the fatty acids or the lipids enter the mitochondria. And that leads to oxygen burning for lipooxidation, that leads to reactive oxygen species generation and also insulin resistance, and the release of free fatty acids also cause beta cell dysfunction. So this is a study which looked at different levels of obesity, and they found that mitochondrial DNA methylation increases in obese people, showing you that mitochondrial DNA methylation could be a factor for insulin resistance. So metabolic syndrome and cardiorenal syndrome are essentially two sides of the same coin, because on one side you have diabetes, hyperglycemia, dyslipidemia, hypertension, coronary artery disease as part of the metabolic syndrome, and the cardiorenal syndrome is heart failure, cardiovascular disease, and chronic kidney disease. So the metabolic syndrome is obesity plus hypertension, dyslipidemia, insulin resistance, and also heart disease, kidney disease, NAFL, and PCOS. Could thiazolidinediones help? Remember, when thiazolidinediones came, they were said to be at the heart of the metabolic syndrome. They were the only drug which could actually address the core of the metabolic syndrome, which is insulin resistance. But while thiazolidinediones keep the fat where it belongs, thiazolidinediones are not the answer, because yes, they do keep the fat where it belongs, prevent lipooxidation. They really do not help the mitochondria, or there's no benefit. There's no study to show that they benefit the mitochondria. So SGLT2s are more complex effects. SGLT2s cause carbohydrate loss in the urine, glucose loss in the urine. Glycosuria causes burning of lipids or lipid oxidation. It generates ketones, which is protective for the heart. But remember, the effects of SGLT2 inhibition on mitochondrial flexibility is so far not very clear. And that brings us to certain other therapies which mimic SGLT2. That is keto diet, intermittent fasting, and these are all examples in carbohydrate restriction mimicry. But switching between these two nutrients, the body provides different fuels for mitochondria, glucose and ketones. As you can see from the diagram of the green color mitochondria, glucose and ketones enter the TCA cycle, Krebs cycle, and then they enter the electron transport chain and release energy. But switching between glucose and fat requires some degree of flexibility. Of course, ketone is also used up and lipolysis also generates ketones, but definitely the effect of SGLT2 on mitochondrial modulation is not clear, because mitochondrial modulation is to choose between glucose and fat. SGLT2s already restrict the glucose level and increase the fat level. So the mitochondria is forced to go in a particular direction. So it may actually stress the mitochondria. Therefore, in future, when we identify people at risk, whether it is moderate risk, high risk, or very high risk, for example, very high risk could be diabetes with established cardiovascular disease and other target organ damage, and 3 or more major risk factors, I think SGLT2s, GLP-1, and mitochondrial modulators all might play a role. So that brings us to this very interesting theory, lipo and glucose toxicity-led excess substrate availability leading to mitochondrial dysfunction and cardiac skeletal inefficiency. Now let's take the car example. Now in a car, you might have two sources of energy. You might have electrical energy, you might have petrol or diesel based energy, and the car can decide, its hybrid car can decide which energy to use. Similarly, the cell can decide whether it wants to use glucose or fat, ketone, etc. So that flexibility should be there. But remember, imagine if the car now cannot choose between these two and the car cannot take electrical energy and has to run on oil. Similarly, when there is inflexibility in the mitochondria, glucose cannot be used and fat or lipids or fatty acids have to be the energy of choice. And that makes it inflexible, stresses the system. How does it stress the system? Because glucose cannot enter, fat undergoes oxidation, lipid oxidation leads to oxidant free radicals, and also free fatty acids because of lipolysis lead to beta cell dysfunction, insulin resistance, and fuel the epidemic of cardiovascular disease. So the ideal oral anti-diabetes drug for multifactorial approach in the thin fat type 2 diabetes. Let's try to define the characteristics. We have targets, we have the intermediate effects, and we have the final effects. The targets could be insulin secretion, insulin resistance, correcting insulin secretion, improving insulin resistance, and maybe mitochondrial dysfunction could be a new target. And that has been talked about today and will be talked about again. The intermediate effects of these targetings are that it may improve beta cell dysfunction, it may improve insulin sensitivity, and it may improve mitochondrial biogenesis. And all these could translate into final effects such as a lowering of HbA1c, lowering of blood pressure, lowering of LDL cholesterol, reducing of cardiovascular risk, and weight neutrality. So friends, I've come to the end of my talk. This is my second last slide. I looked at the global burden of type 2 diabetes, showing you that type 2 diabetes is a progressive disease from pre-diabetes to diabetes with complications. Then I showed you the progressive nature of diabetes, where the HbA1c rises and rises and rises, irrespective of the clusterings, irrespective of the metformin or sulfonylurea. I looked at the possibility of cutting this with meta-flexibility if the mitochondria were flexible enough to choose between glucose and fat. I looked at a very early intervention model of meta-inflexibility where I showed you that an inflexible mitochondria may get stressed out if external interventions which are not correcting the main problem are put into it. For example, if there is a keto diet, yes, the mitochondria may use ketones for energy, but then the glucose pathway gets blocked, and that ketones and the lipid usage may lead to lipid peroxidation, oxidative stress, free fatty acids causing insulin resistance and beta cell function. So therefore, having talked about this meta-inflexibility, I talked about whether we could meet an unmet need potentially via mitochondrial modulator. Once more, I'd like to thank the organizers for the opportunity to participate, to be with all of you and speak here on this very exciting and new topic. Thank you so much for listening to me, and it has been a pleasure talking to you.
Thank you, Dr. Saptarshi and Dr. Unikrishnan, for a wonderful presentation. The whole idea of developing this new concept is because you know that this is a sponsored symposium by Torrent, and they're developing a new chemical entity in this direction. So there is an unmet medical need. So that's very, very clear cut. Now, Saptarshi, my first question to you is that what are your insights do you really believe in this whole concept of meta-inflexibility? You feel it's a pharmaceutical concept or really it's a genuine concept? And as time will pass, do you really feel that this will be a mechanism or a mechanistic way we will be able to intervene with molecules?
So I thank you, sir, for the questions. It's a very relevant question, but I think we are at very early stages of mitochondrial modulation. So there are no like direct mitochondrial modulators which are immediately in the pipeline, but we are there are agents, molecules we have which might have a parallel effect on mitochondria as well, but we do not exactly have an effect agent which is directly acting on mitochondria. Maybe metformin has, we do not know how metformin acts. Maybe metformin has some effect on mitochondria, on the AMP kinase and all those pathways. So I think this is the most important aspect of this concept. It's a dynamic concept. So it takes into consideration so many aspects. So there is a concept that if you say start having a healthy lifestyle, the metabolic inflexibility can actually get be reversed. So there is a concept of reversibility inbuilt in this new paradigm. So which is something which is quite unique. I think it's still early days, but this is an area which we need to look out for.
Dr. Unnikrishnan, you very beautifully, I loved your slides and animation, very wonderfully put out this. See, mitochondria is linked with muscle and is linked to exercise. And, sarcopenia and mitochondria all go together. Do you really feel that this new chemical entity which is being developed, where do you see the slot for this? Because now what has happened is, just 20 years back or 25 years back, we only had metformin, sulfonylureas and insulin. And now suddenly we have 8-10 big blockbuster groups of molecules. So it's very difficult for doctors to choose. So do you really need one more class of therapies? You put out some very compelling points with Saptarshi. And do you really feel the need for another new group of drugs in this space?
Well, thank you for that question, sir. I agree that these are very, very early days in the development of this mitochondrial modulator story, and we'll have to see more and more data with time. Having said that, there's always an unmet need in the management of protection from cardiovascular disease and type 2 diabetes, because despite the current therapies, which still have certain limitations, they reduce mortality, they even reduce cardiovascular events, but there is still, people can do even better with better drugs. So there is a role. Now, whether this will fill up that role, only time will tell. But I also take your point that with aging comes mitochondrial dysfunction, skeletal muscles don't work very well, sarcopenia. That's a completely different area, but that could be another area worth exploring as part of the development of the metabolic syndrome story, and a drug which could target the mitochondria may also have some effect on that as well. So very early days, what we are looking at is a product which might help in reducing several components of the metabolic syndrome. Whether that translates into clinically relevant outcomes, time will tell. But thank you for that question, sir.
So Saptarshi, you talked very nicely. Do you feel in your clinical practice, this is a clinical question, in your clinical practice, you are cluster classifying young onset diabetes in type 2 space?
Again, sir, so we are getting to see more and more young onset type 2 diabetes. So how much that is actually linked to metabolic inflexibility, again, we need to understand, as Dr. Unnikrishnan told, that these are still very, very early days. So this is a concept which is worth exploring, worth pondering. So youth onset diabetes, the whole spectrum has changed over the last 2-3 decades. When we were practicing earlier, maybe 20 years back, there were majority used to be type 1 diabetes. Now the balance is tilting towards type 2 diabetes, and there are some some entities which are not that common, like MODY and maybe secondary diabetes and other causes of diabetes, which do come into our clinics from time to time. But primarily, we have undergone a change in focus in management of diabetes in young, with so many new onset diabetes at very early ages turning out to be type 2 diabetes, with huge burden of metabolic associated cardiovascular morbidity along with them.
So, you made a passing reference to glitazones in your talk and metformin. In the modern practice, are you using these agents freely, or do you feel the glitazone use has come down? Maybe 20 years back, it was like a standard of care. Because
Yes.
as I talked to Unni, it was SU, MET, then came glitazone, and maybe a little bit of AGI. But now, if you see the current thinking, globally, the use of glitazone has come down.
Yes.
But, you showed very beautifully that it is still an insulin-resistant state.
Right.
To handle insulin resistance, still glitazones have a very high pecking order. So how do you use glitazones judiciously in your clinical care today?
So, as you said rightly, so the use of glitazones is coming down in my practice also, but I believe these are very economical and effective drugs when used in the right person, because still it's the only drug that targets the insulin resistance along with metformin. So I use a low-dose glitazone, pioglitazone, and I use it in relatively younger and thinner males where I'm not concerned about weight gain or are not concerned about fluid retention. In people who have retinopathy, I prefer not to use glitazones because there's a slight risk of macular edema. But if all these things are not there and it's a young person, I think glitazones still have a small role to play in practice. I think they are still effective drugs, maybe a little underrated in today's practice. But I must admit that I'm also not a big prescriber of pioglitazone, very careful user.
Saptarshi, I'm putting a question to you. Again, it's a little controversial. You see, today is the era of SGLT2 inhibitors. And we are, people, I think there will be a time when water was with metformin and diabetes. There will be water, metformin, and SGLT2 inhibitors. Now, SGLT2 inhibitors have some wonderful effects and side effects. The side effects are as wonderful as their effects. And, how is a combination of a glitazone with SGLT2 inhibitor? Do you see any synergy in young onset diabetes? Because you see, in young onset diabetes, we also see a lean spectrum. So, you have we are all pushing gliptin SGLT2 combination. But if you see from a pathophysiological standpoint, and both of you all illustrated, actually the better pathophysiological combination is one will cause weight loss, one will cause weight gain. It will actually be a perfect synergy of having a combination of a 15 milligram pioglitazone with a SGLT2 inhibitor. What is your thoughts, Saptarshi?
I do agree with you, sir. It's theoretically it's a amazing concept that SGLT2 inhibitors, obviously they actually have passed all the exams. So if you sit in an exam and if you come out first in IAS or IFS, so SGLT2 inhibitor is that candidate. Pioglitazone has just made it into the lower level of exam. It's a mediocre student or maybe the backbencher in management of type 2 diabetes. But you actually raised very important questions that this can be a wonderful combination. And I think people actually, we have lean diabetes in India, type 2 diabetes in India. And you start SGLT2 inhibitors and they will come back and ask you, Doctor Sahab, mera to tabiyat kharab ho raha hai, mera weight loss ho raha hai. And even though you try to explain this drug is going to protect your heart, protect your kidney, so even they will not be happy after using SGLT2 inhibitors and after having very good glycemic control because of the weight loss. So this is something I think which should be explored. This is a wonderful concept and actually might have promise in clinical practice. So this is something which we always get to learn from talking to you. So new concept worth exploring.
So thank you for both of you. I think I can't see any questions in the chat box. So Sanjay, are there any questions? Because we are running before time.
Yeah, no, sir, there are no questions. I think the concept is new, and
I think one last comment on the molecule which they are developing, Unni and Saptarshi, if you could just throw some light. What is this Torrent's new molecule which will be available? It is supposed to be a metabolic modulator. So maybe Unni, you can throw some lights, and maybe Saptarshi a word, and then we'll wind up.
Well, the concept of this molecule is that it makes the mitochondria very nimble. It alters the energy system in the mitochondria, and it makes it more nimble, allowing it to choose freely between glucose and fat in a way that the body's entire cell's energy is kept into perspective. And also, this may work not just on liver or heart, it may work at different organs. The concept is that it may protect not just against type 2 diabetes, but may also protect against cardiovascular disease at a very early stage, but nevertheless a very compelling and exciting molecule for the future. Over to Dr. Saptarishi.
So again, I will agree with Dr. Unni. So these are very early days, but the important point about metabolic flexibility or inflexibility is that, so it's actually there is studies where it has been shown that it affects, it's not the muscles or the skeletal muscle or the adipose tissue which gets affected. So there are studies which have shown that in the failing heart also there is metabolic inflexibility, or so, and there it's a progressive disease. So if we, and I had tried to show in my slide that it's a vicious cycle which sets in. So if we have a molecule which is safe, again passes the exam like SGLT2 inhibitors and can be quite promising in the long run. There are so many unmet needs, but they all need to pass the exams.
So, the Saptarshi, you make a very nice point of passing exams. So actually, I must illustrate 2 points. It's all about building a narrative, and it's all about marketing, and it's all about science-driven marketing. So actually, pioglitazone passed their exam in flying colors. As far as they had a 5-point MACE proactive trial, 5-point. Okay, after that trial, people got scared and they removed the stroke endpoint. Because 5-point MACE was done for EMPA-REG, EMPA-REG would have failed and it would have not met the 5-point endpoint. See how narrative and how perspective changes. 2005, 2015, we are in 2020. So in 2005, when proactive was being discussed by Normandy et al., it was presented in the Lancet, it was 5-point MACE. Because the earlier comparator for that was STOP-NIDDM. And STOP-NIDDM trial was in pre-diabetes. It was a positive outcome trial for acarbose 100 milligram 3 times a day. Again with 5-point MACE. It didn't work on diabetes, it worked for pre-diabetes. Therefore, then what is the trialists realized that the 5th point is a trouble point. So they dropped it off. And then they attacked rosiglitazone. Record trial showed it is safe, but there were some bullets. Which were the 3 bullets? Number 1, macular edema, weight gain, and unmasking of latent cardiac failure. Those were the things, and some occasional fractures. All these side effects are there for SGLT2 inhibitors. When SGLT2 inhibitors had to come in and they had to be launched, it was the same time. And DAPA was the innovator. And DAPA was linked to cancer. And DAPA was said that it's a carcinogenic substance. Probably you must be doing your DM that time. And it was touted that this will cause some malignancy. And that time, PIO was also linked to some cancers. So, see how the perspective had changed over a decade and a half. That time, this molecule was all linked to malignancy and all. And then ultimately now, we are saying that these are the wonder drugs. They still can cause euglycemic diabetic ketoacidosis. They can still cause genital mycotic infections. Their link on amputation is not over. Okay, it is there at the back of some mind. One compound does cause that. We still have not removed the oncological potential the drug may have. Okay, and we still have UTIs as a challenge. So it's not that they are absolutely safe agents, and they have some very peculiar impact on the lipid biology, which nobody understands. Also, it is a very heterogeneous mix. It's not uniform. The only thing this drug did is it impacted HHF, not even HF. Like everybody is talking of Emperor Preserve. Okay, only HHF has come down. That is hospitalization to heart failure has come down. But we have tom-tommed it so much as if these are some new age of miracle drugs. We don't see heart failure so often. Heart failure was not even discussed 10 years back or 15 years back. Okay, when Sanjay, we used to meet physically, now we are meeting virtually because of this COVID.
Yes.
Okay, and he used to give me a very good coffee and some very good South Indian meal. And now, he's not going to give me the khichdi today. Okay.
Anyway, I miss you there.
but that is the whole story. So I agree with Saptarshi, you and Unnikrishnan. Well, I've done a wonderful job. We are looking forward to this new molecule. Of course, we need a new molecule. It looks to be a very exciting molecule. It has some cellular impact and cellular mitochondrial energetic, as Unni very illustratively said. Both of you all did wonderful talks. It is a lot to learn from both of you all. We are very proud of you. You two are the brightest endocrinologists in the country. Thank you so much. And over to you, Sanjay, again for your next session. Thank you.
So thank you very much, sir. Thanks for moderating this talk. Metabolic inflexibility, mitochondrial modulators, probably the future. And thanks to Dr. Unnikrishnan and Dr. Saptarshi for being part of it. We move on to the next session. I don't see the chairperson, so I will chair this session. I don't see them logging in, so I want, with paucity of time, I will not wait. So we have 3 talks, that is comorbidities and clinical care. We move on to the first presenter of today is for this session, Dr. Binayak Sinha. Dr. Binayak Sinha is a consultant diabetologist and endocrinologist from Amri Hospital, Kolkata. So Dr. Binayak Sinha is going to speak on NAFLD in diabetes practice, screening, scoring and care. Over to you, Dr. Binayak.
Sanjay, as usual, it's a pleasure to be there with you and with Area Primer, albeit just online. But I'm sure good times will come soon and we will meet up. Achhe din aayenge. With that in mind, I will be speaking to you today on a topic which is slowly and steadily going to come up more and more in our clinical practice. I think with people realizing the importance of NAFLD in diabetes practice, I don't think we are putting too much of a stress on it. And I'll be discussing screening, scoring, and caring for people with NAFLD and diabetes. So I say with much sadness that while we were waiting with type 2 diabetes and CVOT and heart failure and all these things, there was something else that was happening. There was a pandemic of death from NAFLD, both in males, which seems to have plateaued a bit, and in females, which continues to be rising, and more so in both sexes around the world. And what was this related to? This was found to be related to diabetes, hypertension, and cardiovascular disease. Now, this is something that I don't think we have discussed much at all in all the CMEs and seminars that we have been doing, and this really needs to be brought into focus, that diabetes and NAFLD are integrally linked and they need to be addressed together if we need to come out with good prognostic outcomes in patients with diabetes. More so because patients with diabetes, particularly type 2 diabetes, have a much higher incidence of NAFLD than people with type 1 diabetes. As you can see, people who are insulin naive have an even more high prevalence of NAFLD than insulin experienced patients of type 2 diabetes. And this is basically known as the metabolic syndrome of the liver, because type 2 diabetes, dyslipidemia, visceral obesity conspire together to lead to this dangerous condition of NAFLD, which is actually very easily replicated by looking at, if you look at the liver content, it completely correlates with the number of fat content, it correlates with the number of components of the metabolic syndrome. So NAFLD is basically fat collection in the liver. The liver is not supposed to be made of fat. Fat is collecting out there. And what does that lead to? This fat leads to worsening of oxidative stress, which leads to NASH, which is steatohepatitis. Now we have an inflammation taking place, which not only takes place in the cells, it takes place in the vessels of the liver. And this translates into further vascular inflammation outside the vessels, outside the liver, and increases cardiovascular risk. Now, has this been reported in the world literature? Actually, ladies and gentlemen, this has been reported repeatedly over the last 20 years or so, but we have not taken too much of note of this. Now, these are 2 papers from 2007 and 2008, wherein they've shown that NAFLD is independently associated with an increased incidence of cardiovascular events. And again, another paper from Diabetologia, which shows an increased prevalence of chronic kidney disease and proliferative and non-proliferative retinopathy in type 2 diabetes. Now let's look at it from the other side of things. So NAFLD associated with type 2 diabetes. What is type 2 diabetes associated with? So this is the Verona study going back as far back as 1999. And here you see one of the biggest causes of death in diabetes is liver cirrhosis. We look at the independent predictors of fibrosis in patients with non-alcoholic fatty liver disease. And one of the main things is diabetes. Again, we look at the risk of hepatocellular carcinoma, which, as we all know, is one of the sequelae of NAFLD. And one of the strongest links that we find is between diabetes and increased risk of HCC. So it is not surprising that the death rate from NAFLD has continued to mount because we have focused mainly on CVOTs, moving away from another big organ of our body, which is the liver. With that in mind, we need to make sure we evaluate all our patients with diabetes for the liver disease. And it is not difficult. It is basically taking a history, which I think all of us do. Family history of diabetes, hypertension, and CVD, along with alcohol intake. This needs to be taken very carefully. I think I know a lot of us here in this panel who I was looking at would fail this. Alcohol intake of less than 20 grams per day in women and less than 30 grams per day in men. So this needs to be looked at very carefully. Simple clinical examination, waist circumference, BMI change in body weight, a history of Hep B or Hep C, looking at a history of steatosis-associated drugs, simple blood tests that we all do, glucose, HbA1c, liver enzymes, CBC, cholesterol, uric acid, and ultrasonography for liver enzymes. A simple 10-step, this is the British Society of Gastroenterology guideline for a comprehensive evaluation of suspected NAFLD patients. You can do other tests like, tests for Wilson disease and other things, but this is the basic tests that you need to do, which will give you an idea about the patient with NAFLD. So with that in mind, we know this is how we assess patients. Let's look at a real-life patient that we've seen very recently, and we'll just apply these things to this patient. So now in this day which is something which has at least become very popular in the eastern part of India, is the routine checkup. And this is related to the packages offered by the corporate hospitals. And this 52-year-old gentleman who's got a family history of diabetes, because he's a non-smoker and does not imbibe alcohol, comes for a routine checkup. He was having GI symptoms, so he thought he'll go for a full body check. And when he comes back, his BMI is 29 kg per meter square, quite obese. Fasting blood sugar of 165, not known to be diabetic, A1C of 7.1%, creatinine 0.8, and AST and ALT are completely normal, 26 and 21. LDL, however, is high, and the albumin is normal, 4.0. His hemoglobin is 14.4, normal. Platelets, 156, normal, a little bit on the lowish side. But his ultrasound had picked up a grade 1 fatty liver. Now, remember one thing, this is an axiom that I'll tell you as we go along. A normal transaminases do not mean no NAFLD. Normal transaminases basically mean that there is no inflammation yet in the liver. It's not that it will not happen, it's not happened yet in the liver. So we need to take these with caution, and there's very beautiful protocols to assess these kind of patients for NAFLD. So if they've got obesity, type 2 diabetes, metabolic syndrome, we look at risk factors like, hyperlipidemia, hypertension. We imaged for fat accumulation. We saw that this ultrasound showed a little bit of fatty liver, liver enzymes are normal. We have excluded secondary causes. So this is NAFLD. Now, how bad is the NAFLD? We can do that with a simple scoring system, the NFS, or the NAFLD fibrosis score, or FIB4. I prefer the NFS, and I'll show you in a little while why. The NFS can be low risk according to the readings, intermediate risk or high risk. If it's high risk, we consider going for a liver biopsy. If it's intermediate risk, we go for a fibro test, FibroScan, consider monitoring every 2 years. Gray zone, again, a FibroScan. And again, we can go for fibroscan in all these situations and just make a decision. If the fibroscan shows a result which is high, we can go for a liver biopsy. So this is how the workup should be done systematically in patients with diabetes and NAFLD who present to our clinics. And the simple reason why I preferred the NFS or the NAFLD fibrosis score, this is an online calculator. You can all have it on your desktop. And it basically looks at very simple things: age, BMI, diabetes, AST, platelets, and albumin. And the only reason I prefer this score is because it takes into consideration patients with diabetes. So let us look at what my diabetic patient scores in this. So he had normal enzymes, remember? He's 52, not known to have any other disease. His BMI is 29. This uses a rounded off system, so it had to be 30 because it was 29.6, I think. He's got diabetes. I've put a tick mark here, and all these markers I have put in. And his score turns out to be 0.757. Now, if it's less than minus 1.5, it's no fibrosis. If it's 1.5 to less than 0.67, it's some degree of fibrosis. And if it's more than 0.675, significant fibrosis. So this gentleman who has come to see me actually has significant NAFLD, probably to the extent of having NASH or is on the verge of developing NASH, which can later translate into cirrhosis or hepatocellular cancer. So what do we do for him? One simple way is to go for a fibroscan, which is a very accurate and validated tool. It goes from 2.5 to 7.5, which is nothing. 7.5 to 9.5 is, again, moderate fibrosis. More than 9.5, you're getting into serious territory of severe fibrosis. And more than 12.5 is confirmed cirrhosis. And if you consider F3 or F4, you might want to go for a liver biopsy, which still remains the gold standard for diagnosis. But as all of you will appreciate, it is an extremely problematic test. It is an extremely difficult and fiddly thing to do, and also fraught with risk. With this in mind, how do we manage these patients? And I'll go through some general principles and then look at the drugs available to treat it. General approach to patients is weight loss and lifestyle modification. This has the maximum amount of evidence, but we put reasonable goals, about 5% of weight loss. We make sure the patients are vaccinated with good glycemic control and BP control. An important thing is statin therapy is completely safe in NAFLD. Stopping of statins because the AST or ALT has gone up is absolutely wrong medicine. We should reduce alcohol consumption, and pharmacologic agents which can lead to a problem with the liver should be avoided at all costs. This is general approach, and lifestyle modification till now has the maximum amount of data supporting its use in NAFLD. The indications for pharmacotherapy are not really known very well. Who do we treat? Who do we not treat? It's always been and remains a bit of a guessing game. But in patients with hepatitis, people who are starting to get elevated enzymes, I think it's probably a good idea to think of starting. So what are the drugs available? Metformin improves insulin sensitivity in NAFLD. Multiple meta-analysis improves transaminases to a certain extent. But the meta-analysis that was done with about 5 or 6 papers, large numbers, showed no improvement. And it is definitely not recommended if the patient doesn't have diabetes. Pioglitazone has the maximum amount of evidence. This is a large meta-analysis showing an improvement with the usage of thiazolidinediones, which this also includes rosiglitazone as well. It shows improvement of ballooning, fibrosis, inflammation, and steatosis. There is improvement of all markers of steatohepatitis, but it has no impact on fibrosis once it has become severe and cirrhosis. But pioglitazone, we know, is associated with a return to the pre-treatment NASH histology and pre-treatment hepatitis markers once you stop the medicines. And as you know, a lot of people with diabetes who are treated with NASH are having to discontinue pioglitazone more and more. There's a distinct worry about weight gain. And of course, I don't want to show it to you as kind of self-aggrandizement, but I'll show you this paper that has been published in Nature Scientific Reports recently, which showed a conclusion that the positive effects are completely offset by the harm. We did a cost-benefit, risk-benefit analysis from all the prospective trials with pioglitazone, and it showed that there is very little that you benefit by treating patients with diabetes other than getting some patients under glycemic control, particularly in the early stages of disease. Other than that, there is very little that you do, and there's a lot of harm by way of heart failure, fractures, and anemia. So this is what we already know about pioglitazone, so we have to be a little bit careful about it. Also, a fact is pioglitazone is inferior to vitamin E, but this is in 247 adults without diabetes. So vitamin E is superior to pioglitazone, and of course, pioglitazone is associated with weight gain that we've talked about. There's multiple studies with vitamin E. There's NEJM paper, one in elementary pharmacology and therapy, and observational studies with 800 units per day, which shows improvement in patients. But vitamin E, be careful because it cannot be combined with other drugs. And also there has been shown to be increased cardiovascular mortality, particularly in patients with diabetes who are using vitamin E. So be very careful about the use of vitamin E. And it should be used very selectively in more severe patients of NAFLD, and combination regimes should be avoided at all costs. And using it should be very frugal. There's one drug that is used quite a bit, ursodeoxycholic acid. I'm not even discussing it. It has no place in the treatment of NAFLD and diabetes. But as I told you earlier, there is one thing that definitely improves outcomes. That's weight loss, improves NASH liver fibrosis. This is this is a weight loss modification trial. And the more you lose weight, the more you improve. There is regression, there is stabilization, there's improvement. And if you do not lose weight, you have a worsening of your NAFLD. In this context, there are two new drugs in the market, the very favorite empagliflozin or SGLT2 inhibitors or GLP-1 receptor analogs. So there we have with empagliflozin, one proven benefit of empagliflozin therapy, a weight loss of about 2 kilograms when you use metformin with empagliflozin or SGLT2 inhibitors with any other drug that you add on to it. And this is fat mass rather than any kind of lean mass that you lose when you use empagliflozin in comparison to other drugs. So there are multiple potential mechanisms contributing to improvement of liver with SGLT2 inhibitors. They can reduce hyperglycemia, they reduce the visceral fat, there's reduction of oxidative stress, inflammation, and increase in adiponectin. And these are all proposed to be the reason why they would be improving NAFLD and NASH. But unfortunately, though it seems a very attractive strategy to treat diabetes and NAFLD, stroke, NASH, it's not been studied in much detail. These are all animal data which have shown improvement in fibrosis and tumorigenesis with all the SGLT2 inhibitors, but very little by way of actually randomized controlled trials. Trials have only come from the group in Delhi. This is Dr. Amrish Mittal's group. This is Mohammad Shkuche, who has come up with this study, which showed an improvement in liver fat by the usage of empagliflozin when compared to placebo from baseline to post-treatment. So this is how you see 16% to 11% and 16% 15.5%. So really strong p-values you can see. And this is probably the largest study. And this is only looking at liver fat and nothing else, which was published in Diabetes Care. So the studies have been heterogeneous, restricted by small sample sizes, and the outcomes have also been pretty heterogeneous. So the reason for this was we proceeded to do a meta-analysis of the effects of SGLT2 inhibitors in NAFLD patients with diabetes. And as you can see, because we pooled in all the things, the study was quite enriched, and we had a pretty large population, 7,000 in SGLT2, 4,000 in the control arm. And as you can see, there is a statistically significant reduction of liver fat as well as visceral fat mass by the usage of SGLT2 inhibitors when compared to controls. This is not against placebo, this is against controls. And again, if you look at the weight triglyceride and HbA1c, there is a statistically significant reduction of weight and HbA1c, which you do not see with an improvement in triglycerides. So it is felt that SGLT2 inhibitors will probably have a salutary effect on NFLD because it reduces fat in the liver, reduces hepatic inflammation because it's a reduction of all the enzymes in the liver, and it is probably driven by an improvement of glycemia and body weight. Now, ideally, any study should be done with liver biopsies, but unfortunately, that is something that we have to do without these days because it is so difficult to do liver biopsies. Another thing that we are looking at is GLP-1 receptor analogs. This is, of course, in a preprint stage. And these are the studies, as you can see, pretty heterogeneous, but very small sample sizes with all the kinds of GLP-1 receptor agonists you can think of, multiple competitors, but no strict and steady outcome. And there's no phase 3 data, except again from Dr. Kuche and Dr. Amrish Mittal's group, which showed an improvement with the usage of dulaglutide. So we again meta-analyzed all these things, and as you can see, there's an improvement in liver inflammation, ALT, AST, and gamma GT, all three are reduced by the use of GLP-1 receptor analogs. Not only that, there's improvement in liver fat content, and there's an improvement in biopsies results in patients with the usage of GLP-1 receptor analogs. Also, there's an improvement in weight, blood pressure, and triglyceride levels. So we did conclude that GLP-1 may be used as an alternative because it reduces fat and inflammation. But again, we need liver biopsy or liver elastography data. And RCTs might be the only way out of this. There is some being planned, but at this point of time, this meta-analysis on a large sample size may be used to shape guidelines for the treatment of diabetes with NAFLD. So to summarize, this is my last slide. NAFLD and NASH coexist with T2D, and each worsens either outcome for the other synergistically. We should work patients up properly to diagnose this. Weight loss is absolutely imperative. Lifestyle seems to be the only available intervention. SGLT2 and GLP-1RA, as I said earlier, present a very attractive strategy because it leads to weight loss, which is visceral. And we should be trying to think of using SGLT2 and GLP-1, which shows a marked improvement in transaminases and liver fat, mediated by weight reduction and improvement of HbA1c. And this has been shown by the two recent meta-analyses. So RCTs are awaited on this, and this is an area I think we should be watching the press. And I hope soon we will reach a day when the ADA algorithm does not only include heart disease, hypoglycemia, weight loss. I'm sure in the near future, we will have another line out here that in patients with NAFLD who should be treated with SGLT2 inhibitor or GLP-1 receptor agonist in addition to metformin. Not far, I think. We still await data before we can actually profess this. Thank you very much.
Thank you, Dr. Binayak Sinha, for that excellent presentation. And I like the idea of you looking at how we're going to take and say, oh, well, we have ignored one of the organs, which is too big to be ignored. And the blue box with ADA recommendation, my dream to see that. I think it's not far. We need to wait for more data and more therapeutic interventions to come. So we go on to the next talk, and we'll take the questions in the end. May I call upon Dr. J.J. Mukherjee. Dr. J.J. Mukherjee is a senior consultant in medicine, diabetes, and endocrinology at the Apollo Glen Eagles Hospital, Kolkata. I call upon him to talk on cardiac testing in the asymptomatic diabetic, who, what, when, and how. I didn't choose this topic. Then this is Krishna who said, no, only Dr. JJ. I will give it to Dr. JJ. So over to you, Dr. JJ Mukherjee. You're muted.
Sorry, good evening to everybody. Thank you for the invitation.
getting a little bit challenged getting the file up. Just give me 1 second. Let me get the talk ready. Can you see that, Sanjay? Yes, yes. A bit flustered, so I did not thank you properly. So thank you very much for Okay, so who do I thank for giving me this topic, Sanjay?
Dr. Krishna. And
He's not there. He's not there. Okay, made me work really hard. So cardiac testing in the asymptomatic diabetic, who, what, when, and how. This, unlike the 3 talks you've heard before, the one on the mitochondria, which is all esoteric, and the one on NAFLD, which suggested that we should have, I totally agree with Vinay. There should be another column coming up about the liver. I'm talking about the time-tested coronary artery disease, and I'm just talking about how to test for it. So a couple of issues with the topic, Sanjay. It said cardiac testing. So I did not know what cardiac testing Krishna wanted. So next time it's a little bit more sharper. Is it screening for ASCVD? And in ASCVD, is it screening for coronary artery disease or vascular disease, including peripheral vascular disease, and whether screening for heart failure? I did not want to talk on heart failure, but because of the empiric, preserved data which came up just this week, everybody's excited about heart failure. So there's one slide for heart failure. This is the idea consensus we had, and this is basically the same everywhere, all along the world. This is how you would screen for heart failure. We don't screen for it often enough. But my brief, I will take away heart failure from my talk, and I'll go straight to how to screen for coronary artery disease. And this one slide sums it all up, Sanjay and Krishna. This is the ESC EASD guideline 2019, and this is the line which is mentioned there. Screening for asymptomatic CAD in patients with diabetes remains controversial. So probably that's why Krishna had it on me and I had to do all this hard work. Anyway, who and when? That's already there in the topic. It's people with type 2 diabetes who are asymptomatic. I'm leaving type 1 diabetes out because 2 to 4% of diabetics in India are type 1 diabetics, even though the absolute numbers are high, but relatively they are quite less. So I will be focusing who and when is type 2 diabetic, and they are asymptomatic. Now, screening for asymptomatic CAD in patients with type 2 diabetes, I'll go through 5 points. Requirements of an effective screening program. First is, sorry, I forgot to time myself. So, Sanjay, can you please remind me? Yeah? Elevated prevalence and or high prognostic impact of the disease to be checked out. There is no doubt about that. I mean, CHD is a big problem in type 2 diabetes, which is the leading cause of morbidity and mortality. It's got certain unique characteristics. The prognosis is bad. If you have CHD in diabetic as opposed to a non-diabetic, the disease is more peripheral, multiple vessels are involved. When you do treatment, even after bypass surgery, they fare worse than the non-diabetic counterpart. It's implicated in 60 to 80% of all deaths. So NAFLD, in the end, you saw Vinayak ultimately comes to the common pathway of cardiovascular disease, inflammation, and death. So in the end, it's the heart. It is 2 to 4 times more common in people with type 2 diabetes compared to general population. And DM and risk of vascular outcomes. This is a famous emerging risk collaborators data. You must have seen it 100 times, almost a decade old now. All it says, just look at the hazard ratio, anywhere between 1.8 to 2.3 times increased risk of coronary heart disease, coronary death, or non-fatal myocardial infarction if you have type 2 diabetes. But you see, we say this as a routine, right? But remember, the variable risk across the whole spectrum of type 2 diabetes. So although type 2 diabetes is a major risk factor for CVD, the risk of developing cardiovascular event differs by several folds across the type 2 diabetes spectrum, depending on the age of the patient, sex of the patient, ethnicity, what are the associated comorbidities, hypertension, hyperlipidemia, NAFLD, what are the habits, smoking, non-smoking, albuminuria present or not present, renal function, whether there is CKD or no CKD. So you can't put under one umbrella type 2 diabetes, cardiovascular risk. It's a spectrum. So as we go on, you will see what that means. So definitely there is the first reason is met, that a certain sort of a screening program should be thought about. I'm not saying do it, thought about, because there's elevated prevalence and there's a prognostic indication. Second question, when you do any kind of screening program, is do we have effective tools to identify at-risk patients? What does this mean? And I just said, if you have a type 2 diabetic who's 24 years old, diabetes for 3 years, no hypertension, non-smoker, male, Caucasian, his risk of getting a cardiovascular event is far, far less than compared to a 55, a 55 to 60-year-old gentleman who's an Indian who's got type 2 diabetes for 10 years, who's got hypertension, hyperlipidemia, is a smoker. So it's a big spectrum. You can't end up doing all tests in all patients. So you have to choose. You have to choose. So for choosing, do we have effective tools to identify at-risk type 2 diabetes patients? Prior to 2007, if you look at the various ADA guidelines, they would just screen everybody because they said type 2 diabetes is a CVD risk equivalent. That's from the Steve Hafner paper. This is the NEGM paper, famous paper way back in 1998, which said if you have type 2 diabetes, it's as good as a non-diabetic having a past history of myocardial infarction, and your risk of mortality survival, that's the opposite. Risk of mortality is as good as a type 2 diabetic as a non-diabetic who already had a past vascular event. But we know now this is not true because, as I said, it's quite a wide spectrum. In Steve Hafner's paper, maybe the people were older, longer duration of diabetes, had more comorbidities. That's why it matched up like a CSD equivalent. But the example I just gave you about 24-year-old Caucasian, he does not, it's not a CSD risk equivalent. So diabetes is not a CSD risk equivalent, but there is increased risk of cardiovascular events. So many scores have been developed: Framingham score, UK Pediatrics Risk Engine, QRIS score, Joint British Society score, a score. So there are so many scores developed. But look at this. This is again the European Heart Journal publication, the European Society of Cardiology and the EASD. What they say is risk scores developed for general population are not recommended for CV risk assessment in patients with diabetes. Amongst all the scores, QRIS score comes a little bit close because QRIS score was developed in UK. It was developed in a huge number of patients in general practice, and then they were validated in a different group of patients in general practice. And there were a large number of type 2 diabetic patients, and they also had a large number of Indian patients, Asian ethnicity. Now, I don't expect you to read this. It's just to tell you that just type QRIS score calculator on your computer after the talk is over. You will find this and all the parameters which they take. And it's basically the risk factors: age, sex, ethnicity, smoking status, diabetes status, chronic kidney disease, atrial fibrillation, blood pressure treatment. I don't know, migraines comes in there, maybe vascular, rheumatoid arthritis, SLE, all these things are put together and you generate a QRIS score. And the QRIS score tells you the chance of having a coronary event over the next decade, over the next 10 years. Again, Dr. Samit Ghoshal and Vinayak Sinha did this meta-analysis. They did a proper study. It's called quantitative measure of asymptomatic cardiovascular disease risk in type 2 diabetes patients. And this is probably the first study which is done in detail, the application of QRIS score to the Indian population. Don't have time to discuss the study in more detail. Don't ask me the questions. Vinayak is there in the panel. You can ask him. This is his paper that I'm quoting. But what it tells you is that in Indians, as you get older, this is the QRIS score, and high risk CVD was defined as more than 20% risk of a cardiovascular disease event, not death, it's event, over a 10-year period. And as you go up, you see at the age of 55 to 64, your chance of quite huge risk of developing a cardiovascular event. Males is slightly more than females, and I've not shown the data here. They have it in the paper that longer the duration of diabetes, the higher the risk of having a cardiovascular event. So based on this and previous data, the Endocrine Society of India and RSSDI has included that the UK PDS risk engine and QRIS-3 are simple and effective tools for identifying and predicting CVD risk in this wide spectrum of type 2 diabetic patients. Is basically doing nothing but taking the same old thing that I just mentioned: age, sex, ethnicity, duration of diabetes, associated comorbidities, hypertension, hyperlipidemia, smoking, everything put together, you get a risk score. But I like this risk score the best. I think this is the simplest. This is the most clinically oriented score, and I think most of us can relate to this when we are sitting in our clinic. It's basically, instead of cardiovascular events, it's cardiovascular death now. So very high risk or moderate risk. 10-year risk of CVD more than 10% is very high risk. Death is not events now, 5 to 10%. And if you see any patient with type 2 diabetes with established CVD, target organ damage, or 3 or more risk factors is very high risk. High risk is if you have diabetes duration of more than 10 years, even without any target organ damage, which is, the microvascular damage, retinopathy, nephropathy, neuropathy, and any additional one risk factor, which is hypertension, hyperlipidemia. Moderate risk is probably, we see quite a few moderate risks in India, because in India, type 2 diabetes developed earlier. So we will see a lot of young people with that duration of diabetes less than 10 years without other risk factors. Then if they're one of the risk factors, they become high risk. If they have no risk factors, hypertension, hyperlipidemia, smoking, then you could probably put them under moderate risk. So do we have effective tools that identify at-risk patients? Probably yes, but I would not say really. QRisk-3 comes closest, and I think the ESC, ESD, dividing them into very high risk and moderate risk comes close to it. So this is the second point. The third point is, do we have a clear definition of the diagnostic techniques and their sequence? It's very obvious. So this is what tests to do. These are all the tests that you can do. Invasive coronary artery angiography. You won't do it in all type 2 diabetic patients. And whom do you want to do it? You do 12-lead ECG, exercise ECG, all sorts of nuclear scanning, the echocardiography, and then the CT, where you can see CT calcium score or the coronary CT angiogram. You can do MRI, and you can do various kinds of hybrid imaging. I won't touch this because I don't understand them. It's more for the cardiologists. Question is how? Now that was the last question, and which is the trickiest question. And the next 12 minutes of time that I have, I will be devoting on to how. That's the question. So you've identified the problem. You know there's an increased risk in a certain subpopulation of type 2 diabetic patients, and you have screening tests. You don't know how to use them, which one to use first, which one to use second. We'll come to it later. But then, if after screening, say you have done a CT coronary angiography in 100 patients with type 2 diabetes with high risk, so you're screening them. After screening, does it make any difference to the outcome with regards to morbidity and mortality? Two aspects to this. One is just the act of screening. So you screen, you find something, you do nothing, it's waste of time. You screen, you do something, but you do not do something to everybody, that's also a waste of time. And the third aspect is you screen, you find a lesion, you go ahead and do something. So all these three things you can do in a type 2 diabetic patient after screening. Question is, do any of these three have any effect on morbidity or mortality in an asymptomatic type 2 diabetic patient? The rest of the talk gets very, very, very complicated, a lot of studies, so you don't need to focus too much, just focus on the headlines, because in 10 minutes, you cannot go through all the wealth of data which is there to answer this question. So what is the defined intervention? That is very easy. We have a defined intervention. If you screen, you find something, you can do something. What? You can do medical therapy, you can do a PCI or stent placement, or you can do a CABG. Now there are 5 studies which are all randomized controlled trials, which are very nicely looked into the impact of routine screening and sub-treatment. Not everybody got treated. That was the problem with some of the RCTs on the effect of outcomes in people with type 2 diabetes. Only one of these RCTs, which was the first one, which was done by Paglia et al. A long time ago, where many of the patients were not on statin, a huge number of were smokers, they were not even on aspirin. So they were not on proper medical therapy. So to do an intervention in a type 2 diabetic patient whose standard of care is not met, this study is absolutely not reliable. So this study did show that in the screened people, there was a reduction in the events, and about 93% of the patients had a coronary angiogram. The second study, which is the largest study, is called the DIAD study. You can see the number of patients, more than 1,000 patients, age group. Again, if you see, not very good statin and aspirin use. They found no difference in cardiac death or non-fatal MI. But here, after screening, when they found there were some issues, not everybody went ahead and had a coronary angiogram. That was a problem with the study. DYNAMIT study is also a reasonably large study. Again, very poor use of statins and aspirin. There was no difference in the composite primary endpoint. Almost more than half of them had a coronary angiogram, and based on the culprit lesion, they had an intervention, but did not make any difference in the composite primary outcome. Factor 64 is a very well touted study done in USA. This was an anatomical study. The previous ones were doing functional screening. This one did a coronary CT angiogram in all these patients. And wherever they found a lesion, they went ahead and do a coronary angiogram in half of them, not in all of them. And they found that the primary outcome event was not significantly different between those with coronary angiogram done and in the control group. And the last study was called DADDY-D from Italy. Again, I will not go into details, did not show any benefit. So this is the meta-analysis. It's a day of meta-analysis. When you have 4 or 5 studies, you put them together and you come up with some data. And this is the meta-analysis done on these 5 studies: Paglia, DIAD, DYNAMIT, Factor, and DADDY-O. It's difficult to do meta-analysis. There are different groups of patients, different groups of baseline therapy, etc., etc. But keeping all that in mind, you do a meta-analysis. That's what meta-analysis is all about, tries to reduce the heterogeneity as much as possible. And what they find that if you take all-cause mortality, if you are screening asymptomatic type 2 diabetic patients with either functional screening, which is exercise test or a nuclear imaging, or if you do anatomical screening with CT coronary angiogram, you find lesions, you do something to them, not in all. This was a screening study, not a therapy study. I'll come to the 2 therapy studies later. You do not have any effect on the mortality. So why screen if you do not have any effect on the mortality? You say, Dr. Mukherjee, cardiovascular events, what about MI, what about stroke? No benefit at all in these 5 large studies which we have in the literature as of now. Paglia study, which I said was the first one, which had a lot of issues with regards to the patients included who were not properly medically treated, skews this data up, but even then, if you see, it does not become significant with regards to reduction of any cardiovascular event. So people with type 2 diabetes, you screen them. After screening, you find a lesion, selectively you treat them, you have no benefit with regards to morbidity or mortality. Third question, which I told you, was we now are going to intervene on the patients. We are now going to intervene on the patients. So first is the COURAGE study. Only 1/3 had type 2 diabetes. These are people who already have a culprit lesion. So one group was medical therapy plus PCI, but then the issue here is they got bare metal stenting. They did not get drug-eluting stent, the latest stent. Anyway, you can argue with that. And the other got medical therapy. Now we're speaking of medical therapy where they got proper ACE, ARB, statin, aspirin, beta blocker, CCP, and nitrates. Even then, aspirin use is not great, but this is what we get in most of the cardiovascular outcome trials. Aspirin use is quite good now. So once you have good medical therapy on board, there was no difference for primary endpoint of death from any cause or non-fatal MI in these 2 groups. But 1/3 were diabetic. Dr. Mukherjee, come on, show us some better data, Krishna says. So this is the data. This is the study which most of you would have heard. The more you read this, the more you learn. It's a very complicated study for the BARI 2B study. All were type 2 diabetic and they had more than 50% stenosis and had positive stress test or had more than 70% stenosis in classic angina. Now you cannot argue. You have so many patients, almost 1,800 plus patients now. There were 2,000 odd, some was lost. So about 1,800 odd patients now, age group. Not very many are smokers. Statin uses per huge now, and aspirin uses huge now. So now they're getting good medical therapy. Now what you did revascularization, PCI or CABG, and continued intensive medical therapy. It's not that you did not give intensive medical therapy to this group, as opposed to patients who got intensive medical therapy alone. So this is exactly what you and I would like to see in our patients. Type 2 diabetic, I did an angiogram for whatever reason I did. I found the culprit lesion. Patient is asymptomatic. He's got no chest pain, no shortness of breath, no anginal equivalence. In this patient, if I send to my cardiology colleague and he or she puts in a stent or does a CABG, I do not get any benefit with regards to primary endpoints of survival or freedom from major CVD events. But again, take this, I'll come to it in India. This is not true for everybody. There are certain culprit lesions which have to be intervened upon, but they are mostly symptomatic patients. So, elevated prevalence, yes. Effective tools to identify at-risk patients, probably yes. URIC score or target end organ damage and the other what you call risk factors. Clear definition of diagnostic techniques, yes. The diagnostic techniques the cardiology colleagues are very good at. Sequence, we don't know whether they want to do a functional test or whether they want to do an anatomical test or whether they want to do all, whether they want to do a stress test, whether they want to do a nuclear imaging test. It's very confusing. After identification, if I screen, I find something, I selectively treat, do I make any difference in morbidity mortality? No. I find culprit lesions, BARI 2 study, I intervene. Do I make any difference in morbidity mortality in the whole group? Answer is no. Why do you want to screen? So ideally, the cost effectiveness is not, there were plenty of slides on cost effectiveness, I've taken them out. So you're confused. Dr. Mukherjee, you're saying in type 2 diabetes with increased cardiovascular disease, coronary artery disease, and you're saying don't screen. So what should we do? 2 agencies have come to our rescue. These are my last 3-4 slides, Sanjay. ADA standards of care, I swear by this. In asymptomatic people with type 2 diabetes, routine screening for CAD is not recommended as is, does not improve outcomes as long as
Important statement. Atherosclerotic CVD risk factors are treated. Please get blood pressure to goal, lipids to goal, LDL less than 100. Please get them off smoking. Please get them to exercise. Please also do diet control. Get these things done. Then screening does not make any difference. But don't go thinking that don't do anything for anybody. Because if they have a left main lesion, if they have a proximal LAD lesion, if they have lesion with heart failure, then the game changes completely. Then you have to screen, then you have to treat because they can reduce mortality there. That was not my brief, so I'm just sticking to asymptomatic. Moment there's symptoms, atypical cardiac symptoms, chest discomfort, unexplained dyspnea, or signs or symptoms of vascular disease, TIA, stroke, claudication, carotid buoy, PVD, or a resting ECG shows any kind of abnormality, they should go ahead and do proper cardiovascular testing. And this is the other group, which there are many bodies which have given advice. I just take these two, the ADA and the European Society of Cardiology and EASD. Every type 2 diabetic patient should be screened for renal dysfunction because there's increased risk of cardiovascular disease there. And a resting ECG should be done in everybody. ADA also tells the same. Do not do carotid ultima media thickness. Do not do biomarkers unnecessarily and risk scores, except for QRIS 3, probably QRIS, which is not QRIS 3. Probably others are Framingham score, maybe are not very helpful. These are the various other tests that you can do. You can do you can do a CT with calcium score, CT with angiography. You can do all sorts of functional imaging, which is echocardiography stress. You can do nuclear imaging stress. You can do PET CT stress. You can do MRI stress. All this come as class 2. It is case by case basis. So this was not really helping us. So then in a Diabetes India conference, we all got together. You can read the names there. And we went through and we came out with even more simpler guidelines for you. At initial visit, screen for all the comorbidities, smoking, family history, weight, blood pressure, lipid profile, UACR, EGFR, and a resting ECG. That's all you need to do in an asymptomatic type 2 diabetic patient. The moment they become symptomatic, resting ECG shows some abnormality, then you could consider any one of these. Which one is your choice? You could go for CT, CAC, CT coronary angiogram, but there's risk of radiation, risk of renal damage, etc. Or you could go for non-invasive ones, all sorts of echocardiography with stress, either a physical stress or a pharmacological stress. So, Dr. Sanjay and Dr. Krishna, cardiac testing in asymptomatic diabetic, who asymptomatic type 2 diabetes, when they are asymptomatic. Please don't take the wrong message from here. If they are symptomatic, please send them pronto to your cardiologist because the risk of mortality type 2 diabetic who are symptomatic is very high. They need to be intervened and let your cardiologist decide which test he wants to do. What is only 12-lead ECG? Screen for comorbidities, screen for renal impairment, aggressively manage blood pressure, cholesterol, aspirin. We will come to it. I'm sure a question of aspirin which will come. Get them off smoking, get them to do good diet control, and if they have albuminuria, make sure they're getting ACR. You'll be surprised how many people just go and open EMPIRE outcome trial, campus trial, declare trial, and see how many of them were on statins, how many of them were. It's surprising, really, that in EMPIRE everybody had cardiovascular disease and not everybody was on a statin. So with that, I will stop. I'll rest my case. Back to you, Sanjay.
Thank you, Dr. J.J. Mukherjee. That was a very nice. I think we put you to work too much. Next time I'll choose something with you. But thank you very much. We'll take up questions in the end and let's go on to the next talk. To do the next talk, we have Dr. Rajiv Chawla. Dr. Rajiv Chawla is he was the past president of RSSDI, and he's also the editor of the RSSDI textbook of diabetes. He's on various panels. He is also the president of DIPSI. So and he runs the North Delhi Diabetes Center. Over to you, sir, to tell us everything preventing progression of renal disease.
Thank you, Dr. Sanjay, for kind words at the outset. Are my slides visible? Okay, thank you. Thanks a lot, Dr. Sanjay, for all those kind words. And at the outset, I'm thankful to my big brother Arvind, Dr. Krishna, Dr. Prasanna, and Bhavna for this opportunity to be part of very, very prestigious conference year after year. Task I have been assigned is to discuss about preventing progression of renal disease in diabetes. What is state of care or standard care today? So Flow of my session will be first to discuss the burden of kidney diseases in type 2 diabetes, pathophysiology of diabetic kidney disease, prevention and management of diabetic kidney disease, what we can do to check the progression, and what is standard care or state-of-art option which are available today. Let me define chronic kidney disease, which is abnormality of kidney structure or function for more than 3 months with its implication. A diabetic kidney disease, it is actually specific to diabetes, based primarily on presence of albuminuria, and diabetic nephropathy is damage to kidney caused by diabetes. Of course, this requires kidney biopsy, which may be of help for a very, very definite diagnosis. Terms DKD and diabetic nephropathy are often used interchangeably. Both ultimately lead on to CKD, and this is what I also will be doing. KDIGO 2013 said that stages of CKD, it has to be based on EGFR and albuminuria. It talked about EGFR categories G1, G2, G3A, B, 4, and 5, and albuminuria categories as A1, A2, and A3. Of course, normal was G1 when you have a normal EGFR more than 90, G2 when it is just getting on the lower side between 60 to 90, and of course CKD, the presence of having an EGFR between 45 to 60 or 30 to 45 or 15 to 30, depending on that you label it as G3A, G3B, G4, and subsequently a kidney failure, absolutely end-stage renal disease with EGFR less than 15. Based on presence of albuminuria, well, A1 is when you have a normal or little bit increase, but it is still into the microalbumin less than 30. Moderately increased A2 when you have between 30 to 300, and more than 300, which is a gross proteinuria or albuminuria, it is labeled as A3. Why to make these classification? Because these have definitely impact on overall prognosis based on their staging. So when we talk about G1 and G2, especially if it is with normal albuminuria, without microalbuminuria, then obviously prognosis is normal. Moment you have G3A, G3B, especially in the presence of an albuminuria between 30 to 300 or more than 300, you carry a very, very poor prognosis. Patients with diabetes, we know, are at a very high risk for developing CKD. Up to 40% of those with type 2 diabetes will eventually suffer from kidney failure. And this is today one of the most common reasons for progression to end-stage renal disease. Well, DKD occurs as a consequence of multiple pathogenic pathways in diabetic kidney, but per se hyperglycemia plays a major role, but this is not the only cause for development of diabetic kidney disease. A Taiwan study has shown that an early DKD also leads on to greater loss of life expectancy, and it could be very, very serious. Men having a loss of almost 11.5 years and women having almost a loss of life expectancy of more than 14 years subsequently if you have presence of early DKD today. That means patients with DKD are going to have worse prognosis amongst all patients with CKD and or type 2 diabetes. Well, when we talk about Asians versus Caucasians, situation is even bad. South Asians, they are at a higher predisposition for CKD, almost fourfold more likelihood to develop albuminuria, very high prevalence of advanced CKD stages 4 and 5, and possibly it could be multiple genetically predisposed mechanism like defects in RAS, maybe an overexpression of RAS, inflammatory cytokines on the higher side, dopamine pathway, RAGE pathway, and oxidative stress contributing towards more progression of DKD in Asian patient versus Caucasian. When we talk of consequences of DKD, we know markers of DKD like a declining EGFR or worsening albuminuria are going to be associated not only with increased mortality, with more composite renal events, CV events, CV death, or even also with an impaired cognition. And this is what 10,000 patient data over a follow-up of 4 years has tried to answer. That moment there is a increase in proteinuria or a gradual reduction in baseline EGFR, there is going to be a much higher overall risk of renal event or composite renal endpoints. We also know that progression of DKD is associated with increased overall morbidity and mortality. 15,000 patient in NHS US population-based study has actually tried to answer that. Moment you have presence of albuminuria in the setting of type 2 diabetes, mortality is already high, almost 4 times. And moment you have presence of albuminuria with reduction in EGFR less than 60, believe me, mortality is almost 10 times higher as compared to someone who is having only type 2 diabetes. But believe me, all patients with diabetes eventually die of CV disease. This is what we see in our hospital day-to-day practice also. Deaths due to CV disease, even in the presence of CKD, is almost 6 times higher than actually because of advanced end-stage renal disease or maybe dialysis. Coming on to the pathophysiology of diabetic kidney disease, let me take you to basic physiology. We know kidney, nephron, and glomerular apparatus. Third year, we knew that each kidney, there were several 100,000 functionally independent units called nephrons, with glomerulus, proximal convoluted tubule, loop of Henle, then draining into a distal convoluted tubule, and macula densa doing all the adjustment through juxtaglomerular apparatus and a collecting duct towards the end. So we know kidney auto-regulates glomerular filtration by modulating afferent and efferent arterial tone. So moment there is a vasoconstriction of afferent arteriole, this is going to reduce eGFR. And if you have a vasoconstriction of efferent arteriole, we are going to have increased GFR. That is how we now, these days, we talk of using SGLT2 inhibitor with ACE and ARB, with SGLT2 leading on to efferent arterial vasoconstriction, so reducing intraglomerular pressure and subsequently the proteinuria, and with the efferent arterial vasodilation by ACE and ARB combined together with SGLT2 inhibitors, you have overall reduction in proteinuria and better preservation of the kidney. We always knew that heart failure and kidney disease, they have a dynamic, a bidirectional relationship with hemodynamic changes to either heart or to the kidneys contributing towards the dysfunction of the other. So maybe protecting the kidney may protect heart and vice versa, because moment you have incipient or a manifest heart failure, there is going to be a reduction in cardiac output, which will not be able to meet the metabolic requirements. That will lead on to compensatory mechanism to restore cardiac output in the form of increased venous pressure, increased sympathetic nervous system tone, and natriuresis, which will then subsequently manifest as hypoperfusion through kidney, apoptosis, fibrosis, and glomerulosclerosis, which then leading on to increased RAS activation with sodium bottom retention, vasoconstriction, which will obviously worsen heart failure also. So it's a dynamic, dual, bidirectional relationship between heart failure and CKD. That is why I said most of the CKD patient will actually eventually die of CVD. So if you can check the progression of CKD, overall cardiovascular mortality will also go down. We know that hyperglycemia and type 2 diabetes ultimately leads to nephron and progression of kidney disease. Hyperglycemia will not only lead on to oxidative stress and inflammation, it will also stimulate vasoactive system. So there is going to be hyperfiltration, hypertension, glomerulosclerosis, and loss of filtration and barrier integrity to then subsequently manifesting as progression of albuminuria, nephron loss, and progression of kidney disease towards end-stage renal disease. So let's see whether we can check this progression or prevent management or prevent diabetic kidney disease worsening in patients with type 2 diabetes. So ADA said there are screening recommendations. Anyone for the first time manifesting as type 2 diabetes right at the time of diagnosis, we must look for albumin-creatinine ratio and eGFR. And even in type 1 diabetes, because it is a linear relationship with type 1, after 5 years, all these patients should be screened for presence of albumin-creatinine. Also, their eGFR should be calculated. And moment you have increased urinary albumin excretion more than 30 milligram per gram of creatinine or reduction in eGFR less than 60, these patients possibly will require monitoring twice annually, then doing just once a year. So we need to have a multifactorial intervention strategy which can slow the progression of DKD. Simply a blood pressure control will go a long way, as well as, of course, getting an HbA1c less than 7% ideally should be there. Blood pressure target ideally is less than 130/80, and first-line antihypertensive drugs in the setting of diabetes, especially in the presence of positive albumin or microalbumin, should be ACE or ARB, because RAS therapy with ACE or ARB is suggested to reduce not only the albumin excretion, but will also check the progression of CKD also. LDL lowering, well, it has been recommended to reduce the risk of atherosclerotic event in the presence of diabetic kidney disease. But unfortunately, despite treating to goals, a significant residual risk still remains in the progression of diabetic kidney disease. So you might get a blood pressure control and less than 130/80. LDL also going down with statin and HbA1c less than 7 but still it will only reduce risk by 60%. You still have good 40% residual risk in all these patients for progression of DKD in the setting of type 2 diabetes or maybe type 1 diabetes towards end stage. Unfortunately, for last 2 decades, no treatments were identified for the treatment of DKD. We were primarily focusing on high blood pressure, which was identified as a DKD risk factor with beta blockers, hydralazine, use of captopril, ramipril, irbesartan or losartan. But over next 15 to 20 years, where there were several strategies which have been explored, but none of these have been actually very, very successful or had a very, very limited success, whether you talk about PKC beta inhibitors or TGF beta production inhibitors, or you talk of endothelin antagonists or pseudodexide with various mechanisms to address DKD, or even aliskiren, which is a renin inhibitor, but all these drugs had very limited success. Even that bardoxolone methyl also, which is a key Kelch-like ECH protein 1 with nuclear factor, had a very limited success. And we possibly after 2015 with SGLT2 inhibitors through CV outcome trials, they established that they could also reduce renal composite endpoint, which has been seen as a breakthrough in management of diabetic kidney disease as early as EMPA-REG in 2016, subsequently with CANVAS or CANVAS-R data, dapagliflozin in decliatini, or even in Credence trial, which got published in 2019, which established the role of SGLT2 inhibitor in checking the progression of diabetic kidney disease by almost 30% in terms of total renal composite endpoints. Similarly, GLP-1 receptor agonist on kidney outcome in patient with type 2 diabetes, they have also been evaluated in various CV outcomes, whether it was earlier lixisenatide, liraglutide in leader trial, semaglutide in SUSTAIN and subsequently in PIONEER, or dulaglutide. All these drugs, they have established that they could check the progression of albuminuria. But when we try to compare SGLT2 versus GLP-1 in terms of kidney benefits, there are differing effects. Hard kidney outcomes or renal composite endpoints have been best addressed in SGLT2 inhibitors, not only in terms of reduction of albuminuria, also eGFR decline also goes down with SGLT2 inhibitor. With GLP-1 analog, benefits are primarily by reduction of albuminuria, but clear evidence in terms of reduction of eGFR decline or hard kidney outcomes has not been very, very clear with GLP-1 analog. Credence was the first completed trial with kidney outcomes, which was conducted in patients with type 2 diabetes and albuminuric CKD. And in this trial, it was seen that there could be a 30% risk reduction, which was p-value wise very, very significant in terms of renal composite primary endpoints, whether it was ESKD or doubling of serum creatinine, death from kidney disease or CV death. And secondary outcomes were also significant with CV death or hospitalization, heart failure composite going down by 31%, 3-point MACE going down by 20%, and hospitalization with heart failure also going down by 39%. So all global clinical guidelines today unanimously recommend that there has to be a preferential use of SGLT2 inhibitors in patient with diabetic kidney disease or CKD. For patient with diabetes or CKD, SGLT2 have been shown to reduce the risk of CKD progression and are recommended with an evidence 1A, with if SGLT2 are either not tolerated or eGFR is very low, something like less than 20 or 15, although cutoffs for SGLT2 is coming down to almost 20 now, there you could use drug like GLP-1 with proven benefits. But various studies are still ongoing. Several studies which are addressing the issue of renal composite endpoints with or without diabetes, that means progression of DKD. Well, DAPA-CKD is already available. Results are out. I'll be alluding to that. Fidelos DKD, which is finerenone, or Fiagro DKD, which is again finerenone. These studies are going on. EMPA kidney may be out in 2022, and even FLOW with semaglutide will be out sometime in 2024. Well, DAPA-CKD results have been very, very positive. We knew that DAPA-CKD was the first dedicated renal outcome trial to assess the efficacy and safety of SGLT2 inhibitor. In fact, this trial was stopped prematurely, lest the placebo misses that benefit, because there was a 39% relative risk reduction in composite endpoints as far as renal endpoints were concerned, 44% relative risk reduction even in the secondary renal composite endpoints, and 29% risk reduction for composite CV death or hospitalization for heart failure or all-cause mortality. So based on that, US FDA in May 2020 itself cleared that dapagliflozin has to be part of a standard care in management of CKD, irrespective whether patient is diabetic or non-diabetic, because benefits even in non-diabetic were very, very overwhelming. So this is Fidelio DKD trial design. I'll not be going into the detail. Suffice to say that this is to assess efficacy and safety of finerenone compared with placebo at reducing clinically important kidney and CV outcome, primarily time to first occurrence of composite kidney failure and sustained decline in eGFR. Of course, they will also be looking for CV outcome. While Figaro DKD, it is little different. Again, they are looking for efficacy and safety of finerenone, but it is being compared with placebo at reducing primarily important CV outcome. Of course, also looking into the secondary outcomes as important kidney endpoints in setting of type 2 diabetes with DKD. EMPA kidney, well, it is already on. I told you, EMPA versus placebo along with the standard care, and results will be out within 1.5 to 2 years. So based on evidence from SGLT2 inhibitor and GLP-1 receptor agonist, all outcome trials, whether they were CV outcome trials or subsequently renal composite endpoints, over the years, last 5 to 7 years, guidelines have evolved, especially AD guidelines have evolved to recommend SGLT2 inhibitor and GLP-1 receptor agonist with proven CV and kidney benefits. Earlier days, 2016, we were talking of only glucose lowering to reduce progression of DKD. 2017, for the first time, we said that you consider EMPA or liraglutide to reduce mortality because the evidence of safety and efficacy was level B. 2018, subsequently, it said that incorporate an agent proven to reduce CV events and mortality with level of evidence A. 2019 subsequently evolved to say that SGLT2 or GLP-1 must be there in every patient whosoever has atherosclerotic cardiovascular disease, heart failure, or incipient diabetic nephropathy or manifest diabetic nephropathy with evidence of efficacy level A. 2020, for the first time, both ADA and subsequently ACE said that SGLT2 or GLP-1, because they have demonstrated benefits in terms of CV risk reduction as well as progression of diabetic nephropathy and composite heart failure and CV death with an evidence of level A. So it has to be part of therapy, irrespective of the glycemic control. Even if patient already has an HbA1c close to 7, we must reduce other drugs to make a space for using SGLT2 inhibitor or GLP-1 analog. So to summarize my session, we know kidney disease in patient with type 2 diabetes is associated with reduced life expectancy and much higher cardiovascular mortality. Systematic effects of hyperglycemia in patient with type 2 ultimately lead to nephron loss, albuminuria, and progression of kidney disease. All guidelines today unanimously recommend that kidney function of patient with type 2 diabetes should be assessed in terms of eGFR as well as albuminuria, and of course evidence from SGLT2 inhibitor and GLP-1 receptor agonist. And I told you a couple of new compounds which might see the light in next 2 years. They might be the standard part of standard care in management of CKD, whether you have diabetes or you don't have diabetes, because benefits are equal even in setting of without diabetes also. Thank you very much for your patience listening. I'll stop share here and stand by for some discussion.
Thank you, sir. Thank you, Dr. Rajiv Chawla. It was really a wonderful presentation about everything on prevention and progression of renal disease. Now, I have a couple of questions here. Let me first start with Dr. Binay. One, is NAFLD familial?
No, not that I'm aware of.
Yeah.
There's no
So there was a question in the chart box, so I thought I'd ask you. And use of saroglitazar in NAFLD.
I was thinking somebody would bring this up. So saroglitazar does not have any evidence base. Saroglitazar has had a few phase 2 studies. There's a couple of phase 2 studies. They have a phase 3 study which has not been published. It has been published in a magazine, not in a peer-reviewed journal, which I think the company professes to a variety of people. If you look at the data in that magazine, it is actually very convincing data. If it's really a phase 3 study and it has been done, it really needs to see the light of day, because it will definitely mean a new treatment option for patients with type 2 diabetes and NAFLD, or even NAFLD, even if you leave aside the type 2 diabetes side of things. But unfortunately, saroglitazar, I find the main problem with saroglitazar is lack of published evidence. It's all in, according to pharma.
As we were aware, muraglitazar and other glitazars didn't see the light of day because of inadequate data on cardiovasculars. I don't know if they were being developed now, they would be looked at very differently.
Sanjay, can I interject?
Please.
Binac, it's been approved by DCGI, you know. But then how?
I know. So much teneligliptin, so much remogliflozin.
So it's been used, and you get somebody walking into your clinic and say, so this is for NAFLD. So
today we have ivermectin, which FDA has actually put out a thing. This medicines are for the cows and the horses. Do you want to have them? This is the FDA statement. It is approved for use in COVID by DCGI.
So sometimes it's really perplexing. Dr. JJ, I don't think there are any questions, but how many of the simplest course, and I liked the presentation, though it was a difficult task to really present it in the way which you could do it. How many of you use scores in clinical practice?
I mean, I'll be very honest. I don't use any score. If I was forced to use a score, I would use the QRISK 3 score. But QRISK 3 score has got a huge number. Binac will tell you much better because they did the paper.
Yes,
there's a huge number of components, including impotence, including rheumatoid arthritis, including many other things. So sitting them and putting down in the clinic myself is not possible. It's very good in the research setting or in Oxford, where your professor sees the patient last, where the legwork has been done by all the juniors. In my clinic, I can't afford to do it. So I find the ESC, ESD gradation very nice. It's very simple. It's very high risk, moderate risk.
Moderate risk.
And it's very easy to remember. Moderate risk is most of the patients that we see who are young, who have diabetes less than 10 years, who do not have any associated comorbidity. So you can count on your fingers how many you see, but there are a large number of patients who have got type 2 diabetes, no hypertension, no dyslipidemia. So these would come in moderate risk. High risk, the very high risk is somebody who's already had a cardiac event or has got any one target organ damage or has got all the three comorbidities, hypertension, hyperlipidemia, and in between it becomes a high risk. So whether you are moderate risk or high risk, your screening is only a 12-lead ECG. Based on that, you progress further. Very high risk patients, you go case by case. If they have already have an established cardiovascular disease, then there is no question. The patient goes to your cardiology colleague and use, as a diabetologist, start an SGLT2 inhibitor. And as Dr. Rajiv Chawla was mentioning. And if you have type 2 diabetes, multiple risk factors, again, very high risk patients, you as a diabetologist will start SGLT2 inhibitors and of course do standard of care. See, I always insist, we forget standard of care when we give these talks. We always have to know that in CVOT trials, in all renal trials, the first and foremost was standard of care is glycemic control, which unfortunately pitiful less than 30% in India are achieving it. I mean, there are many causes for that. Blood pressure control, they're not achieving it. Statins, even Nempa, outcome cancer, they're not using it. So can we first beat the drums that, use enough anti-diabetic drugs, hypertensive medication, and after that, certainly, icing on the cake, use the other drugs. So screening, I think, very simple. I think under Arvind Sosale's admin name, I think Krishna is there. So Krishna, thanks for this topic. Maybe he's muted, he can't hear me. So I think a 12-lead ECG would be the basic. And if you want to screen for heart failure, NT-proBNP we generally can't do in our clinics. It's quite expensive. So that's where a 2D echo comes in. So maybe a 2D echo and a 12-lead ECG. 2D echo only when you think of heart failure. And then if very high risk, then it becomes very confusing. In our hospital, they're still doing treadmill test. Now, treadmill test has got a lot of issues with regards to sensitivity and specificity, but it's easy to do, you see. On the other hand, if you want a stress echo, you want a nuclear medicine imaging,
that's a
expense, and patient does not want to go to another clinic. So I'll stop there.
I know
We
the
can go on this topic for
testings are reserved, even in practice. I'm sure it's not an easy thing to do. Sir, Dr. Rajiv Chawla, So when do you stop? When do you stop using SGLT2 inhibitors? What GFR are you using? We know the data,
Well,
but there's a question
yesterday,
here, so I need to
yesterday
ask you.
only we had Emperor Preserved where they've
Yes.
used up to 20 ml. So I'll definitely like to use an SGLT2 inhibitor at least till 20 ml
EGFR. Yes.
Although although that label hasn't yet been revised, but I'm sure we can safely use it 20 m till 20 m.
20 ml. Thank you for that. Dr. Binayak, what do we see the future of NAFLD? Where do you see it?
I think the first thing is we have to take cognizance of it. I think till now, I think we the kind of focus that we've had on CVOTs and renal disease, I don't think we've had that kind of a focus on NAFLD.
So I liked your last slide, but it's going to be NAFLD-based therapies in future for renal, cardiovascular, and
because it's causing as many deaths. You know,
Yes.
it's not that it's not causing deaths. It's something that's quite a serious illness in diabetes.
I think ever since we have started looking for NAFLD over last 5-10 years, we are finding that many of our type 2 diabetes patients ultimately end up with cirrhosis, which is absolutely
Absolutely, I totally agree with Dr. Chawla. And the thing is, if you have something like JJ said, it's difficult to do a QRIS-3 because it's so fiddly and so many things to do. This the FIBS, NFLD, NFS score is so simple. There's 3 parameters to fill up: diabetes or non-diabetes, BMI, AST/ALT. So it's easy to do. So I've started doing it, but I think I'm still late in this game. I think we should have done this a long time back.
Correct. One of the reasons we don't do it is lack of therapy. You see, in the end, it's lifestyle, where the patient screams at you when you say lose some more weight. That's one of the bugbears you see of NAFLD.
I agree with you, JJ. I think we've discussed this once before also, that the SGLT2 and the GLP data are still in a pretty much a fetal stage. But but that is where I think we will turn to. I think it will prove to be. There is data coming out on SGLT2 in NAFLD with diabetes and without diabetes. The data with semaglutide as far as NAFLD is concerned in cirrhosis is looking very promising. But it's difficult to do. Renal is very easy to do. Creatinine, urine ACR, heart attack, no heart attack. But how do you classify NAFLD? You have to stick in a needle, which is a dangerous thing.
I understand doing a
just add a point here, if it's okay. It's also possible that JJ, just to take from where you left off. It's also possible that we are older.
Morphed into Arvind.
There are 2 Arvinds, both you and.
Right.
Right. We are. He's my alter ego.
Okay.
So
Krishna today is Arvind.
So it's also possible, that going from the collective lack of hair in this group, that we are ballparkers and not measurers. We trained at a time that we ballparked everything.
Yeah.
But I think it's time for us to adapt and start doing scores. To start doing the QRIS-3, or now I use a lot of the calcium CAC based score, and I religiously have started documenting FIB4, not FIB4, but I use the NAFLD. The scores. I think it's time for us old folks to also learn not to ballpark. I think that's part of what a systemic stuff.
Who's old out here, Krishna? I don't know.
I know. Everyone who's 10 years older than me.
Okay. Thank you very much. It was wonderful discussing comorbidities and clinical care. And thank you, Dr. JJ Mukherjee, Dr. Binayak.
We have all 3 of you there, Krishna, Arvind.
Really enjoyed
it. Thank you
Dr.
very much
Rajiv.
for inviting.
Thank you, Sanjay. Thank you, Dr. Krishna. And of course, Big B, brother is not visible. Where is
Here, brother is visible this
Thank
side.
you.
He can
Thank
do
you.
this. Yeah.
Thanks a lot.
Thank you, Dr. Prasanna.
Thank you.
Thanks a lot.
Thank you very much. Bye.
Hi, good evening, everybody. This is Dr. Arvind. I'll be moderating this session. I'll actually be chairing the session, and Dr. Jens Juul Holst will be delivering his lecture now. And I was told that he has recorded his lecture, and he's also live for the question and answer sessions. So we'll be playing his recorded lecture, followed by his presence live. Dr. Jens Juul Holst is an endocrinologist of international repute. Many of you would have read his papers. He's the professor and head of research group that focuses on obesity and type 2 diabetes, especially with the aim of mapping hormonal disorders and the possibilities of treatment based on hormones. His research focuses on basic science and metabolic disorders, concentrating on appetite regulation and hormones that regulate metabolism. Dr. Jens has made several groundbreaking discoveries in his career. He cements his position in the major league of science as a world-class researcher. He will also be receiving this year's Canada's highest award called the Gairdner International Award. Thank you. Can the IT team play his lecture, please? Dr. Jens, would you like to speak live, or can we play the recorded lecture? I think we'll play the recorded lecture, and that's better.
Yes, please do that. Please do that. Yes.
Yeah.
Hello, my name is Jens Juul Holst. I'm a professor at the University of Copenhagen, and I'm here to talk about the incretins. We've called it a game-changing innovation, evolution of GLP-1 analogs from research to patients' outcomes, story of the incretins. First of all, financial disclosure. Novo Nordisk has supported this event, but otherwise I don't have any conflicts of interest to introduce here. So let us start with the beginning. And in the beginning, we had the gut. So if we look back 1 billion years ago, what did life look like? It looked like these animals here. What we're looking at is the hydra. And as you can see, the hydra is in principle a gut. That's all there is in this structure. So the gut was the first thing to develop and the most important organ, of course. So what happened then was that there was in this gut, there were interesting cells that produced regulatory peptides, and some of them would develop into cells that could produce insulin-like peptides and glucagon-like peptides and somatostatin-like peptides. And eventually, as we arrive at the cyclostomes, some of these cells migrate out of the gut tube and begin to start to form clusters. And that's how the pancreas, the islets of the pancreas, were actually gradually formed. So what happened was that the islets were formed from the gut, and they produced then all the known cells in the pancreas that we know today. So, but as these cells migrated out and established the islets, the fact is that they really never left each other, that they always have maintained contact. So that's what we are looking at when we look at the history of the incretin system. It started really back in 1902 when Bayliss and Starling discovered the mechanism behind pancreatic secretion and found the first hormone, a gut hormone, secretin it was. And they were, of course, interested in the regulation of pancreatic exocrine secretion. But as time went by, there was also an interest in pancreatic endocrine secretion. We remember that insulin had been identified in 1921, and there was an interest in trying to see if the gut also regulated insulin secretion and effect. And that's why this term incretin was introduced to differentiate incretins from excretins. That was the secretin molecules that would influence the exocrine secretion, and then there were also molecules that could influence the endocrine secretion. They were called incretins, but they were of course not identified. What was necessary was that it was possible to measure GLP-1 secretion, and once that was possible, then several groups ended up in demonstrating the effect of the gut on insulin secretion. And as you can see here, McIntyre, for instance, showed that there was much more insulin released during oral ingestion of glucose than after intravenous ingestion. Here you can see that even if the blood glucose is lower, the insulin concentration is higher. And several groups studied this and found that a very large percentage of the insulin that was released by gastrointestinal factors. So the next thing that happened was that Brown and Dupre demonstrated that the new molecule GIP, gastric inhibitory polypeptide, it was called in those days, actually had an effect on insulin secretion. It was isolated as an inhibitory peptide for the stomach, but it turned out that this new molecule actually could stimulate insulin secretion greatly, as seen here. So this was perhaps the first incretin hormone. What happened then was that this was, considered an important incretin hormone, but there were many observations that suggested that this was not the only hormone. And first of all, here in our group, Kjeld Lauritsen showed that the incretin effect did not correlate with GIP, but rather with the length of distal small intestine remaining after intestinal resections. Another observation that both we and Werner Kreuzfeld's group did was that immunoneutralization for GIP could not remove all of the incretin activity. A blow to GIP came in 1987 when Ture Krav from our group showed that porcine GIP was inactive in patients with type 2 diabetes. And this was really dramatic because it removed some of the support we had from various sources. So we concluded that there had to be another incretin hormone, but which hormone? So another important date is the occurrence of radioimmunoassays for glucagon and antibodies for glucagon, and they started to be developed by Roger Unk, of course, in 1959. And with these antibodies, it was possible to find these cells in the gut. They are L cells, we call them, and they have glucagon immunoreactivity. At the same time, or a little bit later, Samols and Marx found that glucagon actually stimulates insulin secretion. So if these cells contained glucagon, they might be responsible for this secretion. By 1981, it was found what molecule was actually responsible for this immunoreactivity here. And that was a molecule called glycensine that I will show in a minute, and also one that is called oxyntomodulin. And what we found was that these two molecules together were actually at least a part of the pro-glucagon molecule, the precursor for the pancreatic hormone glucagon. Eventually in 1983, the full pro-glucagon structure was identified by cloning by Graham Bell. And we could then look at the structures in the gut and find out that there was a differential processing of pro-glucagon going on in the gut and in the pancreas. So these L cells in the gut, they actually led to the identification of gut glucagon and pro-glucagon. And here we have pro-glucagon. It turned out to be a source for several hormones. So here we have the entire pro-glucagon sequence. Here we have what happens in the pancreas. Glucagon is cleaved out of this large molecule, and all of this large part is kept together and secreted in this major form. But in the gut, and also in the brain actually, something different happens. Glucagon is no longer liberated from this part. It's still contained in the glycensine molecule. Part of it is cleaved to oxyntomodulin. But over here, we can see that this large part of the molecule, the major pro-glucagon fragment, is now cleaved to release GLP-1, which we have here, and GLP-2, which is a very interesting trophic factor for the gut that we will have to talk about some other time. So the differential processing of pro-glucagon was the key to all of this. So the way we found the short form of GLP-1 that was cleaved out of the major pro-glucagon fragment was to look at secretion from an isolated perfused pig pancreas, which we have lying here. And what it can do is, of course, to produce insulin. And with this new molecule that we were able to pull out of intestinal extracts, we could see that it stimulated insulin secretion very much, very, very powerfully. So this was, of course, extremely interesting. There was one more interesting observation that we did that really turned our attention on, and that was that it also apparently inhibited glucagon secretion as seen over here. So now we had a molecule with two actions. Not only did it stimulate insulin secretion, but it also inhibited glucagon secretion, both of which are, of course, extremely important for the regulation of blood glucose levels. So let's have a look at the two hormones, GLP-1 and GIP, and see how important they are for their incretin function. In these experiments, we were looking at people with glucose clamped at fasting levels, a little bit above and a little bit further above, covering what we normally see after meals. And then we infused GIP on top of these clamps here, and GLP-1, and we made sure that we were reaching absolutely physiological concentrations of the two hormones as you would see them after a meal. And here we have what happened. So insulin secretion was stimulated at the fasting level by both of these hormones, and they were about equally potent, as you can see. At higher levels, both of them were more effective, and at higher glucose levels, they were even more effective. The secretion of both of them depended on the glucose levels. But they differ considerably when we're talking about glucagon. You can see that GLP-1 invariably inhibited glucagon secretion, whereas GIP did not. Glucose alone, of course, inhibited glucagon also, but the GLP-1 effect was clear anyway. So a lot of studies have been done, and most recently we've been able to look at the contributions of these two hormones for insulin secretion after the meal, the incretin function. And we were able to do this with antagonists against the GIP and the GLP-1 receptor in healthy individuals. And what we found was that GIP was responsible for 45% of the effect, that glucose was responsible for 26%, and GLP-1 was responsible for 29% of the incretin effect. Over here, you can clearly see the effect of the two. This is glucose stimulation of insulin secretion, and you can see that what both of them do is to stimulate glucose-induced insulin secretion. This is very important. So they potentiate insulin secretion in a glucose concentration-dependent manner. They don't act if there's no glucose around, and that's why they're safe in terms of hypoglycemia. So GLP-1 was not the most powerful incretin hormone, but it does a lot of other things. So one of the important things was that it also inhibited appetite and food intake. And here you can see the recordings, the first we did in 1998, of appetite scores here, where you increase appetite and increase satiety and decrease hunger. And over here you can see the difference in energy intake as you increase the rate of infusion of GLP-1. The more you infuse, the more you reduce your food intake. So this was another important mechanism of action. So how does it do that? So that's very interesting. Here we have a cartoon that shows the L cell releasing GLP-1 in the gut. And as it's getting stimulated by nutrients coming by here, the GLP-1 molecules are released and diffuse across the lamina propria to be taken up in intestinal capillaries, as shown here. What they meet here is an enzyme called dipeptidyl peptidase 4 that cleaves off 2 amino acids from the molecule, and the rest of the molecule, the truncated form, is now inactive. And this is very, very effective, so that only about 25% of the GLP-1 released over here is still active as we get to the portal vein. In the liver, there's more enzyme ready to cleave more GLP-1, so about half of it is inactivated, and now we're down to about 12% of what was actually released. And in the circulation, you also have DPP-4, so that eventually we are below 10% active GLP-1 over here. The rest is the metabolite. But on its way, it has the ability to interact with sensory neurons. For instance, vagal sensory neurons. They have been demonstrated to express the GLP-1 receptor. It's formed up here in the nodose ganglion and transported down to the termini here. And here GLP-1 can then interact with these vagal afferents and send a signal to the brainstem, to the nucleus of the solitary tract. And here there are other cells that can transmit information further up to the hypothalamus. This has been demonstrated, and also to motor nuclei of the vagus in the brainstem here, so that we can have descending effects on via the vagus system to both the pancreas and the gut and various other tissues. So this is what can happen. And here we see something interesting, that is activation of the neurons in various regions. And here have we activation that is by C-Fos staining. It's shown here. And here you can see the nucleus of the solitary tract after a GLP-1 agonist has been administered. There's also another pathway into the brain, and that is via the area postrema. That's how you can get to the brain via the circulation. And as you do this, as you stimulate these nerves, you also get activation of the central nucleus of the amygdala here, and also in the paraventricular nucleus. These are some of the key nuclei that are activated here. And as you do this, you inhibit food intake. This vagal mechanism, can you demonstrate that this also exists in humans? We did some experiments to show this, and we looked at vagotomy in people that had truncal vagotomies done for duodenal ulcers. And in these individuals, there are two very clear effects here. One was to look at gastric emptying, and this is in healthy controls. And if you give these people GLP-1, you very powerfully inhibit gastric emptying, as you can see. Here we have those that have had the truncal vagotomy. They have a much faster emptying of the stomach, but as you can see, it is now completely uninfluenced by GLP-1. And over here we have the important part of this experiment, that's the food intake. So here we have control individuals with intact vagus nerves, and when we give them GLP-1 infusion, you inhibit the food intake by about 10-15%. This is the typical result. But if you look at those that had their vagus nerves cut, there was absolutely no effect. So we're pretty sure that this can also be observed in people. Another very clear example of some of these mechanisms is observed in people after operations for obesity. Here it's the Roux-en-Y gastric bypass operation. What is it that happens after these operations? What happens is that your food enters the small intestine and gets transported to a more distal site down here where there are many L cells. And one of the L cells, they produce two hormones, GLP-1 and PYY. And both of these hormones are important for appetite and food intake. Of course, the GLP-1 also will act on the pancreas and causes a dramatic stimulation of insulin secretion. And this is one of the important effects for the anti-diabetic effects of the Roux-en-Y gastric bypass. But let's have a look at the secretion of GLP-1 and PYY from these people with the Roux-en-Y gastric bypass and see what happens. So what we did was to look at meal intake and ad libitum food intake over here after we had stimulated the secretion with a standard mixed meal here. And then we tried to block the effects of GLP-1 and PYY. And that can be done because you have a blocker for the GLP-1 receptor, that is the peptide exendin 9-39. But it's also possible to block the actions of PYY. And that's because PYY needs to be activated by being broken down by DPP-4 again. So it is in the form of 1-36 when it's secreted, but then it is transformed to the form 3-36 by the DPP-4, and you can prevent that with a DPP-4 inhibitor. So that's exactly what we did. And now we can see over here that this is the food intake you have in the placebo experiment. This is after you block the GLP-1 receptor alone, no significant effect. This is what happens if you block the formation of the active form of PYY, no significant effect. But if you do both of them, you block both of them, you see a significant 20% increase in food intake, as you would expect if this is important. So here we clearly see the effect of these two hormones on food intake in these patients after the Roux-en-Y gastric bypass. So if we look at the mechanisms together here, here's an overview of the most prominent GLP-1 mechanisms. We have the glucose-dependent lowering of blood glucose. We have the stimulated insulin secretion and the lower glucagon secretion, and both are about equally important. And we also have the effect on gastric emptying. We have the lowering of body weight, and here we have a lower energy intake and increased satiety, reduced hunger, reduced cravings, and also we have altered food choices. And then we have cardiovascular risk reduction that we will come back to, all of these factors here. So if we look at the pancreatic actions, there are both actions on the islets, as we've talked about. Here we have the GLP-1 molecule, and here we have the interactions via the GLP-1 receptor on the beta cell and the stimulated insulin secretion, insulin biosynthesis, the decreased apoptosis. But we also have an effect on somatostatin cells, and they stimulate their secretion of somatostatin, which then inhibits the alpha cell secretion, and that's the explanation for the inhibition of glucagon secretion. We also have an effect on the exocrine pancreas because there's also expression of the GLP-1 receptor on the acinar cells. And here what GLP-1 does is that it stimulates protein and enzyme biosynthesis so that you have an increased secretion of pancreatic enzymes. This is a natural process. So the elevation you have in the plasma of both amylase and lipase, they are the results of a natural interaction between GLP-1 and the pancreatic acinar cells. It is not a sign of inflammation. I think this is important to realize. So if you put all of this together, all the actions of GLP-1 over here and the type 2 diabetic phenotype over here, we have, that almost everything that is wrong with type 2 diabetes is met by the actions of GLP-1. So the impaired beta cell function can be helped by GLP-1, which improves insulin secretion and biosynthesis and improves all parameters of beta cell function you can decide to look at, and regulates all the genes that are essential for beta cell function. You have a reduced beta cell mass, and although it may be that in humans it's difficult to see beta cell proliferation, which have been observed in animal studies, we at least have probably the decrease in beta cell apoptosis that can be nicely demonstrated in human beta cells. You have glucagon hypersecretion, which is effectively met by GLP-1. You have overeating and obesity, and what you have with GLP-1 is a decrease in gastric emptying, an increase in satiety, a decrease in appetite, a decrease in food intake, and weight loss. And then, again, we have the beneficial cardiovascular effects, which will, to some extent, combat the macro and microvascular complications. Actually, we also have insulin resistance. What about that? Well, as you lose weight, you will also improve your insulin sensitivity. So during therapy with a GLP-1 receptor agonist, you will also see improvements in insulin sensitivity, although they're probably indirect, no direct effect on the adipose tissue as far as we know. So let's try to use GLP-1. Why is it not directly a therapeutic agent? That's because it's extremely rapidly eliminated. So if you inject GLP-1 to people with type 2 diabetes or healthy individuals, you'll get an elimination that is extremely fast. So what happens is that this enzyme DPP-4 cuts off these two N-terminal amino acids here, and this part of the molecule, the metabolite, is inactive. And this happens with an incredibly high speed, so that the half-life is just about 1 to 2 minutes in people. In addition, there is a very high renal clearance, so it simply has a very, very short half-life. How can we fix that? So one of the smart ways that we found very early on, back in 1995, was that we could inhibit this enzyme, the DPP-4 enzyme, and then protect the endogenous GLP-1. And this is what you see here. It's not a very pronounced effect, but it's enough to have a physiological effect on insulin and glucagon secretion. And that's how the DPP-4 inhibitors work. But with GLP-1 receptor agonists injected, then you can, of course, obtain any concentration you wish, and you can have very powerful effects on appetite and food intake, causing weight loss, effects on gastric emptying, and also some of the cardiovascular things. So here's the class of GLP-1 receptor agonists. Some of them are based on Exendin, this molecule that was isolated from the Gila monster, the lizard from Arizona, which is GLP-1-like with about 50% of homology, but is quite different. It is resistant to DPP-4, and there are various forms, as you can see here. They are characteristically short-acting. And then there are the long-acting ones, where the survival of the molecule has been obtained with a acylation. Here, a fatty acid has been attached to the GLP-1 sequence, forming the molecule liraglutide, and a different fatty acid here has been combined with GLP-1, forming semaglutide, which now is a once-weekly drug. Over here, a different principle in dulaglutide has been used, that is to couple GLP-1 sequences with a large molecule. This is an FC domain of IgG molecules. In albiglutide, which is interesting because of its cardiovascular actions, but otherwise is not going to be continued, I think you have conjugation to albumin of no less than 2 molecules of GLP-1. And then there's, of course, the most exciting addition, that is the oral formulation of GLP-1. So here you have the semaglutide that we talked about already with its fatty acid moiety, and it's the once weekly compound. It's the most effective GLP-1 receptor agonist we have. It has this weekly half-life. And then you can combine it with something called SNAC, which is a fatty acid derivative. And that promotes absorption across the gastric epithelium. So, and it enhances the oral bioavailability of semaglutide. And you can combine the two in a tablet. And then what you get is this. So what you have, you take the tablet, it adheres to the gastric mucosa, and the semaglutide and the SNAC molecules are released. And aided by the SNAC molecule, semaglutide is now able to cross the cells of the gastric epithelium and enter the bloodstream. The most important of this is to understand that this molecule of semaglutide is exactly the same as any semaglutide molecule that was injected subcutaneously. In other words, as soon as it has entered the bloodstream, they're completely identical. So there's no difference between the oral semaglutide and the subcutaneous injection. It's just that this one has been transported into the bloodstream via the stomach. So this is a very interesting slide that shows the changes in hemoglobin A1c from baseline as a concentration of the exposure to semaglutide. So these are the concentrations of semaglutide. And you can see here that the higher the concentration is, the stronger is the effect on hemoglobin A1c. And this is for a similar curve for the oral semaglutide. And here is how it was obtained. So here you have 3 milligrams oral, 7 milligrams oral, 14 milligrams oral, 1 milligram subcutaneous, half a milligram subcutaneous, and they generated all these concentrations that you can see. So because these curves are completely identical, you can conclude that whether you take in semaglutide orally or have it injected subcutaneously, their effects and the dose-response relationship for its effect on hemoglobin A1c are exactly the same. How good are they? Well, this is a very good question. And how do you look at this? One way is to look at, for instance, a study like the LEADER study, where liraglutide was studied for no less than 5 years, up to 5 years. And you can see that hemoglobin A1c was reduced very nicely in this study, and that the reduction was maintained beautifully over almost all these 5 years. Well, you can say, okay, the placebo group also did quite well. Yes, but that's because in the placebo group, the physicians were encouraged to increase all sorts of other anti-diabetic medicines. In particular, insulin was very much enhanced in this group. So this cannot really be, should not be compared to the liraglutide group. Sure enough, there were much more hypoglycemia in the placebo group than there was in the liraglutide group. And over here, you can look at the body weight over the same kind of period. And also here, you can see that the body weight reduction was maintained for all of these years, which was very encouraging, of course. So here we're looking at something very important, the cardiovascular outcomes that were obtained with semaglutide. And what we're looking at here is MACE. It is the primary outcome. It is the major adverse cardiovascular events. And this was in the subcutaneous study with semaglutide, which was a cardiovascular outcome trial. And it was lasting for 2 years, as you can see here. And over these 2 years, the frequency, the risk of having a MACE event was reduced by no less than 26% with semaglutide. And from these graphs, you can see that this was due to a reduction in non-fatal myocardial infarction and non-fatal stroke. Let me emphasize this result from stroke because it's very important. So this was how this was generated. So these agonists, they have this remarkable effect. So what are the effects that are responsible for this? There can be many things that all can contribute to reduce the cardiovascular risk in type 2. So normally what you have is that you have insulin resistance, which can influence the vessels. You have the hyperinsulinemia in some stages that can also increase the risk. You have hypertension, you have advanced glycation end products, and you have hypoglycemia, that all of it will contribute to the cardiovascular effect. And then you have dyslipidemia with high lipids, and you have obesity, you have TNF-alpha activation, you have CRP suggesting inflammation and thrombosis and dyslipidemia. And all of this is what you can affect with GLP-1 therapy. So let's have a look at the studies that have been out there. So these are the cardiovascular outcome trials that have been presented, and this is really all of them. The two first here, ELIXIR and EXCEL, they're both with exendin-derived molecules, whereas all the others are based on the human GLP-1 molecule. And if you look at them all, you can see that except for ELIXIR up here, there's a nice reduction in the risk of developing MACE here, major cardiovascular adverse event, consisting of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. And these are the individual figures. Note here that the subcutaneous semaglutide is by far the strongest effect of all. And if you do a meta-analysis and combine them all here, then you get a 12% reduction in the overall risk. You can say that we don't want to have the exendin-derived molecules into this calculation. So let's see what then happens. This means that we're going now from 56,000 individuals, where there was an average 12% reduction observed, now to 35,000. But here now you can see that combining those that are based on human GLP-1 agonists, then we have a reduction of 16% from this population of 35,000 individuals. Also very strong data, of course. And if you look only at the things that contribute to this, then you have that cardiovascular death, myocardial infarction, and again, let me emphasize, on this huge population of 56,000, you have a very significant and powerful reduction in stroke. So this is really very remarkable. So these GLP-1 receptor agonists, they do inhibit the risk of stroke. And that's perhaps one of the most striking effects of these compounds. 16% reduction. And if you look at the pool analysis over here for all-cause death and hospitalization for heart failure, you can see that, yes, fortunately, there's no increase in all-cause deaths. It is also proportionally decreased by these agonists, of course. There's also a risk of hospitalization for heart failure that is decreased by them by 9%, but this is not one of the strongest effects, and it doesn't seem to have a major effect on this, except as to say that if you reduce the cardiovascular risk in terms of myocardial infarction, you will also eventually have a reduction in the risk of heart failure, of course. Again, here we're looking at the first MACE in the SUSTAIN 6, which is the subcutaneous semaglutide study. And here we have PIONEER 6. And here you can see it didn't really reach significance. But if you combine them and do a meta-analysis, you have a strong 24% reduction in the MACE risk here. Very nice result. And what's the difference then? Why was it not obtained in the PIONEER, which is the oral semaglutide? That's because it was a completely different study. Both of them were pre-registration studies that were designed to show that they did not increase cardiovascular risk. And that's why they were only carried on for until a certain number of events was calculated. And this was then identified within 1.3 years, whereas this one was a full 2-year study. The participants were about the same, but there were, of course, much less events in the Pioneer 6 study, and that's why the significance was not obtained. The reduction is about the same, as you can see. Secondary efficacy endpoints, let's look at the lipids. Total cholesterol, small reduction. HDL cholesterol, no real change. LDL cholesterol, small reduction. But the triglycerides are actually quite nicely reduced in these studies. And also, what happened to the systolic blood pressure? A very nice reduction, as shown here. Diastolic blood pressure, no real change. Pulse rate, yes, it's increased as always, but apparently the effect on the blood pressure overrides if there is an untoward effect of the pulse rate, then it's overridden by the effect on the systolic blood pressure. And here's something that I again find very interesting. So this is the Pioneer studies, again, with the oral semaglutide, and you can see that there is a very nice reduction in CRP, high sensitivity CRP measurements in both of these studies from the Pioneer studies, registration studies for oral semaglutide. And again, in 3 of the studies here, you can see how the reductions compare to the control groups. Here is it in 2 doses. Here's the control group. There's a strong reduction of high sensitivity CRP measurements during the therapy with oral semaglutide as compared with the placebo or other comparators. So one more important point, what happens to kidney function? And here we have, again, a meta-analysis of these cardiovascular outcome trials. Here we have them all, and here is the overall estimate. And as you can see, there is a significant and 17% reduction in the risk for a worsening of kidney function, the composite kidney outcome during the trial. And that's, of course, very nice. And that's why the new guidelines say that GLP-1 receptors agonists are preferred after metformin and SGLT2 inhibitors because they have the cardiovascular benefits. They have the potent glucose lowering effect, more actually than the SGLT2s. They have a weight loss potential, and they do have kidney benefits because they all reduce albuminuria. And what about the eGFR, which is, of course, the most important parameter? And that's shown here, that this is the annual change in estimated GFR from baseline in people with a low eGFR and with a high eGFR. And you can see that the annual change in these patients is reduced. The annual decrease here and here and here is significantly reduced by the treatment with semaglutide. So there is an effect on glomerular filtration rate. It's not only on albumin excretion. So regarding cardio and renal protection, what I think is important is that the GLP-1 receptor agonists, both liraglutide and semaglutide, improve MACE in the cardiovascular outcome trials. They have no effect on the failing heart. That's important, but they do, in the long run, perhaps protect. Their effect on cardiac ischemia is not completely clear, but there are effects on myocardial infarction rates now. The main effect on the heart is an increase in heart rate, but there's also decreases in blood pressure. There's no effect on coronary reserve and no receptor expression in the coronary vessels. They do prevent stroke, myocardial infarction, and they also reduce the rate of revascularization procedures in the clinical studies. They have powerful beneficial effects on A1C, body weight, and blood pressure. They have also beneficial on kidneys. One of the mechanisms that we have to look at is angiotensin II, and that will come in future studies. Together, their actions improve metabolic health, and that's why I maintain that their cardiovascular actions may, in principle, be mainly preventive. So what's the future like? Well, here we had GLP-1 discovered, and it took some time before we were able to study its use in type 2 diabetic individuals for the reasons we've talked about already. Here we have the once daily, twice daily GLP-1 receptor agonists. Then we had the once weekly, and then now we have the oral GLP-1 receptor agonists, which I think is a great thing. Now various combinations will be studied, combinations with GIP, for instance, and also combinations with amylin for weight. And so the future will probably show an increased expansion of indications. So semaglutide, how do we get along here? There will be triagonists to interact with the GLP-1 receptor. There may be allosteric modulators interacting with the receptor, as we've shown here. There may be biased agonists, which is very, very interesting, so that you can increase the activity of the molecule by changing its pathways intracellular. And there may also be development of small molecules. So if we take it all together, the pancreatic islets migrated from the gut, but they never really lost contact. They still depend on the incretins. The beta cells cannot maintain glucose tolerance without the incretins. The incretin effect is responsible for keeping up to 80% of the ingested glucose away from the circulation. That's how powerful it is. GIP and GLP-1 are the responsible incretins. L-cell hypersecretion accounts for a large part of the effect of Roux-en-Y gastric bypass on weight and glycemia due to the hyperactivation by nutrients. In type 2 diabetes, GLP-1 agonism has a powerful effect on weight, glucose control, and major adverse cardiovascular events. And that's why we can conclude that the incretins are very interesting molecules. Thank you very much for listening. Thank you for your attention, and goodbye.
Thank you so very much, Jens Holst, for joining us live after the recorded lecture. We have time for one or two questions. Dr. Prasanna Kumar, you have any questions to Dr. Holst?
Excellent talk. Thank you. I have a question. Now we have so many gut hormones. Let us say PYY, GLP-1, and leptin. Now the stimulus for all of them is a food intake. Now, how does it discriminate how much of it should be secreted to control satiety or gastric motility? Is there any interaction, or how is it each one of them act differently from the L cells and other ilia?
Yeah, that's a good question. So we think that GLP-1, its major actions really are, as you say, on appetite regulation and on gastrointestinal motility and secretion. That's at least my bias, that this is their major action, and that the effects on insulin really come into play mainly if you take large meals or if you have accelerated gastric emptying, when food and when nutrients are transported a little bit further down the small intestine. In the proximal intestine, there's no PYY at all, even if there are L cells. So PYY also comes into question only when nutrients reach the distal part of the small intestine and, of course, the colon. I must say that we really don't know what the colon is doing in terms of endocrine functions, and we cannot demonstrate for sure that any of the circulating GLP-1 actually comes from the colon. We know that from studies of people with total colectomies, that they have completely normal meal responses with respect to GLP-1. So that there are differences in all of these hormones, and there are differences in the regions that are being exposed to the nutrients, and therefore there's difference also in the timing. So I personally think that the couple, PYY and GLP-1, which actually come from the same cells, the distal L cells, that they work together. They potentiate each other's actions on food intake. And that's why, as I actually showed in the talk, that if you take one away with an antagonist, you can't see anything in these people with gastric bypass. But if you take both of them away, then you really see a large effect. So I think there's an interaction between them, and an important one, and they do have differences in their spectrum of actions and also differences in the timing of their release.
Other question is, we know that semaglutide is used in 7, 14, 21. Now, is there an exponential effect where if you increase it to 25 and 50 milligram of semaglutide, that you see lower A1C and better weight loss?
Yeah, so this is, of course, a historical development, really, because in the very first studies, I actually was part of that myself. We were very much afraid of the side effects, of the gastrointestinal side effects of semaglutide. So it turned out, of course, that a very, very cautious up titration was essential for this, because if you hammer in with a large dose of semaglutide, you will have many side effects, and you'll have vomiting, no doubt about that. So it took some time before the phase 2 study actually suggested that 1.6 milligram would be the optimal dose, but it was for safety and to be cautious, it ended up with 1.0 milligram. But then we did a study where it was dosed daily instead of weekly, and that was precisely to avoid these changes in concentrations that you have with a weekly injection, and that showed that it was possible to increase the dose quite a lot. And as this was increased, actually there were decreases in food intake by up to 14-15%. And that, of course, indicated that it was actually possible to get more out of the same molecule. And that's why these new studies with the 2.4 milligram were initiated. So you can say that this is where we are right now. Whether we can think of even higher doses is something for the future. That it will require probably different up titration regimens, even more careful up titration, but it's not excluded that this could be even more effective. So perhaps you know that the oral semaglutide is also being tested right now in increasing doses, and this is going to be very interesting to see if you can get even more out of it with very careful titration studies.
Thank you.
Okay, so before we leave you, I'll ask the last question to Dr. Holst. There are some talks about worsening of retinopathy with semaglutide, and some of the trials are going on, and your thoughts on that?
Yes, so that was in the SUSTAIN 6 trial, but there were some cases where there was a severe worsening, it was, of retinal disease. So these cases were very carefully looked at afterwards. And it turned out that in all cases, there was a pre-existing retinal problem. It was a severe one. And actually, some of them reverted after the study was concluded. But the most important thing is that it is known and quite well established these days that if you do have a very rapid reduction in glycemic exposure and an improvement in control, there is a risk of having at least a periodical worsening of retinal problems. And this is known from the PCCT study, with type 1 diabetes and insulin therapy. And it's also been noted in other studies where you have very quick, very fast changes in glucose. And so these days, it has been very much carefully looked at by ophthalmologists who have studied this problem. And I think the agreement today is that there's no specific problem with semaglutide at all. It is only a question of how quick you should set in if a person has a retinal problem. And then perhaps you should do a more careful and more slow improvement of glycemic levels. So that's the conclusion today.
Thank you. Thank you so very much, Dr. Holst, for your time and then being with us live for this talk. With that, we conclude the talk, and then we'll move on to the next talk, which is...
Thank you. Thank you very much.
Thank you. Thank you so very much. The next one is called the Primer Honor Lecture for Outstanding Researcher. And this year's Outstanding Researcher Honor Lecture goes to Dr. Rohit N. Kulkarni. Dr. Prasanna Kumar will be on the chair, and it's my privilege to introduce Dr. Rohit Kulkarni. Dr. Rohit Kulkarni is an MD PhD, holds the Margaret Congleton Chair, and is the core section head of the islet cell and regenerative biology at Joslин's Diabetes, and is a professor of medicine, Brigham and Women's Hospital, Harvard Medical School. Dr. Kulkarni is recognized for research in diabetes by the Ernst Hofheimer Award by the Endocrine Society, Albert Reynolds Prize by the European Association of Study of Diabetes, and Julio Viu Santiago MD Memorial Lecture and Dean's Distinguished Lecture. Dr. Rohit is an elected member of the American Association of Clinical Investigation and the Association of American Physicians. Dr. Rohit's laboratory is focused on defining signaling pathways and identifying novel factors that promote regeneration of insulin-secreting beta cells with the long-term goal of preventing the progression or probably curing diabetes, and in understanding the organ crosstalk between pancreatic islets and the liver with implication for the pathogenesis of NASH and NAFLD. Primer Bengaluru takes great pleasure in presenting this citation as a token of gratitude for his commitment to research, teaching, and towards the welfare of individuals with diabetes. Rohit, do please start your lecture.
Thank you very much, Arvind, and good to see all of you. Let me share the slides so that I'm sure it's working. Are you guys able to see this?
Yeah, we are able to see it. Yeah.
Great. So I just want to start off by thanking the organizers and also for making me a part of this group. And I really appreciate K.M. Prasanna Kumar, Arvind, Krishna Shishadri, Sanjay Reddy, and Bhavna and Shubha for putting these programs together over the last 7 years, which we appreciated yesterday. But just a minute to say that all of you guys have done a fantastic job in sustaining this effort, and I hope that we will continue doing this for the next 7 years and beyond. So, as the topic of this talk, and also as a thank you to the ADA Primer Group for recognizing the work that we have done in research over the last several years, upon discussion with how to make this presentation, I decided to give an example of my own journey through medical training and research, where I'm currently at the Joslin Diabetes Center, with a note to younger faculty and students and trainees to give them an idea about how research is done. And as the title says, it's usually a long road, and most of the time it's invisible. And so people need to realize, people who take on research, that immediate gratification of patient care is not immediately felt, but it takes a period of time. And that was what I wanted to give you 3 examples of my own career very briefly, to give you an idea as to how work is done from the bench to the bedside, and that needs to be appreciated. So this, I'm sure many of you have seen this, but just to make the point that pretty much all the work that goes on, for example, the work that you just heard from Jens Holst on GLP-1, starts very early on as a basic scientific discovery, and that has to be translated to humans, has to be translated to patients, to practice, and then to population health. So it's a long road from basic scientific discovery to translation to humans, and then from T1 to T4 is even longer. So I'll give you an example of 2 or 3 examples of the very first step. And so in that context, I also want to mention that mentoring is important. My current, the most recent mentor I've had is Ron Khan, who's at the Joslin Diabetes Center. I have the privilege of working with him now as a colleague and a friend, but continues to be a mentor. But my initial work started off at St. John's Medical College after I graduated from Bangalore Medical College, where Prakash Shetty was in the Division of Clinical Nutrition. And we addressed a very important question at the time as to how individuals with chronic undernutrition, like the daily laborers, how do they maintain energy balance? Their intake is very low, their output is very high, And we undertook a series of experiments in energy expenditure. And that is what has triggered me to continue in research in that context, because that was a very good example of doing human work at the St. John's Medical College at the time. Subsequently, I went on to Hammersmith Hospital, where I worked with Steve Bloom, where I did clinical practice. I used to be part of the diabetes clinic at the Hammersmith Hospital. But Steve inspired me to do a little bit more than clinical medicine. And he said that as physicians, we are in a good position to be trained as scientists and to combine the two efforts to do betterment of human disease. So I went on to a PhD at Hammersmith under the mentorship of Steve Bloom, and then decided to move on to an area of beta cell work, which is where I ended up Johnston Diabetes Center. So that's my BB training, as Krishna Seshadri put it. He would call me a BB rat. BB rat is a very well-known rat model used in diabetes, but in this context, it stands for Bangalore to Boston. So I moved all the way from Bangalore to Boston. So let me give you 2 or 3 examples of this work. I won't go into great detail here, but just to mention that the natural history of diabetes development and beta cell failure is very well known to all of you. You have alterations in glucose over a period of time, which is preceded by insulin resistance occurring very early. You can see that when there's insulin resistance, the glucose is maintained in normal limits. It's only over a period of time that there's alterations in hyperglycemia, coupled with insulin resistance as a consequence of beta cell dysfunction. So with that background, the focus in my group was to begin to understand the defects in the beta cell. And here's another well-known example of for clinicians, the relationship between secretion and sensitivity for insulin. You can see that obese individuals, as long as they stay on this curve, they maintain normal glycemia. But as they keep falling off the curve because of beta cell defects, they go on to become showing impaired glucose tolerance and over type 2 diabetes. And again, it always boils down to the beta cell. Another example of the UKPDS tells us that if one way to look at of this curve, where you have beta cell function or mass on the y-axis, and you look at what could be the beta cell function or mass in years preceding the diagnosis, which is year 0 here, you can see that even 10 years or 6 years or 8 years, 4 years before the diagnosis, there is a steady decline in the beta cell mass. So clearly telling us that there is a defect in beta cell function or beta cell mass much earlier than the diagnosis. So we really have to be focusing on how we can understand more about the beta cell and how we can regulate that. So the beta cell mass is reduced in type 2, but it's very variable in humans. So I just want to make this point that it's not all about the mass, but also about the function. So shown here is the data from Rahier's group, where beta cell mass plotted on the y-axis, and on the x-axis, you have individuals with diabetes, either split into BMIs less than 25 or BMI 26 to 40. And you can see that when in the individuals with no diabetes in the 2 groups, those who are obese have a slight increase in beta cell mass. And that's because of a compensatory effect, we think. And that allows them to maintain their glycemia. But there is no doubt that in both groups, there is a decrease in the beta cell mass. So, but I also want to point out two observations. One is that in the individuals with no diabetes, the beta cell mass can be very, very low, and they still would be normal. On the other hand, individuals with type 2 diabetes with increased beta cell mass, almost higher than those individuals who are lean, can become diabetic. So there is some things which are going on with the beta cell in addition to changes in mass. So the first example I want to give you is our own work in this area, where we looked at signaling pathways in the beta cells. So the next few slides I'll show you is taken about 10, 12 years to complete, but gives you an example of the focus of our efforts on understanding more about the beta cell. So the beta cell signaling network has been evolving over the last 20 years or so. When I got into this field in 1997, the concept was that insulin signaling in the beta cell was important, and it was not very much appreciated at the time and continues to be an area of debate. But we and others in this, as shown in this group here, have shown by a series of experiments, both mouse and human, that insulin signaling in the beta cell is important. So we developed this insulin receptor knockout in the beta cell, also called the Burko mouse, where we showed that this exemplifies a model of type 2 diabetes. So for example, these mice as shown here, which we reported many years ago, show glucose intolerance over a period of time. So just like humans, they develop age-dependent glucose intolerance. We also can take out the pancreas and do perfusion experiments, and we can show that when you do perfusion type experiments in response to glucose or potassium chloride, there is a defect in secretion. So there is a defect in secretion when you isolate the whole pancreas and do perfusion. You can also take out the islets and look at what happens to proinsulin-insulin ratios. In the individuals with the knockout, there is an increase in proinsulin, which is seen also in patients with type 2. And the beta cell islets are smaller. So all this work, as shown here, which took us about 5 to 6 years to complete, gives us a very good idea of this model for a type 2 diabetes. And the question that kept getting asked when we presented this data is, what's the relevance to humans? So in collaboration with Alison Goldfein, whom you might remember was an attendee here for many years as a faculty, we developed an important ELISA for human insulin. So in this case, it was the B27 ASP insulin, which we could recognize if we were to administer it exogenously. So the question here was, can we administer insulin exogenously and look at the effect on the beta cell? But we needed to get something to distinguish exogenous from endogenous insulin. So here was an assay shown on the right, where the Rediman assay was able to detect the exogenous insulin, but the ELISA was not able to detect that. So we took the combination of this and could identify what is the insulin being infused and distinguish it from the endogenous insulin. So we did a series of experiments. I won't go into great detail here. This has been discussed a couple of times, has been published. We took healthy individuals with glucose intolerance and type 2 diabetes, and we infused them with short periods of insulin and asked a very simple question. When you give exogenous insulin, what happens in the normal individuals in terms of graded glucose infusion, shown on the right side here? And then we extended that discussion to see what happens in patients with type 2 diabetes or impaired glucose tolerance. So as shown on this slide here, we observed that in individuals who are healthy, and you infuse them with insulin or with saline, and then give them a glucose bolus, you can see on the right panel here that the endogenous insulin was significantly higher, as shown in the yellow circles. So this told us that exogenous insulin is able to enhance insulin secretion in the normal individual, suggesting that insulin has an effect on beta cell function. What happens in patients with type 2 or impaired glucose tolerance? Shown here in the next slide. Again, these data have been published. On the left, again, is the controls, showing that endogenous insulin is going up as a significant effect in response to beta cell function. In individuals with impaired glucose tolerance, this defect is absent. This defect is very overt, that you don't have increase in endogenous insulin. And on the far right, you can see that there is some response in patients with type 2, but it's very much blunted. So this tells us that exogenous insulin is an important factor in regulating beta cell function. So this currently is being debated, and the question comes up, why is it that insulin is being effective in the beta cell? Isn't there a lot of insulin going around in the beta cell? So recently we had a paper published in Nature in February where a new molecule was identified in the beta cell called Inceptor. The Inceptor is able to regulate the insulin receptor action. And if one looks at the data very carefully, I won't go into too much detail here, but just to make the point that the insulin Inceptor is able to regulate insulin receptor action in the beta cell. And that tells us that insulin action in the beta cell continues to be an important action that needs to be considered in terms of treating patients with diabetes. So I'll leave this for the moment and take on questions if necessary later on. The second example I want to give you is what we've been doing over the last several years and looking at what are the multiple defects in beta cells which trigger diabetes. So shown here are multiple defects that people propose that are having an effect on beta cell function, which leads to diabetes. So we were wondering whether, is it really possible that you have so many different defects? Is it possible that's a very early defect which is able to regulate all of these so-called changes in the beta cell? So we went back to looking at what was proposed many years ago by Francis Crick, the central dogma that DNA gives rise to RNA and gives rise to protein. A number of studies are focused on what happens at the protein level or at the level of the DNA, but very few studies have looked at what happens to RNA. So in a series of experiments, again, very much summarized in this rather complex slide, but just to make the point that the mRNA modifications that could occur and impact beta cell biology have been studied for several years, but no concerted effort has been made in the context of looking at what happens to beta cells in patients with type 2. So we went on to look at M6A as one particular modification, and this has been published recently, that mRNA methylation in the beta cell plays an important role in type 2 diabetes. So I'll give you a couple of slides here just to show that, for example, looking at the changes in M6A using human islets, we can very clearly show that the alterations in the transcriptome of the type 2 diabetic islets has been reported earlier. But when one compares the M6A sequencing shown on the left with the transcriptome on the right, you can see that the M6A signature is much more easier to segregate type 2 from the controls compared to the transcriptome. So this tells us that in patients with type 2, M6A sequencing may be playing a very important role. So we've gone on to look at what are the key genes that are involved in type 2 diabetes. And shown here is an example of the functional enrichment analysis. But the question that came back to us was, okay, all this is shown in human islets, but is it really occurring in human beta cells? So a couple of students in the lab went on to knock down these human cell lines with the enzymes which are important for methylation. Shown here is an example of what would occur when you knock down these two enzymes. But to keep the story short, we can show that when you knock down either the metal 3 or the metal 14 enzyme, it leads to cell cycle arrest. And this would lead to a defect in beta cells and would contribute to decrease in beta cell mass. It also would lead to alterations in basal insulin secretion and reduced insulin content. So I've given you an example where changes in M6A would lead to alterations in beta cell biology. So in summary, the second example, you have changes in methylation patterns, which is relevant for type 2. And what I'm not going to show is what may be happening in type 1. So I hope that you'll read a manuscript on that. So as I mentioned to you, we think that potentially this M6A methylation may be playing a role in very early defects. And so the argument is that alterations in M6A could be important in modulating waves of RNA transcripts prior to protein synthesis, and that could lead to all the defects that we see in beta cells. And the question is whether it is reversible and targetable. In the last 3 minutes, I want to give you an example of what we're doing recently in our lab, again arguing for how research work is relevant in the context of patient care. So we are focused our efforts on MODI. And again, those of you who listen to Lou Philipson won't go into great detail here, but just to mention the focus for our lab has been on MODI-8. And MODI-8 is a very unique MODI because the gene that is affected is in the pancreatic exocrine cells, not in the endocrine cells. And yet, these individuals who have a defect in the carboxyester lipase gene have childhood onset exocrine pancreas dysfunction, and they develop diabetes when they're adults. So the question to us was, how is it that a defect in the exocrine cell can cause a defect in the beta cell? And so this would be an example of a crosstalk between acinar cells and beta cells. I don't need to remind you of the anatomy that the islets are islands of cells surrounded all around by acinar cells. And it makes teleological sense that the exocrine cells are regulating some aspects of beta cells and vice versa. So we took that as an example for MODI-8 and began to look at studies in our lab on how to address this. So again, without going into too much detail, we could show that if you co-culture acinar cells with beta cells, especially in those cells which have a mutation in the carboxyester gene, which is the gene which is important for MODI-8, we could show that in the culture medium, there is a certain amount of mutant protein that is secreted, and this protein is being taken up by the beta cells. So this tells us that the protein secreted from the acinar cell is being taken up by the beta cell. If the protein is in the normal situation, not much of the protein is present in the beta cell. But if it's a mutant version of the protein, it still persists in the beta cells. And so that would lead to aggregation of these proteins in the beta cells and would lead to some dysfunction of the beta cell over a period of time. Again, without going into great detail here, but just showing the fact that when you have these mutant proteins shown on the blot on the right, one can see that only in the mutant protein is there a large amount present in the beta cells. But in the wild type situation, which is the normal healthy beta cell, you don't see this defect. So what does this mean? So this means that there is a defect in the beta cell because it's taking up certain proteins from the patients with MODI who are expressing a mutant version of the carboxyester lipase gene, and that can have an effect on insulin secretion and also lead to a defect in the stimulation index. So just to summarize the last part, we believe that alterations in the acinar cells are leading to uptake of certain proteins in the neighboring beta cells, which then leads to a series of defects causing impaired function of the beta cell, growth arrest, and ER stress. So I hope that with these three examples, I know I'm running out of time, I've given you an idea about how research can be progressed from the bench to the bedside. In our own work, we believe that beta cell dysfunction is because of resistance in the beta cells, because of defects in insulin signaling, which can lead to alterations in hyperproinsulinemia, alterations in ER stress, and in turn lead to defects in glucose control. So we continue with this model, and I hope that as we move forward, we'll find ways to make sure that the patients with diabetes are improving, and potentially would also propose that some of our efforts would lead to a cure one day. And I thank all the people in my own lab who have done all this work over the last several years. And again, want to thank ADA Primer for this opportunity to share some of this work.
Thank you, Dr. Kulkarni, for an excellent talk. As it is an honor lecture, by convention, we don't have any questions. But if you permit me as a chairman to ask one question, I'm really excited about Inceptor. How this Inceptor, that is insulin inhibitory receptor, works. And is it acting on both the insulin receptor or IGF-1 receptor, IGF-2 receptors? And what is the mechanism? Because Dr. Chirag Jain's paper recently in Nature, I think throws more light about how it is likely to work and what is the mechanism. Or is there a future prospect that it could be one of the targets for treatment for diabetes? We have 12 targets, maybe 13 target is available in future, working on these lines, how it can translate it to future practice as such.
That's a great question, Dr. Prasanna Kumar. And as you rightly mentioned, the recent paper in Nature provides us with ideas. So to directly go to your question, we believe the Inceptor is specifically acting on the insulin receptor, but not on the IGF-1 or the IGF-2 receptor. And even more interestingly, the Inceptor is localized at very high levels in the beta cells, but not in the adipocytes or hepatocytes or myocytes or muscle cells, which is very remarkable because we think that the Inceptor somehow has evolved over time to have a regulation of the insulin receptor in the beta cell because the beta cell makes insulin. And it would make teleological sense that the regulation of insulin is being controlled by a different mechanism in those cells which are producing insulin versus those cells which are having the action of insulin. So yes, in terms of the targeting, absolutely. And my own group is working with Heiko Lickert's group in Germany to see whether one or more proteins downstream of the Inceptor could be used as one of the targets for making sure that insulin action is maintained in the beta cell, because we know that insulin action in the beta cell is critical for maintaining viability. So we think it has implications for type 1 as well as type 2 diabetes.
Thank you. Over to Dr. Arvind.
I think I have no more questions. Thank you so very much, Rohit, for that wonderful lecture. It was the honor lecture, ADA primer honor lecture for the best researcher. I think the next session is about to start.
Thank you very much.
And then we have the two plenaries. Rohit, if you have the time, please stay back because Dr. Malone Pregnell and Cynthia Munoz will be speaking after this. May I request Dr. Krishna Sheshadri to take over as the chair of this particular session, introduce the speakers and take it forward, please.
I don't think Krishna is there, Dr. Arvind.
Dr. Krishna Sheshadri. Prasanna Kumar, you can continue, Prasanna Kumar.
Thank you, Dr. Arvind. It's my pleasure to introduce Dr. Marlon Pregnell. Dr. Marlon Pregnell is Vice President, Research and Science, Research Portfolio and Scientific Sessions with over 2 decades of experience in research and science. He is an international leader in diabetes research and has led efforts focused on diabetes complications and glucose control worldwide. He also served on the Artificial Pancreas Project, which he actively managed prior to successful commercialization of the first closed-loop system in 2016. As a principal scientist in renal and metabolic disease in Genzyme, he focused on the bone-kidney axis and managed company-sponsored research collaboration in the USA and internationally to complement in-house research development. Dr. Marlon Pregnell will be talking about a very important topic, that is the Precision Medicine in Diabetes Initiative, providing a roadmap for precision medicine in diabetes to help improve the quality of life for all those with diabetes. Over to Dr. Marlon Pregnell.
Hello?
We can hear you. We can see the slides, Marlon. You can start your lecture.
Great, thank you. Just a moment, trying to get all set up here.
You can go to the full screen mode.
Great, great. So can you see my slides?
Yes, perfect.
Great. So I can't thank everyone enough for this kind invitation to participate in Primer 2021. It's truly an honor to be able to speak to you today at this really exciting and unusually informative conference. So let's go ahead and proceed. So my talk today is about the Precision Medicine in Diabetes Initiative and the roadmap we hope will provide to help improve the quality of life for all those with diabetes. Dr. Lou Philipson gave a really beautiful talk yesterday in the first plenary session, where he touched briefly on the broader view of precision medicine. He then went on to explore the opportunity and the promise of using simple clinical measures in precision medicine in the context of type 1 and type 2 diabetes. I'd like to take this time in this talk to take a step back to the more global view and describe the scope and vision of that initiative, the PMDI initiative, and give you a sense of where we were, how did we get here, and where we're going in this effort. And I must say, it's really a thrill to watch the evolution of this important and potentially transformational initiative. So as they say, it takes a village, and this is a lot of hard work by many people, and this is only a subset. And ADA, we want to pay our credit to the many people who have been involved at the outset. In particular, we want to recognize the Executive Oversight Committee of Dr. Paul Franks, Dr. Steve Rich, Dr. Lou Philipson, Dr. John Nolan, and Dr. Bob Eckel. And as you may recall from yesterday, two members of the Oversight Committee, Dr. Lou Philipson and Dr. Bob Eckel, gave some very nice presentations. This group has been meeting on a weekly basis for some years now to lay the groundwork for the initiative. And Dr. Gabe and I, Dr. Gabe, our Chief Medical and Scientific Officer, and I have been really privileged to be able to sit in on some of those discussions. The Executive Oversight Committee is supported by a world-class group of scientists in the steering committee as well as advisors. And there's more than 200 clinicians and scientists around the world that are really engaging in this really important initiative. And these are people who have their own clinical practices and very much are on the front line of dealing with diabetes. There are people with excellent scientific credentials. This group includes experts in big data, people with expertise in monitoring and devices, pharmacogeneticists, experts in different areas of lifestyle, which are really particularly pertinent for the prevention of diabetes. I know people often think of genetics in the context of precision medicine, but we need to think more broadly. And there are clearly, definitely really important markers, other types of markers, for example, clinical markers and other molecular biomarkers, omics, if you will, such as proteomics and metabolomics. So what's the mandate and vision for the Precision Medicine and Diabetes Initiative? Well, it's through expert consultation, stakeholder engagement, and systematic evaluation of available evidence. We want to establish a consensus on the viability and potential implementation of precision medicine for diagnosis, prevention, and treatment of diabetes. And really the vision is to realize a future of longer, healthier lives for people with diabetes, achieved by applying the appropriate treatment for the appropriate person at the appropriate time. So this is really an opportunity to work towards changing the way care exists for people with diabetes. And what more better time than this 100th year anniversary of the discovery of insulin to get together and imagine the future in this paradigm changing way in which diabetes could potentially be cared for. So the overall objective then is to improve diabetes care by realizing the promise of precision medicine. And I'll share a bit more about that. But how did we get here? Well, this has been a labor of love by a number of individuals. And it really started with three people in particular in December of 2017, Dr. Paul Franks, Dr. Will Cefalu, who provided a great deal of the intellectual vision for what this could be, and Dr. John Nolan. The initiative was launched in January of 2018, and we, in the spring at ADA, worked to create a task force. That summer, we partnered with ESD and developed a mission statement and plan, much of which we're still following in many ways. In the fall, a task force was created that included a multi-stakeholder group. Really important. We feel that this multi-stakeholder group is an essential path forward, and that we believe will be the the main reason for the success of the initiative is bringing all these partnerships together. Then there was the first symposium that we held at our annual scientific sessions, the large ADA scientific sessions in San Francisco. That continued onward with an important meeting in Madrid that brought stakeholders together to map out much of what the vision is currently. And in March, we released the first consensus report. And I really encourage everyone to look at this because it really lays out really nicely the science and the vision of this initiative in great detail. And then in April, we held a very successful virtual conference. And I really encourage everyone to review this, the excellent talks in that. And these are all freely available online if you go to the ADA website. Excellent presentations. And I think probably many of you may have heard of this. Excellent, very extensive background in precision medicine. So this is the consensus report, and I really encourage you to take the time to read this as well. As I mentioned, this really beautifully lays out the story, the vision of the initiative. So what are the goals of the initiative? Well, there are a number of different areas. First is really figuring out how we can improve the diagnosis of diabetes, and what do we mean by that? We know that diabetes, we see from this many talks, we know that diabetes is much more than just one or two diseases. For example, you could take type 2 here, and you can see that there are many subsets within that. Question is, how can we improve that and understand the different forms of diabetes? We need to establish what evidence we have and what evidence is needed. It's ultimately to develop practice guidelines and best practices and study designs for future research that will lead to these guidelines. And once we have that, what we want to do then is we want to educate and implement these best practices to really transform the way we deliver care. And this is going to require establishing a research program to address a number of important open questions, and we have an RFA coming out shortly. And ultimately, the goal will be to accelerate the process for accessing to trial and regulatory authorization, to take what we discover scientifically and put that into practice. And really what it all boils down to finally, it's really about changing our guidelines so that we're practicing and delivering care differently, leveraging the benefits of precision medicine. I mentioned it takes a village, and the over 200 experts that are involved in this undertaking. I just want to highlight 8 different work groups. Each of these work groups have numerous kind of leaders in the scientific and clinical world, really true experts, and they're defining the issues by developing manuscripts and summarizing the scientific research on the direction of where we can go. The first is around improving diagnostics for known types of diabetes. Then precision therapeutics, what's right treatment? The right treatment for the right individual. Using precision lifestyle for prevention. So we can use all the plethora of data, the vast amount of data out there to understand what lifestyle interventions are most effective for which individual, and really target that treatment and lifestyle change to those individuals that can most benefit from it, whether it's nutritional, exercise, or other behavioral changes. And that also gives you a sense of the scope of the initiative, not just going from genetics through to metabolomics and so on, but also lifestyle changes as well. We can use genetic risk scores in actual clinical management as well, and potentially in everyday care. Then also too, we need to understand the adoption. What are the standards for implementation? Once we understand these things, how do we get that into practice? And how is that adopted? And we know this is an area, in this area, we know that it takes so many years to go from scientific discovery to adoption. So we really want to kind of shorten that gap. We also want to know what the treatment responses in type 1 diabetes. what do we need to know more about, and what do you already know, and the promise of being able to prevent diabetes. And we're on the cusp of this, as we've seen recently in some of the recent news. And finally, how can we accelerate data access for trials using trials, EMR, and electronic medical records and biobanks? And this is something that, we 10, 15 years ago was not even possible. Now we're on the cusp, we're on the verge of being able to leverage this kind of broad information to help guide our understanding. So what are some of the specific strategies we envision? Well, it'll require us to work together to support research initiatives to really answer many of these questions. Will require enhanced use of data, and that really is the promise of precision medicine. We now have a host of omics data, genomics, proteomics, metabolomics. All that can be leveraged in a way that really couldn't have been done before, and could merge us now with data that exists in electronic medical records and patient registries. Thinking about, like, for example, wearable device data that indicates where the status of an individual patient and what they're doing, and really to be able to merge that data together to drive care. That's really the excitement and the vision of precision medicine. Then also, very importantly, how do we take these learnings from research and the data to really recommend guidelines for clinical implementation? Because ultimately, what we need to do is then really educate our healthcare provider colleagues, as well as people living with diabetes, to really leverage all the knowledge and the expertise that's coming out of these efforts in precision medicine. So ultimately, really what this boils down to, everything we're talking about here, is really going from the laboratory, from the research that we have on precision medicine, and ultimately taking that and transforming our standards of care. As you know, the American Diabetes Association publishes the standards of care on a yearly basis, and what we really want to do is take all that we learn, all the knowledge from precision medicine, all the advances, and put that into the standard of care. So really, clinicians all around the world can leverage this knowledge and all the incredible work that we foresee coming out of this. And really importantly, this really only happens through partnership. And so one of the things we are really pleased to see in the vision of the Executive Oversight Committee and others involved in this work is like thinking of partnerships in a new and a different way. So in particular, I'd like to highlight our relationships with industry. Historically, these have been largely transactional, where the model here now, though, we're looking at is really, we envision as being really more about a partnership where we're sitting all together at the table to think about solving problems. Because really, this is really a broad vision, and not any one group will be able to realize this alone. So we need partnerships, and it will be through these partnerships that we'll be able to solve these problems. There are some excellent examples of in Europe, for example, where this has worked in other fields, and we're planning to are looking at those models to see what we can do in that context. Also, importantly, we're going beyond the usual suspects. Who else could we bring to the table to solve this? So we're looking at a wider swath of individuals that may be involved in any given initiative. And this is really important to think out of the box, bring as broad a stakeholder group as possible to really realize the benefits and the potential of precision medicine. So what's been our timeline? We envision this happening over 4 phases, and we've accomplished a lot. We're essentially completed phase 1. We've accomplished a lot in that. I've talked through some of those. For example, we've had the initial symposium. We brought the task force together. We were identifying the vision of where things were moving. The first consensus report came out. Significant progress. So we're now right in phase 2. And with appropriate funding collectively, we'll look to funding new research projects and convening more precision medicine meetings. And I mentioned RFAs. We have an RFA coming out. It should be out very shortly. So it's very exciting. A lot of work to do, but very important and very exciting. And so we imagine in the years to come, the ensuing years, it will be the research that helps translate what we're finding, the data into clinical guidelines that will ultimately lead to the change of practice by educating providers and people living with diabetes on how they can incorporate this new knowledge. So we have a kind of a clear path forward. Excellent phase 1, now in phase 2. And we're very excited, looking forward to completing phase 2 and going through to phase 3 and phase 4. So I'd like to end here with really a special thank you on behalf of the ADA to the incredible oversight committee. And they've been really incredibly passionate about this work. And their leadership is really why we're moving so well on this today and where we are today. And they really deserve a special recognition. You can see each individual person is an amazing scientist and clinician, and they've really collectively worked together to help move this field forward enormously. Dr. Lou Phillipson, Dr. John Nolan, Dr. Franks, Dr. Rich, and Dr. Eckel. And so with that, I'd like to thank the organizers for giving me the opportunity to present this brief talk, and also again to thank all those 200 or more individuals participating in this major, very important effort, and looking forward to the next steps. Thank you very much.
Thank you, Dr. Marlan Pragnell, for an excellent talk. After yesterday's initiative by Lou Phillipson, we have heard what are the initiatives you have taken and what is the milestone that you are going to do in future. We'll come back to again after the second talk with question if we are still there. We move on to the next talk, because at the end of second talk, we'll take questions. The next speaker is Dr. Cynthia Munoz. Dr. Cynthia Munoz is a bilingual licensed psychologist and appointed as Assistant Professor of Clinical Pediatrics at UCSC Keck School of Medicine. In addition to providing clinical care and conducting research, Dr. Munoz is member of the ADA Board of Directors and President of Healthcare and Education, and President of ADA Community Leadership Board in Los Angeles. She also conducts research targeting behavioral health issues associated with pediatric insulin-treated diabetes. Dr. Munoz co-developed a group intervention, Teen Power, in 2006 for youth with insulin-treated diabetes, siblings, and caregivers. She is also a member of the ADA National Advocacy Committee and Safe at School Working Group. As a member of ADA APA Behavioral Health Steering Committee, Dr. Munoz is also actively involved with collaborative efforts to increase the capacity of mental health professionals who treat people with diabetes. Dr. Munoz will be talking about the imperfect storm, diabetes and psychological impact of a global pandemic. More so in type 1 diabetic children, we see a lot of psychological problems. We are very eager to listen to. Over to you, Dr. Cynthia Munoz.
Good morning here, everybody. It's a pleasure to be here. As Dr. Pragnell mentioned, it is an honor to be invited to join you today and to collaborate on so many important initiatives and programs. So I will be switching gears a little bit in talking about a topic that is near and dear to many of our hearts, and that is children with diabetes and the psychological impact of the pandemic. So if you will give me a moment, I will share my slides and get started.
Yes, all set. We can see the slides.
Okay. Okay. So I may be speaking a little bit faster than Dr. Pragnell, bringing in some energy and also trying to cover a lot of important information in a short period of time. So today I will be focusing on how the demographics of diabetes in children has changed over time. The psychosocial aspects of diabetes, both in general and through the lens of the pandemic, and ways that we can promote optimal coping with the daily demands of diabetes. So we know that diabetes impacts too many people, all ages and all walks of life. The demographics of diabetes in children and adolescents have changed. With type 1 diabetes, we have seen the increase in numbers. And with type 2 diabetes in children, this is still really a relatively new entity in pediatrics. Type 2 diabetes disproportionately affects children of color, children and families with high rates of diabetes, and those impacted by social determinants of health. And of note, type 1 diabetes is increasing as well at higher rates among specific groups, including Asian Pacific Islander individuals, Hispanic, non-Hispanic, Black, and Hispanic children. There are observed differences based on gender as well. So for type 1 diabetes, rates have increased more rapidly among males. And for type 2 diabetes, the rate has risen more rapidly among female youth. And this is significant, as I'm sure you also think about when you look at these trends, because we think about, these girls becoming young women, and particularly the young women in communities that are under-resourced, and how they will face the risks that accompany type 2 diabetes, such as decreased fertility and the challenges of managing diabetes during pregnancy. There's also the higher risk for the product of their pregnancies to develop type 2 diabetes, and the cycle, will continue. So thanks to the discovery of insulin, we all know that diabetes is no longer a death sentence. Unfortunately, we see trends that are concerning, to say the least. And this is a trend of higher A1Cs for children and youth. And this is despite the advances in therapy and technology. Misdiagnosis and DKA also continue to be issues, unfortunately. And we know that diabetes care can be complicated, to say the least. And if you don't have diabetes, have you ever tried taking on some of the behaviors and some of the care that we advise patients every day, such as calculating carbohydrates and the amount of insulin that you would need for all meals and snacks? And if you have tried this, have you tried this for a day? Have you tried this for a week or longer? And how did that go? And if you haven't tried it, I might suggest using this exercise to increase appreciation for all that we ask our the people that we see in our offices. So diabetes really can be daunting, and it can be a complex collection of tasks. So when meeting with people with diabetes in our offices, it is important to understand what are their biggest challenges, worries, or fears. And it is equally important to understand what your biggest challenges, worries, and fears are. Because we do worry as healthcare professionals. We care for people and we want the best for them. And when we see people struggling with their diabetes management, it certainly raises concerns and questions for each one of us. This is all important because we also know that there is a bidirectional relationship between psychosocial factors and diabetes. Because I work with children with diabetes, you will notice that I like to include little cartoons in my presentations. I hope you appreciate them. And so let's talk some about the common psychosocial issues that can impact an individual's health management. So for example, mood symptoms and trauma, but also health beliefs, limited support systems, limited financial resources, learning challenges, and physical challenges. There are so many. Diabetes-specific experiences can also negatively impact a person's health management. So for example, diabetes conflict and distress, diabulimia, and other eating disordered behaviors. We often don't think about the focus that is placed on food and eating for people with diabetes, particularly for individuals that are asked to engage in carbohydrate counting and calculations of medications around their food and beverage intake. Also, fear of hypoglycemia. So for individuals that have very real fears of having a significant episode of hypoglycemia, whether or not they have had one, these fears can drive individuals to either avoid taking the amounts of insulin that you as a provider are prescribing. They may purposefully want to float or keep their blood glucose levels higher, again, out of fear that they will experience hypoglycemia. And as if that were not enough, our world continues to fight against this global pandemic, which has devastated our diabetes community and really just beyond. So researchers have identified an increase in new onset diabetes during this past year and a half plus. Most notably, a team of researchers from the US reported that the rate of DKA for patients with new onset type 2 diabetes, and these are pediatric patients, doubled compared to data from 2018. Researchers from Canada stated that the incidence of severe DKA among children presenting with new onset type 1 diabetes doubled during the pandemic compared with data in 2019. And the UK reported that presentations of children newly diagnosed with type 1 diabetes were more severe during the first 3 months of the pandemic compared to the 9 preceding pre-pandemic months, including higher A1C at diagnosis, greater risk of developing DKA, and severe DKA. So people who experience DKA diagnosis, we know are at risk for poor outcomes, and timely diagnosis and symptom management become more difficult. They have become more difficult during the pandemic because we know that people have, often stopped going to well visits. There has been a hesitancy to leave their homes, let alone go to hospitals, clinics, emergency departments. And this is a real issue that is contributing to some challenges that people with diabetes are facing. The pandemic has also illuminated health disparities. So during the pandemic, education, healthcare support in most aspects of life, have become largely, accessible only on the computer. And the pandemic has created a digital divide as some individuals in under-resourced areas have had less access to the very technology that they need to optimally manage their health. So recent data has shown that children with type 1 diabetes from low-income families have the lowest diabetes technology use and highest hemoglobin A1C. Faced by the loss of employment and financial challenges, some have decreased access to the very medications needed to save their lives. So according to a survey, approximately 1 in 4 people with diabetes ration their insulin use due to financial limitations. And we, most of us, recognize, if not all of us recognize, that rationing insulin is not a novel to the pandemic, but certainly it has heightened the challenges around access. Youth residing in under-resourced communities also experience crowding and multi-generational living, again, not unique to the pandemic, but ongoing. What has added this additional layer of psychological impact is that they have, they have seen vulnerable adults become ill with COVID-19 and die because of underlying higher rates of exposure to the virus at work and for many other reasons, and because of more comorbidities like diabetes and obesity. So as a pediatric diabetes psychologist, I have seen the way the increases in diabetes and the impact of COVID-19 on people with diabetes, especially people with diabetes in under-resourced communities, has affected mental health. So pre-pandemic data from the T1D Exchange QI Collaborative have showed us that there are 5 times more depressive symptoms in adolescents with diabetes than the general population. And depressive symptoms are associated with higher A1C and increased short-term complications. In turn, increased risk and progression of complications can further exacerbate mental health issues. So the mounting mental health burden brought on by the pandemic has had a negative impact on diabetes management and outcomes, including this increased A1C and also comorbidities. Unfortunately, access to the optimal treatments, as I mentioned, has been an issue, but also access to other treatment options that are critical, such as mental health support, preventative treatments, and additional supports have also been challenging to access. And they have not kept up with the demand, especially for our under-resourced communities. Furthermore, access to mental health treatment, is negatively impacted by stigma, and particularly in our most affected communities. The pandemic continues to ravage our communities, and the mental toll is incalculable. So in the US, more than 25% of high school students and 20% of school-aged children have experienced worsened mental or emotional health since the beginning of 2020. In some major cities, the number of emergency room mental health visits has skyrocketed. So one finding, which is really just heartbreaking, is that even for children age 5 to 11, there has been an estimated 24% increase and a 31% increase for adolescents compared to the same time period in 2019 with regards to the mental health visits. There has also been a reported increase in substance use and domestic violence. So many challenges. For people with diabetes, there have been less opportunities to engage in physical activity, decreased access to food, not to mention healthy foods, and some have experienced reduced access to diabetes medications and supplies. I can't stress enough that a lot of this is not unique to a pandemic, but it certainly has made these challenges and these needs so much more palpable in the lives of so many. And researchers have reported that people with diabetes who experience higher levels of worry about the pandemic could be more vulnerable to diabetes distress, hyperglycemia, depression, anxiety, on and on. So many challenges. So many families have been impacted by unemployment and financial struggles, decreased access to healthcare and education, shortages of food and supplies, lack of social support. And this has led to increased anxiety, depression, substance use, and has also exacerbated other pre-existing mental health issues in adults. There is a subset of children with diabetes who have not been seen in person by pediatric endocrinologists and other healthcare providers. Though hopefully, some have been seen through telehealth, but as healthcare providers, we do not necessarily know what has been happening in the lives of these children and families. We don't know if their parents and guardians are doing well, and if they have been able to provide for the basic needs of their children. We don't know if they have food, let alone healthy foods, or if the family is being impacted by financial strain or depression, domestic violence, or so many other things. So this so far has been a lot of information. And I think it's important for us to pause and just take a moment and take a deep breath. There is so much happening in the world and so much happening around us. There is a reason that some smart watches have a feature that reminds one to stop and breathe, which I used to think was a silly feature, but as it turns out, it is not, especially when we are busy in our clinics and hospitals. So let's talk about emotional support for people with diabetes and what we can do. Adaptive coping strategies are associated with better self-care, metabolic management, and psychosocial well-being. So taking a moment to breathe is an example of adaptive coping. It's fairly easy, it's free, it's something we can all do at any time. And it can calm our mind and ground us. There are several basic ways that you as a care provider can promote improved diabetes management. So basic strategies like discussing treatment options in a way that the person you are speaking with will truly understand, encouraging collaborative problem solving, establishing realistic goals. I'll say that one more time, establishing realistic goals, watching for risk-taking behaviors. Also monitoring attendance and performance for people with diabetes, whether it's school, work, or other routine activities. When there are changes in their performance or attendance that may be indicative that there are other challenges happening in a person's life, that can impact diabetes management and overall health. Psychosocial factors exist along a continuum, so the same behavior can be adaptive or maladaptive. I mentioned fear of hypoglycemia earlier. So when a person has fear of hypoglycemia, they may be more vigilant with their diabetes care, and this can lead to improved management. So this, most would say, is a positive. However, a person who has a fear of hypoglycemia may also be so consumed with this fear that it interferes with their ability to function on a daily basis. And it can, in some cases, even lead to the avoidance of diabetes management that is so important for a person. So different issues arise also across the lifespan. Members of the diabetes care team can and should assume various roles to provide optimal whole person care. As Dr. Pragnell mentioned, our standards of care is one resource that we all refer to in guiding our care. Another is specifically the American Diabetes Association's position statement about the psychosocial care for people with diabetes. To provide patient-centered care, it is key to ask questions and to listen. And the questions that we ask may include, what do you think caused your diabetes? We all know that there are many beliefs around the cause for diabetes. So with the families that I work with, so there are many Latino or Hispanic families, a common belief is that something called susto, or a traumatic event or a frightening experience causes diabetes. If that is the case for a person with diabetes, that is important information for me to have so that I can inform my educational efforts. And there are so many other beliefs around what causes a person's diabetes, as well as beliefs and fears around the use of different medications. And so it is important to find out if a person is fearful of administering insulin because they fear that insulin is harmful. And we know that many people have this belief. And so it is important information for us to have. The other question that we can also ask is, what is the most difficult aspect of managing your health? We can make assumptions, and oftentimes we may be right. But asking someone what is most difficult for them can also inform our communication, our education, and our treatment planning. When people do not follow the prescribed treatment, it could be that they have heard scary things and believe that it's harmful. So one way to start that conversation is to say something as simple as, sometimes family and friends have suggestions about ways to manage your health. What are some suggestions that you have been given? That can be one way to open the conversation in a way that is not confrontational. So the way that we communicate about expectations also matters. It matters because people with diabetes can experience diabetes-related distress when there is a perceived discrepancy between the expectations of their self-care and their actual ability to perform. So diabetes distress refers to the emotional stress of managing one's diabetes. And a person who is experiencing diabetes distress may struggle with their self-care routines, may experience feelings of failure, disappointment, and powerlessness. They may also experience depressed mood or anxiety. And all of this can lead to suboptimal diabetes management, avoidance behaviors, and so forth. Diabetes distress is more closely associated, not surprisingly, with higher A1C, but it is more closely associated with higher A1C than depressed mood. The good news is that this type of distress can be alleviated with diabetes education. Maintaining the patient at the center of our care can have benefits for both the provider and the person with diabetes. So some tips are talking about regular everyday things before talking about diabetes. And I know in the past and with my fellow president colleague, Dr. Ruth Weinstock, we've talked about this. And from her perspective, she says, well, I use sticky notes, and the sticky notes help me remember some of the things that my families mentioned. So I can be sure to check back in with them when I meet with them the next time. Another thing that we can do is to praise individuals for completing diabetes tasks. And yes, this can be challenging, especially when someone walks into your office and their diabetes management is not going well, and the A1C has gone up and all kinds of things have happened. It may be difficult to find something to praise, but it is important to even praise the fact that they're standing in front of you or sitting in front of you. If nothing else, that is something that is praiseworthy. So after all, we know that diabetes and diabetes management is not easy or fun. The more that you praise and reinforce adaptive behaviors, the better they and you will do and feel. Identifying and discussing anticipated social challenges can be helpful for people when they're faced with peer pressure or dilemmas, including, exploring those health beliefs or advice that they may be given by family and friends. Screening for psychosocial conditions can help identify barriers and that people may not share with you directly. Some people simply don't think that something may be relevant to their diabetes care, and so they may not share it with you for that reason. We know that psychosocial issues can affect every aspect of a person's life, both directly and indirectly. So screening and evaluation really does allow the team to identify meaningful factors and ways to optimize the person's health and well-being. And this includes, of course, the psychosocial factors. And this really can inform our treatment planning. So for example, screening can help identify people who are experiencing depression, anxiety, and diabetes-related distress. Once they are identified, psychosocial factors that impact the patient's self-care and psychological states, should then be monitored and addressed and incorporated throughout the education and the treatment planning. When discussing concerns, it is important for us to consider the person's priorities and resources. Many times our priorities are not aligned. And so it's important to have that conversation and to arrive at a plan that can work the best for the person with diabetes who's going to be leaving your office and spending a lot more time self-managing than they are going to be spending with you. Follow-up to assess the individual's experience or any recommendations that you and your team have offered is important. So again, thinking about Dr. Weinstock's sticky notes of bringing something up and checking back in around what's worked and what hasn't worked, that can be really helpful to identify ongoing needs. So we have discussed that there is an intersection between mental health and diabetes. Diabetes is a complex disease, and mental health issues can impact diabetes self-care and health outcomes. The psychological impact of the pandemic has exacerbated mental health challenges. We talk about, the perfect storm, when things don't go well, but there is really nothing perfect about the situation that we have been in. There's so much changing, and when we think we may have arrived at a conclusion or at an understanding for something that is happening and how it's impacting people with diabetes, we get new information or the trends change. And so it becomes increasingly complicated for all of us. Each person's mental health must be considered, as part of their comprehensive diabetes care. And person-centered communication, screening measures, and follow-up can help identify meaningful psychosocial factors to inform treatment planning, which in turn can lead to improved health. Collaboration and the use of existing guidelines are also key. And last but not least, I want to direct my final statement to all of you, the healthcare providers. Please take care of you so that you can take better care of those around you. As our sayings go, that if we do not take care of ourselves, if you do not take care of yourself, then who is going to be around to provide all this information about the research? Who's going to conduct it? Who's going to provide that education and that very important critical care that our patients need now more than ever? So please, please, please take good care of yourselves. Thank you for your time. It is a privilege to be here and share with you. And with that, I will conclude my talk. Thank you.
Thank you, Dr. Cynthia Manos, for an excellent talk and also finishing time. We have exactly 8 minutes for question and answer session. And we have got Dr. Marlon Pregnell. Let me start with Dr. Marlon Pregnell. You talked about precision medicine in diabetes. Especially I'm interested in type 1 diabetes pregnant women, where you have also been part of the trials, where concept trial and all. How do you think that the precision medicine will help in type 1 diabetes with pregnancy? And what is it you look for in future with these things?
That's a very interesting question. I think, in terms of precision medicine, it's very important to understand what are the parameters that lead to complications in pregnancy and diabetes. For example, a lot of these things are behavioral in terms of diet, in terms of control of their blood glucose levels leading into pregnancy. So not, there could potentially be genetic indications and so on, but many of the aspects around precision medicine are also too around just how people handle their diabetes and what are their behavioral approaches, what are their what physiology they have, if they level of the history of glucose control, whether there's diabetes in the family, things like more behavioral, actually, in a sense. Yeah, and what the ideal scenario in that would also be that you could ultimately in the future maybe take some blood glucose measurements or some other measurements that will then give you a sense of the trajectory of the pregnancy, and so lead to better approaches to reduce, example, for large for gestational age, or reduce the incidence of preeclampsia, for example, which is really elevated in women with type 1 diabetes, and really improve the glucose control throughout the duration of the pregnancy, which changes actually, and also the insulin needs and so on. So, there's so much to potentially learn around this, and to be able to then turn back and improve the outcomes.
Yeah, I agree. The question is, a type 1 diabetic lady become pregnant. Of all the situations, this is where involvement of the patient will maximum, nowhere else. At least those 9 months, whatever you say she is willing to do. Most often, I think we may be unrealistic in trying to get a A1C of 6, trying to get a fasting of 90, 1 hour, 140, 2 hours, 120, and doing 7 blood sugars per day. What is advice is the best. It almost becomes practically impossible to motivate a patient, maybe resource limited country, maybe motivationless, maybe finances, whatever reasons, that though we say this is what we want, but there's a huge gap between what is ideal, what is practical, what is possible. We only look forward to how do we use the technology and how do you use and where else we should use that the precision medicine to see that you have a good control to reduce the maternal mortality and fetal mortality, of course, complications, as you said.
Yeah.
But real life, it's really difficult.
And that's an excellent point. And I have a lot of hopes for closed loop technology and hybrid closed loop. A lot of the challenges in terms of behavior, people are trying their best. So sometimes it's very difficult, and then in those situations, then you may have to start thinking about technology. Bringing into, and I'm sure you've seen this, all the excitement around these hybrid closed loop systems, where a person can wear both a pump and a sensor at the same time, and the pump communicates with the sensor and delivers the right amount of, or attempts to deliver the right amount of insulin at the right time. And we're seeing actually now, lots of benefits. We see in the trials, people are improving their A1C, for example. So I think these are also kind of ways to, sometimes it's difficult to control, in those situations, really need to try and see whether they can go on various kinds of technologies. Ideally, a closed loop, so a hybrid closed loop. And ultimately, in the future, if we can develop something that is a fully closed loop and automated, then it takes a lot of the burden away from people to try and ensure they have good control.
Though we have this technology from 1985, I have been using pump for 35 years. I don't have a single patient on insulin pump. Most of them are very comfortable. 80% can manage with 2 PMIX. Even with basal bolus, very minimal, not even 10%. Even today, I had 2 patients. We manage very well. A1C is 5.8, blood sugar 90 and all. So though we insist on a pump, many of them are reluctant. And just putting a pump, many people think that's the end of all. Neither type 1 nor pregnancy, that putting on a pump is going to solve, because the amount of engaging, the amount of involvement, mindset, and motivation what they should have is so high that I don't know. This is what my personal experience.
Yeah.
I don't know whether Arvind has so many patients on pregnancy.
No, I think you're absolutely right. I think I was about to ask a very similar question to Dr. Scindia about it. In patient-centric management, we talk about it's just not the knowledge, but it's the attitude. It's not just the discipline, but it's also the motivation. These are the 4 pillars that we keep talking about it. And counseling is something that we all have to do, but counseling also has an expiry period. And people say that thoughts creates behaviors, and behavior changes from time to time. It has its rhythm. Like any drug, even counseling has its own expiry period. How do you really make them stick to your counseling? Because their problems change from time to time, and suddenly there is a rebound, and you're not there to help them out at that time. How do you manage as a counselor, as a psychologist?
Yeah, this is an excellent question. And it lends itself to, the previous question about technology. So absolutely, I agree that technology is incredibly helpful and useful for so many, and so many of us wish that more people use technology, but there are a lot of people that don't wish to use technology. The use of technology is also very much a personal choice. And also there are access issues, which is a whole other conversation that we would need to work on. There are many people who want them but can't access them. So my job as a psychologist is certainly not to have somebody coming in to see me over long periods of time. Sometimes that does happen, and that is okay. Because sometimes the challenges are very complex. When someone is not managing their diabetes well, or they're not following the directions that the endocrinologist and the team has painstakingly explained and taken so much time to do, it is my job to help explore, why is that happening? What are the underlying things that are going on in that person's life that they may not be sharing with you or with the medical team? So once I have an opportunity to talk with a person, I have to know how to talk with a person in order to gather information. And then once I gather that information, it's my job I say that it's my job to help make life a little bit easier. But it is then my job to help create these practical approaches to improving diabetes management. And what I try to do is to help a person develop and learn strategies that they can then generalize to other situations. So we explicitly talk about not only the challenges a person is experiencing, in the moment, but we anticipate what challenges might come up in the future. So when I talk with adults, we are anticipating, what could happen. And we call those like these high risk situations. So the high risk situation might be going to a family gathering, a celebration with a family. When we're talking about children, a high risk situation may be, going out into the community, going where there might be, street vendors or food available. So again, we want to anticipate, we want to generalize the use of the strategy. So some people think, psychology, mental health, therapy, counseling, that it's common sense. Some of it is, but also there's a lot of education behind how to deliver this service. And there is a lot of thoughtful, methodical strategy around how, I work with a person with diabetes and how we arrive at these strategies, how we motivate. And we certainly, do our best to help, work together with our colleagues. And so I work very closely with my medical providers. And, I'm not always going to be the one communicating the plan to the patient. So sometimes I'm talking with the provider and we're coming up with, solutions or treatment plans based on the information, that I have gathered. And then the provider is delivering that information. It helps us all. So the two takeaways are that, there is a lot of science behind psychology and counseling. It is not just talking and having a conversation with someone. And two, the goal is to really help someone learn a lot of the strategies so that we can tackle the burnout. And sometimes a way that we can help a person with burnout is to switch their technology or switch them to technology. And what do we do when a person doesn't want to use technology? We have to, think about other ways that we're going to bring in additional support, even if they are adults. So, there are a lot of different components, but I really appreciate the question.
Thank you. Thank you.
Thank you, Dr. Manoj. Thank you, Dr. Pragnell, for excellent talk and also answering the questions very well. We are already 2 minutes late. We move on to the next one. I hand it over to Dr. Arvind to carry over the last session of the day.
Thank you. Thank you, Dr. Scindia. Thank you, Dr. Pragnell. We close this session and we move on to the next session. May I request Dr. Neeta Deshpande to come on and take the stage and take this talk forward. And this incidentally is a tape lecture by Dr. Samuel Klein. In fact, he's busy with his daughter's wedding. So since we changed the dates, he had to tell us that he will immediately record it because he has always come for all the ADA primer meetings so far. So this is a recorded lecture, but since Neeta and Nitin have done a lot of work in this particular field, it's lovely to see Neeta and Nitin on the same screen after such a long time. I used to see Nitin when he had just got in to do his endocrinology, and after so many years, I've seen you now. And Neeta was all praise for you for doing something very similar to what Samuel Klein is going to be speaking about. So after the lecture, you two will take the discussions further, and Neeta can moderate and Nitin can answer and bring it to a close. And again, I've requested Neeta to take it till the end and close the session of today after this lecture. Thank you, Neeta, and over to you.
Thank you. Thank you so much. Am I audible?
You are audible. You can
Yes.
introduce Dr. Samuel Klein and
Yes, yes. It is indeed a pleasure to be here for this wonderful session, and I'm so happy to co-chair with Nitin for this session. And we are going to be talking about a very important topic, and that is normal weight obesity. And for this, we have one of the best, and that is Dr. Samuel Klein. MD is the William H. Danworth Professor of Medicine, Director of the Center for Human Nutrition, Director of the Center for Applied Research Sciences, Chief of Geriatrics and Nutritional Sciences, and Director of Weight Management Program at Washington University School of Medicine in St. Louis, Missouri. He has had consistent R01 funding from the NIH since 1990 and has published more than 400 papers in nutrition, metabolism, and obesity and received numerous awards. His research activities are focused on understanding the mechanisms responsible for metabolic dysfunction associated with obesity, particularly NAFLD and therapeutic effects of weight loss. So with this, I ask the team to please put on the lecture of Dr. Samuel Klein.
Participate in this conference. I'm going to review briefly some aspects regarding the pathophysiology of obesity, regarding metabolically healthy and unhealthy obesity. This is a concept that's been developed over the last 15 or 20 years or so. And I'd like to review with you some of the mechanisms that might be involved in why some people seem to be protected from the adverse effects of having excess body fat, whereas most people have the full complementation of metabolic abnormalities associated with excess adiposity. So you know, when you go from being a lean person here on the left to an obese person here on the right, that almost every organ system is adversely affected. But the most important complications that are associated with increased adiposity are the metabolic complications shown here in the middle of this slide. And these metabolic complications include insulin resistance and beta cell failure, which lead to type 2 diabetes, atherogenic dyslipidemia, which is high triglyceride and low HDL cholesterol concentrations. And now we know that having increased triglyceride inside of our liver, known as non-alcoholic fatty liver disease, is also part of this constellation of metabolic problems that are associated with excess body fat that are important risk factors for heart disease, stroke, and heart failure. It's believed that insulin resistance may be a very important feature that underlies all of these complications, metabolic complications associated with obesity, but that insulin resistance may also be involved in some of these other complications of obesity, as shown here on the right. And so cancer, cognitive dysfunction, even osteoarthritis may be associated with having increased insulin resistance to insulin concentrations. Now, the definition and prevalence of metabolically healthy obesity is not really very clear. In fact, there's no standard definition for metabolically healthy obesity, and there have been more than 30 different definitions that have been published in the literature. And these are some of the definitions that are listed here. And so the prevalence of metabolically healthy obesity depends on really the population being studied, as well as the definitions used to define metabolic health. And so if you define metabolically healthy obesity as having less than or equal to 2 metabolic syndrome components, as shown here, which is the criteria used in many, many studies, 50% of people who are obese will be metabolically healthy. But if you define metabolically healthy obesity as having a low HOMA-IR value, which is a measure of insulin resistance based on plasma glucose and insulin concentrations, only about 25% of people have metabolically healthy obesity. And then as you drill down to become more aggressive in your definition of metabolic health, meaning 0 metabolic syndrome components or 0 metabolic syndrome components and a low HOMA-IR value, you see that very few people who are obese truly have metabolically healthy obesity. And only about 5 or 7% have metabolically healthy obesity based on these very strict definitions. But these strict definitions are not even strict enough, potentially. Although, if you were then to follow people long-term with metabolically healthy obesity and metabolically unhealthy obesity, you see that even by using these crude definitions, that people who have metabolically healthy obesity have a much better outcome than people who have metabolically unhealthy obesity. And so if you look at people and follow them for a period of 8 to 10 years, as done in this study, and define metabolically healthy or metabolic normal obesity as having 2 or fewer metabolic syndrome criteria, you see that people who are obese in black have a much lower risk of developing type 2 diabetes than people who are obese in black, shown here, who have metabolically unhealthy obesity. And the same goes for cardiovascular disease, where people who are obese with metabolically healthy obesity are at much lower risk of developing cardiovascular disease than people who have metabolically unhealthy obesity, as shown here. But people with metabolically healthy obesity have a higher risk than those who are lean and metabolically normal for cardiovascular disease, as well as those who are lean and metabolically normal for the incidence of type 2 diabetes, as shown here. So metabolically healthy obesity, defined by these very crude definitions, are not really the same as being metabolically healthy and normal, but much better than being metabolically unhealthy and obese. Now, if you measure insulin sensitivity very carefully by using a hyperinsulinemic euglycemic clamp procedure, and this is a procedure where you infuse insulin at a certain level and infuse glucose needed to maintain euglycemia during that insulin infusion. And the rate of glucose infusion determines how sensitive your body is to insulin. So if you're very sensitive, you require much higher glucose infusion to maintain euglycemia, whereas if you're insulin resistant, you require much lower glucose infusion rates to maintain euglycemia because glucose uptake is impaired. And you can see that as you become more and more obese with increasing body mass index, as we have done here in these people that we have studied who do not have diabetes, you see there is an inverse negative relationship between BMI and insulin sensitivity, where the glucose infusion rate progressively declines with increasing BMI. But if you look at any particular given BMI, for example here, a BMI of 35, you see incredible heterogeneity in the glucose infusion rate. And so there's incredible differences between some people who have a BMI of 35 who are very, very insulin resistant, and others with a BMI of 35 who seem to be insulin sensitive and are similar with insulin sensitivity to those people who are lean and healthy. And so these people here, these obese populations here, ranging from a BMI of 30 to around 50 in our study, are considered insulin sensitive, whereas these shown here in the bottom tertile are insulin resistant. And so by using these very sophisticated, more intense tools, we still see that there are people who are obese, and they can be very obese, that are insulin sensitive compared with lean people, and much more insulin sensitive compared with other obese populations. And so the question is, why is that? Why is that the case? Why are some people protected from these adverse effects of excess body fat? Well, one thing we know now is that having increased fat in your liver, intrahepatic triglyceride content, is an important biomarker of metabolically unhealthy obesity. And so having non-alcoholic fatty liver disease is a very important criteria for evaluating someone's metabolic health. And in this study, we found that the greater your intrahepatic triglyceride content, with some people going up to nearly 50% of their liver volume is composed of triglyceride, that the more fat in your liver, the worse is your insulin sensitivity as measured by the hyperinsulinemic euglycemic clamp procedure, where insulin-stimulated glucose uptake increases much less with insulin when you have a high liver fat content than when you have a low or even normal liver fat content, as shown here. And so now we know that fat in the liver is a very important marker of insulin resistance and metabolic dysfunction in people who are obese who are not African Americans, because African Americans tend to have lower liver fat content despite being insulin resistant. The prevalence of non-alcoholic fatty liver disease in adults are shown here in this slide, where if you look at the study that was performed in Dallas, where they studied over 2,000 people and measured liver fat content, you see that people who are obese had a high prevalence of steatosis, of abnormal liver fat content. About 65 or 70% of obese people have NAFLD. And if you look at people with type 2 diabetes, whether they're obese or not, they also have a high prevalence of non-alcoholic fatty liver disease. So increased fat in your liver is certainly associated with obesity and also associated with type 2 diabetes. And this demonstrates this connection between fat in the liver and metabolic dysfunction in obesity as well as in type 2 diabetes. In this study, we evaluated people who were matched on body mass index, as you can see here, a BMI of 36, both obese groups, but one group had normal intrahepatic triglyceride content of 3.7% liver volume as triglyceride, and the other group had high intrahepatic triglyceride content, 25% of liver volume as triglyceride, and we matched them with visceral fat to remove the confounding variable of having differences in intra-abdominal fat on our results. And we measured both insulin sensitivity in the liver and muscle, shown here on the left, and also VLDL triglyceride secretion rates shown here on the right. And you can see from this study that if you have high intrahepatic triglyceride content, even though you're matched on BMI, total percent body fat, and matched on visceral fat, intra-abdominal fat, that those people with high intrahepatic triglyceride content have impaired insulin sensitivity in the liver and impaired insulin sensitivity in skeletal muscle, presented as insulin-mediated stimulation of glucose rate of disappearance during the clamp procedure, as shown here. In addition, if you were to measure VLDL triglyceride secretion rate, again by using a stable isotope tracer method that involves evaluating the incorporation of glycerol into triglycerides, you see that people who have the high intrahepatic triglyceride content have double the rate of VLDL triglyceride than those who have normal intrahepatic triglyceride content. So people who are metabolically abnormal with increased liver fat content have much higher secretion rates of VLDL triglyceride than those who have normal intrahepatic triglyceride. And this also helps explain why people who are metabolically abnormal with high liver fat content have increased serum triglyceride content and low HDL cholesterol concentrations, because increasing VLDL triglyceride secretion increases the concentration of triglyceride in the bloodstream, and the high VLDL triglyceride concentration interacts with cholesterol ester transfer protein to change the conformation of HDL and increases the clearance of HDL from the plasma. And so having increased VL triglyceride secretion will cause a high triglyceride concentration and low HDL cholesterol concentration at the same time. Now, the difference between why some people who are obese are metabolically healthy and others are metabolically abnormal is unclear, but it seems that adipose tissue biology might be very, very important. And if you look at people who are metabolically healthy obese, compare them with people who are metabolically unhealthy obese, as done in this study by Steve Elbine, you see here that the genes that were upregulated, the differentially expressed genes in muscle tissue that were upregulated or downregulated muscle between the two groups are only a very small number of genes. But if you look at adipose tissue, a very large number of genes are different between the metabolically healthy and the metabolically unhealthy obese people. 38 upregulated genes in adipose tissue and 134 downregulated genes in adipose tissue, showing this difference between the two groups. This suggests that adipose tissue biology could be very important in determining who is metabolically healthy and who's metabolically unhealthy when they become obese. This is a summary of data from studies conducted in rodent models presented by Phil Shear, as shown here, with this hypothesis or proposal that as we become heavier and adipose tissue expands, if we're unable to increase capillarization of adipose tissue adequately, shown here in the bottom, then adipose tissue becomes a little bit hypoxic, and this hypoxia drives a series of events which increase inflammation and fibrosis of adipose tissue because of HIF-1 alpha increases and also the attraction of immune cells to adipose tissue, which increase inflammation as well. And that this process then somehow causes systemic insulin resistance. If you are metabolically healthy obesity, it requires a much larger amount of fat to develop this hypoxia and then develop all of these abnormalities. But this has not been very well carefully studied in people. And so we finished a series of studies evaluating different aspects of this hypothesis in human beings to see if this really might fit what happens in people. And so one study that we performed here, and this is a study by Vincenzo Cifarelli, where we measured adipose tissue interstitial oxygen content in people who are lean, people who are obese, and normal metabolic function, compared with people obese with non-alcoholic fatty liver disease or metabolically unhealthy obesity. And you can see that adipose tissue oxygen tension progressively decreased among these groups and was statistically significantly lower in people who are obese with fatty liver disease or metabolic unhealthy obesity. And if you look at adipose tissue oxygen content here on the x-axis and correlate it with insulin-stimulated glucose uptake, which is a measure of whole body insulin sensitivity, you see this progressive increase in insulin sensitivity with a progressive increase in adipose tissue oxygen. And so this is a remarkable correlation between measurement of adipose tissue oxygen content by using these probes in interstitial space and comparing them with insulin-stimulated glucose uptake in vivo. This supports the concept that oxygen might be important in humans as well as they are in rodents. The next thing we did was look at collagen metabolism or fibrosis in adipose tissue of people who are metabolic unhealthy obese with fatty liver disease compared to those who are obese with normal liver fat content and metabolically normal, and comparing them with lean normal volunteers. And you can see by measuring collagen synthetic rates, this is now collagen 1 alpha 1 measured in adipose tissue by using a stable isotope tracer technique, that there's a progressive increase in the fractional synthesis rate of collagen in adipose tissue as you progress from lean healthy to obese metabolically healthy to obese metabolically normal individuals. And if you measure gene expression of collagen in adipose tissue, you see the composite of all the different collagens in adipose tissue also progressively increase as you go from lean to obese healthy to obese fatty liver disease or unhealthy. And this is manifested by increased collagen, as you can see here in this trichome stain, and also an increase in connective tissue growth factor, as you can see here on this stain in panel D. And so obese people who are metabolically unhealthy with NAFLD have increased fibrosis histologically compared to lean subjects. They also have larger adipocytes, as you can see, and they also have increased connective tissue growth factor staining, supporting the concept that obese metabolically unhealthy people have increased fibrogenesis, as shown here, increased markers of collagen production, shown here, and also increased fibrosis, as shown here histologically. And this collagen expression, shown histologically, when you correlate it with insulin sensitivity by measured as glucose disposal rate, you see that there's a negative inverse correlation. The more collagen expression adipose tissue, the worse is insulin sensitivity, supporting very much the idea that fibrosis in adipose tissue is a marker. This does not tell you cause and effect, but is a marker of insulin resistance systemically. The next thing we did then was look at inflammation, because adipose tissue immunology has been a hot topic of research, and it's been proposed that inflammation adipose tissue, meaning an increase of inflammatory immune cells in adipose tissue with increased gene expression of inflammatory proteins, causes insulin resistance systemically in people, as they may do in rodents as well. And so we evaluated this in our subjects, again, the lean, the obese, normal, the obese with NAFLD, which are metabolic unhealthy obese, and found that M1-like macrophages, which are the inflammatory-like macrophages in adipose tissue, progressively increased as you go from lean to obese NAFLD. And the M2-like macrophages, which are more the anti-inflammatory type of macrophages, progressively decrease as you go from lean to obese NAFLD or unhealthy obesity. And these M1-like macrophages, as a percentage of total macrophages, are negatively correlated with insulin sensitivity. So the more M1-like macrophages you have, the worse is your insulin sensitivity. But the more M2-like macrophages you have, shown here on the right, the greater is your insulin sensitivity. Again, showing an association between adipose tissue, inflammatory immune cells, and systemic insulin sensitivity. But again, to underscore, this is simply an association and doesn't tell you anything about cause and effect relationships. And so we tried to evaluate this further, because it's proposed that these inflammatory cells in adipose tissue cause systemic insulin resistance by secreting pro-inflammatory cytokines into the bloodstream. And these pro-inflammatory proteins go to other tissues and cause insulin resistance. But what we found is when we measure these pro-inflammatory cytokines in blood over 24 hours, not just at basal overnight fasting conditions, because we always live mostly in a postprandial state, that the first thing we found when we did this measurement in our subjects, again, the lean normal are in blue, the obese healthy are in green, and the obese unhealthy are in orange, shown here. So obese NAFLD are in orange, obese metabolic and normal green, and lean in blue. The one thing to note is that these inflammatory markers pretty much stay steady all day long, despite eating meals, moving around the clinical research unit, and doesn't change very much, except for PI1, which has a remarkable diurnal variation, as has been shown in the past. What was very interesting, though, is that the concentrations of all of these cytokines that are proposed to be important in the pathophysiology of obesity and causing insulin resistance were really not different between the obese normal in green and the obese abnormal in orange. And sometimes the obese abnormal in orange were actually lower than the obese normal in green and the lean in blue, as shown here. And so here you can see in all of these different cytokines, TNF alpha, CCL2, IL-6, IL-1 beta, interferon gamma, there is no real indication that these are involved in causing systemic insulin resistance because their concentrations are really not much difference between the groups. Moreover, their concentrations are very low. These are picogram per ml concentrations, ranging from 0.6, 0.4, 6, 4. Here it's a little bit more, from around 40 to 80, as shown here, but still very low concentrations in blood, which are probably below the threshold needed to cause any kind of effect systemically in other organs, except for Pi1. You can see that the values here for Pi1 are much greater than the values you see here for the other plasma cytokines, and the Pi1 concentrations are much greater in the obese metabolically unhealthy, shown here in orange, compared to the obese metabolically healthy, shown in green, and the lean subjects that are healthy, shown here in blue. And in fact, Pi1 concentrations in blood, if you do the area under the curve over the in total 24 hours, correlate negatively with glucose insulin sensitivity, of glucose rate of disappearance divided by insulin concentration during the clamp procedure, where you can see insulin sensitivity, which is this value here, progressively declines with a progressive increase in Pi1 concentration. This really supports the concept that potentially Pi1 produced by adipose tissue is an important stimulator or cause of insulin resistance in people who are metabolic abnormal obese. But again, this shows correlations and really can't tell you cause and effect relationships. Now, the final thing I'd like to review with you is this new target that people have been very aggressively studying, which is exosomes. Now, exosomes are these small extracellular vesicles that are released by every cell in the body that go into the bloodstream. And by carrying certain cargo of microRNA, proteins, even lipids, they deliver this cargo to other tissues. And so they communicate from one tissue to another by releasing these exosomes from a cell in one tissue, going into the bloodstream and delivering this cargo to another cell in another tissue. And so exosomes that are produced by adipose tissue might be very important in regulating potentially insulin action in other tissues. And so we measured, and this has been shown in rodent models. So obese rodents who are metabolically unhealthy, diet-induced obesity or insulin resistance, if you take their exosomes and inject them into rodents that are metabolically healthy, you will cause insulin resistance. And the reverse is true as well. If you take the exosomes that are made from adipose tissue macrophages of insulin-sensitive obese mice who are lean and inject them into insulin-resistant obese rodents, then you make them metabolically normal. And so in rodent models, it looks like exosomes that are released from adipose tissue, macrophages in particular, are important regulators of insulin sensitivity. And this has been attributed to the microRNA cargo that these exosomes deliver to these other tissues. So we looked at this in people and found that the number of exosomes in the bloodstream in metabolic unhealthy obese people, obese NAFLD, is much greater than exosomes in the healthy obese people versus the lean people. And if you incubate these exosomes with myotubes, as shown here, you find that the plasma exosomes incubated with these myotubes cause an impairment in insulin signaling, which is phosphorylation of AKT, in the ones that are incubated with the exosomes from the obese unhealthy humans from their plasma. And that the lean people have actually an increase in insulin signaling in terms of AKT phosphorylation, as shown here compared to the control group. And then the obese normal is somewhere in between the lean and the obese NAFLD or unhealthy obese group. And so incubating these myotubes with insulin, as shown here, and different exosomes from plasma of these different groups regulate insulin signaling in these particular cells. And if you look at these exosomes that are produced by subcutaneous abdominal adipose tissue, SAAT, again incubated with insulin, as shown here, you see here that the same pattern evolves, that there is an impairment of insulin signaling with the obese NAFLD exosomes compared to obese normal and compared to lean subject shown here. And very interestingly is that the effect of these exosomes on insulin signaling in myotube, shown here on the x-axis, from either plasma exosomes or from adipose tissue exosomes, shown here on the left and the right of this part of the screen, was directly correlated with insulin sensitivity in vivo. And so glucose rate of disappearance divided by insulin concentration during the clamp procedure progressively increased with evidence of increasing insulin sensitivity in exosomes, as shown here from plasma exosomes and here from subcutaneous abdominal adipose tissue exosomes. And so finally, I'd just like to conclude that it looks like obesity is a very heterogeneous disease, where there's some people who are very insulin resistant and have beta cell dysfunction and all of the metabolic complications that are typically associated with obesity. And some have very few of those complications, and some have none of those complications and are metabolically healthy with even normal insulin sensitivity. And so obesity can cause all of these physiological changes shown here in the middle circle of insulin resistance, beta cell dysfunction, dyslipidemia, adipose tissue inflammation, adipose tissue fibrosis, even increased blood pressure, which I didn't talk about. And these abnormalities are responsible for causing diabetes, fatty liver disease, cardiovascular disease, and heart failure. And so finding the mechanisms for why obesity is causing these problems and then trying to block these mechanisms, particularly potentially adipose tissue fibrosis and inflammation that produce exosomes as well as PI1, may help in the treatment of people who are obese with metabolically unhealthy obesity and even prevent potentially the development of diseases like 2 diabetes. Thank you very much. I'd just like to thank the group that's involved in doing these studies. These are complicated studies that involve dietitians, technicians, junior faculty, research fellows, people who are basic scientists to do the insulin signaling and other aspects of these studies that I showed you. Requires really a cohesive group. I won't go through all the names, but these are the picture of the people that were, some of the people that were involved in doing these studies. And without their support, these studies would never be done. And of course, support from the NIH for providing our research grants to study these patients. Thank you very much.
Well, I think that was an excellent deliberation on metabolically healthy obesity, and what we gather from this studies, there's a lot of molecular studies and in-depth studies have been done. And what we gather from this, from the clinical point of view, is that the culprit is fatty liver, not in causation, but I would say something that we should all be looking out for. It is not at all innocuous. And at the clinical level, when we're treating obesity, I think it's very, very pertinent to keep looking at if a person has fatty liver and treat them more aggressively, because as was said, these patients are more metabolically unhealthy, or rather it is metabolically unhealthy obesity, and it has been used as a marker, in fact, in dividing the patients in most of Dr. Samuel's studies, that obese NAFLD were considered to be the metabolically unhealthy patients. So that is very important thing for us all to remember. So Nitin, I know that you have done a lot of work in metabolically healthy and unhealthy obesity. And taking this a little forward to the clinical point of view, do you think that for these kind of patients, metabolically healthy people, lifestyle intervention is important, and does it work? How do you see that in the work that you have done?
Thank you so much, ma'am, and thank you for having me here, Dr. Arvind and Dr. Neeta. It's a great privilege and honor to be here. And a very pertinent question, an excellent talk. I completely echo all what you said, and I think it's the location of fat, as you mentioned, in the liver and other ectopic sites, which is of great importance. And talking about lifestyle intervention, yes, the role is enormous. From the work that we have done, we've looked at the effect of lifestyle, diet and exercise, followed up a large cohort of over 1,000 people for a couple of years. We've seen that it helps, but somehow these people with metabolically unhealthy fat are more resistant as compared to those who are, even obese otherwise without this excessive fat. So they are more resistant. We've seen changes with drop in blood pressure and triglycerides over a period of 2 years, but probably the duration required is much longer. In people who've just got obesity, we've managed to bring down their fat without a lot of visceral fat. We've been able to bring down their diabetes, blood pressure, and lipids. But those with specifically metabolically unhealthy obesity, it's been more resistant.
Yes. So, and I also feel that Dr. Samuel Klein showed us that if you use rigid criteria, then the people falling into the metabolically unhealthy obesity are much more. So it also depends upon what criteria you're going to use to define metabolically healthy or unhealthy obesity. And just carrying on in the same vein, what I would like to know is that he mentioned about African Americans being an exception, but in India, we have this typical phenotype. So what do you think is the prevalence of metabolically healthy versus unhealthy obesity in our population?
Right. Again, very important. And it's very important to look at the definition for diagnosis, as Professor Klein mentioned. When we look at global data, the definitions vary. But from our population, when we look at the data, and this is data from the Kerala Diabetes Prevention Cohort, in people with high risk of diabetes, we found 1 out of 3, 30% of the population have metabolically healthy obesity. When we look at just normal weight people, so about 50% of the population had normal BMI less than 23, about 2/3 of them had high body fat. So it's enormous. 1/3 of the population, 2/3 of the people who walk into our clinic having normal weight actually have high body fat.
Yeah, and if you remember, Nitin, way back in 2009, the two of us had done a similar study in a small way, and we had done some inflammatory markers, etc., and found that people who are normal weight but metabolically unhealthy, so to speak, they were right in the middle between the normal people and the metabolically unhealthy. So yes, that is the other end of the spectrum. Normal weight but metabolically unhealthy. So that is the other end of the spectrum that we should be looking at as Indians, especially because of the thin fat Asian Indian phenotype that we talk about. So in this, since we don't have too much time, just one more question to you. In these times of COVID, because it is very relevant, what do you think we should be looking out for because of, that obesity has turned out to be one of the worst determinants of bad outcomes in COVID-19. So would this apply to normal weight obesity, metabolically healthy and unhealthy? Would they be different?
Right. So a lot of interesting data. And as we know that a lot of CT scans have been done in people with COVID, CT chest, and that has given an opportunity to look at fat. And a lot of interesting data is coming up in people who have normal BMI, but high fat, which is determined by CT, they have much worse outcomes with respect to COVID. So normal weight obesity or metabolically unhealthy obesity is now being recognized as an important risk factor. I'm aware of a couple of multi-center studies which are currently ongoing, and I'm sure we'll have good data in print in the next 6 months on that. But whatever preliminary data is available, it is definitely a bad marker.
That's very pertinent and very relevant, and something to look out for in our patients, and especially in this particular pandemic. So I think we have had a very nice discussion and a beautiful talk by Dr. Samuel Klein, and nice inputs given by you also. And before we close this session, I would like to announce that tomorrow's sessions would start at 9 a.m. and we have some very good stalwart speaking. Dr. Sundar Mudliar, Dr. V. Mohan, Dr. Shashank Joshi, and Dr. Tini Nair would be taking up the sessions in the morning sharp at 9 a.m. And thank you all for being with us all day and listening to this last session also. And thanks again to ADA Prima for on behalf of both Nitin and I. And thank you very much, and good night and be safe. Thank you.
Thank you. Bye-bye.
Bye.
Recording stopped.